Hello, everybody. Today we're going to go over the most high-yield topics from Step 1. All of these questions are completely original. However, they do cover everything that I believe you need to know by the time you finish MBME 28. Now pop the popcorn and let's begin. For the first question, a 17-year-old boy presents to the emergency department with sudden onset severe left-sided scrotal pain that began 1 hour ago while he was at soccer practice. He denies trauma, dysuria, or urinary frequency. He vomited once from the pain. On exam, the left testicle appears swollen and elevated compared to the right. Cremasteric reflex is absent. That means it's torsion of the testes, 100%. Indeed, our answer is C. This is a surgical emergency, and the signs, the way you can tell, is sudden severe unilateral testicular pain. Absent cremasteric reflex was the giveaway, and the high riding testes. Vomiting is the autonomic response to the pain. Renal calculus would be flank pain that radiates to the groin. It's not epididymitis, and the reason why that there would be relief with elevation there. But here they said elevation worsens that pain and the cremasteric reflex is absent, not preserved. The big distinguishing factor is that cremasteric reflex for testicular torsion. Also, true story, once I was in Guatemala and I was in charge of driving home a missionary who had testicular torsion. And Guatemala notoriously has tons and tons of speed bumps. And let me tell you, while I was driving in the front, my buddy in the back with testicular torsion was not having a good time. And at the hospital, the doctor goes, "I'm sorry, guy, we're going to have to take that out." So imagine we're in Guatemala, I'm translating in Spanish, and I'm like, I got to take out the pelota, man. He took it like a champ. But if you're in Guatemala, definitely pay attention because it's thanks to the competent surgeons that he was able to be okay after that incident. But true story. Wow. Ugh, gives me shivers. Diverticulitis would be lower left quadrant pain and fever, which there is not here, so that's not the right answer. And colon neoplasm would have weight loss and anemia, but this is scrotal pain, so it's totally different. And this is a big emergency because in just 6 hours, it can cause irreversible damage. And I think it's probably helpful to distinguish this from another condition, which is ureteral calculus. Now, there you could see some sudden left flank pain, and it radiates to the groin, and it causes nausea. And the vitals would show hypertension. So you could have like a 160 over like a 110, just some high value here. And tachycardia, so you know you're at 110 per minute. So you're breathing fast, you've got hypertension, you got left flank pain and also left lower quadrant tenderness, and also mildly hypoactive bowel sounds and a negative stool, a cold blood test. And you probably have heard the word colicky to describe this pain. That's basically severe pain in the abdomen due to the gas or some sort of an intestinal obstruction. So it's that abdomen on the side pain that radiates to the groin. So the groin is the area between the abdomen and the thigh on either side of the body. And the presentation, if this were ureteral calculus, would have the colicky flank pain that radiates to the groin. We talked about that. The hematuria, which is the gross or microscopic presence of blood in the urine. And the urine analysis would show red blood cells, but no casts. There's not going to be any glomerular involvement either. And the treatment here is just going to be pain control. And if the stone is less than 5 millimeters, then it's probably just going to spontaneously pass. And it's important to know the onset of these different conditions. For instance, a colonic neoplasm would usually be insidious, not very acute. And insidious means that it proceeds in a very gradual or subtle way, but it still has some harmful, problematic effects. It's not acute, basically, is what it means in the medical context. And a colonic neoplasm would also present with weight loss, which I will write here, anemia, change in the bowel habits, but definitely not flank pain. And typically, you know, if the patient's mid to late 20s, early 20s, something like that, that's a bit too early for colonic cancer for step 1. I mean, I just wouldn't be looking for colonic cancer in a 20-some-year-old unless there were signs, like clear signs like weight loss, anemia, and the change in the bowel, but not flank pain. Flank pain would definitely make me think of a ureteral calculus. Okay, so that's ureteral calculus, but what about diverticulitis? Well, diverticulitis usually presents with fever, diarrhea, and left lower quadrant pain. In a diverticulitis, the flank pain would be pretty unusual. You'd also expect some hyperactive bowel sounds, not hypoactive. The epididymitis, that would cause scrotal pain, so you can kind of tell the difference there from the groin pain. Also swelling and dysuria, not flank and groin. And it would not cause lower left quadrant flank tenderness. And a physical exam of the scrotum itself would be abnormal, but they didn't mention any weird findings. And so probably not going to be epididymitis. Renal infarction, that is a very rare, but I guess plausible cause of flank pain. And that typically would not radiate to the groin. What you should be looking out for in these types of questions would be thromboembolic risk factors or atrial fibrillation. And if you have somebody in their 20s, then you really shouldn't be thinking about a renal infarction unless there's a reason to suspect they have a renal infarction. You know, like thromboembolic reasons, risk factors, atrial fibrillation, something like that. Otherwise, it's much more likely that they just have a little stone. They got some deposits, much more likely. And we already talked about testicular torsion. That was what our practice question was based off of here. And the most important thing to know is that would have absent cremasteric reflex and abnormal testicular. So a way to really just dial this in and know that this is ureteral calculus, not something else, would be the severe flank pain, the nausea, the pain that radiates to the groin, not limited to the flank or the low abdomen. So just some quick recall questions. I would ask, what kind of hematuria is seen in the ureteral stones? And to that, you would say probably microscopic hematuria without the casts. And you might be asked, hey, what's the most common type of kidney stones in the pelvis? And lastly, just because it's so high yield, I really wanted to cover diverticulitis, and it would present with hyperactive bowel sounds. Also wanted to note that for epididymitis, that's usually going to be secondary to other STIs like chlamydia or Neisseria gonorrhea. And in older males, you could also see some E. coli problems, which lead to epididymitis. But yep, renal involvement in the infarctions would definitely be associated with some thromboembolic risk factor, which we don't see. Torsion of the testes, super painful. It's a true urologic emergency. Sudden severe unilateral scrotal pain. This guy in Guatemala, he was 20, I believe, and I did not elevate. I knew none of this. I was just driving that car, trying to navigate over the speed bumps as slowly as I possibly could, but also as quickly as I could to get to the hospital. And it was like 1 a.m. He called me, I was like, say no more. I drove 2 hours to get him. All right, in our next question, we have a 58-year-old man with a 25-year history of alcohol, presenting with difficulty walking, and he has no complaints of numbness or tingling on examination. He is unable to maintain a straight line during tandem gait and shows wide base stance. Finger to nose testing is intact, and vibration and position sense is normal in all extremities. Damage to which of the following structures most likely underlines this patient's symptoms? All right, well, let's look at our answers and kind of dive into each one. You can see my beautiful drawing, which we'll use soon. A says the dorsal columns, and that carries fine touch, vibration, proprioception, that crosses at the spinal cord in the anterior white commissure. C, the primary motor cortex is involved in voluntary movement. A lesion there would have contralateral weakness, upper motor neuron signs if the cortex is involved. The anterior cerebellar lobe is involved in truncal coordination, particularly gait stability. And if you have a lesion there, you'll have truncal ataxia, and that is what's damaged often in alcoholics with cerebellar degeneration. So that is probably going to be our answer. And then E is standing for the VPL, nucleus of the thalamus, and that would be the spinothalamics, the pain and temperature, and the dorsal columns, which is the medial and the medial lemniscus, which would be touch and proprioception. A lesion there would cause contralateral body sensory loss. That'd be the lateral, whereas the VPM would be the face sensory. So the answer is indeed D. It's the anterior lobe of the cerebellum because it's involved in unconscious proprioceptive input from the lower limbs via the spinocerebral tracts. Alcohol degenerates that region despite intact conscious sensory modalities like vibration, proprioception. They have truncal ataxia. Dorsal, we discussed this, would be vibration and also position. The spinothalamic would be associated with pain and temperature loss. VPL would have contralateral sensory loss. And the primary motor cortex would actually be associated with paresis and not ataxia with preserved strength. And it's kind of cool because the anterior cerebellum actually gives rise to your body's ability to know unconsciously where it is in space. So you close your eyes, you spin around, you're like, oh, where am I? Well, that's all thanks to your anterior cerebellum. And if that's gone, you close your eyes and you're going to stumble, you're going to fall. And that's what happens if you have anterior cerebellar damage. And so patients will try to protect themselves. They'll have like a really wide base gait so that they don't fall. But they can still kind of manage just a little bit because their conscious sensations like vibration and joint position are intact. And you have to know the tract that this flows through is the spinocerebral tract directly to the anterior cerebellum. And it bypasses the cortex. That's crazy, but it does. But you can see the anterior lobe is here, the primary fissure is here, and there's the vermis. Back here is the posterior lobe, the cerebellar vermis. Medulla oblongata right here. There are the peduncles. You can see the middle and the inferior peduncles. That's the tree of life, arbor vitae. I was actually teaching a class of 7th graders about this. There's my picture of the tree of life. Very beautiful. Looks like a seahorse, honestly. Who did it better, me or Google? So again, I'm just showing you a different perspective. This is the anterior lobe. That's the fissure. This is the posterior lobe. And here we're referring to the anterior lobe for unconscious proprioception, whereas conscious proprioception is controlled by the dorsal column medial lemniscus pathway. Again, here's another look. Anterior, posterior, cerebrum, cerebellum, pons, cephalon, that comprises the brainstem. And look at that cerebellum. Oof, the brain is so freaking cool. By the way, you guys should comment below what you believe the mechanism for free will is. Libertarian free will, not compatibilist free will. Here's the midbrain, the pons, the medulla, superior, middle, and there's the cerebellum, anterior lobe, posterior lobe, kind of looking at it from a different angle. And if you guys ever handle sheep brains, it looks identical to the human brains. You can actually see the tree of life when you cut it open. All right, so there's our last photo. I think you guys get the idea. If not from this, then at least from my beautiful drawing. And so we're going to thank our 58-year-old man here with this 25-year history of alcohol and difficulty walking. Because of that, we now know that his unconscious proprioception and wide gait is probably due to this anterior part of the cerebellum. If he had conscious proprioception problems, then it would be the dorsal column medial lemniscus pathway, but this was unconscious and therefore it was the anterior lobe right here. So that's our answer. By the way, if he had like problems with pain sensation, then it would probably be his spinothalamic pathway. And just when you thought my drawings couldn't get any better, we have a 29-year-old tennis player presenting with weakness and turning his palms upward against resistance while keeping his elbow flexed at 90 degrees. All right, so flex your elbow at 90 degrees and then go like this. And then tell me what pops out. And I want you to do this on test day because it'll make this so much easier. I guarantee a lot of you guys would miss this question until you actually do this exercise yourself. So physical exam shows a preserved wrist flexion and extension, but limited power to resist the supination. And remember, it's like, I want soup. You got to resist that supination. The reflexes are intact except for the reduced biceps reflex on the right, which the following muscle is responsible for his impaired function. The answer is actually the biceps brachii. Why? It's the main supinator of the forearm when the elbow is flexed, particularly against resistance. So you can kind of see, maybe you can see in my arm, how when I try to supinate with the elbow inflected, then you get some action from the biceps brachii. And there it is in all of its glory. Look at that, compare it to mine over here. Not mine on my body, rather this beautiful drawing I have here. The pronator does pronation, duh. Supinator is a good choice. However, this is not going to be under resistance. So it has less contribution than your biceps whenever the elbow is flexed. All right. Kind of crazy, but yeah. Flexor carpi radialis, that's the wrist flexor. That would have radial deviation. So the biceps brachii is a really powerful supinator of the forearm, especially when the elbow is flexed. And that receives the innervation from the musculocutaneous nerve. And I like to think of that because it's muscular. It's biceps brachii. It's the most powerful supinator against resistance. The brachialis is elbow flexion only. Does not supinate. That's what distinguishes the brachialis from the biceps brachii. You know how people do this and this when they're trying to show their strength? It's because you can activate those muscles differently, and you're not, by supinating or pronating, going to be activating the brachialis. The triceps are involved in elbow extension. You can see your triceps will be involved there if you extend. Does not have a role, however, in supination and pronation, and the innervation there of that extension of the triceps is the radial nerve. The flexor carpi radialis does wrist flexion. There's no action at the elbow at all, and that is actually done through the median nerve. And the pronator teres does the pronating, which is, of course, the opposite of supinating, and that's also done by the median nerve as well. To recap here, you've got your elbow flexed. Let's see this elbow word flexed at 90 degrees, and then you try to supinate it, supinator. And the nerve that innervates the biceps brachii is the musculocutaneous, which is C5 to C6. In this next question, we have a 42-year-old woman, but it could also be a man, and so the demographic I've chosen here is a man, with acute myeloid leukemia, presents with fever, dry cough, and shortness of breath. She underwent allo stem cell transplant 4 months ago. Okay, so transplant should key you into CMV, and immunosuppressive for graft versus host. That's definitely CMV. Yep, it literally tells us it's CMV. And she started on antiviral therapy that inhibits the viral DNA chain elongation after phosphorylation by viral kinases. Which of the following enzymes is the direct target? All right, so let's get down to business to defeat the Hun. What do I need to know about antivirals? Well, first of all, we should know that for CMV infections in immunocompromised patients, we're going to use something like ganciclovir. And the mechanism of action of ganciclovir is that it's a guanosine analog. And you can kind of tell because they both start with G. Guanosine, ganciclovir. And so this guanosine analog inhibits viral DNA polymerase. Guanosine inhibits viral DNA polymerase and does that by CMV UL97 kinase, not thymidine kinase. What is thymidine kinase involved in? Because that is super crazy high yield. In fact, whenever you guys who are about to take the step 1 exam enter into the step exam and you see thymidine kinase and you know the mechanism, then thank me in the channel afterwards because this is going to be on your test. I guarantee it. It's a factoid that everybody misses. Because thymidine kinase would be for like HSV and VZV only here. Different than ganciclovir. So ganciclovir would be a DNA polymerase inhibitor for cytomegalovirus. And there's a way to remember that. It's the G and cyclovir, and also the G and guanosine look similar. So G, cyclovir, G, guanosine virus. So try to bucket them together, group them together. So our answer is DNA polymerase. It's a guanosine analog. We talked about that. It competitively inhibits the viral DNA polymerase, inhibiting DNA synthesis, particularly critical in immunocompromised patients where CMV reactivation causes tissue-invasive diseases. Integrase would be the genome integration of HIV. Reverse transcriptase would have RNA to DNA, and ganciclovir targets the DNA polymerase, not the reverse. Now, most of the time, CMV is dormant, it's silent, but you get to be immunocompromised. You have a bone marrow transplant, and now it comes back. So you give them ganciclovir. This antiviral gets phosphorylated, and then it targets and it blocks that viral DNA polymerase. It's good to know the other mechanisms like integrase, and I have a video on these, but integrase prevents the integration of the proviral DNA into host. It's like, stop that. You do not get integrated. You do not have access to this pool. I just thought back to like 12-year-old me trying to get into the pool, like a hotel. I couldn't get in because I didn't have a key card. But yeah, integrase inhibitors prevent that, the integration of the DNA into the host genome. And so activation of ganciclovir requires the phosphorylation within the infected cell. And CMV, by the way, is the human herpes virus 5, and it's opportunistic. So look out for it whenever you have a transplant. Also, ulcerative colitis, or maybe they have like HIV or AIDS, something like that. And you can transmit this a whole bunch of ways. Sexual contact, for instance, is one. Be respiratory, could be a fetus through the placenta. This could be valacyclovir, acyclovir, famiciclovir, and ganciclovir. They're all guanosine analogs. They inhibit viral DNA polymerase. Okay, the next question has to be a woman. 28-year-old woman presents with fertility. For fertility evaluation, her menstrual cycle is regular, and mid-cycle serum hormone levels show a peak estradiol concentration just before ovulation. Which of the following ovarian cell types is responsible for the conversion of androgens into estradiol? They're basically asking about aromatase, what aromatases into estradiol. And there's androstenedione, which comes from the theca interna, that gets converted into estradiol by aromatase, and the granulosa cells secrete aromatase when they're stimulated by FSH. The follicle stimulating hormone causes the granulosa to secrete aromatase, which causes the transfer of this into this, and that's why it's elevated at her phase in the month, menstruation cycle. So the theca interna cells provides these androgens that are then aromatased over to estradiol. That happens because of the granulosa cells, which are stimulated by FSH. The luteal cells, they're called luteal because they're present in the corpus luteum, and they're derived from granulosa before the ovulation follicle. And these guys will secrete progesterone. The luteal cells secrete progesterone and estrogen, but they don't actually develop until after ovulation takes place. All right, the answer is like not stromal because those are just supporting cells. And so the answer to this question is the granulosa stimulated by FSH to make the aromatase, which causes the conversion to estradiol. And it's that rise in estradiol that triggers the LH surge, and that leads to ovulation, which is that discharge of the ova from the ovary. The externa is the outer fibrous layer. The stromal is the support tissue. Corpus luteum would be the post-ovulation progesterone. It's after the estradiol peak afterwards, corpus luteum. And the theca interna would be androgen synthesis. It's crazy because the estrogen levels actually go up 200-fold during the menstrual cycle. And it all starts with the granulosa because of the FSH, because of that aromatase, which converts the androgen into estradiol. Next is question 6. We've updated our demographic. Now, this is an autosomal recessive condition, and so we're just going to say it's a 10-year-old boy or a girl. They're evaluated for progressive irritability, poor coordination, and a new rash after playing in the sun. Mother notes that they have several episodes of watery diarrhea, eating poorly, loss of appetite, red scaly rash on the back of the hands and neck, and mild unsteady gait. Labs show decreased tryptophan levels and normal, neutral aminoaciduria. Which of the following vitamins is deficient? All right, so a photosensitive rash and neutral aminoaciduria. It's probably heart-nut disease. And that is a pretty rare genetic condition that prevents the body from absorbing certain amino acids. This especially occurs in the small intestine and the kidneys. And this is autosomal recessive, and it does occur in childhood. That's why we had the young girl, the young boy. And you get these light-sensitive skin rashes. And also you can have some problems like an unsteady gait, maybe speech difficulties and emotional instability, and then they're usually a little shorter. So for treatment, you have a high-protein diet, niacinamide supplements, and sun protection to manage the symptoms and the severity of the attack. So we mentioned this is some sort of a deficiency, but what is exactly that deficiency? Well, the answer is niacin, but I want to explain the reason why. Now, niacin, you should know it also by the name vitamin B3. This is actually used to make NAD+, which is nicotinamide, adenine dinucleotide, and NADP+. Those guys are superessential coenzymes in redox reactions. So you may have seen these guys. They're pretty popular in glycolysis, the TCA cycle, the electron transport chain, all that good stuff. And now, how exactly is niacin made? And like, what is niacin all about? Well, your body can make niacin from this thing called tryptophan. Tryptophan. I always say like tryptophan because that helps me remember what it looks like. But tryptophan is an essential amino acid, and it requires vitamin B2, which, for those of you in the back, is riboflavin. And it also requires B6, for those of you in the front, pyridoxine, as cofactors. I don't know why I said front and back. I'm just being a silly goose. And so what happens if you are niacin deficient is that you get pellagra. And you guys might have remembered the terrible Ds, right? Dermatitis, diarrhea, dementia. DDD, dermatitis, diarrhea, dementia. That's like one of those memorization things. But dermatitis would be the skin rash, especially on the neck and the arms. The diarrhea obviously would have GI, mucosal atrophy, and dementia would have CNS symptoms, the irritability, memory loss, and hallucinations, things like that. You might have been told there's a fourth D, and what is that fourth D? It is indeed death. So it can be fatal. And so why, you might be asking, does niacin deficiency cause a problem here? Like what actually is going on? Well, no niacin means that we don't have our awesome little buddies, NAD plus and NADP plus, which as if you've taken biochem, you know those guys are pretty important. And so you'll have tissues that have some high energy needs. Can you think of some tissues that have high energy needs? I don't know. How about the skin? How about the gut? How about the brain? Wow, look at that. DDD, dermatitis for the skin, diarrhea for the gut, and then for the brain, it's dementia and death, because other organs also need it as well. So niacin is required to make NAD+, and that is a key coenzyme in metabolism. And metabolism, by the way, is the process that occurs in order to maintain life. It's how you change your food into energy. That's why you can die if you don't have niacin. But why is it not these other guys? Pyridoxine would have different associations: seizures, glossitis, irritability. The dermatitis is really the giveaway, the photosensitive rash and aminoaciduria. Riboflavin would present with corneal vascularization and no diarrhea and sun-induced rash. It's really that rash that gives it away. Ascorbic acid, bleeding gums, corkscrew hair, scurvy, vitamin C. And cobalamin, macrocytic anemia. B12 deficiency causes spinal cord demyelination, not aminoaciduria, and photosensitivity, so cobalamin. Be macrocytic and paresthesias. And paresthesias is the pins and needles sensation in your peripherals. And oftentimes what happens with these kids is that they get some sort of a rash and then they're like, oh my gosh, you got a rash, time to get that checked out. It's hardened up disease. You have the genetic defect because the transportation of a neutral amino acid like tryptophan is damaged. And you need that for vitamin B3. And if you don't have vitamin B3, you're going to die and your gut's going to hate you. All right, here we have a 74-year-old man, and I've gone ahead and made him a pretty young looking dude administering this shot menacingly. He's got a prosthetic mitral valve presented with fever, malaise, and a new murmur. Blood shows it's enterococcus. In fact, the infectious disease team recommends a combination of antibiotics for synergistic bacterial killing. That's what this person is doing. That's what you're going to be doing in a hospital system soon. And one of the chosen targets is, they didn't have to tell you this. That was nice of them. 30S ribosomal subunit causing misreading of the mRNA. Which antibiotic is most likely being used in combination to enhance the penetration efficacy of this drug? The answer is carbapenems. Because these guys, carbapenems, they weaken the bacterial wall and they block peptidoglycan cross-linking. This allows aminoglycosides to just come on in. But first you have to destroy that peptidoglycan cross-linking. And so you do that with the carbapenems and penicillins. Cephalosporins are less effective against enterococcus. Macrolides are 50S inhibitors, different mechanism. Fluoroquinolones target the DNA gyrase. No synergy there. Glycopeptides block the synthesis. So the core concept here is the synergistic killing of bacteria through penicillins. Because we got to break down that wall, kill the bacteria more effectively. And aminoglycosides will then enter more easily if you give them with a penicillin. Carbapenem, they bind the 30S ribosome and it blocks the protein synthesis by causing mRNA misreading. That's the mechanism. And so bacteria, they're weakened and they can't make proteins. And so essentially they're just little dead bugs. And so we have to use this before Enterococcus, Listeria, and Streptococcus species. And sometimes they're paired as like ampicillin and gentamicin is a classic combo. Are you amped up because he's a gentle guy? Well, the ampicillin helps you break in and then the gentle guy sneaks in and does his thing. It's also used in endocarditis and neonatal sepsis. So it's a big farm question, but macrolides is 50S and the penicillins. All right, the next question, we have a 9-year-old boy brought to the clinic for evaluation of behavioral concerns. His teacher reports increased difficulty with concentration, repetitive hand flapping, and social withdrawal. His parents mention that his uncle on his mother's side has similar history. And he has an elongated, narrow face, large protruding ears, and large testes for his age. Okay, that should tell us. Okay, and then they even gave us CGG. They did not have to do that. That was super nice. They're just being so nice today. Which of the following best describes? The answer is genetic silencing due to repeat expansion. And we know this as Fragile X. GG stands for giant gonad. It's a repeat expansion disorder. I made videos on this before. The gene that's affected here is FMR1 in the trinucleotide repeat, CGG. It's X-linked dominant and is actually associated with autism spectrum disorder as well. All right, in our next question, we have a 68-year-old man, could also be a female, hence this photo, demographic photo, presents the dermatologist for evaluation of a pigmented lesion on the left temple that has gradually expanded. History of extensive sun exposure. Examination shows a 2-centimeter asymmetric flat macule with irregular borders. Biopsy shows nests of single atypical melanocytes confined to the basal layer. No dermal invasion. This is often seen in elderly patients with chronic sun exposure. Grows slowly, but it carries malignant potential. Dysplastic nevus would have irregular borders, possibly, but it'd be in younger patients and not basal layer atypia. Superficial spreading would be faster growing than this. Actinic keratosis would be a precursor to squamous, not melanocytic. Mosaic would be the stuck-on waxy appearance. In our next question, a researcher is evaluating the occurrence of new cases of type 1 diabetes in children under the age of 10 across pediatric practices. Which of the following best measures this data? All right, so really the only hard ones on this question are the incidence and the prevalence. And here what we're looking for is the keyword is new cases in a defined period of time. New cases is the incidence, whereas the prevalence is the total burden at one time, not the new cases. Okay, so here's our little kiddo wanting to do his little test for diabetes. If he is found in that year, you're tracking the new cases, it'll be added to the prevalence. But kids who did not already have the disease are included there. All right, everybody, if you found this helpful, then please consider liking and subscribing. Please let me know how I can improve these videos. I plan on doing 190 more. We'll see you guys in the next one. Hi, everybody. Welcome back. 10 high-yield questions for step 1. Here we have a 29-year-old woman, as you can see in this patient demographic photo, presenting for evaluation of her newly diagnosed hypertension. She's got persistent blood pressure of 170/100. Wow. Over the last couple of months, she denies smoking. Examination reveals a soft bruit in the right periumbilical area. Labs show normal creatinine and electrolytes. Renal duplex ultrasound shows decreased perfusion of the right kidney with preserved to the left. She starts on lisinopril, an ACE inhibitor. 2 days later, now her creatinine rises from 0.9 to 2.1. What best explains the mechanism for decreased renal function? The answer is, why don't you take a second, try to figure out the answer, and then we'll talk about what this patient has, and then we'll choose the answer together. All right, here is your juxtaglomerular cells are right here, and you have an afferent and an efferent artery. So we have decreased perfusion there, and that stimulates renin, causing angiotensin to then constrict the efferent arteriole to maintain the GFR. And so ACE inhibitors block that angiotensin II, and so the efferent dilation occurs and it drops the pressure. So you get an acute fall in the GFR, especially in already hypoperfused kidneys. And we have an abdominal bruit in a young woman, so we should be thinking of fibromuscular dysplasia. And this is when the medium-sized arteries in a woman will grow a little bit bigger. And there's a sudden rise in creatinine after starting an ACE inhibitor, and there's asymmetric renal size. There is a decreased GFR with preserved renal blood flow. And so our correct answer is the dilation of the efferent arterioles, reducing glomerular filtration pressure, because angiotensin II can no longer accumulate, so our correct answer is C. Okay, now here is our explanation. They actually go and give us the diagnosis of fibromuscular dysplasia, nice of them, which causes right renal artery stenosis. And the GFR was being maintained by angiotensin II, the squeezing of that efferent arterial constriction. An ACE inhibitor blocks that, and so you get a drop in the intraglomerular pressure. And that's why the GFR falls. So there are some trap answers, but basically what you need to know is that in renal artery stenosis, the affected artery receives less perfusion pressure. And as a compensatory mechanism, renin will be secreted. They're like, oh my gosh, look at that low perfusion. We got to do something about it. Let's activate this RAS pathway. Now renin will go to the scene, and that will eventually lead to increased angiotensin II. And angiotensin II constricts the efferent arteriole, and that will help to maintain the glomerular filtration pressure despite the low renal perfusion pressure. But whenever you give somebody an ACE inhibitor, you're blocking that angiotensin II, and so the efferent arterioles don't have a chance to be constricted. In fact, they're going to dilate, and that result is the reduced glomerular hydrostatic pressure, which leads to a reduced GFR. And this can be really problematic whenever one kidney is affected and then the other one is compensated and blocking angiotensin II and reducing that filtration in the compromised kidney. And so really the way to think about this disease is focus on renal blood flow regulation, the afferent and the efferent arterial tone. And then the drug side effects of ACE inhibitors could also be questioned sometimes. Typically, you think of like increased creatinine, hyperkalemia, that kind of stuff. And then renal artery stenosis pathophysiology is important for this question. All right, so the kidney is trying to push the blood through the narrow, if you think about like a narrow hose, by clamping that exit pipe, right? So think of it like a hose, and it's trying to constrict by clamping down right here at the efferent. And the ACE inhibitor is going to be like, hey, no worries. Let me just take off this clamp. And now you can be free. You can dilate again. And then the pressure will fall. And if the pressure falls, then the kidney is like, dude, I don't have any pressure. You got to squeeze that thing harder so you can get through and filter. And so the GFR is falling as well. Okay, so that is why our answer is C for this question, the dilation. It's not decreased blood volume due to aldosterone suppression. It's not the cause of the acute GFR falling. Vasoconstriction of afferent, that's opposite. They do not cause afferent constriction. Immune complex deposition would be post-strep glomerulonephritis and hepatitis, and direct toxin effect on ACE inhibitor on renal tubule cells. ACE inhibitors are not directly nephrotoxic. All right, hopefully that made sense. We'll go on to our next question now. All right, so in this question, we have a 17-year-old male athlete. You can see him here, presenting with episodes of shortness of breath and dry cough that occur during running, but resolved after 10 minutes of rest. He denies chest pain or symptoms at rest, and his physical exam is unremarkable. On his baseline, spirometry is normal. He has a history of mild seasonal allergies. Which of the following is the most appropriate initial management of his condition? All right, they could present this all sorts of ways. You essentially have a young athlete. They could say he's like a collegiate swimmer playing sports, but they start to get progressive shortness of breath during the practice sessions, especially after like 10 to 15 minutes of really hard sprinting or swimming. They have chest tightness and persistent dry coughs that resolve after rest. And you should be thinking of, in this condition, an increased airway resistance that's due to exercise-induced bronchospasm. And this is exercise-induced asthma, which is commonly seen in swimmers, runners, basketball players, typically young athletes. And so the answer is a short-acting beta agonist prior to exercise. Because during exercise, rapid breathing through the mouth allows the cold, dry air to enter into the lungs. And that causes evaporative water loss from the airway epithelium. Okay, so the airway epithelium right here has some water loss, which leads to mast cell degranulation and the release of histamine. And the histamine and leukotrienes, which are being triggered by those mast cells. So here's our histamine, and here's our leukotrienes, triggered by the mast cells. They're going to trigger bronchospasm. So now you have bronchospasm. Again, it's the evaporative water loss because of that cold air coming after you're exercising, triggers the mast cells to degranulate, causing the histamine and the leukotriene. And so you get reversible airway narrowing, especially 10 to 15 minutes or shortly after the exercise. And what's important about this question, if you remember, is it said that there was normal spirometry at rest post-exercise. They might say something about maybe there's like some sort of, maybe they'll say like a greater than 10% decrease in FEV1. That'll confirm that it's exercise-induced bronchospasm. And so you just give them a SABA, a short-acting beta-2 agonist. And what's an example of that, for instance, would be albuterol. Open up those lungs, right? And you do it about 10, 15 minutes before exercise. Actually, probably like 15 minutes would be better. And if you're looking for other options, and this might be a little bit more helpful for step 2 studying, you could also consider montelukast. And the reason why that's a leukotriene receptor antagonist, and it's a non-stimulant option, and it's useful for people who don't tolerate albuterol very well. Also, you could try inhaled corticosteroids for those with concurrent persistent asthma. And so our answer is indeed C. Here is the explanation that we kind of went over. The short acting would be given about 15 minutes before exercise to prevent that constriction. Some trap answers: daily inhaled corticosteroids would be for persistent asthma, but this is exercise-induced bronchospasms, so kind of different mechanism there. Chest CT for pulmonary embolism that would cause dyspnea, not linked to exertion. Cardiac stress testing, there's no cardiovascular flags here. Inhaled cromolyn sodium after exercise. Cromolyn is preventative, not a treatment for post-symptoms. 90% of patients with asthma have this problem when it's induced by exercise. Whenever they run, jump, or swim, they feel fine at rest because of that bronchoconstriction that is exercise-induced. That rapid breathing causes the cooling and drying of the airway, which triggers inflammatory mediators like histamines and leukotrienes that cause bronchos. So you get wheezing, shortness of breath only during exercise. Coach, I can't breathe when I sprint, but I'm fine later. That is exercise-induced. Transient, you treat it with beta-2 agonists like albuterol before workouts. Cool beans. Okay, for our next question, we have a 30-year-old woman evaluated for persistent right-sided chest pain. Could also be a male, hence our demographic photo, but I'm going to change it to a female now, as you can see there. So there is our female, persistent right-sided chest pain, dyspnea. She recently returned from a 10-hour flight. Her father had a pulmonary embolism. Okay, so you can kind of tell what they're getting us at. A DVT, a hypercoagulable workout reveals isolated protein C deficiency. Wow, okay, what does that mean? Well, this is going to be a memorization question of the coagulation cascade. I have a video on that on the channel if you want to check that out. I'll be making another one soon, because I feel like I could have improved it. But which of the following is unregulated in this patient? And the answer is factor 5 and factor 8. And again, this is kind of memorization heavy. But what's happening here is that we have protein C, and it's a natural anticoagulant that degrades factors 5A and 8A. Okay, that's what the factor C does. Those cofactors are super important in amplifying the thrombin generation. Okay, so basically what happens is our protein C is over here like chilling, and it degrades these guys right here, so you cannot make the thrombin. And without the inhibition of protein C, you get a hypercoagulable state. Factor 9 and factor 11 are intrinsic pathway not regulated by protein C, and 7 and 10 are, well, 7 is part of the extrinsic. Neither is inhibited by protein C. You just kind of have to memorize that it's 5 and 8A. 2 and 7, so 2 is actually prothrombin, and 7 is essential for clotting, but it's again not degraded. Again, memorization problem. Factor 7 initiates the intrinsic cascade, but has no direct role in thrombosis. And so basically people with protein C deficiency can develop life-threatening clots whenever they're sitting at a long flight. And I've heard it said that it's 2 hours is typically what you should be thinking of for that clot formation. So definitely be sure to stand up whenever your Apple Watch tells you to, because they know what's up. And protein C is a brake for the clotting cascade. It's activated and it shuts down factors 5 and 8A, which amplify thrombin. And if protein C is deficient, then the cofactors are going to keep going, and that leads to a bunch of clots. Okay, so that is the mechanism. It's a young patient, as you can see here in our patient demographic. They're not old. You wouldn't think that it's super thromboembolic, and that's why you should think of a protein C deficiency. Also, protein C has a short half-life. Starting warfarin can worsen the clotting at first and cause skin necrosis as well. All right, you can see this in a couple of ways. I'm going to go ahead and shrink down our patient here so we can break this down really thoroughly. You can see my cartoon drawing, but they could also say, hey, we have like a 24-year-old woman. She's got some dyspnea and right-sided pleuritic chest pain. She has no past medical history, and she's been using some stuff, her oral contraceptive pills, and she recently underwent some sort of a surgery for ovarian cysts, and she has been pretty sedentary in the last couple of days. All right, so she's just resting after a surgery. That's another way that they could show it to you. And they could give you other certain labs that you should be able to recognize as well. And the labs I'd look out for would be like normal INR, relatively normal APTT, but then you have the protein C is low, and then the protein S and the antithrombin 3 are normal. And they could ask something like, hey, a deficiency in that protein C directly leads to a decrease in activation of which of the following coagulation factors? And then the answer would be 5. Okay, so C goes with 5 on this test. You just got to know it, got to memorize it, because protein C is a vitamin K dependent glycoprotein that's synthesized in the liver. And once it's activated by thrombin bound to thrombomodulin in an endothelial cell, you get activated protein C. All right, so vitamin K is needed for vitamin C, and it then inactivates factor 5A and 8A, which are, of course, the cofactors in the coagulation cascade that amplify the thrombin generation. So if we have some sort of a protein C deficiency, then that means that factor 5 and 8A are not adequately inhibited. And so they're going to have excess thrombin formation creation and promote the clot formation. And also we already had some problems with hypercoagulability in this question stem, but she's going to be at risk of a venous thromboembolism. And the inheritance pattern of this deficiency is actually autosomal dominant. And so it could present with a DVT, pulmonary embolism, or warfarin-induced skin necrosis. And that will happen if you're anticoagulated without heparin bridge. So watch out for like long flights, oral contraceptive use, and also surgery. Those things will all increase the risk of clotting. And I wanted to talk really briefly about warfarin as well, because I know that warfarin kind of heparin bridge thing can be a little bit confusing at times. So just to kind of round this question out, we should talk about what warfarin-induced skin necrosis is. Well, it usually happens about 3 to 5 days after you start warfarin, especially if you have some sort of an underlying protein C deficiency, because the mechanism here is warfarin inhibits vitamin K, epoxide reductase. That's its mechanism. The vitamin K-dependent clotting factors, well, they are 2, 7, 9, and 10. But protein C has a much shorter half-life. The half-life of protein C is something like 8 hours. And so you'll get like a super rapid drop in the protein C activity before the anticoagulant effects of warfarin fully kick in. And so that'll lead to a very pro-coagulant state early in the therapy. And so patients with inherited protein C deficiency can have this transient drop that can cause widespread microthrombi in the dermal vessels and also skin necrosis. So that clotting will happen. Clot. Because of that short half-life of C. Clot. So that C will be stopped until you have increased clotting, causing the skin necrosis, because warfarin is a vitamin K inhibitor because it inhibits the epoxide reductase, which will decrease the activation of vitamin K. All right, hopefully that makes sense. I think it's an important mechanism to know. Don't want to get too much into the weeds, but the feedback you guys have given me is that you kind of like that level of detail, so I'll continue doing that. Please let me know how I can improve. On to the next question. All right, for this next question, we have a 25-year-old man presenting to a fertility clinic after 18 months of unsuccessful attempts to conceive with his partner. Physical exam shows normal secondary sex characteristics, and the serum LH and testosterone are within normal limits, but FSH is on the low end. Semen analysis reveals oligospermia. Testicular biopsy shows intact Leydig cells and impaired maturation of the germ cells in the seminiferous tubules. Which of the following mechanisms most likely explains this low intraluminal testosterone concentration? This is a pretty direct way of asking this question. I think it's important to go over some of the physiology, so I'm going to shrink this 25-year-old male over here to the side, and we'll talk about some of these notes that I took beforehand. Sertoli cells. Those guys actually line up the seminiferous tubules. They're all over, and they perform essential functions for spermatogenesis. And so actually under the stimulation of FSH, which I've written out here, the Sertoli cells actually will produce what's called androgen-binding protein, ABP. And you're also going to secrete inhibin B and also the anti-Müllerian hormone. And so the function of androgen-binding protein is that androgen-binding protein actually goes out and it binds testosterone inside of the lumen of the seminiferous tubule. And also the LH pathways. These guys are both intact, so check, because of normal testosterone. And normal FSH and inhibin suggest that the Sertoli cells are also intact. So based on these labs of inhibin being normal and Leydig and testosterone being normal, we know that a lot of things are operational. And there's a low sperm count. What's probably happening is this defective testosterone concentration in the tubule. And so that's actually a defect right here, ABP defect, is what's going on in this question. And so our answer is going to be decreased Sertoli cell production of androgen-binding protein. Okay, hopefully that made sense. I think it's kind of really cool to know those mechanisms. Let's see why the other answers are incorrect. So yes, indeed, testosterone is produced, but you can't concentrate it where it's needed inside of the seminiferous because of that ABP absence from the Sertoli cells. It's not impaired LH-mediated steroidogenesis because that would be low testosterone. It's not reduced Sertoli cell secretion of inhibition because inhibin suppresses FSH. And it's not excess aromatization because that'd be gynecomastia and a low testosterone. But we already established that the testosterone levels are normal. And so what's really interesting is that even if your testosterone levels are normal, you can still be infertile. And the reason why is the testosterone needs to be concentrated inside of the seminiferous tubules. And that's done by androgen-binding protein made by Sertoli cells stimulated by FSH, not LH. LH is the testosterone. But we have a painful ulcer on the inner lip that began 4 days ago. So there I've updated the photo. And he reports similar episodes several times a year since his early teens. He denies fever, weight loss, or recent travel, and he notes that eating citrus fruits and hot sauce worsens the pain. He underwent a routine dental cleaning a week ago. On examination, there's a 0.5 centimeter shallow round ulcer coming with a yellow-gray base and surrounding erythema on the buccal mucosa. There are no vesicles, and the rest of the oral mucosa is normal. Which of the following is the diagnosis? Well, we have painful ulcers, and it starts out as just a little red papule. It's on the inner lips and the tongue, and it progresses to a shallow, round ulcer with gray-white pseudomembrane, and it's triggered by stress and sleep deprivation and acidic foods. They could say you've got like 5 millimeter, just basically like a shallow ulcer of some sorts, and they're going to ask you, hey, what's the diagnosis here? And it's going to be aphthous stomatitis, and the condition itself is called RAS. It's reoccurring aphthous stomatitis, and you get the painful, shallow, round or the oval ulcers, and they're covered with fibrinous exudate, so it's gray or white pseudomembrane. And it's surrounded by erythematous halo. So that kind of red-looking circle-y thing around it. It's kind of gross. I just got the chills. Happens all the time to me. I literally have the chills just talking about this. But it occurs in non-keratinized oral mucosa. So usually it's the labial mucosa or the buccal mucosa or like the ventral tongue will have it too. And the hard palate. And the trigger here is mechanical trauma. So typically they'll mention something about the dentist. I was in a play where I was Audrey too. But anyways, this reminds me anytime I talk about dentists, about that musical, Little Shop of Horrors. I digress. But yeah, so stress, sleep deprivation, menstruation, all those stressful things, spicy acidic foods. And sometimes it's just like idiopathic, right? And when it's idiopathic, it's usually going to come in conjunction with a celiac disease or Crohn's disease or irritable bowel disease, maybe HIV. And the good thing is this is self-limiting. And so you just give some topical corticosteroids and anesthetics as well for pain. And you can really prevent this if you just have good oral hygiene. And so here are some answers. Let's figure out why it is indeed B. Well, it's recurrent aphthous stomatitis. We got that. A would be herpes simplex. So it's group vesicles, usually on keratinized tissue. Oral candidiasis has the white plaques that can be scraped off. They can be, if it's oral candidiasis, you can get them scraped off. Erythema multiforme would be on lesions of the skin. It's kind of a different area. And usually they have a systemic illness as well, so HSV. And then oral lichen planus would have that lacy white striae, and chronicity not. acute painful ulcers. And this actually occurs in about, oh my goodness, the guy was taking up the whole screen. You didn't get to see my celiac and Crohn's. I gotta do a better job of that. But a lot of the population experiences this painful mouth ulcers at some point. Spicy, no vesicles. And by the way, why is it no vesicles? Like, why do they feel the need to really single that out? Well, that would rule out herpes. Yeah, cool. But recurrent aphthous stomatitis is going to be non-infectious. And it's also immune mediated. And so it does not involve viral cytolysis or epidermal dermal separation. And those are the mechanisms that create the vesicles. It's the cytolysis and epidermal dermal separation. That's what causes it. It's that separation, cytolysis, separation. That causes the vesicle. You don't have that epidermal dermal separation, you're not going to get vesicles. And there's no lacy striae, so it's not lichen planus. And it's recurrent after you go to the dentist or have that acidic food. Nice. All right, for our next question, we have a 17-year-old snowboarder falling on the outstretched hand. This is a fouche injury. Obviously, this could be male or female. And so you have your female here. He or she has swelling over the radial wrist and marked tenderness within the anatomical snuff box. If you go like this with your hand, you can kind of see there's like a snuff box thing that forms. You can infer why they call it a snuff box. Neurovascular exam is normal. Wrist radiographs are obtained 45 minutes afterwards. There's no fracture or dislocation. What's the best next step? Now, this is more of like a step 2 question that I'm throwing in here, but we want to immobilize and repeat radiographs in 10 to 14 days. Why? Because there's a clinical suspicion for scaphoid, some sort of a scaphoid fracture. And for that, you have to immobilize the thumb. And the reason is because those early x-rays will miss those displaced fractures. And because there's retrograde blood supply in the scaphoid, it makes the proximal pole very vulnerable to AVN. So you repeat it a little bit later after you've kept it stable for some time. All right, so before we kind of break down and talk in detail about the scaphoid, I want to also talk about some high yield facts with the other bones in the hand. Some lovers, the lunate, would cause a high risk of carpal tunnel syndrome. The pisiform is often just mistaken for some sort of like a fragment or just some sort of a fracture fragment. And we talked about a little bit of the scaphoid, but that has a risk of avascular necrosis of the proximal fragment. So avascular necrosis is what I'd think for the trapezium is likely to compress the radial artery in the snuff box. So maybe think of the radial artery with the hamate is going to be associated with the ulnar nerve compressions of Guillen's canal, and the capitate would have the central carpal instability with a paralunate dislocation. And this is called fouche, right? The falling on the outstretched hand. Have you ever seen that happen? It looks horrible, but you have like a wrist extension and a radial deviation. And that would be some tenderness of the anatomical snuff box. You have minimal swelling. And so you can actually miss this on the initial x-ray. And the reason why is because it's like a non-displaced fracture. So you don't see that displacement. And the borders of the anatomical snuff box are interesting, and the abductor pollicis longus, and the floor is the scaphoid and the trapezium. And so let's talk about why the scaphoid fractures matter. So the blood supply is distal to proximal. And so a fracture through the waist of the scaphoid would disrupt the proximal fragments and lead to avascular necrosis. And so you should definitely do a repeat imaging about a week later if there's a high suspicion for that sort of non-displacing fracture. All right, so early ROM, you do not want to have motion because you can displace it, so bad. Carpal tunnel release would be median nerve compression. Immediate ORIF. ORIF means open, reduction, and internal fixation. And I don't want to get too much into that, but it's basically saying we're going to surgically expose the fracture and realign the bone fragments, kind of like in Harry Potter, how they like, boom, do a spell fix it. And internal fixation is stabilization of the bone, and typically use some hardware for that, like screws or plates or rods, something like that, to like really make sure that it's fixed internally. And so that's only indicated if you have some sort of like displaced fracture where you have like misaligned bones that aren't going to heal unless you fix them, at risk of collapsing or shifting, or the joint surface is disrupted, or there's like literally just bone peeking through the skin. Like that's the situation in which you do ORIF. And NSAID only would not protect the scaphoid or prevent necrosis. Scaphoid necrosis. Just think of that and you'll be fine. And what's crazy is, about 33% of these are going to be hidden on the first x-ray. And so you got to immobilize it and then you repeat so you don't get that problem whenever you have the fouche. She's got the fouche. I love that word, fouche. All right, next we have a 71-year-old woman, but it could be a man as well, hence this demographic photo, so you don't get all cut up in the demographic here, but she or he reports no fever, no changes in bowel habits, and no blood in the stool. A recent colonoscopy performed for routine colorectal cancer screening revealed multiple mucosal pouchings, so diverticulitis, and biopsy is showing mucosa and submucosa protruding through the muscular area. Which portion of the colon is most likely involved in this condition? All right, a little bit of factoid. This question's all about factoids, but the things to look out for whenever they're asking about this particular condition, I'll shrink down this dude here, would be they'll probably say there's some sort of painless rectal bleeds, but there's like some bright red blood, Maybe there'll be a history of constipation, coronary artery disease, or hypertension. And what gives this away is going to be also outpouchings of the colonic clustered in the posterior. Where is it going to be? It is going to be this sigmoid colon. All right, so a couple of things to note. There's this thing that you probably have heard of called a true diverticula. And true would be rare and congenital, like in Meekel's diverticulum in the ileum. It would be a full thickness would be a true diverticulum, which is not typical in the colon. It's not going to be like NSAIDs. NSAIDs would cause colitis or ulcers, but this is a more diverticular bleeding problem. So the answer is the sigmoid colon, and this is diverticulosis affecting the sigmoid colon because of why? It's small diameter, really small. And that causes the higher pressure, and it's going to be a false diverticula because it only involves these two layers. The other ones just are not readily involved. The ascending can be involved, but it's less common than the sigmoid. So 50% of people over 60 have colonic diverticulum. Super duper common. You get the outpouching caused by the pressure, especially the sigmoid, because it's super small. All right, next we have a 65-year-old man, could be a woman as well, hence this demographic photo. Altered mental status and fever. Loved one reports complaining of right flanked pain and dysuria for 2 days. We got a fever, 112 heart rate, BP is low, tachypneic, respiratory rate is 28, costovertebral angle tenderness, and warm extremities. Okay, so we got some form of shock here, right? And we have an infection, and so we should automatically be thinking of something like sepsis. And sepsis is a dysregulated host response to an infection that leads to life-threatening organ dysfunction. Hypotension and septic shock, it's not due to some heart problem either. It's caused by inflammatory mediators like systemic vasodilation and also capillary leaks and misdistribution of the blood flow. That's the problem. And so it's going to involve nitric oxide mediated vasodilation. And so the answer to this question is D, nitric oxide, excessive vasodilation by the inducible nitric oxide. And so what's happening is the bacterial endotoxins, and so here you should think of like lipopolysaccharide in the gram negatives. For instance, E. coli is a gram negative. That stimulates macrophages, and the macrophages are going to release TNF alpha. You've heard this little triad IL-1 and IL-6, and these activate the inducible nitric oxide synthase, right? INOS. If you ever played Need for Speed, nitric oxide. Nitrous oxide, wow. But yeah, nitric oxide causes profound vasodilation. We're just dilating like crazy up in here. So you get vasodilation because of this, because of that. All right, so that's the chain that you should be thinking about for sepsis. My goodness, you can't see because this woman is in the way. Let's move her out of the way. All right, so there we go. The answer is D. This person has septic shock. We knew that because of the E. coli, this urinary tract infection. Septic shock, decreased cardiac contractility would cause cold extremities. Hypovolemia is seen in hemorrhagic or dehydration-related shock. It's a different mechanism. Here we have the pathogens causing this, the vasodilation, the lipopolysaccharide, all the stuff that I mentioned before, the vasodilation. Increased vascular permeability, that does happen, but it's not the primary cause. And then immune complex vasculitis would be a different presentation, glomerulonephritis and the rash. And this kills like crazy. It kills tons of people, more than breast cancer and AIDS combined. And so the body is the problem here. It's like, yeah, it's bad that you're being infected, but the infection only causes the host to just be like, oh my gosh, I'm freaking out. Time to vasodilate like crazy and just lose all control of my body and just freaking die. That's what our body does. It's not smart. And it relaxes the blood vessels, and so you have wide open vessels and the plummeting blood pressure, and your bloods are not getting enough oxygen. That's how my friend would say it when I did workouts in high school basketball. He'd say, I need some oxygen, coach, oxygen. Yeah, they're not getting enough oxygen. And so it's because of that dilation that occurs, and the dilation only occurs because of this TNF alpha, interleukin 1 and 6. Cool? Cool. Too cool for school. But I'm also going to show you the photo of the female because it is not specific to the sex. Presents with difficulty rising from the chair and progressive fatigue for 2 months. He reports occasional dry cough and unintentional weight loss at that time, about 24 pounds. Anytime we see weight loss, what are we thinking? Cancer. It may be cancer. Neurologic exam reveals decreased proximal muscle strength. I'm going to go ahead and change it to a man, though, so you can kind of visualize this patient. There he is. Decreased proximal muscle strength that improves after repeated exertion. MRI of the brain reveals 2 contrast-enhancing masses in the parietal lobe with surrounding vasogenic edema. Biopsy shows small hyperchromatic cells with minimal cytoplasm, positive for synaptophysin and chromogranin. What does that mean? All right, so we should know that this is small cell carcinoma of the lung. This is probably going to be like a cerebral metastasis from the small cell lung carcinoma. And you might be asking, how do you know that it's small cell lung cancer? Well, we have a triad here. We have proximal muscle weakness with facilitation. See? Look at that proximal muscle weakness. What is that telling us? Probably Lambert-Eaton syndrome, right? Lambert-Eaton myasthenic syndrome. We also have, I mentioned it was a triad. The second thing is neuroendocrine tumor markers, chromogranin, synaptophysin, cytokeratin. I'll say it again. Chromogranin, synaptophysin, keratin. Neuroendocrine tumor markers are going to indicate that it's probably going to be small cell lung cancer of the lung. And also there's probably going to be a smoking history, but we didn't want to make it way too easy for you. So we know he's got some sort of a cancer. And they might even describe the cells on histology. I've seen that happen before, where they'll have like the small round blue cells with scant cytoplasm, and of course that positive stain. Sometimes they have neuron-specific enolase and cytokeratin, but we have a neuroendocrine tumor, which originates from the Kolchitsky cells. And the risk factor that's really strong here is smoking. This is a paraneoplastic syndrome. So for those, you should be thinking of SIADH. I'm going to move my guy who looks kind of sad over here. Cheer up, my guy. SIADH, also ACTH, paraneoplastic syndromes, and of course, so the ACTH would be kind of like Cushing syndrome, Lambert-Eaton myasthenic syndrome as well, the cerebellic degeneration. And so you have metastasis, and it's early, often to the brain, the liver, the bone, and the adrenal glands. And so in Lambert-Eaton's, you have antibodies against the presynaptic PQ voltage gated calcium channels, and so you have decreased acetylcholine release. Right, so the acetylcholine release is not as strong, and this often precedes a diagnosis of some sort of an underlying malignancy, particularly squamous cell lung carcinoma or small cell lung carcinoma. Strap answers: renal cell would be hematuria and flank pain. It can metastasize, but it's not associated with Lambert-Eaton. Primary CNS lymphoma is seen in immunocompromised patients. Glioblastoma multiforme is ring enhancing, probably in kids. Primary CNS not associated with systemic weight loss. Medulloblastoma is a pediatric tumor that's not seen in adults. All right, medulloblastoma, that's a pediatric tumor not seen in adults, but have small blue cells, but not Lambert-Eaton. Okay, in our next question, we have a 20-year-old woman, could also be a man, hence her demographic photo. I'm going to go ahead and change it to a female because in this question, she's delivering a premature infant at 30 weeks gestation. A newborn develops respiratory distress within minutes of birth, requiring oxygen supplementation. Surfactant deficiency is suspected. Which of the following structures is most directly affected due to the abnormal differentiation of the same germ layer as type 2 pneumocytes? Okay, so we need type 2, and we're talking about some differentiation. So thank you to our relevant demographic photo. We'll move you over to the side here. Okay, the same one. The answer is the ciliated tracheal epithelium. And the reason why is the ciliated tracheal epithelium, like the alveolar pneumocytes, is derived from the endoderm. So this is really just an embryology question. And structures like smooth muscle, cartilage, pleura, and vascular would originate from the mesoderm. So endoderm, mesoderm. So let's talk about this real quick. The epithelial lining of the trachea, the bronchi, and the alveoli all arise from the endoderm. And it's the endoderm of the embryonic foregut. And type 2 pneumocytes, which are responsible for surfactant production, are also going to be derived from the endoderm. Surfactant is made up of dipalmethyl-phosphatidylcholine, which is a fun word to say, DPPC, and it's a phospholipid that reduces the alveolar surface tension. And that's what prevents the collapse, which is known as atelectasis, on exhalation. And surfactant production typically begins around 20 weeks and it becomes adequate by 34 weeks in gestation. All right, so now the visceral pleura, that's mesoderm derived. Filler macrophages would be mesoderm as well. Pulmonary capillary endothelium is mesodermal. And cartilage plates in the bronchi is mesoderm as well. So you need surfactant. It's secreted by type 2 as a way to keep the alveoli open, and it's from the endoderm because it forms the entire epithelial lining of the respiratory tract, the trachea all the way down to the alveoli. If something goes wrong, now you don't have surfactant, and now you got a problem with your type 2 pneumocyte. The answer is ciliated tracheal epithelium because it's also built from the endoderm. Smooth muscle, cartilage, and vasculature, that's mesoderm. All right. Hopefully you guys found this helpful. If it was, please consider liking and subscribing. These videos take a long time to make. We'll see you guys in the next one. Hello everybody, welcome to Ivy Tutoring. I'm about to give you 10 extremely high yield questions with full breakdown to help you pass step 1. There's just one condition. And that is if you found this helpful, then you gotta like and subscribe, and if not, then just let me know in the comments how I can improve. These videos take dozens of hours to make, and I'm doing it because I wish that I had this material when I was in your shoes. So let's begin. Our first question involves a 3-day-old female infant brought to the pediatrician by her parents due to feeding difficulties. So up here I wrote, you can't pass the tube, which you can see right here, and that's extremely important. That alone should key you into the answer, but also this feeding thing is important too. So I want to explain every single malformation or anatomical variation which would cause this problem. That way on test day, you can think of these for your differential diagnoses. So first is obviously trichoesophageal fistula with esophageal atresia. And this normally involves the frothy secretions, choking, coughing, and cyanosis, the 3 Cs. Choking, coughing, cyanosis during feeds, and the nasogastric tube will coil and you have air in the stomach. And the key feature is the failure of the foregut positioning. The next condition on your differential diagnosis should be esophageal webbing or ring, and that would be dysphagia to solids and often in an older child. And this is congenital. Again, I'm telling you everything on your differential diagnosis for feeding, because whenever you see there's problems with feeding, you should think of these things. Next is pyloric stenosis. This presents with non-bilious projectile vomiting, goes all the way across the room. I've seen a practice question where they say that it hit the wall, and you have olive-shaped mass, and they're usually hungry after the vomiting. And this usually presents around 2 to 8 weeks, and it's hypochloremic metabolic alkalosis associated. You should also think of duodenal atresia, that's bilious vomiting. Next, you can think of the annular pancreas. Annular just means ring-shaped. And this is where you have the pancreatic tissue that encircles the duodenum, and that can cause a duodenal obstruction and vomiting. And the last one that's associated with feeding is Zenker's. These are just the most high-yield differential things. So Zenker's diverticulum, which is rare in infants. This would present with cough, halitosis, regurgitation, and usually it's an older age outpouching of the esophageal mucosa. So those are some differential diagnoses. So that's what we're thinking when we deal with our feeding difficulties. We have our list right here. And she was born at 38 weeks gestation via uncomplicated vaginal delivery. Her mom says the infant has cyanotic episodes during feedings and often appears to choke and cough. There's also that frothy oral secretion. And we have a healthy appearing infant and no distress. However, when she attempts to feed with a bottle, she gets the coughing and cyanosis again. NG tube is inserted, resistance is felt and can't be advanced. An X-ray is performed and shows a distended stomach with air-filled abdomen. Which of the following events most likely explains this? All right, now I'll show you the answer is indeed the incorrect partitioning of the foregut. This is classic presentation of the tracheoesophageal fistula with esophageal atresia. And this is actually the most common congenital abnormality of the esophagus. And the way that you should think about this question is you have a newborn who looks totally fine until the feeding starts. And then suddenly she's coughing, she's turning blue, she's spitting stuff out. And when you try to pass that nasogastric tube, oh no, it coils up in the upper esophageal pouch. And then the X-ray hits you with another clue. There's air in the stomach. Why is there air in the stomach? Well, there's a fistula. And a fistula is this abnormal or a surgically made passage between a hollow or tubular organ and a body surface, or between two hollow tubular organs. So there's a little tunnel between the trachea and the lower esophagus. And so air from the lungs is inflating the gut. And so all of this points to the embryologic misstep. It's the failure to correctly partition the foregut into the trachea and the esophagus. And so our answer is the incorrect partitioning of the foregut. Now it's good to know why the other ones are wrong. Incomplete recanalization, that would be duodenal atresia, bilious vomiting, and that would have a double bubble sign, not coughing and choking, and no end coiling. Abnormal rotation would have volvulus and bowel ischemia, so you'd have abdominal distension, not respiratory distress or the blockage. Malformation of the pharyngeal arches would have thymus, thyroid, and ear and facial abnormalities, and failure esophageal elongation would have a short esophagus. So the bottom line is the frothy secretions and cyanosis during feeding in newborns suggest esophageal atresia due to the incorrect partitioning of the foregut. And the foregut is the anterior part of the gut. It's toward the mouth. From the distal esophagus to the first half of the duodenum. That's the foregut. If you learned something, then like and subscribe. We got 9 more just like it coming. In this question, we have a 34-year-old woman who was hospitalized with severe respiratory distress requiring intubation and mechanical ventilation due to pneumonia induced acute respiratory failure. Her current ventilation settings include a tidal volume of 6 milliliters per kilogram and a rate of 14 breaths per minute, and the PEEP of 8 centimeters H2O. And discussing the pathophysiology of mechanical ventilation with her team, the resident asked about the typical pressure changes that occur in patients' alveolar and intrapleural pressures. Which description accurately represents the expected pressures? We have our alveolar pressure and our intrapleural pressure. Okay, so whenever we're doing mechanical ventilation, the lungs fill out with air by being pushed, not pulled. And so spontaneous breathing is different. That's where your negative intrapleural pressure draws the air in, and there's a positive pressure ventilation that forces the air into the lungs. And so this then flips the normal pressure gradient, because during inspiration, alveolar pressure rises above the atmospheric, and then at the end of expiration, the PEEP keeps the alveolar pressure elevated to prevent the collapse. And now what this question is kind of getting at is even the intrapleural pressure becomes positive, especially during inspiration. So both the alveolar and the intrapleural pressure are positive throughout the cycle. And I know that can be complicated, so just bear with me for a second. PEEP stands for the positive end expiratory pressure, and that keeps the alveolar pressure positive at the end expiration to prevent the alveolar collapse. Okay, so you should be dialing in at one of the answers, and it is indeed A. And now to just make this extremely clear, when you breathe on your own, your chest pulls in air by making pressure inside of your chest negative. It's kind of like sucking air in with a syringe. That's what happens when you breathe. But when you're on a ventilator, then it pushes air into your lungs and uses a positive pressure. And that's like blowing air into a balloon. And so the key concept here is that everything gets pushed in. The alveolar pressure, that's the pressure inside of your lungs' air sacs. On a ventilator, it's positive whenever the machine pushes the air in, and it stays slightly positive even at the end of expiration if the PEEP is on, the positive end expiratory pressure, because it prevents your lungs from collapsing. That's its whole job. And then the intrapleural pressure, that's the pressure in the space around your lungs, which is called the pleural space. And normally it's negative to keep the lungs open. But with the ventilator pushing in the air, then that becomes positive, especially during inhalation. And so in this patient, they're on a ventilator, they got a PEEP, and it said to 8 centimeters H2O. And so she's getting positive pressure both during inhalation and between breaths. thanks to the PEEP machine. All right, so all these guys are wrong because they show either 0 or negative pressures, which only happens in normal breathing, not when the machine is pushing in stuff. So everything stays positive. All right, so the bottom line is during ventilation with PEEP, alveolar pressure peaks positively while intrapleural pressure remains. All right, so positive is the answer. In this question, we have a 28-year-old man who comes to the clinic for evaluation of fatigue. He reports that he's been feeling excessively tired, especially in the afternoons. He denies any significant weight loss and changes in appetite, and he exercises regularly without any issues. He's been experiencing increasing thirst and urination. Father was diagnosed with type 2 diabetes at age 50. Physical exam shows a BMI of 23, and fasting laboratory results show blood glucose level of 110. Further testing indicates a mutation in the gene affecting glucose metabolism, leading to mild form of hyperglycemia. Which of the following enzymes is most likely affected in this patient? Okay, so we have some mild fasting hyperglycemia, and there's no obesity, no signs of insulin resistance, and there's positive family history of diabetes, and a normal BMI, and a gene mutation that maybe affects the glucose metabolism. And all this makes us think of maturity onset diabetes of the young, particularly MODY2, which involves a mutation in glucokinase gene. And so some really important kind of buzzwords for this question are the mild fasting hyperglycemia. That's stable and often asymptomatic. And he's a young, non-obese patient. That suggests that it's not type 2 diabetes. There's a family history that suggests that it's autosomal dominant maybe. And then maybe there's a gene affecting the glucose metabolism in there. We think of the enzymes that are affecting this, like glucokinase is one of them. And so in MODY2, we have a glucokinase gene that mutates and it leads to impaired insulin secretion threshold. This is autosomal dominant, and it may not require treatment unless there's like a pregnancy or some other risk factors. And this is often discovered incidentally or during pregnancy. And the pathophysiology is that we have glucokinase, which is the glucose sensor in our beta cells, and it phosphorylates glucose. So now we get glucose 6-phosphate. And so if we have a mutation, then glucokinase has a higher threshold for sensing glucose. And so the result is you have delayed insulin release, and so the blood sugar stays mildly elevated. And that leads to stable, mild hyperglycemia, and often it's non-progressive. So it's the glucose sensor that's messed up in the pancreatic beta cells. And it leads to higher glucose thresholds for insulin release, and so it's kind of stable up there. Why is it not hexokinase? That's involved here. Yeah, that's found in most tissues, but it has a low Km for glucose, and it's not the sensor for the beta cells. So that's not the answer because it doesn't match the beta cell specific sensing defect. Isocitrate dehydrogenase, that's a TCA cycle enzyme, and acetyl-CoA carboxylase, that's in fatty acid synthesis, and your PepsiK is involved in gluconeogenesis, not related to sensing glucose or insulin release. And this is important because many people think diabetes always comes down to just insulin resistance or autoimmune destruction, but sometimes the pancreas just does not notice the sugar until it's a little bit too high, and that's MODY2. That's what this dude has. So I think the hardest detractor here is hexokinase, because these are both enzymes that phosphorylate glucose to glucose 6-phosphate, which is the first step of glycolysis, but they have very different behaviors depending on where they're found. So hexokinase is located in like the brain, the muscles, the fat, tons of tissues, and it phosphorylates even very small amounts of glucose very quickly. So the Km is low, it's got a high affinity for glucose. That's what that means, the Km being low. And it works even when the glucose is low, and it's inhibited by its own product. In contrast, glucokinase is the sensor guy, right? It's found only in the liver and the pancreatic beta cells. That's super duper important. Liver, pancreatic beta cells, glucokinase. Its function is it acts as a glucose sensor and it controls the insulin release in the beta cells. And the Km is high, so it has low affinity and it only works when glucose is high. It's not inhibited by its own product. It keeps going even if the glucose is high. That's the big difference between these guys. Just wanted to kind of explain that briefly and then say that glucokinase mutation leads to mild hyperglycemia and increased thirst and urination in young patients. Wow, check this out. I think it's kind of funny that I'm on the photo like that. Okay, our next question, we have a 5-year-old boy who's brought to the clinic by his mom due to recurrent skin infections and persistent cough over the last 6 months. Medical history is significant for several hospitalizations due to severe bacterial infections, including hospitalization for pneumonia caused by Burkholderia, and he's been treated for abscesses caused by Staph A. He has mild hepatomegaly on physical examination, but no lymphadenopathy is noted. Lab tests reveal normal levels of IgG, IgA, and IgM. Neutrophil function test shows impaired respiratory burst activity. That was really nice of them. They didn't have to say that, but basically we got a kiddo here. He's got recurrent catalase positive bacteria infections, especially Burkholderia. And he's got impaired respiratory burst. And so all of that is like a dead giveaway for chronic granulomatous disease. So his immunoglobulin levels are normal, which rules out any humoral deficiencies. And CGD results from a deficiency in NADPH oxidase. And that's going to be the answer here. It's chronic granulomatous disease. All right, hyper IgE would be Job syndrome. That's going to present with eczema, retained primary teeth, and very high IgE, obviously. Hyper IgE syndrome in the name, and it's recurrent skin and lung infections. But that would have very high IgE and coarse facies, and that's not seen here. All right, what about common variable immunodeficiency? Well, that's the low IgG and IgA and recurrent simopulmonary infections. But this patient's immunoglobulin levels are normal, and that's the reason why it's not common variable. The answer is indeed C. Severe combined, that's severe infections in the infancy and failure to thrive in lymphopenia. This patient's 5 years old and he has normal IgG, and so it's not profoundly immunocompromised, and so definitely not D. Ataxia, telangiectasia, that has a triad associated with it. It's the ataxia, so cerebellar ataxia, and then the spider angiomatas, the telangiectasias, and also the low IgA. And there's no neurofinding and no telangiectasias, and so that's not the answer. So anytime you have a child with recurrent severe infections but catalase positive, that's the very important part. Catalase positive organisms like Staph aureus, Burkholderia, then the step 1 radar should be lighting up. You should be like, oh my gosh, this happened because the neutrophils can't perform the respiratory burst. And so there's a defect in NADPH oxidase, and that causes chronic disease. Usually it's X-linked. So impaired respiratory burst indicates CGD, leading to recurrent bacterial infection. In this question, we have a 12-year-old girl coming to the emergency department because of frequent urination, increased thirst, and an intentional weight loss over the past month. On physical examination, she appears mildly dehydrated, but the exam is otherwise unremarkable. Lab tests show a serum glucose level of 400. A urine analysis shows 3+ glucose and no ketones. Which of the following renal transport mechanisms most likely contributes to her findings? Okay, so we have a serum glucose of 400, and so the kidney's SGLT2 transporters in the proximal tubule are going to be overwhelmed, and so they can't reabsorb all the glucose. And so once they're saturated, the glucose appears in the urine, and it leads to osmotic diuresis, polyuria, and dehydration, and that's why glycosuria occurs in uncontrolled diabetes. So let's look at these answers. Decreased activity of the sodium, hydronium, exchanger. So that's involved in acid-base handling, not glucose stuff, and so I just would not choose that as the answer. Inhibition of sodium potassium ATPase pump. Well, that provides to the sodium gradient indirectly by powering the SGLT, but it's not going to supply the saturation itself. All right, C is our correct answer because glucose is reabsorbed in the proximal tubule via the SGLT2. D, aquaporin stuff. That's in the collecting duct stimulated by ADH. Nothing there. Dysfunction of the proximal tubule by carbonate reabsorption. That's seen in Fanconi syndrome or acidosis compensation, no link to hyperglycemia or glycosuria. All right, so really quickly, let's talk about 1 versus 2. So SGLT2 is located in the early proximal tubule, and then SGLT1 is going to be in the late proximal tubule, the S3 segment. And this guy does like 10% of it, and this guy does like 90% of the filtered glucose reabsorption. And one has a high affinity and low capacity, and this guy has a low affinity and a high capacity. And really, SGLT1s, there are no pharmacologic targets there for DM drugs, but the SGLT2 inhibitors would be like the flozins. And the 2 is only found in the kidney and the proximal tubule, and the 1 is found in the small intestine as well. All right, in this next question, we have a 7-year-old girl who was brought to the clinic by her parents due to progressive weakness and difficulty walking. On a physical examination, she has decreased deep tendon reflexes and muscle weakness in her lower extremities. Her medical history is significant for cystic fibrosis, and recent lab shows that there's low serum concentrations of fat-soluble vitamins. Which of the following processes is most likely impaired, contributing to her current condition? All right, we got a lot of answers here. But in cystic fibrosis, we have a thickened secretions that block the pancreatic enzymes like lipase. And lipase is required for fat digestion. And without proper fat digestion, the micelles can't form. And micelles are the aggregate of molecules in a colloidal solution. But basically, in simple terms, they are tiny particles that are made of substances that are soluble in water and that come together to form a little ball. And they can carry other little substances inside of them. And so they're formed in the digestive tube as a result of the interaction of water molecules, fats, and fat-soluble vitamins in the blood and in your food, and the bile salts produced by the liver. And so the bile salts emulsify, and the lipids of food increase their solubility and absorption by the intestine. And so if you don't have fat digestion, you can't form micelles. And so fat-soluble vitamins like A, D, E, and K are not absorbed. And so the child's symptoms of neuromuscular weakness and areflexia point to vitamin E deficiency, which is definitely going to be tied to the formation of your micelles. Now, why is not the absorption of the amino acids? Well, protein digestion is typically found to be normal in cystic fibrosis, and it doesn't explain the fat-soluble vitamin deficiency. Why isn't it the formation of the chylomicrons? Well, the chylomicrons package fats after reabsorption, and this issue is before the absorption, so it can't be chylomicrons. Sodium-dependent is used for glucose, amino acids, not fat-soluble stuff, and the synthesis of ceramide. Well, ceramide is part of the sphingolipid metabolism, and the sphingolipids are just those compounds which are fatty acid derivatives of sphingosides, and they occur chiefly in the cell membrane of the brain and the nervous tissue. They're not involved in the fat-soluble vitamin absorption. So the most important stuff here, this is the pathophysiology if you want to read that, but this guy's got cystic fibrosis and some progressive weakness, and it makes you think of a fat-soluble vitamin deficiency, especially vitamin E, because of those symptoms that are neurological in nature. And the reason you can't absorb the fat-soluble vitamins is because you can't form micelles, the tiny little guys made of bile salts that trap the lipids, and they shuttle them to the intestinal wall. And the whole reason here, the pathophys, is that in CF, you have the thick mucus that blocks the pancreatic lipase, and so the fats cannot be digested. Without digestion, there's no micelle formation, and so vitamins E, D, E, A, and K cannot be absorbed. All right, the bottom line is impaired micelle formation leads to malabsorption of fat-soluble vitamins in cystic fibrosis patients. All right, in our next patient, we have 35-year-old man presenting to the clinic with a 2-week history of progressive difficulty lifting his arms and his legs accompanied by also a new rash. And the rash initially appeared as reddish purple spots on his knuckles and has since spread to his upper chest and his neck. He has no significant medical history, and he's not on any medication. Physical exam reveals erythematous plaques on his knuckles and a heliotrope rash. Heliotrope is just the violaceous, dusky erythematous skin eruption with or without edema, and it's symmetrically involving the periorbital regions and also sometimes the forehead as well. So that's what heliotrope means, the heliotrope sign. And it should definitely cue you into dermatomyositis. And indeed, our answer is dermatomyositis. Okay, so he's got the hallmark features of it, like the proximal muscle weakness, the Gatron's papules, and the heliotrope rash. Elevated CK also confirms a muscle injury, and the combination of the cutaneous findings and myopathy rules out polymyositis, which lacks the skin findings, and it makes dermatomyositis the correct answer. All right, so polymyositis is a proximal weakness without a rash. No rash there. That's why it's poly, not derm. So you have those Gatron papules. And the Gatron papules are the small, raised, reddish purple bumps that appear typically on like the knuckles, elbows, and the knees in individuals with dermatomyositis. They're raised bumps. That's what a papule is, reddish purple. And they can also be kind of scaly, but they're often located on the prominences. And this is an autoimmune disorder, and it affects the muscles in the skin. And the exact cause is unknown, but we think that it's related to inflammation and immune system dysfunction. All right, how about myasthenia gravis? How's that for an answer? Well, no. Have you have fluctuating weakness and ocular involvement and no rash? There's no CK elevation or rash there. So myasthenia gravis affects the neuromuscular junction, so it's not the answer. How about systemic sclerosis? That's tight skin sclerodactyly, which is just the hardening and the tightening of the skin of the fingers and the toes. That's where the body prepares too much collagen and it causes fibrosis. So not that, no Raynaud's, nothing like that. Erythema multiforme has the target lesions, often after HSV and certain drugs, and the skin findings just don't match that. So the purple rash on the eyelids and the red bumps, dermatomyositis. So that heliotrope rash and proximal muscle weakness indicate dermatomyositis as the diagnosis. That's the bottom line, folks. All right, so here we have a 67-year-old man with a history of hypertension and dyslipidemia presenting to the emergency department with a right-sided weakness and difficulty speaking that began 4 hours ago. He's been taking nalopril and torvastatin regularly. On examination, his blood pressure is 145/85, and his pulse is 130 per minute, and it's irregular. And there's a right-sided facial droop with a 2 out of 5 strength on the right upper and lower extremities. His speech is slurred. A head CT scan shows no acute intracranial hemorrhaging, and an ECG reveals an irregular rhythm with the absence of P waves. All right, so that is very, very generous of them to give you, because due to this, we know that it's atrial fibrillation, and it's going to be an acute embolic stroke because he has got like 4 to 5 hours of symptoms with no hemorrhaging on the CT, and so it's the criteria for TPA. And that can restore the perfusion and also improve neurological outcomes. All right, so which one would actually improve the stuff? How about a beta blocker? Well, that's just used for rate control in AFib. And it doesn't actually address the stroke, and it could actually worsen the hypotension and the cerebral perfusion acutely. How about calcium channel blocking? Well, that would be used for rate control as well, and it's not appropriate in acute strokes. There's no neurological benefit from that. So what's the reason you're doing that? Statin loading dose. That is used in stroke secondary prevention, not acute treatment, and it does not improve immediate neurological function. You need fibrinolytic therapy. How about low molecular weight heparin? Well, that is used for DVTs and pulmonary embolisms. This is not the first line for cardioembolic stroke stuff. It's contraindicated acutely before imaging, excludes the bleed, and is not shown to improve the function immediately. So don't do that one either. Here's the explanation and some of the kind of trap answers and why they're wrong. But basically, atrial fibrillation is the most common cause of embolic stroke. So if a patient shows up with like a sudden onset of weakness and slurred speech and irregular rhythm, then you should think of a cardioembolic stroke. And the window of treatment is super duper short. You've got 4.5 hours to give TPA and rescue the brain tissue. And I do also want to mention like how TPA works, because I think that's kind of cool and important. So TPA stands for tissue plasminogen activator, and plasminogen is just a fancy word for the inactive precursor of the enzyme plasmin. And so this is a serine protease that turns plasminogen into plasmin, and then it dissolves the fibrin clots. Okay, so what happens is you have your fancy TPA, and that binds to the fibrin inside the clot, right? And it activates plasminogen and turns it into plasmin. And plasmin digests fibrin, and it breaks down the clot. And then blood flow is restored. So it's a clot buster. It restores perfusion to the ischemic tissue, it reduces infarct size, and improves neurologic recovery if you give it early. You got to give it early, though. There's ischemia. Time is tissue, baby. The bottom line is fibrinolytic therapy is crucial for acute ischemic stroke within 4.5 hours of symptom onset. There are some risks, though, like intracranial hemorrhaging. So it's contraindicated if you have an active bleed, history of hemorrhagic stroke, maybe some recent surgery or trauma, and if the blood pressure is 185/110. So there are some contraindications, but in this case, he's within all the windows. We're good to go, and it ought to be given, and it'll be life-saving. So If you spot a stroke, then give TPA before the brain croaks. Wow, I'm a poet. I didn't know it. All right, hopefully you guys are ready for the freaking coolest question ever. We have a 45-year-old woman with a history of type 2 diabetes presenting to the clinic with muscle weakness and exercise intolerance. Further evaluation reveals a mitochondrial disorder, and you decide to educate her about mitochondrial genetics and explain the mitochondria and why they have their own genetic material, which the following is the primary reason for mitochondria encoding their own tRNA. So I'm going to quickly give you guys the answer, but then I'm going to dive into this because this is fascinating. So the mitochondria utilize a unique genetic code that differs from universal genetic code. Okay, so this is one of the times that evolutionary biology really comes in clutch for step one. And as many of you guys may know, I actually studied evolutionary biology at Harvard, and I think mitochondria are some of the clearest and most powerful evidences. Actually not powerful, there are plenty of examples. Endogenous retroviruses is the most powerful. But mitochondria are super powerful evidence for the theory of evolution. And basically, they are living proof that eukaryotic cells evolved from ancient symbiotic relationships. And this theory is endosymbiosis. And basically, what it says is long time ago, a large, primitive eukaryotic ancestor engulfed a smaller anaerobic prokaryote, right? So eukaryotes, again, just basic biology here, they're organisms that have membrane-bound nucleus that contain the genetic material, DNA, and other specialized membrane-bound structures called organelles. Okay, so like animals, plants, fungi, these guys are all eukaryotic. Even a protist is eukaryotic. And their cells are large and they're complex, more complex than a prokaryotic cell. That's a eukaryote. And so one day, a big old eukaryote, one of our ancestors, was just chomping up a small aerobic prokaryote, likely alpha proteobacterium. And instead of just destroying this, the two formed a symbiotic relationship. You help me, I help you. So a small bacterium helped to generate ATP for the host. Wow, thank you. I love ATP. In return, what does the ATP guy get? A stable environment and nutrients. Wow, it's synergistic. Okay, so that didn't just have to happen like randomly by chance. Now you get a favorable organism which now has ATP inside of it. And now the aerobic prokaryote has a little shell. It's got a stable environment where it can do its thing. And so over time, this bacterium becomes the modern mitochondria. Okay. And it has its own circular DNA. Just like bacteria, it's nonlinear, and they've got their own 70S ribosomes. It's the same size and type as the prokaryotic ribosomes, right? This is mitochondrial evidence for evolution. Also, binary fission occurs. So mitochondria replicate like bacteria, not via mitosis. Also, they have the double membrane. So the inner membrane is from the engulfed bacterium, and the outer is from the host cell. Look at that. Also, they have smaller gene sequences. Mitochondrial genes are closest to the alpha proteobacteria, and that's the reason why we think it originated from them. And then lastly, the maternal inheritance. There's no recombination. It's just passed clonally, and that allows tracing ancestry, like mitochondrial Eve. Okay, so that is like super cool. And if people understood that, then they would understand a lot more about science and the world and their religion, and just they'd be so enriched to know exactly why the mitochondria gives us evidence for the theory of evolution. And mitochondrial diseases show maternal inheritance. And so basically what that means on step one is all the kiddos from an affected mother are going to get the disease. And so drugs that inhibit prokaryotic ribosomes, like tetracyclines, may affect the mitochondrial translation. And so mitochondrial DNA mutates faster, which is useful in phylogenetics and evolutionary timelines. Okay, and why does this matter? Really quickly, let me do this because I freaking love evolutionary biology. This provides a direct molecular and structural evidence that complex life evolved via symbiosis. So the mitochondria and the chloroplasts in plants support this theory. And so this shows how prokaryotic life forms merged to create complex eukaryotic cells. Okay, why else would mitochondria look, replicate, and function just like bacteria? Well, it's because they used to be bacteria. They're a living fossil inside of your body that proves complex life evolved from simpler organisms that work together. Okay, so a primitive eukaryotic cell engulfed the prokaryote, and that prokaryote became the mitochondria. And so all you really need for this to happen is you need a nucleus and a cytoskeleton, and then you need a free-living prokaryote that makes ATP. And then that immediate symbiosis forms over millions of years. The prokaryote loses the independence and becomes a mitochondria. Okay, so a mitochondrion is an organelle inside of a eukaryotic cell. It's the powerhouse of the cell. It makes the ATP. And it still has prokaryotic features, but it's no longer an independent cell. And so today, mitochondria are not like prokaryotic cells anymore, but they are descended from one. And that's why they have circular DNA like bacteria. That's why they had the 70S like the prokaryotes. That's why the membrane is double membraned. That's why they divide through binary fission like bacteria, not mitosis. That's why the genetic code is slightly different, and that's why the inheritance is maternal only, whereas the whole eukaryotic cell is diploid, has a maternal and a paternal. And so mitochondria are clearly prokaryotic in origin, even though they now live inside of a eukaryotic cell. Now, guys, that is fascinating stuff. And so the answer is the mitochondria utilize the unique code that differs from the universal genetic code. All right, and that's the bottom line right there. Cool beans. And thanks for indulging me there. Let me know if you like those tangents, because I love talking about evolution and biology. I even wrote a book about it. Maybe I could put that on the channel or give you guys a huge discount so you can read that book. But it's called Did We Evolve? Spoiler alert, the answer is yes. It is fascinating. What a beautiful thing. Doesn't that just get you jazzed up? Doesn't want to make you just start a YouTube channel and just talk about this? Oh, I love it. All right, I digress. Our next question, we have a 52-year-old woman presenting to the clinic with complaints of intermittent flank pain and unintended weight loss over the last 3 months. She also reports noticing some episodes of blood in her urine. She has a 30-year pack history and drinks alcohol occasionally. Physical examination reveals tenderness in the left flank. Lab studies show normal renal function, but a hemoglobin level of 18 grams per deciliter and a serum calcium of 11.2 milligrams per deciliter, and a contrasted CT scan of the abdomen shows a large, solid mass in the right kidney with an area of necrosis. A biopsy is performed, and histology reveals nests of cells with abundant clear cytoplasm. Which of the following is the most likely diagnosis? Okay, so we got a couple of things. We got a triad for renal cell carcinoma, right? We have flank pain, ouch, we have hematuria, and we have a mass. And we also have some paraneoplastic signs like polycythemia from the elevated EPO and hypercalcemia from the elevated PTHrP. And so histology shows the clear cells with this, which is just pathognomonic for the name, right? It's clear cell subtype of renal cell carcinoma. And the risk factors are smoking, and also in imaging, you have a solid mass with necrosis. So all of that totally fits. But let's talk about why it's not some other stuff. Whoa, what about this? Chromophobe. Okay, that's kind of weird and confusing. Basically, we just put that there because it is weird and confusing. And this is the pale eosinophilic cells with perinuclear halo. This is not a paraneoplastic syndrome. And so our answer is indeed just a renal cell carcinoma. Always go with the basics. Go with what you know on this test, and you'll be just fine. C is transitional cell carcinoma. This is a urothelial carcinoma, and this arises from the renal pelvis, and it would have painless hematuria and no paraneoplastic syndromes. Oncocytoma is benign, mahogany brown tumor, and angiomyolipomas would be benign tumors of the blood vessels and smooth vessels in the fat associated with tuberous sclerosis, like a fatty tumor, not the clear cells of perineoplasms. So the big things here, the big takeaways are the hematuria, the flank pain, and the weight loss. Hematuria, by the way, is just the presence of blood in the urine. And so that's the triad. And it's a triad because it's 3 words, renal cell carcinoma. All right, it's a triad. And so you add in the hemoglobin of like 18 and the calcium of 11.2, and that's paraneoplastic effects of EPO. And it's just all going to be telling you, man, we got renal cell. And especially that solid mass with necrosis. And I wanted to just end this video by talking about paraneoplastic syndromes because they're super highly tested on step 1 and step 2. And they're all over medicine, right? Especially in oncology, if you want to be like Watson in-house. But paraneoplastic syndromes are the systemic effects that are caused by the tumor secreting hormones and the cytokines and the immune associations. It's not due to local invasion or metastasis, right? So they're remote effects of cancer. And it's often the first clue that there's a malignancy. All right, so the high yield paraneoplastic syndromes by tumor type, small cell lung cancer, carcinoma, and that one has polycythemia, hypercalcemia, hypertension, and Cushing's, right? So polycythemia from the EPO, calcemia from PTHrP, parathyroid hormone-related protein, and hypertension through the renin, and the Cushing's through the ACTH. There are also gynecologic or breast cancers. So like ovarian teratomas, those have anti-NMDA encephalitis. Breast cancer would have dermatomyositis associations, and endometrial cancer, acanthosis nigricans. There are also some hematologic malignancies that cause different syndromes like Hodgkin's lymphoma, cause increased 125 vitamin D to hypercalcemia. Thymomas can cause myasthenia gravis, leukemia. And there are some other classic associations like pancreatic cancer would have migratory thrombolytis. That's the Trousseau sign. And gastric adenocarcinoma would cause acanthosis nigricans. And medullary thyroid cancer would cause increase of calcitonin and hypocalcemia. And hepatocellular carcinoma would cause elevated EPO. And polycythemia is just the abnormally high number of red blood cells in the blood and is the primary disease, or it's a secondary condition like living at high altitude or something like that. Okay, so small cell in the lung is ACTH and SIADH. Clear cell, renal cell carcinoma, would be EPO and parathyroid hormone-related protein. Pancreatic would be Trousseau's thrombosis. Renal would be renin and EPO. Cervical and ovarian would be anti-NMDA. Encephalitis would be, and you have other conditions that we kind of talked about there. Encephalitis, Lambert-Eaton, all that stuff. All right, so this can actually precede the cancer diagnosis and it helps to identify the hidden malignancies, right? So super important to keep your eyes out for those syndromes. Bottom line, clear cell renal carcinoma is indicated by renal mass in the clear cell cytoplasm, hematuria, and hypercalcemia, and that flank pain. All right, guys, look at all those notes that we've taken here. Have you learned something today? If you did learn something, then please be sure to like and subscribe. I really appreciate it. It's so fun creating this community for you guys. Look out soon. We'll be launching our website, ivmed.net. We're making it free. It's a free resource where I've typed up a database of everything you need to know about every single condition on step 1. Also, I'm uploading practice questions. And I also just recently launched a Discord, and I'm looking for somebody to run that Discord. So Please let me know if you're interested in that. Basically, it's a free space where everybody can study together, be like, oh my gosh, I hate step 1 too. Let's be friends. I don't know whatever you guys are going to do on there, but it's a little Discord. There's a Telegram, and I'm going to start an Instagram, a whole bunch of other things. Just click those links in the bio, and thanks so much for being along for this journey. And also just treat yourself. Go out there and do something fun today. Good job watching this video. All right, this isn't the funnest stuff to watch. I'm trying to make it as fun as possible, but good job. So hopefully you guys have a great rest of your day. Make sure you're studying a lot, and we'll see you guys in the next video. Hello everybody, welcome back. My goal is to help you pass step 1. These videos take hours to make. Every single question I'll show you is super high yield. We'll be going over awesome visuals, and I'll be explaining the ins and outs of every single practice question. Your time is valuable, so let's dive right in. So we're starting out strong with the 45-year-old man who visits the clinic with difficulty using his right hand for the past 3 months, making it challenging for him to perform daily tasks such as buttoning his shirt. You can see he's had some trouble with those top buttons there. Upon examination, you observe that he has weakness in the right hand with intact strength of his biceps and his triceps. Reflexes are normal with no muscle atrophy. His forehead movement is symmetrical. A brain MRI is obtained. Which of the following areas of the brain is most likely to show an abnormality correlating with the patient's symptoms? So we have weakness in the right hand, and here are all of our options: medial, lateral, anterior, superior, and orbital portions of different parts of the brain. It seems like our patient is having some problems with voluntary movement. And there's a location in your brain called the primary motor cortex, where the upper motor neurons live. Now, I want to show you this photo. Here you can see how the lungs, here you can see how the legs are on the medial side. And as you move toward the lateral side, you have access to the face. This is the homunculus. This is how the brain is laid out. And this individual has some contralateral weakness, and that is due to the decussation, which, by the way, the decussation is just a fancy word for the crossing of the nerve fibers or other structures, typically in an X shape. And that's how the entire nervous system, the central nervous system, is laid out. So as you can see here, the medial part of the brain is going to correspond to the contralateral leg. And over there we have the face and the hands. So let's look at the brain here. We have our frontal lobe, parietal lobe, occipital lobe, temporal lobe. And here's the central sulcus. Anteriorly, we have the precentral gyrus, and posteriorly, the postcentral gyrus. Now, what we need to know is that upper motor neurons originate from the precentral gyrus, so this guy right here. They descend through the internal capsule and they decussate at the medullary pyramids and they synapse at the spinal cord. And so if you have a lesion there, you'll have upper motor neuron signs. That's like spastic paralysis. You also have increased tone and reflexes and a positive Babinski sign. And as we already kind of discussed here, the medial portion of the brain is going to correspond to the leg, and the face is going to be more on the lateral side, whereas vascular lesions can have localized deficits. And so if we have a stroke that involves this precentral gyrus, which is right here, and that stroke might be something like an MCA, then we will have contralateral hemiparesis, especially in the face and the upper limb. And so this location is in the frontal lobe. It's just anterior to this central sulcus, which kind of divides the parietal lobe from the frontal lobe. And the lesion signs are going to be spastic paralysis, hyperreflexia, and Babinski reflex. All right, so remember our homunculus right here as well. And remember that it's going to be contralateral due to the corticospinal decussation patterns. And that precentral gyrus is the primary motor cortex, and it's super important for initiating voluntary movements on the opposite side of the body. So this hand here, this left hand, is being controlled by this right side, my precentral gyrus, in the primary motor cortex, and it's voluntary movement. And so the neurons firing over here are going to trigger the voluntary movement on this opposite side of my body. And as we move more medially, now you can't tell, but it's my legs are moving. And this could be due to like some sort of a stroke, like an MCA stroke. And so the answer is going to be that lateral aspect, because you can see the medial would be the toes and the lateral would be like the hands and the face. So it's that lateral aspect of the precentral gyrus. The medial precentral gyrus would be leg weakness. Anterior frontal lobe would be executive dysfunction. The superior parietal lobe would be sensory integration, and post-central is the sensory. And the orbital frontal cortex would be disinhibition and personality change. Now let's talk about some wrong answers. We mentioned the post-central gyrus, and that's the sensory cortex, not the motor cortex. It's not the basal ganglia, because that does modulate movement, but it does not initiate via the direct cortical control. There are other parts of the brain, like the cerebellum, which also coordinate movement, but they don't generate that movement directly. And so the key takeaway here is that every single time you voluntarily lift a finger, that command starts in the precentral gyrus of your brain. And there's a narrow ridge on the frontal lobe, is the primary frontal cortex. It's known as Brodmann's area 4. And it sends a signal through the internal capsule that crosses over through the pyramids of the medulla, and it lands in the spinal cord and it triggers the movement on the opposite side of the body. And so if you have a stroke in that area, it'll cause contralateral weakness. And then you have to think of the motor homunculus, and you see a lesion in different areas is going to affect different body parts. For example, a medial lesion that would hit the leg, that'd be like an ACA stroke, but then a lateral lesion that hits the face and the arm would be like an MCA stroke. And you'll see these upper motor neuron signs like spasticity, hyperreflexia. And spasticity is just the involuntary contraction of the muscles. And the hyperreflexia is, you have reflexes that are exaggerated. And of course, there's the infamous positive Babinski. That's when your toes are going to be like spread out and up. So next time you like wave your hand, you should know, hey, that's the precentral gyrus on the opposite side of my brain. That's the muscles commander. And then for the board exam, you just have to know anterior to central sulcus is going to be motor, and then posterior is going to be sensory. If that explanation was helpful, then like and subscribe. For our next question, we have a 55-year-old man that's brought to the emergency department by his family due to confusion and a fever at 101.3. That started yesterday. He has a history of hepatitis C and decompensated liver cirrhosis with known ascites and managed with diuretics and salt restriction. On physical exam, he is disoriented to time and place, and he has a flapping tremor, and his abdomen is distended but not tender. Emergency paracentesis is performed and yields a cloudy acidic fluid. Laboratory analysis of that fluid shows an elevated white blood cell count of 1,300 cells with 85% neutrophils. Blood cultures are pending. Which of the following is the most likely cause of his current symptoms? All right, so some key things that are happening here are we have cirrhosis with ascites, and that can create some sort of a vulnerable environment in the peritoneal cavity. This person is disoriented. They have asterixis. That's just another way of saying a flapping hand tremor. You have brief, irregular, involuntary jerking movements in the hands and some other muscles. We also have that fever, then we have that cloudy fluid. And we can see there's a neutrophil count that's greater than 250. And I want to briefly talk about the asterixis because that's going to be referring to hepatic encephalopathy. And usually have a fever and neutrophils, which means that there's an infection. So it's some sort of an encephalopathy. And the associations here are going to be some sort of a bacteria. We could think of E. coli, for instance. Maybe it's Klebsiella, Streptococcus. These are common pathogens. And you could have like a bacterial translocation from the GI tract. And that cirrhosis, the portal hypertension, and the gut congestion, that can cause increased bacterial migration. So the cirrhosis just is not helping with this whole bacterial influx. And you get hepatic encephalopathy that's precipitated by some sort of an infection. You got a bleed, electrolyte imbalance, and also that high nitrogen load. And so the pathophysiology of this patient who's got his hands up and they're like, what's wrong? Nothing's wrong with me. Is it starts out with portal hypertension. There's portal hypertension in his cirrhosis, and that leads to the ascites formation. And ascites is just the accumulation of any fluid in the peritoneal cavity that causes the abdomen to swell. As you can see in this photo, he's got a really swelled up abdomen. And peritoneal just refers to the peritoneum, right? That's the delicate little membrane lining inside of your abdominal cavity that covers your organs. And the function is to act as like a barrier. It protects the organs. And it also has fluid so that you can reduce friction. Because imagine if you didn't have any fluid in your body, your organs are just like scratching up against each other. No fun. So you can get like things like peritonitis, that's inflammation of the peritoneum, or peritoneal cancers. All of this to say that we have ascites formation due to the increased hydrostatic pressure and hypoalbuminemia. And we get bacterial translocation that I was talking about earlier. Our bacteria is going to be mobile. It's going to migrate now. And we get impaired mucosal immunity because of that and slow lymphatic clearance that allows the gut flora to migrate into the peritoneal fluid. No good. And so now we get that ascitic fluid becomes infected and it triggers inflammatory responses. That inflammatory response is measured with the labs. So anytime you see like the neutrophils that are elevated, in this case over 250, that tells us we have some sort of an inflammatory response because of that infection. And then you get systemic inflammation and liver dysfunction, and that just worsens. It's like a spiral. It worsens the hepatic encephalopathy, and that causes confusion and also a coma. So the things to look out for on this question stem that really differentiate it from other diseases are going to be the fever, the confusion, the asterixis, the abdominal distension, the cloudy acidic fluid. Also, oftentimes they'll have like a positive culture. For instance, E. coli might be present. And the mental status changes are going to be here. And typically you treat this with a third-generation cephalosporin like cefotaximine. And so our answer is going to be a bacterial translocation that leads to the peritonitis. Now there's some compelling answers here like hepatic encephalopathy. Why is that not the right answer? There, the flapping tremor is actually going to be seen in this patient, but that fever and PMNs suggest that there's an infection, not just a dehydration problem. So it's more than that. Acute hepatitis C, you don't see jaundice and elevated transaminases, and so it's probably not going to be hepatitis C. Drug-induced liver injury, that would not cause the PNM, predominant acidic fluid. Ruptured hepatic cyst would cause acute peritonitis with tenderness, but there was not tenderness in this patient. So the asterixis would fit for some hepatic encephalopathy, but it's not dehydration. because he's got high neutrophils, right? And for hepatitis C, I would not think about that causing encephalopathy. And chronic hepatitis C usually progresses pretty slowly as well. And if it's a drug-induced liver injury, then you would probably see some liver problems, right? The transaminases, elevated liver enzymes, not neutrophilic ascites. And it's not a ruptured hepatic cyst because that would cause acute abdominal pain and possibly a hemorrhagic fluid. It's not going to be fever with neutrophilic ascites. So this is a spontaneous bacterial peritonitis, and it presents only with confusion sometimes. And what's interesting here is that there's not going to be any belly pain necessarily. There's no guarding. It's just like mental status changes. And this is often seen in patients who have cirrhosis and ascites. And the pre-central gyrus isn't going to be the problem bacteria here. What happens is there's increased portal pressure that weakens the gut bacteria, or that weakens the gut barriers. And that allows the gut bacteria like E. coli to sneak into the peritoneal cavity. And there's not any trauma or anything like that, no perforation. It's just that migration happens. And then the infection starts to inflame the ascitic fluid, which we then spot on the paracentesis because we have that neutrophils elevation. And then that infection just kicks off the systemic inflammatory response, and that worsens the fever, worsens the liver function. It leads to hepatic encephalopathy, the confusion, the esterixis. And so it's the bacterial translocation into the peritonitis. And so you guys might be wondering with this question, okay, well, why are there neurosymptoms in SBP, like confusion, disorientation, all that stuff? Well, that's because of the infection. Your liver starts to fail, and then you have that detox failure means that we can't detoxify the ammonia and other nitrogenous wastes. And so in cirrhosis, the liver already is impaired and can't clear any toxins efficiently. And so you have an inflammatory stressor, an infection causing like inflammation all over your body, fever, the cytokines, the bacterial endotoxins are going to be increasing the ammonia production, and you can't get rid of that ammonia, and it just builds up and it enters the brain because ammonia can cross the blood-brain barrier. And the astrocytes are going to take it up and they're going to convert it into glutamine, and that causes cerebral edema, and you have neurotransmitter disruption. And so the brain gets all foggy, encephalopathy, and the result is like confusion, slowed down cognition, disorientation, and of course, estrixis, that flapping tremor. So the infection causes more ammonia, less detox, the brain dysfunction, cerebral edema, hepatic encephalopathy. That's the pathway. Now, the bottom line for this question is that cloudy acidic fluid with neutrophilia indicates spontaneous bacterial peritonitis in cirrhotic patients. In our next question, we have a 32-year-old woman presenting to the clinic with complaints of increased irritability, palpitations, and difficulty sleeping. She reports recent weight loss and increased appetite. So we're already thinking of hyperthyroidism. On physical examination, her heart rate is 110 beats per minute, and her skin is warm and moist. Her eyes appear prominent, and there's lid lag. The thyroid gland is diffusely enlarged. Lab tests reveal elevated T4 level, decreased TSH, and the presence of antibodies against the TSH receptor. This is the world's easiest question. It's Graves' disease. Now, the way to think about Graves' disease is your body is turning up the gas and just forgetting. Your body is just throwing fuel into the immune system. Your immune system is super hyperactive here, and it forgets to let up. It forgets to let up, and you get autoantibodies that stimulate your thyroid nonstop. They just can't stop pestering the thyroid. And so you get too much thyroid hormone, and that means you have a racing heart rate, and you have weight loss, you have heat intolerance, and protruding eyes. It also presents with moist skin, tachycardia, proptosis, which is just like the abnormal protrusion or displacement of the eye or another part of the body. There's also diffuse goiter, and goiter is the swelling of the neck, and that results from the enlargement of the thyroid gland. And also there's that positive TSH receptor antibodies. And that's something you just kind of have to memorize. The antibodies is like really the giveaway for this question. It's overstimulating directly because your immune system is just hyperactive. It's not the pituitary or anything like that. It's just antibodies. And so only Graves' disease explains this condition. The TSH is low because you're compensating for it. It's not toxic multinodular goiter because that would not cause the eye protrusion. It's not subacute. It's not painful. Not Hashimoto's because that'd be hypo, not hyper. And not thyroid storm because that's severe, acute. And this person is stable. They just are hypotensive. It is the most common autoimmune disease, especially in females. Bulging eyes and also lid lag, hyperparathyroidism. Boom. Lock it in. You got it. Elevated T4, low TSH, Graves' disease. Okay, in our next question, we have a 25-year-old man evaluated in the urgent care clinic after experiencing a collision while playing soccer. He's got some sudden left-sided chest pain, difficulty breathing following the incident. Physical exam shows tachycardia, decreased breath sounds on the left side, and tenderness upon the palpation of the chest wall. When palpating the chest, there is a noticeable cracking sensation under the skin. Which of the following findings best indicates this patient's symptoms are due to chest wall injury involving the lungs? All right, I like to call this one the Rice Krispies underneath somebody's skin. You know, snap, crackle, pop. And this is because of subcutaneous or under the skin crepitus. And crepitus is that little friction between the bone and the cartilage and fractured parts of your bone. And Basically, this person's playing soccer. All of a sudden, he's got some chest pain, trouble breathing, and decreased breath sounds on one side. And if you press on the chest, you're going to feel something really weird. It's like bubbly and it crackles. That is the air that escaped from the ruptured lung or the airway, and it's now trapped inside of the tissue. So that's going to be a trauma-induced lung injury. If you feel it and you're like crackle, then it's going to be maybe like a small pneumothorax or like a bronchial tear of some sort. And you might be tempted to say like there's dullness, there's fremitus, agophony, all that stuff. Well, those are going to be other lung pathologies like pneumonia or some sort of an effusion. But subcutaneous crepitus is very unique. It's like the air is trapped where it should not be. Dullness to percussion over the affected area. That was just that there's like some fluid, like a hemithorax or maybe some pleural effusion, not air escaping. So dullness to percussion is not the right answer. A tracheal deviation away from the affected side is seen in tension pneumothorax, but this patient is stable and does not have like some severe hemodynamic problems. So that's not the answer. Increased tactile fremitus on the affected side. That occurs in consolidation if it's on the affected side, and it's not going to be pneumothorax or like a lung problem. And agophony is also a sign of consolidation. It's not expected if you have some air leakage. Okay, so I kind of went over that explanation, but there it is. If you want to pause and read it. And here's the bottom line. Subcutaneous crepitus indicates a chest wall injury involving the lungs, often associated with pneumothorax or an air leakage. Very nice. In this question, we have a 55-year-old man presenting to the clinic with a chronic productive cough and worsening shortness of breath over the past 5 years. He has a 40-year pack smoking history, but quit smoking 2 years ago. On physical examination, he has an increased anterior-posterior diameter of the chest and decreases breath sounds bilaterally. Pulmonary function tests are performed, revealing the following. VC is 70% predicted, FEV1 is 50% predicted, FEV1, FVC is 0.55, total lung capacity is 120%, and residual volume is 150%. These values show no significant change after administration of bronchodilator, which the following best explains his pulmonary condition. Wow, we got a whole lot of answers involving the airway resistance and the lung compliance. Now, there's one thing to emphasize about the lungs, which I have beautifully drawn right here, and that is that these guys are not just like sacs, okay? It's not the way to think about them. They're actually springy. But there's something called emphysema, which makes that spring snap. And so we got this 55-year-old, he's got some coughing, some dyspnea. Dyspnea just means that you're having trouble breathing. He has a barrel chest and he's got some lung smoking history. So all this points to emphysema. But we see that this is an obstructive pattern. And the reason why is really because of that total increased volume. That's one of the signs that's differentiates it from other conditions, and also that increased residual volume. And the reason why you have increased residual volume is because of the trapped air, which we'll talk about in a second. And importantly, this is not reversed when you have bronchodilation. And that means that there's some irreversible damage, right? If it doesn't reverse, irreversible. And that's classic COPD. And so what's actually happening here is you have your alveolar walls that are destroyed. They're literally just damaged. And so you have increased compliance, right? Increased compliance. The lungs are going to stretch out more because the alveolar walls are destroyed. They're going to stretch out, but they cannot recall. It's like that spring snaps is the way to think of emphysema. The spring is what contracts it, but that's not able to happen, right? So you have increased compliance, but not the snapping back. And so at the same time, the airway resistance is up. And that's because the floppy airway is going to collapse during exhalation, right? Breathe in, out. Whenever you breathe out, your floppy airways are going to collapse. And so the answer is going to be increased airway resistance and also increased compliance. Now, this topic was hard for me at first, so I really want to explain this extremely clearly. He has COPD, specifically emphysema, and that is caused by years of smoking. So when you smoke, your lungs get damaged and they stretch out from the inside. And the tests are saying some different things. They're saying FEV1 is low, and also that ratio is low. And all that means is that the expiratory volume, you're having trouble breathing out. And that tells us having trouble breathing out, well, that's an obstruction. And he has a high total lung capacity and residual volume because there's air that's trapped and it stays inside. It's overinflated. Okay? Hopefully that makes sense. Now, what this means in super plain terms is that his lungs have become floppy and overstretched because they've been damaged by smoking, right? So it's like a balloon that has been blown up way too many times and it expands easily, right? A balloon that has been blown up so many times expands very, very easily. And so that's what we call compliance. It's compliance if you put stuff in it, but it's not going to snap back very well. The airway is narrow or it'll collapse during exhalation. And so it's really, really hard to get the air out. And that's why you should not smoke. Please, for the love of God, do not smoke. Putting toxins right into your body, just damaging your airways. So the airway resistance is going to be higher, and that's due to the damaged, collapsing airways. And the lung compliance is higher, and that's due to the stretchy or the destroyed alveoli. So here's the explanation. They're basically saying the same thing here. Lung compliance, airway resistance is increased airway resistance. That'd be ignoring the hypercompliant lung aspect of things. because it's not normal, it's increased compliance. And that's pretty much all there is to say about this particular condition. Emphysema, it's that obstruction. The forced expiratory volume is decreased. They get narrower. They start to collapse on expiration. They get trapped there in the body. The lungs are going to be damaged because of that smoking. Be sure not to smoke. Now, here's the bottom line. Chronic obstructive pulmonary disease shows increased airway resistance and increased lung compliance with fixed airflow limitation. So you can't really breathe out. All right, so just to recap here, we've covered hepatic encephalopathy, right there, Graves' disease, COPD, subcutaneous crepitus from a pneumothorax, and some other high-yield medical facts. And so what I'm going to do is something different than normal. First of all, please like and subscribe, but I'm actually going to be putting a song that kind of recaps all of these things together at the end of this video. Until next time, peace out. But if you want to hear that song to recap all the information we covered, then just keep listening. See you guys in the next video.
Brown bigot, confused and febrile, belly full of fluid, liver took a hit and the bugs ran through it. Cirrhotic with a sites, neutrophils in the tap. That's SPP, it's time to bridge the gap. Ammonia builds up, brain cells swell. Astrocyte stress, not doing too well. Asterixocene, disoriented mind. Infection triggers encephalopathy every time. Young woman, weight loss, anxious and thin. Eyes popping out, that's where we begin. TSH low, free T4 flies high. Autoantibodies making that gland go wild. TSI hits the thyroid, overstimulation. Water grows big, it's hyperthyroidation. Obeopathy's real, lid, lag, and stare. Graves is the cause, nothing else compares. Got that bowel chest, breathing in vain. FEV1's low, it's a lung disease thing. TLC expanded, RP won't drop. Compliance is up, but recoil it stops. Smoking's the villain, upper lobes attacked. Airways collapse, that's a hard fact. Bronchodilator, no reversal inside. That's cowled deep, and it's tight. Chest hit hard, and now we can't breathe. Air under skin, that's what we perceive. Subcutaneous crepitus, crackles you can feel. Collapsed lung maybe, yeah that's real. Timpani, tracheal shift if it's extreme. But crepitus tells you where the air's been. Forget firmitus, any go for the games. Crepitus equals lung injury, remember the name. SBP brings bugs to the belly. Graves brings heat in the eyes that's swelly. Emphysema makes the lungs too loose. Crepitus, that's air on the loose. Use your steth, your brain, your hand. Know which signs go with which gland. Step one isn't just recall and fear, it's pattern recognition. Make it clear. Hiver Roman. Wow.
Hello, everybody. We recently hit 1,000 subscribers, and I just want to say thank you, everybody, so much for being a part of the journey. My only goal in making this content is to help make Step 1 studying a little bit more fun and a little bit more easy. If I've accomplished that, then I'm a happy man. Just wanted to start the video by saying I'm super proud of the progress that you've made. Make sure in dedicated period to just breathe, find joy in the journey, and treat yourself as nicely as I know that you're going to be treating your patients someday. Okay, so in our first question, we have a 3-year-old girl who has pale skin, light hair, photophobia, and nystagmus, despite sunblock, has normal vitamin D and calcium. What explains these findings? The answer is deficiency in the production of melanin. So the pathway to get to melanin involves first tyrosine, next dopa, and then lastly the melanin, and that's via the tyrosinase. Okay, so that's the pathway, and if you have a mutation in this guy right here, then that means that you can't make any melanin. And in these conditions, you have the melanosomes are present, but the melanin isn't. And if you don't have any melanin production, that means that since the sun is a deadly laser, the sun is going to be shooting down all these UV rays, and you're not going to have protection against it. And so the eyes and the skin are going to have underdeveloped pigmentation, and you'll have some visual defects, and you'll have sun sensitivity. So the buzzwords that you're going to see on Step 1 for this are going to be photophobia and blisters with the sun, and that's just due to the no UV protection because you don't have the melanin. Also, the translucent iris, the nystagmus, that's because there's no melanin in the retinal pigment epithelium, and so you get abnormal vision development. And these people will put on a bunch of sunblock and they will still have pale skin, and that's because this is a genetic condition, right? It's not environmental, and this is a problem with your pigments. All right, so some associations would be like oculocutaneous albinism. It's autosomal recessive inheritance pattern, and it's often that tyrosinase gene defect. And of course, you're going to have a really high risk of skin cancer, unfortunately. Okay, so we have in this question a child who's got photosensitivity, pale skin, nystagmus, normal vitamin D and calcium, and also normal melanocyte number and melanosomes, but there's just no pigment inside, and so it's a defect in that pigment pathway. And that is why our answer to this question is deficiency in the production of melanin. Transfer would cause hyperpigmentation. The melanosomes are present, so that's why it's not B. C would cause hypo, and it wouldn't have the eye signs, and E would not be albinism. And so the kind of lesser known fact here is that melanin has some other functions, including shaping how we see. You got to have pigment in your eyes so you can block out the sun. So the bottom line is you have that deficient production of the melanin, and that causes photosensitivity, and that's why we have albinism in this patient. All right, in this question, we have a 72-year-old woman with COPD who develops pneumonia, and despite ciprofloxacin, she does not improve. Genetic testing shows a mutation. What structure is altered? Ciprofloxacin is going to target the DNA gyrase. And so if you mutate the DNA gyrase gene, you have some resistance. And ciprofloxacin is a fluoroquinolone, and that's how we know that it stops this DNA gyrase. And the role of DNA gyrase is to essentially untwist the bacterial DNA during replication. And so if a bacteria mutates the DNA gyrase gene, then the drug can't bind anymore, and so you can't be treated. DNA gyrase is pretty much the same thing as bacterial topoisomerase 2. And its job is just to relieve all that supercoiling that happens in bacterial DNA binding. And this is totally essential. Your bacteria cannot replicate DNA without it. And so you give them a fluoroquinolone, like ciprofloxacin, and it targets that DNA gyrase, and the topoisomerase 4, by the way, but that's not important. And so it just binds and it stops the DNA from unwinding, and so the bacteria then can't divide, and so it's bactericidal, it kills it. Okay, so here's our brief explanation and also our trap answers and why they're wrong. Love for you to take a second to look at that. And another thing is Pseudomonas aeruginosa is going to have that grape odor and also the blue-green pigment. There's a really good sketchy on that. I think it's worth watching if you can get your hands on it. Cell wall is the target of the penicillin cephalosporins, not the fluoroquinolones. Outer membrane, no, this is in gyrase. DNA-dependent RNA polymerase, that'd be rifampin. R for RNA polymerase, rifampin R. Lipopolysaccharide would relate to the immune response, not to antibiotic resistance. So Pseudomonas is a super drug-resistant bacteria. Basically, the most important point here, and I'll kind of go to this scene, is that Pseudomonas is a bacteria that can mutate the DNA gyrase gene, and then the drug can't bind anymore, so you can't do that treatment. All right, so think of the topoisomerases, the supercoiling, the DNA gyrase, and you'll get this question right on test day. All right, let me know if you like this new background color. In our next question, a 24-year-old man presents to the clinic with complaints of painful sores on his penile shaft and a surrounding redness that started 3 days ago. He's also got some mild itching and dysuria. That's just like pain whenever you're urinating. And there's a history of an occasional fever and inguinal lymphadenopathy. He is sexually active with multiple partners and uses condoms inconsistently. He's got some clusters of the erythematous vesicular lesions on the glands in the shaft of the penis. And erythematous is just that reddened kind of color. Basically, doctors got to be fancy, and so we have to find a way to say inflamed, red, and this commonly is just going to be associated with like infections like bacterial, viral, fungal, some allergies, and also autoimmune disorders and trauma, just erythematous, right? Redness of the skin, swelling, painful, itchy kind of stuff. You see it in a lot of things, so I digress. There is no urethral discharge. Lab shows multinucleated giant cells on the zinc smear. What is the diagnosis? All right, some things should be coming to mind here. Let's go through each one by one. Molluscum contagiosa. Sounds like a Harry Potter spell, but that one, it would be painless. So if I change that to painless, then you're in business, folks. But I don't know why, but like the M just sounds like ba-ba-ba-ba-ba. I don't know, just like nice and welcoming and not painful. And so that's how I remember molluscum contagiosum is not painful. It's painless, and it's also dome-shaped, right? It's dome-shaped. Those are the umbilicated lesions, and there's no vesicles and definitely no pain from contagiosum. What about the chancroid? So those guys are painful, right? You do cry, right? They're painful ulcers. It's Haemophilus do cry. That's why I said do cry. But there's no vesicles on those guys, right? The lesions are going to be ragged and deep with a purulent base and unilateral lymph nodes that can suppurate, which basically means they fester, they form pus, they suppurate. And so that's not our answer, right? No vesicles. And here, whoop, we got vesicles. And that's why it's not the chancroid Haemophilus do cry, even though you do cry because it is painful. Unlike the M one, molluscum contagiosum, the Harry Potter spell, those guys are not painful. I mean, it just sounds like a nice little guy. D, primary syphilis, Trichoderma pallidum. These guys are painless ulcers. Yeah, they're pretty much the chancres, and they have the firm, clean base, and there's no pain, there's no vesicles, and there's no giant cells, and so D is wrong. E, lymphogranuloma. All right, that's going to be like the chlamydia, trachomatis L1 to L3. Those would be small, painless ulcers, again, painless, followed by painful buboes. Those guys are the swollen, inflamed lymph nodes in the armpit usually, or the groin, the buboes. So E, lymphogranuloma, would be chlamydia, trachomatis. L1 to L3 would be small, painless ulcers followed by painful buboes, which are seen in the armpits and the groin, but you would not have any vesicles. All right, so the big things that I would say is this vesicular and this painful thing together makes us think that we're starting from HSV somewhere. And what this does is it's a virus that actually hides in your sensory ganglia. And then whenever you are stressed, like you're studying for a big test, unrelatable, right? Or you have multiple sexual partners, or you have an illness and you start to have like this painful reoccurrent problem. You might have some systemic symptoms, might have like a fever, lymphadenopathy, And then you get and it's like, oh my gosh, look at that. It's a multinucleated giant cell. And the way that they'll show this on test day, they'll have like this, and then you'll just see like little tiny little clusters inside. That's what they mean by multinucleated. All right, so just don't overthink this one. All right, so just don't overthink this is just going to be genital herpes and then just move on, right? So here's our bottom line. I don't know, by the way, why I always do this. I just like put my face on this poor AI-generated character here, but clusters of vesicular lesions with multinucleated giant cells in the smear indicate genital herpes diagnosis. There you have it, folks. There you have it. You guys are doing so good today. For our next question, we have a 74-year-old man with a history of type 2 diabetes and hypertension presenting to the emergency department with a 3-day history of fever, malaise, and increase in confusion. He was recently discharged from the hospital 1 week ago after being treated for bacterial pneumonia, during which he had a central venous catheter for intravenous antibiotics. On examination, his temperature is at 102. Blood pressure is 110/70, heart rate 110 per minute, respiratory rate is 18. Lab tests show a white blood cell count of 14K with 50% bands. Remind me in the comment section to explain what on earth that means, the 14K and the bands. And by the way, by comment section, there's no way you can tell me right now, so don't worry, I'll remember. I'm just trying to like pump up engagement for no reason at all. But yeah, back to this patient. So we check this out, and then 48 hours later, boom, we got yeast. Which organism is most likely causative for this condition? And we got a lot of them here. One's it gonna be? Are we gonna guess? No. Well, maybe. We'll see. Seems like a strong answer. A is a good letter, right? Well, I don't see anything in the question stem about Southwest US and lung disease, and so I'm not going to choose that as my answer, okay? Because it's always going to have at least one of those two things in the stem, and I don't see either of them. Histoplasma capsulatum is going to be in Ohio and Mississippi river valleys. I feel bad because like medical school just like primes you to anytime like I go to Ohio or Mississippi, I'm like, watch out for the histo, and you just don't want to breathe, right? Because you're inhaling that stuff. Just kidding, you're fine. But it's a pulmonary infection, right? It's not going to be histo. All right, I'll skip C for now. D, Sporothrix. Sounds like Bellatrix, but it causes skin infections, Rose Gardner disease. That one spreads through the lymphatics, not the bloodstream. And then Rhizopus, that would cause mucor in diabetics with diabetic ketoacidosis, but not candidemia. And candidemia just means fungal infection, right? It's where you have the Candida species like Candida albicans, and it enters the bloodstream, not the lymph, the bloodstream. And this is often seen in like healthcare associated infections, eyes, and this can be life-threatening. So you do have to treat it immediately. Broad spectrum antibiotics. Often you see this with indwelling catheters, that kind of stuff. Maybe they have a weakened immune system. Maybe they got like HIV or chemotherapy going on. Symptoms would be like fever, chills, muscle ache, skin rash, confusion, and low blood pressure. Okay, and so our answer is indeed going to be Candida, any type of Candida. And why is it Candida? Well, that is the most common fungal organism that's found in the blood, and it usually gets there through an IV catheter, as we spoke of. So we got this dude, look at him over here, it's actually me. Surprise. See, look, it's me. Anyways, just got out of the hospital and had a central line, was on antibiotics, and now I'm getting a spiky fever, and the blood culture is going to show yeast. And all that is just Candida, right? And in older adults, glabrata, Candida glabrata, although you don't really have to get that detailed, but that's like a tough little yeast that doesn't form true hyphae and it can resist azoles. But all we need to know is that this is Candida, and then we're good to go for this question on Le Step Uno. All right, here are the sharp answers and why they're wrong. So feel free to pause that if you want to dive deeper. The bottom line is blood culture, growth of yeast in patients suggest Candida. By the way, I hope I'm not being too facetious. I just want to make sure you guys are having a good time while studying. It's fun to have a relatively fun video every now and again, as Rick says in Rick and Morty. A little horseplay is good every now and again. What does he say? In our next question, a 32-year-old man presents with a decreased libido and erectile dysfunction. He's got some low labs here. Prolactin super high though. MRI of the brain shows a pituitary lesion. The most appropriate pharmacological therapy is going to be what? All right, I've written some notes here in preparation for this question. What I want to explain now is prolactinoma, because that's going to be the first thing you're thinking of. This is a common pituitary tumor, and you get high prolactin. It's a prolactinoma, right? And what you have to know is that prolactin is a wet blanket. It likes to inhibit GnRH. It sees it at the party and it's like, no. It's like, is it Tim Robinson from I Think You Should Leave in that one sketch where he like tries to make the guy at the party have a bad time? That's what prolactin does to GnRH. And consequently, downstream to GnRH is LH. And if you don't have LH and FSH, then you're not going to have testosterone either. And that explains all of his labs and the low libido. And so like the lay of the land here is you look at the low T, you look at the low FSH and the LH, it's hypogonadism, and also the super high prolactin and the pituitary lesion of 9 millimeters. And all of that tells you we got prolactin secreting pituitary adenoma. So this is a prolactinoma. Also, by the way, it's important to like know what an adenoma is. I realize that sometimes we just throw words like this around and we don't even know what they mean. So an adenoma is a benign, non-cancerous tumor that forms from the glandular tissue, and it grows really slowly and it does not spread to other parts of the body. And so adenomas can occur in different organs, like the colon. If you think of some examples of the colon, tubular adenoma, villus adenoma, right? The pituitary gland, and that's what we're talking about right now, pituitary adenomas, right? Thyroid gland, thyroid adenoma, liver, hepatocellular adenoma, adrenal glands, adrenal adenoma. And so these causes can sometimes be unknown, but there are certainly factors like age, family history, hormonal imbalances, and all that stuff that cause this. And oftentimes you get these through physical exam, but sometimes imaging as well, or just biopsy. Usually they don't need treatment, but often you'll do, some observation and maybe surgery to remove the adenoma and then some medication to manage the hormonal imbalances. So we got a prolactinoma and that's causing decreased libido and ED. Hopefully that mechanism makes sense. Now, I want to talk about some of the associations because in this question we have a man, but this can also happen in a female as well. And so men with prolactinoma have decreased libido and erectile dysfunction. Women with prolactinoma would have galactorrhea, and the treatment in both cases is the same. The treatment is going to be a dopamine agonist. And this is where it gets so funny. And for you guys, I know there are some people who are taking the MCAT and they're watching another one of our YouTube channels. But dopamine inhibits prolactin, and prolactin inhibits GnRH, and GnRH causes LH and FSH to go up. And so I remember when I was studying for the MCAT way back in my youth that I was like, man, why do I have to keep track of all these long cascades? And well, this is a perfect example. Dopamine agonism would increase this dopamine, causing increased inhibition of prolactin, which causes decreased inhibition of GnRH, and the pathway just goes on and on. So the physiology here is prolactinomas secretes prolactin. Oh my gosh, surprising, right? High prolactin suppresses hypothalamic GnRH secretion. Low GnRH means low FSH and low LH and low testosterone. And so the symptoms are erectile dysfunction, low libido, and infertility. My friends, the bottom line is this. Prolactin secreting is treated with dopamine agonists to reduce prolactin levels and restore testosterone. All right, in this question, we have a 30-year-old woman who presents to the ED with severe abdominal pain. She frequents for severe complaints. She reports unstable relationships, chronic emptiness, emotional instability. Which personality disorder is most likely? All right, so anytime you have relationship instability, you should automatically be thinking of borderline. All right, paranoid is obviously suspicious about others without reason. Histrionic is attention-seeking, avoidant, social inhibition. Obsessive-compulsive is perfectionism and control, not emotional dysregulation. So she's got borderline. And how do you know? The repeat visits for dramatic physical symptoms, but normal labs, chronically feeling empty, and intense, unstable emotions. Intense, unstable emotions. This is one of the worst, absolute worst conditions for relationships. It can blow up people's lives. It is an extremely sad and serious condition, and it makes me sad just thinking about it. But emotional instability, impulsivity, and splitting. Splitting is the key thing to be thinking about for this one. All right, so that's all I wanted to say for this one. Intense emotional instability, tumultuous relationships, and remember splitting. Truthfully, one of the worst conditions out there. It's hard not just on the individual, but also on people who are in relationships or family members of those with borderline personality. All right, for this one, I have drawn the patient myself as a 4-year-old girl who's brought to the pediatrician by her parents due to recurrent infections and failure to thrive. The parents suggest that she has had several episodes of bacterial infections affecting her skin and respiratory tract last year. Physical exam shows pale, thin child with petechiae and moderate hepatosplenomegaly. Lab shows pancytopenia and notably low neutrophil count. Bone marrow reveals the presence of immature blast cells, and they do not express these guys or CD19s, but they do express the 34s and TDT, which the following is the normal counterpart to these malignant blast cells. All right, hematopoietic stem cells of the bone marrow. Well, that would be way too primitive, right? There would be no rearranged immunoglobulin genes yet. Immature myeloid precursors in the bone marrow. Well, myeloid precursors would be MPO positive, not TDT positive. And I'll talk about that in a second. Double negative T precursors in the thymus. That's a T cell lineage, and so that would rearrange on TCR, not the IG heavy chains. D is our correct answer. B precursors in the bone marrow. The B cell lineage is the precursors are going to be really timely here because this is before the CD19 expression. And mature natural killer cells in the peripheral blood. Natural killer cells do not rearrange immunoglobulin genes. All right, so it's a 4-year-old recurrent infections, and that is the age for acute lymphoblastic leukemia, right? ALL. And you can see pancytopenia. The reason is because the marrow can be replaced by the blasts. And there's rearrangement of the immunoglobulin heavy chain segments, and that's like a B cell lineage marker stuff. And there's no CD3, 4, and 8. And that CD3, 4, 8 tells you it's not T cells. That's super important. And there's no surface CD19, and that's a mature B cell. And then the CD34 positive and TDT positivity tells us that it's very immature lymphoid blasts because TDT is a marker for lymphoid precursors. And so the blasts are lymphoid, right? And we know they're lymphoid because of TDT positivity, but they're in their early stage of development. And they are B cell, and we know that since the immunoglobulin heavy chain rearrangement is like the hallmark of B cell development, but it's before CD19 expression. And so That comes later in the cell maturation process. And that's how we're able to kind of time this and say exactly where it is. That's why the answer is the early B cell precursors. Now, I promised I'd explain a little bit more about a commonly confused topic, but one thing I wanted to mention was this word, which you've probably seen, but maybe don't know how to say. But don't worry, a lot of us have trouble with it. Yeah, that's pretty hard to say, so let's just call it APAP. And that is normally metabolized through glucuronidation. And those are just two fancy words to say the primary phase 2 metabolic pathways in the liver that detoxify a wide array of endogenous compounds and foreign substances. They're called xenobiotics. So an example of those would be drugs, right? And by increasing the water solubility for excretion, they're able to detoxify stuff. All right, now conventionally, these are viewed as harmless, usually just inactive metabolites, and some conjugated proteins or some conjugated products can remain biologically active and become toxic. But we need to know the mechanism here. Like, it's super important to educate yourself about this. So a small portion via the CYP450 enzymes, especially CYP2E1, this guy right here, are going to be generating NAPQI. And that is a highly toxic metabolite. But usually the glucuronidation and the sulfation is like non-toxic. But there is this toxic metabolite component. But normally you have glutathione, and that neutralizes this guy, right? So it's like, hey, no worries, no big threat. But if you take a ton of this extremely difficult to say kind of thing, then you can get hepatocellular necrosis. And a big sign of the massive elevation of the AST and the ALT are going to present. It's going to be like greater than 1,000. And so you got to give them N-acetylcysteine, NAC, which replenishes glutathione. I felt inclined to kind of just put that out as a PSA so people know what this extremely difficult to understand medicine is. Yes, I'm being sarcastic. And instead of feeling fear, you should feel intrigue and curiosity, and you should pick up some science textbooks and just learn about the mechanism of action of these drugs. And you won't be as afraid. Oh, and then also I realized that I said AST and ALT, but I didn't really explain what those are. AST is a aspartate aminotransferase, and that is the enzyme that's found in many, many tissues. So the liver, the heart, the skeletal muscle, the brain. And so you might be asking, okay, well, cool. Why is the AST high in a liver injury? Well, in hepatocellular injury, like acetaminophen overdose, you have hepatocytes that die, right? You get necrosis from NAPQI that we talked about, toxicity. And of course, this is an extremely high doses. And then that causes the cell membranes to literally just break down. And then you get AST and ALT that just leak into the blood and the enzymes will spike. And that's how you get it all the way up into the thousands if you take a huge overdose, but you have to be taking tons. Like they'll say, it's like, oh my gosh, 16, 18 tablets, crazy amounts. And no, you will never be asked about autism and the link there, because that is fake science. And look, I always encourage everybody to study these things relentlessly. Don't take anybody's word for it. But the US Food and Drug Administration from Yale School of Public Health, as of 5 days ago, and the CDC continue to recommend acetaminophen as the safest over-the-counter pain relief for pregnant women. And the studies, as far as I can tell, suggest correlation, but no proof at all that acetaminophen causes autism. So no causal link, that is to say, has been found in 2025 between acetaminophen and autism. Now, other factors like fever during pregnancy could be a risk for neurodevelopmental delay or genetics or other illnesses as well. But it's so important to know that correlation is not causation. And now they're doing a lot of like global studies on acetaminophen's effect on. In this paper, they're doing like 6 different areas of child neurodevelopment. But yes, it is still the safest over-the-counter pain reliever in pregnancy. Now, I will say that NSAIDs are not recommended after 20 weeks. Due to fetal risks. But the bottom line is always that you're going to use the lowest effective dose for the shortest duration. And also untreated pain and fever in pregnancy is more dangerous than taking acetaminophen. And there definitely needs to be more research before we say absolutely insane things to the public without having the facts to back it up. And by the way, the NSAIDs, just because we're preparing for step 1, would be like ibuprofen, naproxen, and aspirin high dose. That stuff, it works by inhibiting the cyclooxygenase 1 and 2. That's the COX 1 and 2 pathways, which decreases prostaglandin synthesis, and that leads to reduced inflammation and pain and fever. And so why 20 weeks, right? So why avoid NSAIDs after 20 weeks? Well, after 20 weeks, NSAIDs can cause fetal renal dysfunction because you decrease the urine, and that causes oligohydramnios. And so the fetal kidneys make most of the amniotic fluid. And so if you decrease the urine, if you have few urine, oligohydramnios, then you have decreased amniotic fluid. And then also after 30 weeks, then you have risk of premature closure of the ductus arteriosus. And that's normally kept open by what? The prostaglandins. So you shut it. And that leads to fetal pulmonary hypertension and cardiac complications, right? So there are like legitimate risks. It's not like people are just like saying don't do stuff or do stuff. Like by and large, people are trying to, I know I'm literally preaching to the choir right now. Like you guys are all going to become physicians, but maybe all the more reason to just stay informed and learn as much as you possibly can about these mechanisms and stay up to date. I like the Yale School of Public Health. Let's just say there are some other less reputable anything goes sites out there. Next up, we have a 45-year-old man participating in a physiology study where isolated skeletal muscle fibers are subjected to various Patterns of electrical stimulation. The experiment utilizes a setup that records the force output of the muscles in response to the stimuli delivered at different frequencies. During one part of the study, the muscle is stimulated at intervals mimicking normal muscle twitch, muscle tetanus, and various submaximal tensions. Oh, submaximal, so just like not the highest tensions. Given tracings observed, when is the calcium uptake by the sarcoplasmic reticulum expected to be at its peak, allowing the muscles to fully relax? All right, let's talk about muscle relaxation, something that we do not get enough of as medical students for sure. That occurs, I know it's very rare for us, when calcium is actively pumped back into the sarcoplasmic reticulum, right? That's the process. The calcium goes back, and it is the fastest and most complete during the isolated muscle twitches with adequate time between contractions. Okay, so we have to know how the skeletal muscles contract and relax, the role of calcium in all of that, and the sarcoplasmic reticulum's role in releasing and reabsorbing that calcium. And so let's just talk about the calcium flow in the muscles, shall we? So if we dive down into the muscle, we will see, but you didn't know that it goes this far, but it does. There's a stimulation phase, and that's where action potentials, they open the voltage-gated calcium channels in the sarcoplasmic reticulum, and that causes the calcium to flood the cytoplasm. So now we got all this calcium in the cytoplasm, and then we go to the contraction phase. We move from stimulation to contraction. And so that calcium is going to bind to troponin C. All right, so we're binding to troponin C, and the tropomyosin then shifts, and you get the myosin-actin cross bridge, and that leads to the contraction. And now this relaxation phase, which is what this question was actually asking about, this occurs when the circuit pumps actively to return the calcium ions into the sarcoplasmic reticulum, hit that reset button, the cytoplasmic calcium then decreases and the muscle relaxes. All right, that's where our answer is during individual twitches with sufficient time between each stimulus. And SERCA, by the way, just stands for Sarcoplasmic Endoplasmic Reticulum Calcium ATPase. It's just that transmembrane pump that actively moves the calcium from the cytosol back to the sarcoplasmic reticulum in skeletal and cardiac muscle after the contraction occurs. So here's our bottom line. Calcium uptake peaks during individual twitches and sufficient time between stimuli, allowing full muscle relaxation. All right, this next question is kind of like the last one. 25-year-old male athlete presents to the laboratory studying the skeletal muscle, and his right bicep is isolated, and you get the stimulations, and we measure at different frequencies over a period of 10 minutes. As the frequency of stimulation increases, muscle's ability to completely relax diminishes. At which frequency is the sequestration of calcium into the SR expected to be most complete? All right, I know it's been a while since we've taken science classes and the MCAT, so it's been a while for me too. It stands for Hertz. And that just means the amount of times per second. So 1 Hertz is 1 event per second. 2 Hertz is 2 events per second, which arguably, if I'm getting really excited, I talk at like 3 or 4 Hertz per second. Just kidding. Just, events per second, right? So 10 Hertz, 10 events per second, you get the idea. It's just a fancy word for frequency. It's how often something happens. And so in muscle physiology, when a question says there's stimulation at 5 Hertz, what they're saying is the muscle is being zapped 1, 2, 3, 4, 5 in 1 second, right? And so if you clap your hands once every second, then that's 2 Hertz. If you clap 10 times, then that's 10 Hertz, right? That's really fast. And we've kind of gone over this, but a higher frequency means there's less time between the contractions. And so there's the calcium that accumulates, and you get the summation of the tetanus. And so the lower stimulation frequency would have the most complete calcium sequestration and the most complete relaxation between the twitches. So our answer is 0.5 Hertz. And remember that the whole sequestration thing that can be confusing, that's just meaning like trapping or the isolating or storing of something. And so in muscle cells, after contraction, the calcium is taken back to the sarcoplasmic reticulum, and that is the sequestration process. So the S is just tucking the calcium away by the circa. All right, so think of calcium like confetti that you throw after a party, and then you need to go clean it up and you have to put it back in the box. That's sequestration. And if the party is happening every single second, then you don't have time to clean, and so there's going to be confetti everywhere. And so then the 0.5 Hertz is like super slow, whereas the 20 would be super fast. Cool beans? Hopefully that was a nice kind of way to round out that question. Here's the bottom line. Calcium sequestration into the SR is complete at lower stimulation frequencies like 0.5. In this question, a 45-year-old woman presents to the emergency department with complaints of swelling and pain in her left hand and forearm over the past month. MRI has a bone growth at this C7 vertebrae, causing compression, and surgery is planned. Which nearby structure is going to be preserved or should be most carefully preserved? And honestly, this is kind of a subjective question, but allows us to talk about a lot of things. So the C7 transverse process, and for this one, I'll actually give you 2 answers. And so first, let me say, if a patient has a cold hand and numbness, then you should also be thinking about the arteries. And she's got a bone growth at her C7 near the thoracic outlet, and that's compressing the nerve and the blood supply. And so there's an argument. There's a very strong argument for the subclavian and the axillary arteries. Like, I'll give you both of them. But the vertebral artery passes through the transverse foramina of the cervical vertebrae, and that starts at C6. And so C7, the artery is really in the danger zone there. And so if you're doing a surgery to remove that growth, you could damage the vertebral artery, and that leads to a posterior circulation stroke. And so I'd probably be more partial to that answer. However, I completely understand if you said left subclavian artery as well, because that's super reasonable as well, just based on like real life surgical anatomy. But I do think the vertebral artery is the better bet just because it focuses on the C7 vertebrae, especially if we're talking about like the transverse foramina or the bony growth of C7. But just to make this like not confusing at all, the subclavian artery passes between the anterior and the middle scalene lateral to the C7, and the vertebral passes through the transverse foramina of C6 to C1. That's pretty close to the C7. The subclavian obviously supplies the arm, and the vertebral will do the posterior brain circulation. And again, I will totally give you subclavian artery because that is anterior to the scalene muscles, and it can be compressed in thoracic outlet syndrome, but it's a little bit less likely to be injured during like a vertebral surgery, but still it's possible. And then remember as well, thoracic outlet syndrome, and that can compress the brachial plexus and the subclavian artery and also the subclavian vein. But the surgery of the C7 would probably be the vertebral. So you have that bony overgrowth, right? The neurovascular bundle is affected. Blood supply to that hand is affected. And surgical resection then puts the vertebral artery at direct risk. Other things like the ulnar artery would be distal to the forearm and the wrist. Axillary artery would be lateral and below the clavicle. Radial would be the distal forearm and the wrist, and that's irrelevant here as well. All right, now with that being said, if you have a cervical rib surgery, then that would lean you more toward thoracic outlet syndrome. And the subclavian artery travels adjacent to the cervical rib and the scalene muscles. So cervical rib, you should think of thoracic outlet syndrome, especially compression of the brachial plexus. And here's the pathophysiology, and there are the key features for that. Hello, everybody. Welcome back. Today, we are covering everything you need to know by the time you finish MBME 28. I've made a couple of updates for longtime members of this channel. Over here, you'll see a patient demographic. Over here, you'll see an AI-generated image. And over here, you'll see a diagram that I've pulled online. And down below, you'll see the most high-yield takeaway, the bottom line, if you will, what you need to know for step 1. This is me, and this is the field wherein I'll be doing the work. All right, so here we have a full-term newborn delivered via a spontaneous vaginal delivery. Within minutes, the baby becomes cyanotic and demonstrates severe respiratory distress, including nasal flaring, intercostal retractions, and tachypnea. On examination, the infant has a flat, scaphoid abdomen and diminished breath sounds on the right. A chest radiograph reveals bowel gas patterns occupying the right hemothorax and mediastinal shift to the left. Despite intubation and oxygen administration, hypoxia persists. Which of the following complications is the most likely to determine the infant's immediate prognosis? Okay, the answer is going to be persistent pulmonary hypertension. So pulmonary hypertension is the life-threatening complication of congenital diaphragmatic hernia. The lungs are underdeveloped, and you have reduced vascular beds, and so oxygenation is poor. So here we have congenital diaphragmatic hernia, which leads to pulmonary hypoplasia. And we know this because the scaphoid abdomen, which is where the abdominal contents are going to herniate into the chest, and so the abdomen starts to appear pretty shrunken. And this will appear during the neonatal period with respiratory distress due to herniation of the abdominal contents into the thoracic cavity. So it goes from down here all the way to the thoracic cavity. And this is most commonly through the foramen of Bacterial, which you don't need to know, but it's the posterior lateral defect. And it's usually on the left side, but right-sided can also be possible. And so the hernia compresses the developing lung, and that leads to pulmonary hypoplasia. And so you have an underdevelopment of the alveoli and the pulmonary vasculature. And that can result in decreased lung compliance, pulmonary hypertension, and severe hypoxemia and acidosis. So pulmonary hypoplasia is the most common life-threatening complication in this scenario because it compromises the gas exchange and rapidly leads to respiratory failure. Bowel sounds in the chest would be classic for herniation through the diaphragm. Respiratory distress at birth would show immediate signs of hypoxia. Mediastinal shifts would occur from the mass effect. And the reason why is the hernia is compressing the developing lungs. All right, here are the associations. Here's the pathophys that we talked about. The diaphragm doesn't close, and so the abdominal contents enter the thorax, and you get some hypoplasia of the lung, hypoplastic pulmonary vessels, and persistent fetal circulation from right to left shunting. So here's another helpful practice question. So pulmonary hypertension is the most life-threatening complication of congenital diaphragmatic hernia. You have lung underdevelopment, reduced beds, high pulmonary resistance, which leads to the persistent fetal circulation with right to left shunting. The answer is not encephalopathy. There you would see some seizures. It's not neonatal sepsis. That'd be associated with abnormal white blood cell counts. And it's really due to that failure of the diaphragm to close, the compression of the lung buds causing the hypoplasia, the underdeveloped pulmonary arteries, and the right to left shunting that then occurs. The most dangerous complication right now is going to be persistent pulmonary hypertension because of high pulmonary vascular resistance. Not sepsis. You don't have any signs of sepsis, not tracheal stenosis. There's no stridor, not pulmonary hyperplasia. Although that could be relevant, it's not the most dangerous immediate threat. And hypoxic encephalopathy would be after the prolonged hypoxia. So pulmonary hypoplasia is a decent answer, but persistent pulmonary hypertension would be the most dangerous immediate complication. Okay, in our next question, we have a 28-year-old woman delivering a full-term male infant via uncomplicated vaginal delivery. The mom has poorly controlled gestational diabetes managed with diet and insulin. The newborn is noted to be large for his age and weighs 4,500 grams, 9 pounds, 14 ounces. Approximately 2 hours after birth, the infant becomes jittery and irritable. Bedside glucose measurement reveals blood sugar level of 25, which of the following processes was most likely altered in the fetus prior to delivery. Okay, here are your answer choices. Now, the mom has poorly controlled gestational diabetes, and so we'd refer to this as an infant of a diabetic mother. There's macrosomia, which refers to a baby being larger than the average. Usually it's defined as a birth weight that's over 4,000 grams, so like over 8 pounds, 13 ounces. And this increases risks for both the mother and the baby during delivery, like birth canal trauma for the mom or birth injuries, such as like a shoulder dystocia. And this is commonly due to the maternal obesity and the excessive weight gain during pregnancy and diabetes. But not to get too ahead of ourselves, what is contributing to this? In gestational diabetes, the maternal hyperglycemia leads to increased transplacental glucose transfer over to the fetus. And so the fetal pancreas responds by increasing the insulin secretion, and you have fetal hyperinsulinemia. And the insulin acts as a growth factor, right? And that explains the macrosomia. Why is the baby super big? Because of the insulin. Why is there insulin? Well, because the fetus has a pancreas, and it's responding by increasing the insulin whenever it has a lot of the glucose that gets transferred through the placenta. And so after delivery, the maternal glucose supply ceases, but the insulin is still going to remain elevated. So what's going to happen? You're going to have rapid glucose uptake and the inhibition of gluconeogenesis and glycogenolysis. And so the result is you have a neonatal hypoglycemia that presents as jitteriness, irritability, lethargy, and even seizures. All right, so increased lipolysis, that would be decreased in this fetus. All right, so increased lipolysis, the insulin inhibits lipolysis, and so that would be decreased in the fetus. Increased gluconeogenesis, insulin inhibits gluconeogenesis, right? You have glucose and insulin causes the reuptake of glucose, and so it's going to inhibit this process. Increased pancreatic beta cell sensitivity. Well, the issue is not increased sensitivity, it's increased insulin production due to chronic hyperglycemia, and so that's not the answer. D, increased hepatic glycogen storage. While the insulin promotes the glycogen storage, the key driver of hypoglycemia is persistent insulin secretion, not stored glycogen alone. So that's the correct answer is indeed E. So yep, we have a diabetic mother, develops hypoglycemia due to the persistent fetal hyperinsulinemia. In utero, maternal hyperglycemia stimulates fetal beta cells to secrete excess insulin. After birth, maternal glucose stops, and then the insulin is high, and that causes super low glucose, and that's the consequence for poor glycemic control in pregnancy. We went over these answers here. And so here's the mechanism. The mom has uncontrolled diabetes, her blood sugar is high, the glucose crosses the placenta, and the fetal pancreas ramps up the insulin, and you have fetal hyperinsulinemia. And then at birth, that glucose supply is gone, but the baby's pancreas is still pumping out the insulin. And so you have a huge glucose crash. And so the babies have jittery, irritable problems, and they're hypoglycemic within hours after birth because they're not attached to all of that glucose stream like they were before. In other words, mom. And the insulin also relates to that growth factor, and that's why they have macrosomia. You have a big, huge baby. All right, guys, be sure to like and subscribe, especially if you like this new format where I have essentially I've got 4 study aids for every single question, and each question is completely new just for you. So on to my 33rd original question. Here we have a 45-year-old research scientist studying activation of DNA polymerase enzymes in human epithelial cells under various conditions. During his experiments, he observes that before progressing to the phase where DNA synthesis takes place, there is an increase of transcription of specific genes leading to the production of proteins involved in DNA replication. In which phase of the cell cycle does this increase in protein synthesis occur and prepare for the DNA replication? All right, so this is a question about DNA replication preparation, increased transcription, protein synthesis, all of that good stuff. And so we have to talk about the cell cycle for a larger context. So let's start right here with our G1 phase. And here, the cell grows and it prepares for DNA synthesis. That's the G1. The key activities there are going to be increased transcription and translation of proteins that are required for DNA replication, and that includes DNA polymerase, nucleotide biosynthesis, and replication of the licensing factors. And there are checkpoints to ensure that the environment in the DNA is suitable. Okay, and then we can progress on over to the S phase. So now we're into our S phase, and that's where the actual DNA synthesis takes place. And you can remember this because the S stands for synthesis. So you have DNA polymerases that are already active in replicating DNA, and they're not being newly synthesized. And then we go on to our GS phase. And the GS phase is where we prepare for mitosis. And you have a focus that your focus shifts to synthesis of the proteins that are required for mitotic progression, not necessarily DNA replication. So G2 is really preparing for this next phase, which is the M phase. And that's mitosis. That's where you have the cell division. And there's no transcription, there's no translation of the DNA. And then we have our quiescent phase, which we had a question on this not too long ago. And that is our G0 phase. That's the resting state. So now you're just chilling, having a good old time resting. There's no active preparation for DNA replication. All right, so G1 is that phase where we're just getting ready for DNA synthesis. S stands for synthesis. G2 prepares for M, which is the mitotic phase. Okay, and so our answer to this question is going to be the G1 phase, because G1 is the preparatory phase where the cell makes all the enzymes that are required for DNA synthesis. It's not the M phase, that's mitosis, it's when it's dividing, not the G0 phase, that's the quiescent phase, that's non-dividing, not the S phase, that's DNA replication, not the G2 phase, that's post-replication, it prepares for mitosis. And here's the interesting thing, your cells spend over 90% of their time not dividing, but millions are prepping meticulously to copy their DNA. And the scientists are like, hey, before DNA polymerase kicks into gear, the cell ramps up its transcription of replication-related genes. The transcription surge does not happen in the G1 phase, that happens in the S phase. It does not happen during the M phase, that's mitosis. And it certainly doesn't happen in the quiescent phase, not the G0. The G1 is when the cell preps. It gears up and it produces proteins like DNA polymerase, thymidine kinase, and histones. All right, moving on. And as always, here's our bottom line. Make sure you check that out. It's going to be updated for every single question so that you know what the high yield takeaway is. By the way, these videos take hours of work. If you want to show your support, please like and subscribe. All these questions are completely original and designed to just help you pass step 1. And I know a lot of you guys are studying for step 2 as well. You're studying for MBMEs 29, 30, 31. It takes a long time for me to make original questions for all of these. So please, if you like and subscribe, trying to get up to 1,000 subscribers. It'll really help me and support me as I make over 1,000 original questions for you guys. Also, be sure to visit ivmed.net. I'm building a free resource that you guys can study for this exam completely free of charge. If you'd like a Harvard tutor like myself to meet with you in a one-on-one session, please visit ivtutoring.net, fill out that form, and I'll help you guys. None of this is sponsored. I'm just doing this because I'm passionate about it. This is not where I get my main income. I just love the basic sciences, and I love helping people crack this silly exam. All right, on to our next question. Thanks for your time. Okay, here we have our next question. A 20-year-old college student, as you can see, I've given you 4 different tools that you guys can latch onto, as well as this practice question, and then I'll be explaining it right here. This 20-year-old is unresponsive on the floor of his dorm room. Earlier that day, he participated in a competitive drinking challenge during a weekend festival. His friends report that he consumed a significant amount of water, approximately 8 liters, talk about polydipsia, in a short span of time. On examination in the emergency department, he is somnolent and withdraws to painful stimuli. Here are his vitals. There's his pulse, respiratory rate, blood pressure. We also have several labs, sodium potassium chloride bicarbonate, all the good stuff. Which of the following is the most likely cause of his current condition? Now, I kind of gave this away, but there are a lot of basic science facts that are important. And the basic facts here are that we have a college student and they had a water drinking party. They probably attended BYU, not an actual drinking party. And what's interesting here is the serum sodium, check that out, 118. Okay, so a little bit low, right? There are also some neurologic problems. And so that leads us to believe that what's happening here is the excessive water intake is what's caused this. And this is actually known as dilutional hyponatremia. And that is cool to know, but what they're probably going to ask you as well is the mechanism. So this is cerebral edema, and that's due to the osmotic water shift in the brain cells. And so you have neurological symptoms like somnolence is a neurological symptom, confusion is a neurological symptom, seizures and coma, for instance. And so this guy's kidneys cannot excrete the water fast enough. In fact, the max urinary dilution is about 15 to 20 liters per day. And so the max rate is 0.8 to 1 liters per hour. And so there's excess water, and that dilutes the plasma sodium, and that's the reason why the sodium appears low. It's because of all that water. Now, it's not the excessive sodium loss, because that would also cause hyponatremia, but that would also be associated with like vomiting, diarrhea, diuretics, and also signs of volume depletion. And it's kind of the opposite, right? C, increased aldosterone activity, that causes sodium retention, right? So it wouldn't cause loss. D, SIADH, that can cause euvolemic hyponatremia, but it's not likely in a healthy person after drinking, and especially because they're not taking any drugs. And so there's just no real reason to think of D. E, inadequate dietary sodium intake. That would take days to weeks to cause hyponatremia. And this is like a super acute presentation. So this is just too much water, and then the brain is going to swell. And so you have acute water intoxication, and that's severe hyponatremia, and also you have that CNS depression. All right, so here's the explanation. You can kind of read this, pause and read this if you'd like. I kind of already went over a lot of these answer choices. Oh, inadequate dietary, that'd be a tea and toast diet. That's important to mention. SIADH would be like small cell cancer, problems like that. Euvolemic hyponatremia we mentioned. There was a woman on a radio show who was like drinking insane amounts of water, and she actually died. Crazy. Drink too much water, you overwhelm the kidneys. Water rushes to the brain cells, and then you have cerebral edema. So that's the answer to this question. Moving on. All right, next we have a 42-year-old man. He's got a history of obesity and newly diagnosed type 2 diabetes. By the way, do you guys prefer it if I do this demographic patient right here? Because this is actually a picture of this patient, or would you prefer if I expanded and showed more demographics? Just let me know. I think in the future, I'm probably just going to show the actual demographic of the question so as not to confuse anybody. But I digress. Obese, 42-year-old type 2 diabetes. He's got minimal physical activity and a diet high in carbohydrates and fats. His current medications include lifestyle modifications. So basically no medications. Physical exam reveals central obesity, big old waist. Laboratory studies reveal fasting glucose of 150 and hemoglobin A1C of 8. So that is actually high. And they decide to start metformin, which of the following is the primary mechanism by which it exerts its anti-hyperglycemic effect. So this is just asking, how does metformin work? And it's actually a really easy question, or I should say a memorization question, because it's not like you're just born with this knowledge. You just have to actually memorize it. By the way, medical school is not about how smart you are. It's just about how much you care about this content. It's like eating 11 pancakes every day. Anybody can do it. It's just if you get behind a day or 2 days, then you can't eat 22, 33 pancakes, right? Nobody can do that. It's just a collection of a bunch of easy facts that is soon going to be replaced once the medical profession starts to embrace artificial intelligence. But I digress. The primary effect of metformin, since we have to know it for this question, is that it inhibits hepatic gluconeogenesis, and it does that by activating the AMP-activated protein kinase. And so you have decreased hepatic glucose production and decreased glucose levels. Also, it increases peripheral glucose uptake in the muscle. And it decreases intestinal glucose absorption. And it does not stimulate insulin secretion. So there's no risk of hypoglycemia when you use it alone. Now, you might be asking about the other answers like A, stimulating pancreatic beta cell function. That's the mechanism of sulfonylureas. So like a glipizide, not metformin. B, enhancing insulin receptor sensitivity. Metformin has some effect there, but this is actually secondary. And the main action is gluconeogenesis and inhibition. So that's the better answer. D, blocking glucose absorption in the intestines. So that's the mechanism of alpha glucosidase inhibitors like carbos. And E, decreasing renal glucose reabsorption. That's the mechanism of SGLT2 inhibitors like the flozins. They decrease the renal glucose absorption. They let it flows in the liver. All right, so metformin acts on the liver and it makes it stop making sugar. So the answer is indeed C, inhibiting that gluconeogenesis. It primarily works by decreasing the glucose production through the inhibition of gluconeogenesis. It's mediated by the activation of AMPK in the liver, which suppresses the gluconeogenic genes, stimulating pancreatic beta cell insulin secretion, enhancing insulin receptor activity, insulin sensitizer, blocking glucose absorption, acarbose, decreasing renal glucose reabsorption, let it flows in the renals, let it flows in the urine, flozins. So the liver of somebody with type 2 diabetes churns out twice the normal amount of glucose, and metformin's job is to block that excessive liver glucose production, and it does that by activating AMPK. Once that's activated, it's like, hey, liver, you got to stop. You're making too much. No more gluconeogenesis. All right. So there's a patient. All right. There's the bottom line. That's what you have to know for step 1. Moving on. Here we have a 30-year-old woman is found unconscious in her home by a roommate, and she is brought to the emergency department. The roommate reports that she's been increasingly somnolent. It's a CNS problem here. Over the past few days after receiving medication for dental procedure, on exam, she has respiratory rate of 8 breaths per minute, pinpoint pupils. All right. So this is like opioid stuff. And they're just going to ask very simply, hey, which receptor type when activated is responsible, and you just have to know is the mu opioid receptor. This is like a really simple kind of memorization question. So they're having opioid overdose. How do you know? CNS depression, low respiratory rate, and meiosis. That tells you it's mu. Delta is involved in mood regulation. Kappa is dysphoria, Psychotomy effects, the inability to feel some pain, and minimal respiratory impact. Whereas the mu opioid receptors, these guys are responsible for analgesia. So that's actually a commonality there, but also euphoria, respiratory depression, and meiosis, and reduced GI motility, so constipation. Overuse would be an excessive mu receptor activation in the medullary respiratory centers. And so you have decreased respiratory rate, that's the bradypnea, hypoventilation, and unconsciousness. All right, the sigma here, this isn't a classidopa receptor. This is involved in psychotomimetic effects like hallucinations would be sigma. NDMA in the back garden. I just think of that song with Lord. And MDA receptors. These are involved in pain modulation and synaptic plasticity. And so there are some opioids that actually do interact here, like for instance, like methadone would act there, but they're not primarily the cause of respiratory depression. The main cause is the mu receptor. It's the main culprit for meiosis and respiratory minimization. So it's respiratory depression. And that kills like tens of thousands of people every single year. It's the mu receptors in the medullary respiratory centers. And you know the pinpoint pupils, the respiratory rate is low, and the CNS depression tells you it's opioid toxicity. It's not the kappas, because that would alleviate pain, but it actually opposes the reward signaling pathway, and so it can cause dysphoria. And also, it doesn't change the respiratory rates, so you wouldn't have respiratory depression with kappa. Here's the next question. We have a 6-year-old boy is brought to the clinic by his parents due to concerns about early signs of puberty. His parents report noticing the rapid growth, development of facial acne, and deepening of his voice over the past few months. Physical exam shows a tall stature for his age, coarse pubic hair, and increased muscle mass. Laboratory shows increased testosterone, could have told you that, and low luteinizing hormone levels. Okay. Ultrasound of the abdomen identifies a mass in the adrenal gland. This mass is most likely derived from which of the following cell types? And here we have all of them listed. So 6-year-old boy, early puberty, high testosterone, low LH, and adrenal mass. Those are the big indicators of this case right here. And so this seems like a classic case of gonadotropin-independent or peripheral precocious puberty. This is also called pseudo-precocious puberty, and it's likely due to a functional adrenal tumor. And the key lab is going to be the increased testosterone and the lower LH. And the lower LH is due to the negative feedback, not the central origin. And there's an adrenal origin of the androgens, right? So the zona reticularis of the adrenal cortex actually produces the androgens like DHEA and that can be peripherally converted to testosterone. And so if you have a tumor in the zona reticularis, then that could cause androgen excess, like premature pubarchy, which is like the pubic hair stuff, the growing acceleration, the deepening voice, the acne, the muscle mass. That's how your body works. It's always science all the way down. We have to eliminate our biases whenever we're diagnosing patients. There's also the zona glomerulosa, remember GFR. The zona glomerulosa produces aldosterone, and aldosterone would be helpful for your salt balance, not your androgens. The adrenal medullary, the adrenal medulla cells, those guys produce catecholamines like epinephrine and norepinephrine. So if they were asking about the catecholamines, it would be in the medulla or the medulla. And the renal tubular cells are involved in urine formation, not hormone production. And the zona fasciculata, that is our F that we have not mentioned yet, that produces cortisol. And that's involved in the stress and glucose metabolism. And they like to say this gets sweeter as you go because it's salty, and then it's sweet, and then it's sexy. So it gets sweeter as you go is the mnemonic, helpful for remembering zona fasciculata versus the granulosa versus the reticularis. And so this is the reticularis because the DHEA, sexy testosterone, is the defect here, and so it's going to be the zona reticularis. Now, they could also mention that this could be a female, and I want to talk about granulosa cell tumors. The location is the ovary, hormone is estrogen, and it's found in precocious puberty, but it's going to be in a female. So granulosa cell tumors are malignant ovarian sex cord stromal tumors that secrete estrogen. You have the call external bodies, the small eosinophilic fluid filled spaces in the granulosa cells. And so inhibin has elevated levels would be produced by the granulosa cells, and that can serve as a tumor marker. Endometrial hyperplasia would be due to the chronic unopposed estrogen. Turner syndrome, they're monitored closely for ovarian pathologies because of their gonadal dysgenesis. And the pathophys of a granulosa cell tumor is that the tumor arises from the granulosa cells, produces the excessive estrogen through the aromatization, and that leads in children to early development in females here, and in adults, endometrial proliferation and hyperplasia, and estrogen acts on the endometrium, breast, and the HPA axis. And how they might ask you about that is they'll say, hey, there's a 7-year-old girl. She's got breast development, vaginal bleeding. Biopsy shows proliferative endometrium, which the following is the likely the tumor. It's going to be the granulosa cell tumor. A dysgerminoma would be LDH marker. Yolk sac would be AFP elevation. Sertoli would produce androgens that causes virilization in a female. And mature teratoma would be benign. All right, here we have a 28-year-old man evaluated for potential liver transplant donor from his 30-year-old sister suffering from end-stage liver disease due to primary sclerosing cholangitis. Genetic testing shows that the brother is HLA A1, A3, and HLA DR7, DR15 positive, while the sister is HLA A1, A24, and HLA DR7, DR14 positive. To assess all potential activity, alloreactivity, a mixed reaction is performed using the irradiated cells from the brother and responder cells from the sister. The T lymphocytes that proliferate in these cultures will most likely react to which of the following as well. Kind of a complicated question here. So the way that this will present on the step exam is they're going to have mixed reaction and then a liver transplant and irradiated donor cells and responder recipient T cells. And they're going to be asking about the alloreactivity. So a mixed lymphocytic reaction, MLR, is used to detect the T cell reactivity, especially in CD4 positive T cell response to a foreign class 2 MHC molecule, right? So CD4 plus your helper cells, helper T cells responding to foreign masses of MHC2 molecules. And so in this case, we have the donor who's the brother, and he's got the HLA, so I'm going to write this out like the brother. He's got the A1 and the A3 and the DR7 and the DR15. And then the sister is the recipient, and she's got HLA, A1, A24, DR7, DR14. And so the mixed lymphocytic reaction is set up where you have an irradiated donor cell. That means there's like no proliferation, there's no present antigens, and the responder recipient T cells can proliferate in response to the non-self HLA. And then you go and compare the class 2 MHC, major histocompatibility complex 2. You're looking at the HLA DRs, and they will both share, if you see here, the DR7. And that recognizes as self. But the sister has a DR14, and the donor does not. And so it's not going to be as relevant here because the recipient will respond to her own DR14. But the donor, what does he have? DR15, and the sister does not. And so the recipient T cells are going to see the DR15 that the brother gives. They're going to be like, oh my gosh, that ain't me. They're going to proliferate, and that will occur in response to DR15. And so looking at these answer choices, 14 only, that's shared between them. And the one that's not is the DR15. The 7 is shared. A3 only, A24 only. Those are going to be class 1 MHCs. And we're testing the class 2. And so it's going to have those 2 letters for 2 and then 1 letter for 1. And so that's the reason why it's not going to be C and D. It's a common mistake to be like, oh, why isn't it those? Well, here we're just testing here our T, MHC class 2s. And so ideally you should match all of the HLA loci. Like that's the theoretic perfect match. But in a mixed lymphocytic reaction, you're going to react to whatever somebody gives you that you're not prepared for, if that kind of makes sense. Maybe that's an easier way of thinking about it. All right, in our next question, we have a 55-year-old woman admitted to the hospital for acute myocardial infarction. Her medical history is significant for hypertension and type 2 diabetes. Cardiology team prepares her for urgent percutaneous coronary intervention, and they give her aspirin and also medication that inhibits the final pathway of platelet aggregation by blocking the binding of fibrinogen. Which of the following medications is most likely administered? All right, we got a lot of fancy smashy medications here, so I don't want to immediately give away the answer. And so what we're talking about here is what inhibits that final step of platelet aggregation. The aggregation, I've just updated that patient demographic photo, is going to be involved in this final aggregation step, the GP2B3A receptor. The fibrinogen can't bind because it normally links the platelets together via fibrinogen, and it's used in PCI, so acute coronary syndromes. So you have an acute coronary syndrome, and this is actually derived, what you're going to give them, derived from rattlesnake venom. And what this is eptifibatide. It's a GP2B3A inhibitor in acute myocardial infarction. And so that is our answer A. And so we have a patient who has an acute or PCI, and we're inhibiting the final pathway of platelet aggregation. We're blocking fibrinogen binding. And so A is a glycoprotein 2B3A receptor antagonist. And so this receptor, the 2B3A, is the final common pathway for platelet aggregation, and it binds fibrinogen, which cross-links the platelets, and that block would prevent the platelet aggregation. And so that's super critical if you're doing a PCI to reduce the risk of thrombosis. Now, why is it not B or C? Well, those would both inhibit the P2Y12. You're probably familiar with that receptor, and that reduces the ADP mediated platelet activation. And it's important in antiplatelet therapy, but they act upstream and not on the final fibrinogen binding step. So these could be some good answers if we're talking about the P2Y12 receptor that reduces the ADP mediated platelet activation. All right, it's not warfarin because that would inhibit vitamin K dependent clotting factors. That's 2,7,9,10, and that affects coagulation. Rivaroxaban is a direct XA inhibitor. You can tell because it's in the name, XA inhibitor. And that is direct XA inhibitor, and it affects the coagulation cascade, not the platelet aggregation. So we're really talking about the final fibrinogen blocker. It's the 2B3A inhibitor, so you should think of the TIDES, or tirofiban, or abiximab. All right, there's your bottom line. Make sure to memorize that. Bada bing, bada boom. All right, next we have an X-linked recessive disorder that affects approximately 1 in 250,000 males. A researcher is interested in estimating the prevalence of female carriers, and assuming this is Hardy-Weinberg equilibrium, what is the expected frequency of heterozygous female carriers? All right, so this is just a simple little math question. Actually, it's focused on genetics at Harvard. So I've done a lot of Hardy-Weinberg questions, but it gets easier over time. Basically, what happens is we have, for X-linked recessive disorders, a male prevalence of Q. And just by the way, the P is the frequency of the dominant allele, and then Q is the frequency of the recessive allele, and 2PQ is the probability of heterozygosity. And so here we have, given that Q is equal to 125,000, or rather Q is equal to 1 in 250,000, the expected frequency of the heterozygous female would be 2Q, which is 1 over 125,000. And the reason why we do this is because we're using Hardy-Weinberg's approximation, where P plus Q is equal to 1. And if Q is super, super, super small, then that means P is super, super big or close to 1. And so it's just going to be P is approximately equal to 1. And so it just cancels out. Now we have 2Q is equal to 1 over 125,000. And that is why our answer for this question is C. All right, easy peasy lemon squeezy. All right, there's your bottom line right there. Let me know if you guys like this new format. I hope it's helpful. It's just essentially just a little bit more work for each question, but you get a bit more bang for your buck. I make sure to read all of your guys' comments and all of your suggestions. Please be sure to like and subscribe if you like this content, and we'll see you guys in the next video. Hello, everybody. Welcome back. I drew a picture of you just now. That's you getting super swole. And if you zoom in, you can see this is also you passing step 1. Friendly reminder that you can do it. In our first question, we have a 34-year-old woman who presents to the clinic with a 3-week history of fatigue, weight loss, and non-productive cough. She mentions recently renovating an old barn on her property. Physical exam reveals mild hepatosplenomegaly, and a chest CT shows multiple small lung nodules and highly lymphadenopathy. Bronchoalveolar lavage is performed, and the specimen reveals numerous oval yeast forms inside of macrophages. Which of the following environmental exposures is most likely related to your condition? All right, so these are the restated bare bones facts. We have a woman with fatigue, weight loss, cough, hepatosplenomegaly, T showing lung nodules, highly lymphadenopathy. Those are the highlight points right there. And we have a lot of choices, but we have to know what the diagnosis is. And this is histoplasmosis. This is a dimorphic fungus, and it's found in bat and bird droppings. And so renovating old barns disturbs contaminated dust, and that releases spores into the air. And the intracellular oval yeast inside the macrophages and the pulmonary symptoms with highly adenopathy are diagnostic. All right, why is it not something else like desert hiking? Well, that'd be coccidioides immitis. That's the southwest US. That's the valley fever. So it's the wrong geography and the wrong organism. Working with mosquito-infested water, that'd be the West Nile virus or malaria, not fungal infections. There's no vector-based transmission here. Regular exposure to decaying vegetable matter and compost piles. So that would be Aspergillosis in the immunocompromised. Does not explain the macrophage internal yeast or the histoexposure. Gardening and sustaining minor cuts from the plant thorns is sporothrix. That's the rose gardener's disease. All right, so you have the subacute pulmonary symptoms like cough, fatigue, weight loss, and the exposure to the bat and the bird droppings in the caves, the barns, the attics. And on histology, you have the oval yeast inside of the macrophages in Ohio and Mississippi River Valley. And this can cause a disseminated disease in the immunocompromised, like the hepatosplenomegaly. And so what happens is you inhale the spores convert to yeast and form in the lungs. The yeast are phagocytosed by alveolar macrophages, and the organism survives intracellularly, and it spreads via the reticuloendothelial system, and that causes granulomatous inflammation and mimics TB and sarcoidosis. All right, so really watch out for the Ohio and Mississippi River Valleys and the farm spelunking people in old buildings and barns. All right, renovating old barns with bad exposure is linked to pulmonary histoplasmosis indicated by yeast forms in the macrophages. There you go, folks. Here, a 72-year-old man presents to the clinic with difficulty urinating and frequent need to urinate. Over the past several months, he reports waking up multiple times at night to urinate and straining during urination. His medical history includes controlled hypertension, and dyslipidemia is characterized by abnormal levels of lipids in their bloodstream. So like cholesterol, triglycerides, HDL, which is like the good cholesterol, things like that. Sometimes you can have the yellow deposits in the skin, in the eyes, the pain, the cramping in the legs, that kind of stuff. And you analyze that through a lipid panel. But anyways, he denies any dysuria and hematuria in physical examination, and the abdomen is soft and non-tender. But a digital rectal examination reveals an enlarged non-tender prostate. A post-void residual urine volume is measured at 150. Which of the following, oh my gosh, is the patient's condition? This is definitely going to be benign prostatic hyperplasia. So he's got nocturia, straining, and weak stream combined with the enlarged non-tender prostate and a high post-voidal residual that's classic for BPH. The absence of the dysuria and the hematuria, along with the normal DRE, which means there's just no nodules on induration, makes the malignancy of infection less likely. And induration is just the hardening of the tissue. Okay, here's a brief explanation that this answer has. The classic lower urinary tract symptoms, nocturia, hesitancy, straining, increased PVR is BPH. All right, let's look at these urethral stricture stuff. So that's often seen in younger men post-injury or infection. It's less common in the prostatic cancer. So this case has smooth, non-tender enlargement, so it's BPH. What about bladder cancer? Painless hematuria is how that would present, not LUTS, right? Not that stuff. And then UTI would be dysuria, urgency, and fever, and leukocytosis. So I wrote down these things that stood out to me when I was answering this question. And he's like an older dude waking up many times in the night, straining during urination. He feels like he hasn't emptied his bladder because he hasn't. He still has 150 milliliters in there. All this points to an obstruction from prostatic tissue growth, especially DHT-driven hyperplasia of the transitional zone. So the bottom line, enlarged prostate in older men, it's probably BPH. All right, so here we have a 60-year-old woman with type 2 diabetes. She reports adhering to her medication regimen and diet plan. She's been monitoring her fasting blood glucose at home, and it's consistently around 90 mg per DL. During the visit, she asked how her body regulates blood glucose during the fasting periods. Which of the following types of receptors in liver cells is primarily involved in maintaining her stable fasting levels? So we know that this is glucagon associated, and glucagon maintains this via hepatocyte G protein coupled receptors, the GS pathway, activating the CAMP to the PKA to the glycogenolysis and gluconeogenesis. Insulin uses tyrosine kinase, while ligand-gated and toll-like receptors are related to glucose regulation. So whenever you're fasting, glucagon is the main hormone, and glucagon acts on hepatocyte G protein coupled receptors to increase the CAMP, cyclic AMP, and that drives glycogenolysis, and gluconeogenesis uses the RTKs, which is the receptor tyrosine kinases, and then cortisol uses the intracellular receptors, which are slow stress responders, but the primary immediate fasting signal is glucagon via G protein coupled receptors. All right, so why is it not the ligand gated ion channel? That'd be nicotinic acetylcholine receptor, or like GABA. Why is it not receptor tyrosine kinase? Well, that's insulin. That's the fed state. What about intracellular hormone receptor? That's steroids. And toll-like receptor would be pattern recognition receptor in the innate immunity system, not involved in glucose stuff. So when you fast, your blood sugar is stable, and that's because of your liver. The hormone in charge is glucagon, which rises as the insulin drops. And so glucagon doesn't use an insulin-like receptor. Instead, it binds to the G protein coupled receptor on your liver, triggering CAMP, activating PKA, and it turns on the enzymes that break down glycogen, and it makes new glucose. And so that's how your liver keeps your glucose at 90 even when you haven't eaten in a while. Kind of cool. So the bottom line is G protein coupled receptors in the liver regulate glucose homeostasis during fasting. In our next question, a 65-year-old woman with a non-small cell lung cancer has just started treatment via carboplatin and paclitaxel. A week after her first infusion, she visits the emergency department complaining of severe fatigue and persistent diarrhea. On physical examination, she is noted to have thinning hair and pale conjunctiva. Her complete blood count shows leukopenia, anemia, and thrombocytopenia. Which of the following tissues is most likely affected in this patient due to chemotherapy regimen? Okay, so cytotoxic chemotherapy is what this question is about, and that targets the rapidly dividing cells. I had another question about this, I think like 2 months ago, like 500 videos ago. And that includes not only the tumors, but also the normal tissues with high turnover. And so the way they test this on step 1, they're like, oh, it's the bone marrow, because that's the blood cells. It's the GI mucosa, because that's the lining of the gut, and those need to be replaced. And the hair follicles, right? Those are particularly vulnerable, and that causes pancytopenia, diarrhea, and alopecia, exactly what this patient's suffering from. And so it's gut mucosa, bone marrow, and hair follicles. All right, so why is it not heart muscles and liver and kidneys? Well, cardiotoxicity would be doxorubicin, and nephrohepatotoxicity comes from other drugs, salivary glands. Those don't have high turnover. Neither does cartilage and tendons. That's low turnover, the connective tissues. And skin epithelium and lymph nodes in the spleen. The skin can have mild changes, but the main effect is in the GI and also the bone marrow and the hair follicles. So lymph nodes and spleen are not typically destroyed except in like radiation or immune suppression. So chemotherapy drugs like carboplatin, paclitaxel, they destroy the cancer drugs, but they also like target all rapidly dividing cells. And so week after treatment, you could have pancytopenia, mucositis with diarrhea, and hair loss. So chemotherapy with these guys affects the rapidly dividing cells in the gut, bone marrow, and hair follicles. If you want to see more on this, then watch my video on Homer Simpson. It's kind of fun. Also, be sure to like and subscribe if you're liking this stuff. I did it for you. All right, here we have a 48-year-old farmer presented to the clinic with a week-long history of fever, chills, and a painful ulcer on his right arm. He reports that the ulcer developed after he scratched his arm with a thorn while tending to his rose bushes. Sounds like my grandpa. On examination, there is a 2-centimeter ulcer in the forearm with erythematous base, eschar in the center. By the way, that's the dry, dark, scabby stuff that falls away on the dead skin. It's caused by like a burn or a bite of a mite or anthrax infection. And he also has tender regional lymphadenopathy. Lab tests are ordered for further evaluation, and a polymerase chain reaction test is used to identify a specific gene involved in the synthesis of lipopolysaccharide component lipid A. Which of the following organisms is most likely responsible for this patient's condition? So let's break them down. Bacillus anthracis. Well, that one does have the buzzword of the eschar, but it's wrong because it's usually from animal hides, not rose thorns, and so that's not the answer. How about Borrelia? Well, no, because that's a tick bite in erythema migrans, so that's going to be Lyme disease that starts with a target rash, not an ulcer or anything like that. And Francisella is the right answer. Pseudomonas, that would be burns in a hot tub folliculitis. That rarely causes eschar or painful ulcers. It's normally nosocomial infections. They are opportunistic. And Streptococcus pyogenes would cause cellulitis and necrotizing fasciitis. And that's a gram-positive cocci, no lipid A or ulcer formation. It's more diffuse soft tissue environment. All right, so this is indeed going to be C. And the interesting thing here is that just one bacterium of Francisella tularensis can make you sick. All right, super, super infectious bacteria. It's one of the most infectious ones known to man. So we got this farmer, thorn scratch, and then he's got an ulcer with tender lymph nodes. And so it's going to be an ulceroglandular type. So it's a tiny gram-negative coccobacillus, and it just sneaks into your skin through little cuts or punctures, and it causes local necrosis with a central black spot. And that lipid A gene that's mentioned in the PCR is the giveaway, right? That's the gram-negative organism with endotoxin activity. All right, then the Bacillus anthracis, that's going to be a painless eschar, usually from the animal hides. But Borrelia is like a target rash, right? So the thorn, ulcer, lymphadenopathy, and lipid A means that it's Francisella tularensis. So ulcer with eschar and lymphadenopathy in a farmer suggests cutaneous tularemia from Francisella tularensis. There you go. Here we have a 32-year-old woman presenting to the clinic with a 3-week history of increased fatigue and easy bruising. She reports occasional joint pain and swelling in her fingers and wrists, and she also notes that her face tends to redden when she spends time in the sun. Review of symptoms reveals no other symptoms. Physical examination shows petechiae over the lower extremities. That's the smaller red-purple spots caused by bleeding in the skin. And the lab tests reveal a positive antinuclear antibody, ANA, and also anti-Smith antibody. So which laboratory findings is most likely associated with this patient's condition? The answer is thrombocytopenia. And the reason why, she's got lupus. So she's got the immune thrombocytopenia because of the autoantibody-mediated destruction of the blood cells, type 2 hypersensitivity stuff. All right, so we know this because of the photosensitive rash, arthralgia, fatigue, bruising, and this is confirmed by the positive ANA and anti-Smith antibodies. And the presence of and bruising points to an immune-mediated thrombocytopenia, which is a common hematological manifestation of lupus. So the platelets are destroyed by the anti-platelet antibodies, similar to the idiopathic thrombocytopenia purpura. Let's look at the other answers and why they're wrong. Elevated reticulocyte count. All right, so the buzzword there is hemolytic anemia. And that's wrong because the reticulocyte count may be elevated only if hemolysis is occurring. And this patient's primary issue is platelet loss, not necessarily the red blood cell destruction. And so that's why A is not right. How about B? Hypereosinophilia. Well, the buzzword there is going to be allergic reactions and parasitic infections and neoplasms. So there's no sign of eosinophil-driven disease or allergy, so that's why it's not the right answer. How about the smudge cells, the CLL? Well, that's wrong because it's seen in older adults and it's not related to autoimmune conditions like lupus, which it clearly has. And thrombocytosis is the opposite of what lupus does. Instead, lupus typically causes the low platelets, right? Because in SLE, the problem is platelet destruction, not overproduction. All right, so up to 50% of patients with lupus develop some sort of a blood cell deficiency. So lupus isn't just like the rashes and the joint pain, it also kills the blood cells. All right, so the patient's got fatigue, joint swelling, bruising, photosensitivity, positive ANA, all the anti-Smith stuff. Like she just clearly has lupus. Malar butterfly rash, like how could they have made it more simple? But they made it tricky with the petechiae, the tiny red spots that are caused by the low platelets. And so in lupus, the immune system creates auto antibodies against the platelets, and it leads to their destruction. And that's why the lab findings here is thrombocytopenia. Okay, so the bottom line is the positive anti-Smith antibodies indicate systemic lupus, commonly associated with thrombocytopenia. There you go. All right, let's talk about glucocorticoids. So a 52-year-old woman with a history of autoimmune hepatitis is being treated with corticosteroids. And corticosteroids is just any type of steroid hormone that is produced in the adrenal cortex or made synthetically. And there are two kinds, glucocorticoids and mineralocorticoids. And they have various metabolic functions, and they're used to treat inflammation. All right, so she is being treated with corticosteroids. And despite resolution of her symptoms and a decrease in circulating levels of the medication, the therapeutic effects persist beyond the expected duration, which the following characteristics of glucocorticoid, right, like hydrocortisone is an example of that. There's involved in the metabolism of carbohydrates and proteins and fats and have anti-inflammatory activity, right? So the glucocorticoid receptor is most likely responsible for the prolonged effect of the medication. Does it activate receptor tyrosine kinases? Well, that'd be like growth factor receptors like insulin or EGFR. That's wrong because glucocorticoids are not tyrosine kinase receptors. How about B, competes for binding site with the heat shock proteins? Well, these guys are displaced whenever the steroid binds. And it's wrong because it's not responsible for the prolonged effect. It's just one of the steps, right? C, directly increases cyclic adenosine monophosphate, or the CAMP, concentrations. That'd be a GS protein coupled receptors, like beta-2 agonists. And that's wrong because steroids don't act through the second trimester systems. Stimulates prolonged gene transcription. Bingo, bingo. Corticosteroids act on the intracellular receptors, not membrane-bound ones. These receptors translocate into the nucleus and regulate gene expression because protein synthesis and downstream cellular responses are going to take time to reverse. That means the therapeutic effects are going to be persistent long after the drug levels are declining. All right, and then what about E? Triggers acute release of intracellular calcium storage. That's the GQ pathway, all right? And the GQ, I've made a couple of videos about this, maybe 400 videos back. That's seen in like the IP3 and DAG systems. And that's wrong because steroids do not trigger rapid calcium-based responses. All right, so glucocorticoids, they work long after they leave the bloodstream. And here is the explanation. They change what your cells actually make. All right, so when glucocorticoids enter the cell, they bind to the cytoplasmic receptor. And then they kick off some of the heat shock proteins, and then they march into the nucleus. And then they rewire the gene expression, and they turn off pro-inflammatory genes, and they turn on the protective ones. So it's kind of crazy. They just go and storm the Capitol. It's kind of insane. Okay, so they stimulate prolonged gene transcription and lead to extended therapeutic effects despite decreased circulating levels. All right, what about this new view? It's kind of funny, right? All right, so somebody is brought to the clinic because of the eating habits. The roommate mentions that the patient often eats large amounts of food in a short period, then isolates herself in the bathroom, basically purges, and she has mild dental erosion. And which of the following is most likely present in this patient? The answer is hypochloremia. Now, this is an interesting one, right? So we know what this is. I actually can't say it on YouTube or else I will get blocked, but you know what it is. You can read it. Here is the explanation description. Basically, it's the repeated vomiting that causes the loss of the gastric acid, right? So you lose that HCl, and that results in hypochloremic condition. That's hypokalemic metabolic acidosis. And the hypochloremia is the hallmark laboratory clue here. Hyperkalemia would be the opposite, and hyponatremia and hypercalcemia and hyperphosphatemia are not typical here. Okay, so basically this is like an acid draining problem. Every purge is like a dumping hydrochloric acid out of the body. And as you do that, you'll have the dental erosion, the calloused knuckles, and it's just such a sad syndrome, truly is. It actually just breaks my heart when I talk about this. But every episode of the vomiting, you lose the hydronium and the chloride ions, and this creates a hypochloremic metabolic alkalosis environment, and in aldosterone activation and potassium levels also drop. So hypochloremia, hypokalemia are the go-to answers. Okay, so there's the bottom line. Recurrent vomiting and electrolyte imbalances. Very real condition, very stigmatized, a lot more work to be done in that area. All right, here we have a 67-year-old man with a history of stable angina. He's admitted to the hospital for evaluation of chest pain that occurs with moderate exertion. He is currently taking aspirin and has become recently prescribed a new medication. During hospital stay, he reports episodes of wheezing and difficulty breathing. On examination, he has prolonged expiration and wheezing. A pulmonary function test shows decreased FEV1 to FVC ratio, which improves significantly after administration of an inhaled beta agonist. The new medication is suspected to have triggered his respiratory symptoms. Which of the following medications is most likely responsible for his wheezing? All right, this is carvedilol, but we need to talk about why. So carvedilol is a non-selective beta blocker. And that means it inhibits both beta-1 and beta-2 receptors. And so blocking beta-2 receptors in the lungs prevents normal bronchodilation, and that could potentially trigger a bronchospasm, especially in people with asthma or reactive airway disease. And so that reversible drop in the FEV1 confirms the asthma-like physiology and then makes carvedilol the most likely choice. What about other things like atenolol? Well, that one is a beta-1 selective drug, right? So the minimal effect on the lungs. Lisinopril is going to be an ACE inhibitor, so that can cause cough, but not wheezing and bronchospasms. Hydrochlorothiazide, that is not associated with bronchospasms. It may cause metabolic changes like hypokalemia, but nothing like that. Diltiazem is a non-dihydropyridine CCB, and that's wrong because it affects the heart rate and conduction, not the bronchioles. So the asthma is suddenly becoming worse if you start any medication, then you should check if it's a beta blocker because he's treated for angina, but now he's wheezing and his spirometry shows reversible airway obstruction, so he's got like the asthma stuff. And that's because carvedilol is a non-selective beta blocker and it's great for the heart, but it blocks B2, beta 2 in the lungs, stopping bronchodilation and triggering bronchospasm. And you probably heard of that like A through M rule for the beta-1 selective stuff, the general kind of stuff, beta-1 selective. It's like atenolol, metoprolol, esmolol, bisoprolol, that kind of stuff. There are some exceptions though, like carvedilol and labetalol, because those start with A to M, but they're mixed alpha-1, beta-1, beta-2 blockers. And carvedilol and labetalol both block beta-1 and beta-2 and alpha-1, and that causes bronchospasms. So even though it starts with C, it's not necessarily beta-1 selective. And so you should think of beaming the heart. Bisoprolol, esmolol, atenolol, acetylol, and metoprolol. Okay, those are the go-to drugs for hypertension, post-MI, heart failure, and carvedilol and labetalol are non-selective with alpha blockade. All right, this next question, we have a 23-year-old female college student presenting to the emergency department with a right lower quadrant abdominal pain. It began 12 hours ago. She says it's sharp and constant. She's experienced nausea but no vomiting. Her last menstrual period was 10 days ago, and she reports regular cycles. She is sexually active with one partner and uses condoms consistently. Her temperature is 100.9. Blood pressure is 118/74, and heart rate is 92 per minute. Physical examination reveals tenderness of the right lower quadrant and pain upon cervical motion. Pelvic examination demonstrates mucopurulent cervical discharge, and a urine pregnancy test is negative. Which of the following is the most likely diagnosis? All right, so the big conditions here are lower abdominal pain, cervical motion tenderness, mucopurulent discharge, and a fever. And she's sexually active with an STI risk, and negative pregnancy test rules out ectopic pregnancy, so that's why A is wrong. Acute appendicitis would be right lower quadrant pain and also some of the rebound there. There's no CMT or cervical discharge in appendicitis, and this patient has gynecologic signs, so that's the reason why it's not right. Pyelonephritis would have flank pain, CVA tenderness, urinary symptoms, but it's wrong because there's no urinary symptoms or CVA tenderness. And it's not endometriosis because that have chronic pelvic pain, dysmenorrhea, and dyspareunia, but this is acute, not chronic, and there's no cyclical pattern there, right? And fever, so it's pelvic inflammatory. She's got right lower quadrant pain, fever, mucopurulent discharge, and pain on the motion. So the pain, discharge, and the tenderness is going to tell you it's pelvic inflammatory disease, not ectopic pregnancy because you took the test. And so the bottom line here is that pelvic inflammatory disease is likely due to the right lower quadrant pain, fever, and cervical motion tenderness with mucopurulent discharge. Thank you guys so much for watching. If you enjoyed this, please consider liking and subscribing. Let me know what I should cover next, and we'll see you guys in the next video. Hello, everybody, and welcome back to Ivy Tutoring. My goal is to help you pass step 1. The next 10 questions are going to be super duper high yield, important information, so be sure to like and subscribe if you're into that. New questions every single day. And without further ado, let's get started. A 35-year-old male mechanic presents to the clinic with a 3-month history of hand weakness and frequent injuries that he does not notice until later. He reports dropping tools more often and having difficulty gripping objects. Neurological examination reveals bilateral loss of pain and temperature sensation on his hands and his forearms, along with muscle wasting and decreased strength in the intrinsic hand muscles. Deep tendon reflexes are diminished in the upper limbs, but normal in the lower limbs. MRI of the cervical spine is performed. Which of the following is most likely the cause of the symptoms? All right, so this condition is syringomyelia, and you break this word down, syringomyelia, to mean syrinx, which is like a cyst cavity, and mylia, which refers to the spinal cord. So we have our spinal cord right here, right? It looks something like this. And this will start really medially. I'll zoom up so you can kind of see it. Put that in a different color. It starts medially, and then it expands outward. And it'll damage the spinothalamic tract right here. And so this is a classic presentation of syringomyelia. You have bilateral loss of the pain and temperature. And they always describe this as a cape-like distribution plus the intrinsic hand muscle wasting. And this results from the expanding central canal of the spinal cord that damages the crossing spinal fibers and the anterior horn cells. Expanding central canal into the cervical spinal cord, well, that is exactly what we described, right? That's the reason that you're having the damage that causes this spinothalamic fibers and the anterior horn cells, like where they cross, it causes that to be damaged. So A is a perfect answer. Thrombosis of the anterior spinal artery. So any sort of arterial or anterior spinal artery thrombosis would cause bilateral motor paralysis, and also a loss of pain and temperature below the lesion, but it would spare the dorsal columns. So that'd be more sudden onset. Herniation of the cerebellar tonsils. So that's like a TRE1 malformation. And that can predispose you to this, but the herniation itself would cause occipital headaches and cerebellar or brainstem signs, and that's not the pattern that we see in this patient. Inflammation of the peripheral nerve roots. For that one, you should think of Guillain-Barré, and that causes ascending symmetric weakness, areflexia, and the sensory loss is very mild there. Compression of the brachial plexus by the cervical rib. That would cause thoracic outlet syndrome, pain, and paresthesia is just that abnormal sensation, typically the tingling and the pricking, the pins and needle stuff. And that's usually caused by pressure or damage to the peripheral nerves. You could also have some vascular issues for E in the upper limb, but you'd have no disassociated sensory loss or bilateral pattern. If you have painless burns on the hands of a young child and it isn't neuropathy from diabetes, it's just going to be that cyst of the spinal cord that's called a syrinx. And so here, our 35-year-old mechanic, he keeps injuring his hands and he can't feel the pain and temperature. And on exam, he has bilateral loss of pain and temperature and a cape-like distribution with wasting of his intrinsic hand muscles. And that tells us that the lesion sits right at the middle of the cervical spinal cord. And so the imaging of where that crosses the spinothalamic fibers in the anterior horn cells is where the lesion is expanding. So that's stringomyelia. So the bottom line is cervical myelopathy from central canal expansion causes hand weakness and a sensory loss in this patient in the cape-like distribution through the spinothalamic tract because the syrinx is expanding medially, or rather it's medial and it's expanding out. All right, we're going to have a really good question to really just drive this home. So here I've got a cross-section of the spinal cord, and we are told about a 40-year-old man who's brought to the emergency department after he's found unresponsive at home. On examination, he rouses to painful stimuli but is otherwise confused. His temperature is 98.6, blood pressure is 130/85, pulse is 88, and respiratory rate is 14. Neurologic examination reveals that he has diminished pain and temperature sensations on the left side of his body below the T6 dermatome. But crude touch sensation is intact. There's normal proprioception and vibration sense. Motor function is intact. Throughout, MRI of the thoracic spine shows an isolated lesion affecting a specific tract on the right side. Which of the following best describes the affected tract? It's going to be this guy right here, which is the right lateral spinothalamic tract. And what we have to know is that pain and temperature cross within 1 to 2 levels of entry, and then they ascend to the contralateral lateral spinothalamic tract. And so a lesion on the right lateral spinothalamic tract at T6 would cause loss of pain and temperature on the left below T6 with preserved vibration and proprioception. So that loss of pain and temperature on the contralateral side with preserved vibration and proprioception is a hallmark of lateral spinothalamic tract lesion. Very similar to the last question. The bottom line is right lateral spinothalamic tract injury causes contralateral loss of pain and temperature sensation below the lesion level. A 72-year-old woman with a history of hypertension and mild dementia is found unresponsive by her spouse at home. She was last seen in her usual state of health the night before. In the emergency department, she regains consciousness and reports a severe headache. Neurological examination shows left-sided hemiparesis and hypertonia. Paresis is another term for hemiplegia, which is just paralysis on one side of the body. And her pupils are equal and reactive to light. And a non-contrast CT scan of the head shows a crescent-shaped hyperdense area along the right cerebral hemisphere. Which of the following structures is most likely injured in this patient? So let's say that we have like a crescent-shaped hyperdense area in an elderly woman with cerebral atrophy and a history of dementia is going to indicate a subdural hematoma. And that occurs from the rupture of the bridging veins. So these veins are connected to the cerebral cortex of the dural venous sinuses, and they're super vulnerable when they're stretched. That's why our answer is B, the dural bridging veins. Anterior cerebral artery, that would be an infarct from an ACA stroke. That would cause leg weakness, not subdural stuff. Posterior communicating artery, a rupture there would cause a subarachnoid hemorrhage, not subdural, and it's associated with the worst headache of my life. So that'd be the posterior communicating artery. The superficial temporal vein, that drains the scalp, and then trauma there actually causes a scalp hematoma, not intracranial bleeding. And the tentorial artery is a small branch of the meningohypophyseal trunk. And so injury there would cause a small subdural or subarachnoid bleed. And this is kind of an intense situation because even just like falling out of your chair can be life-threatening in terms of the bleeding that occurs in the elderly. And that's because cerebral atrophy stretches the bridging veins that anchor the brain to the dura. And that's how you get this like crescent-shaped bleed. And it's every time you see that, it's going to be a subdural hematoma. And these guys can go unnoticed for hours and even days. And the structure is not an artery, it's just those bridging veins that are torn by the brain pulling away from the dura. And we have to know about the subdural versus the epidural hematoma and the lucid interval concept. So an epidural hematoma has a bleed shape that's a biconvex lens shape, and the subdural is obviously the crescent. The subdural is the one that crosses the suture lines, and the source of the bleeding for a subdural is the bridging veins. But for an epidural, it is the middle meningeal, so that's trauma due to the temporal bone. The onset is usually more rapid there too. It's slower in this condition that we have this question about. And that lucid interval is just that little transient period of time where you have regained consciousness after that initial loss. And that usually happens before the rapid deterioration. And that's a classic time for epidural hematoma because the arterial bleeding quickly expands and then it compresses the brain. The subdural, on the other hand, is usually a slow onset, but it can occasionally have just a mild lucid phase if it's acute. So epi acts super fast and it's extra deadly. Epi for emergency. Sub is more subtle. So subdural, subtle, slow onset, subclinical, and it has more chronic signs. Crescent shape, hyperdensity on CT indicates subdural hematoma, typically from injury to the dural bridging veins. All right, pretty easy question. We'll go quickly. 28-year-old man participating in clinical research examining the hormonal levels after appetite regulation. What time most likely corresponds to the time that he consumed the meal if he's analyzing the ghrelin? So for this, we just have to know what ghrelin does. And the most important things to know for step one is that it increases during fasting and it decreases with feeding. If you know that, then you're good to go. This is the hunger hormone, right? This is produced by the stomach, especially the PD-1 cells. I'll write that down so you can just know that factoid. And it acts on the hypothalamus, the arcuate nucleus specifically, and it increases your hunger. It can also stimulate GH release from the anterior pituitary, and this is counter-regulated by leptin from the adipose tissue and insulin. So the pathophys here is you fast, you have an empty stomach, and then that empty stomach causes the secretion of ghrelin, acts to stimulate hunger, and then you get a meal intake, the stomach stretches, and you get the nutrients, and that decreases the ghrelin. All right, so they're going to give you some sort of a graph if this is a meal. And it's like, oh, you're increasing ghrelin before, and then afterwards you decrease the ghrelin, and then eventually you get hungry again. And so the answer is the subsequent drop in the plasma ghrelin levels, because that corresponds to the time that you consume the meal. All right, so here's our guy. Now it's me. Plasmin levels drop after meal consumption, indicating appetite suppression post-ingestion. Easy peasy. Okay, in our next question, we have a 3-day-old boy is evaluated for a neonatal intensive care unit for low calcium levels detected on a routine newborn screening. He was born a full term via the uncomplicated pregnancy and delivery, and on examination, he has a slight facial dysmorphism, including a small chin and slanted eyes. He also has a harsh systolic murmur, heard best at the lower left sternal border, and significant muscular hypotonia. X-ray shows no visible thymic shadow. That should be making us think of something already. Further genetic analysis reveals a 46XY karyotype, which the following is the most likely genetic mechanism causing this person's condition. Okay, so nice little question stem there. We've got a lot of findings. We have some things that come to mind is hypocalcemia, and a big one there that you notice is the absent thymic shadow. That's huge. There's also some congenital heart diseases, some dysmorphic facies, and that's all classic for one condition. We have some sort of a deletion. It is DeGeorge syndrome. It's a microdeletion of the chromosomes at 22q11.2. All right, one of those. If you guys don't know what to set for your password, then pick some random numbers, maybe call it DGS and then 22q11.2, and you'll be safe forever, right? You just have to memorize all these random numbers, but this is a deletion, right? It's not a non-disjunction or translocation, and so the answer is going to be deletion. Really quickly, a non-disjunction, that's going to be a trisomy like Down syndrome or Turner's, not DeGeorge. Paracentric inversion, that's a rare chromosomal arrangement. It's not associated with the syndrome at all. And Robertsonian translocation would be familial Down syndrome. That's the 1421 guy. And the trinucleotide repeat is like Fragile X, Huntington's, Friedreich's ataxia, and myotonic dystrophy, not DeGeorge. All right, so the pathophysiology is you have that deletion, and that deletion of that part of the chromosome actually leads to a loss of the TBX1 gene. And that causes defective third and fourth pharyngeal pouches. And then if you don't have your third and fourth pharyngeal pouches, well, that's going to cause some problems with thymic stuff. You have thymic aplasia and parathyroid hormone aplasia, so you have decreased PTH and decreased calcium subsequently. All right, so that's the cascade. And the neural crest migration defects cause a conal truncal heart abnormality. And the conal truncal just means any congenital heart defect that is characterized by the abnormal development of the outflow tract and the great vessels. So you should think of tetralogy of flow, transposition of the great arteries, and truncus arteriosus, and double outlet ventricles. Usually it's due to the formation and rotation problems of the outflow septum during embryonic development. That certainly would be the case with DeGeorge. Here are some of the explanations you guys can look at. I kind of already went over those, but just so that you can see, and just know that the TBX1 gene causes that malformation of the pouches 3 and 4, and then you get the thymic aplasia due to that, and the parathyroid hormone aplasia. So less PTH means less calcium, and the neural crest migration defects lead to that conal truncal heart abnormality. All right, so there's our cute little baby. He's got it. And that is our question. So hopefully that was helpful. Okay, and our next question, we have a 72-year-old male presenting to the ED with worsening shortness of breath and wheezing over the past several days. He has a history of COPD, currently using albuterol inhaler as needed. 2 weeks ago, he started on a new medication and recently diagnosed it as open angle glaucoma. On exam, his respiratory rate is 24 breaths per minute, and wheezing is noted bilaterally on long auscultations. His oxygen side is 89% of room air. Pulmonary function test shows a decreased FEV1 compared to his baseline, which of the following drugs is most likely responsible for his current respiratory symptoms. All right. So non-selective, so beta blockers like timolol are used for open angle glaucoma, and they can be systemically absorbed and antagonize the B2 receptors in the bronchi, and that causes the bronchospasms and the lower FEV. And so that can be dangerous in patients with COPD or asthma. A prostaglandin analog would be like a first line for open angle glaucoma, not bronchospasms. Carbonic anhydrase inhibitors, those can cause metabolic effects, but not bronchospasm. Cholinergic agonists like pilocarpine, those cause meiosis, brow ache, and have no pulmonary effects. And so it's our beta blockers that worsen asthma and COPD, and it can mask hypoglycemia. Glaucoma is tested with timolol as a culprit for bronchospasms. So we give them timolol for the eye drops. That's a non-selective beta blocker. COPD exacerbation because of this blockade, and we have that drop in FEV1, which is a hallmark of your bronchospasms. So that's what's happening. That's the mechanism. Carbonic anhydrase inhibitors decrease the aqueous humor, so kind of different mechanism there. Beta blockers decrease the aqueous humor production, but they also block the B2 in the lungs, since that causes bronchospasm. And so the bottom line here is that beta adrenergic receptors can exacerbate COPD symptoms, causing worsening wheezing and shortness of breath. My next question is, can you handle the truth? And the answer in terms of a patient is always going to be yes. Somebody's like, hey doc, I've been feeling this way. Is it because the cancer's gotten worse? The answer is going to be, unfortunately, has progressed. We can discuss what this means. Always break the bad news truthfully. Don't beat around the bush. Don't just ask endless questions. Ultimately, you have to convey things. Also, pay attention to question marks in these stems, okay? Whenever they ask a question, you have to answer that question in your answer. That's my biggest tip for this ethics. So honest communication is the most important. So look at me, I'm talking to you right now. I would turn to this person like I'm doing now, and I would say, look, yes, the cancer has progressed. You have to be honest about that because that was her concern, and that's how you do this question. All right, here we have a 22-year-old woman who presents to the emergency department with a sudden onset of swelling around her eyes and her lips. She reports a similar episode in the past, often minor illnesses. She's not on allergies. Physical examination shows non-pitting, non-pruritic facial edema, so she already know what this is. This is decreased C1 esterase inhibitor levels because this is hereditary angioedema. You have the recurrent episodes of non-pruritic angioedema with abdominal pain, and low C4 indicates that there's C1 esterase inhibitor deficiency that causes the bradykinin-mediated angioedema. All right, these other answers are good too. Defective phagocyte, NAD, pH oxidase, that's going to be chronic granulomatous disease. That's recurrent bacterial and fungal infections, not angioedema. Loss of alpha galactosidase A activity, that'd be Fabry disease, because the fairy gets around the world. Fabry galactosidase, that's how I remember that one. Angiokeratomas, neuropathy, renal stuff, not angioedema would be seen in that condition. So renal stuff, not angioedema. And that is our answer. C, D, excessive HMB synthase activity. So that's acute intermittent porphyria. So this porphyria would present with abdominal pain and neuropathy and dark urine, not swelling. The hypersensitivity to environmental allergens, that'd be like IgE-mediated allergic angioedema with pruritus and urticaria and normal complement labs. So it's not that. All right, there you go. There are the explanations. So the non-pitting, the dental, and the low C2. This is hereditary angioedema. And then really quickly, the pathophysiology is important here. A C1 esterase inhibitor normally inhibits the complement activation of C1 and kallikrein system. But if you have a deficiency there, then you have excessive activation of the complement, and that leads to the increased bradykinin and capillary leakage and angioedema. So the C4 is low because the complement is constantly being used, it's constantly being activated, and so it's the decreased C1 esterase inhibitors. There's a bottom line. All right, next question. We have a 56-year-old man has a history of chronic obstructive pulmonary disease, and he's admitted to the hospital with pneumonia. He started on the appropriate antibiotics. On the fourth day of hospitalization, he develops high-grade fever and hypotension. His temperature is 102 and blood pressure is 95/55. Blood clusters are drawn and eventually show Klebsiella pneumoniae. A complete blood count shows the following: hemoglobin at 12.5, white blood cell count at 200 with 92% lymphocytes and 4% monocytes, and a platelet count of 150K. And this patient is found to have severe neutropenia. Which of the following is most likely the reason for this patient's increased susceptibility to infections? Okay, let's talk about the pathophysiology and some labs that should stand out to us. Basically, what we need to know is that neutrophils are the primary defense against extracellular bacteria. Cool, we know that. And you have severe neutropenia, that's anytime it's below 500, you have a high risk for gram-negative septicemia. Septicemia is just a fancy word for like blood poisoning, especially it's caused by like a bacteria and their toxins. And so the lymphocytes are intact, as seen on the CBC, and there's antibody and T cell functions that are relatively normal. But the key vulnerability is you have no neutrophils, right? There's a counts problem. It's not the function problem. And we know, look at our white blood cells, they're like at 200 and 92% lymphocytes. And so the ANC, the absolute neutrophil count, is basically 0. All right, so our answer is the impaired neutrophil count. Now let's talk about some of these other Trap answers: low antibody production. You'd have sinopulmonary infections there, not sepsis in 4 days, and normal B function here. Decreased T cell function would cause viral, fungal, and opportunistic infections like CMV and PCP. Reduced phagocytic activity would be close, but the stem is about the quantity, not the function. And deficient serum complement levels is usually linked to recurrent Neisseria infections, not Klebsiella, or sepsis in neutropenic patients. And some causes, some associations that we should know here is like bone marrow suppression from drugs like chemotherapy or antibiotics, like chloramphenicol, which is used against things like typhoid fever, would cause neutropenia. And that's when you have low neutrophils in the blood, so increased susceptibility to infection. And sepsis-induced neutropenia can occur in hospitalized patients, and neutropenia can also cause your viral and fungal infections. So those are some associations that you should know. And that gram-negative stuff is because of the lack of the neutrophils. And so the bottom line of our nice little story right here is severe neutropenia significantly increases infection risk due to impaired neutrophil count. In this next question, we got a whole lot of labs. Basically, there's a 62-year-old man who has a history of diabetes and hypertension, presents in the emergency department with confusion and generalized weakness over the past 2 days. He has a poor appetite and increasing fatigue, and he denies any chest pain, shortness of appetite, and increasing fatigue. He denies the chest pain, shortness of breath, and abdominal joints. Sorry, I read that too quickly. Let me read that again. 62-year-old man, history of diabetes, hypertension. He goes to the emergency department with the confusion and general weakness for the past few days. He has poor appetite, increasing fatigue. He denies chest pain, shortness of breath, or abdominal pain. His medications are metformin and lisinopril. On examination, vital signs are temperature at 98.6, pulse at 92, respiration rate at 16 per minute, and blood pressure is at 150/88. He is disoriented to time and place, but he follows simple commands. And then we have tons of nice little labs here, okay? So which of the following is most likely the cause of this patient's symptoms? Okay, so basically the story made short is there's confusion, disorientation. There's a very high BUN to creatinine ratio. There's anemia, which involves a low EPO, and also metabolic acidosis, and there's normal vitals, and there's no hypoglycemia, and it's often seen in diabetics and hypertensives with, what do they have? CKD. Okay, so the answer is going to be uremic encephalopathy, and let's explain exactly why. So let's start here with our pathophys. I feel like I need like a theme song when we do the pathophys of each question. It's pathophys time. Basically, we have the kidney function first. That starts to fail because of the accumulation of the urea, the creatinine, and other nitrogenous wastes. All right, so all that nitrogen, just whoosh, waste, the kidney damaged. And then these toxins interfere with the neuronal mechanisms and the metabolism. And so then you get reversible encephalopathy and confusion and altered mental status. All that waste because of the failure of the kidney caused the encephalopathy and the confusion. And you can improve this with renal replacement therapy, dialysis. So you also see the high BUN seen in diabetics and hypertensives with CKD. All right, why is it not DKA then, huh? Well, DKA is usually in younger patients, and it would usually have a lower pH and high anion gap with the ketones and rapid breathing. You don't see that here, so that's why it's not the answer. Hyperosmolar, hyperglycemic state, that would require hyperglycemia and dehydration, and glucose is not provided, but the symptoms don't fit that. Hypoglycemia, no glucose is provided, but the normal vitals and the fact that he's like alert enough to follow commands make this less likely. Hepatic encephalopathy, there's no history of cirrhosis or liver disease, so that's not the answer. So here's the bottom line. Confusion and weakness in a diabetic patient and elevated creatinine suggest uremic encephalopathy as the most likely diagnosis. If this was helpful for you guys, please like and subscribe. I'm just trying to help you guys pass step 1, new questions every single day. And later on, not just step 1, but step 2, step 3, and all things medical. So if you're interested in that, the videos are only going to improve over time, especially if you guys like and subscribe. We'll see you guys in the next video. Hey everybody, welcome to Step 1 Prep. First question, 6-year-old girl presents to the emergency department by her mother due to swelling around her eyes and abdomen over the past several days. The mother mentions she recently recovered from a respiratory infection, and on examination, she has periorbital edema and ascites. Blood pressure is 90/60. Lab shows serum albumin at 2.1, cholesterol of 450, and urine analysis shows a 4+ protein with no hematuria. Renal ultrasound is unremarkable. Which of the following findings is most likely to be observed on electron microscopy of a kidney biopsy from this patient? All right, so periorbital edema, ascites, hypoalbuminemia, hyperlipidemia, massive proteinuria, without hematuria, normal renal ultrasound. All right, so this is minimal change disease. It's the most common pediatric nephrotic syndrome, and it presents following an infection with selective albuminuria and edema, and biopsy shows normal glomeruli on light microscopy and negative IF, and EM reveals podocyte effacement. So what about these other answers? We know the answer is A, the fusion of the podocyte foot process, the subendothelial immune complex deposition. That would be lupus nephritis, the wire looping, nephritic and nephrotic syndrome. The tram track appearance of the basement membrane, that's membranoproliferative glomerulonephritis. IgA deposition in the mesangium is Berger's disease, recurrent hematuria, and post-URI and a nephritic syndrome. Mesangial expansion of the Kimmelsten-Wilson Wilson nodules is diabetic nephropathy. That's nodular glomerulosclerosis in adults. And so really it's just minimal change disease in a child if it's nephrotic syndrome until proven otherwise. 6-year-old with puffy eyes, abdominal swelling, and labs shows low albumin and high cholesterol and massive proteinuria. There's no blood in the urine. All that tells us nephrotic syndrome, and this usually follows a recent infection. All right, so the bottom line is electron microscopy and nephrotic syndrome shows fusion of the podocyte foot processes, indicating minimal change disease. Next question, we have a 57-year-old man presenting to the clinic with a fatigue and difficulty concentrating. His past medical history is significant for recurrent gouty arthritis. His current medications include allopurinol. Lab studies reveal elevated serum uric acid level. To understand his condition, the physician explains how his body naturally synthesizes certain compounds, which are also administered in the treatment of gout. During this biochemical process, a specific enzyme catalyzes the early committed step and is subject to feedback inhibition by the end products. This process primarily controls the synthesis of which of the following? Okay, so every single molecule of uric acid in gout patients starts its life as a simple purine molecule. It's a purine nucleotide. And so here we got a 57-year-old dude who's got some recurrent gout and he's on allopurinol. And the doc is like, hey, purines didn't just come out of nowhere. The body regulates them. And the first committed step in the purine synthesis is catalyzed by glutamine PRPP aminotransferase. It's the gatekeeper enzyme. And it shuts down whenever AMP, GMP, or IMP levels are too high. And that regulation prevents overproduction of purines. But if purines builds up, they're degraded to uric acid, which drives the gout attacks. And so the process here is de novo synthesis of purine nucleotides. So amino acids, they're regulated by transaminases and feedback from the endpoints, but not linked to PRPP aminotransferase. Fatty acids, the committed step is acetyl-CoA carboxylase. It's not inhibited by nucleotides. Purine nucleotides is the correct answer. Steroid hormones is the rate-limiting enzyme would be desmolase. And triglycerides, synthesis would begin with glycerol 3-phosphate and fatty acyl-CoA, not nucleotide regulated. So every molecule of uric acid in gout patients starts with purine. All right, so here's the pathophysiology. More PRPP, more purines, more gout. Xanthan oxidase is inhibited by allopurinol. Start with ribose 5-phosphate, then PRPP is added. The first committed step is right here, and the regulation is by AMP, GMP, and IMP. So it'll precipitate in the joints and cause gout. So purine nucleotide synthesis is regulated by feedback inhibition. It's crucial in understanding gout physiology. All right, here's our practice question. 65-year-old man, type 2 diabetes, coronary artery disease, presents to the clinic with a 1-month history of worsening chest discomfort during his daily walks. He underwent drug-eluting stent placement 6 months ago. He's on metformin, lisinopril, 130/80, heart rate 78. Now he's got new ST segment depression in leads 5 and 6. What's the cause of his new symptoms? Neointimal hyperplasia in the stented artery. So the pathophysiology is you have some sort of a mechanical injury and the cytokines, and then neointimal hyperplasia, the gradual narrowing of that stented area. And then months later, you get angina with exertion-induced ischemia, which is stable. Bottom line is neointimal hyperplasia is the most likely cause of new angina after recent drug-eluting stent placement. All right, in this question, we have a 60-year-old male factory worker, persistent fatigue, easy bruising, recurrent gum bleeding. He's been a non-smoker his whole life. He's working for over 30 years in a chemical plant that manufactures plastic resins. He appears pale. Petechiae is noted on the forearms and the legs. Lab shows hemoglobin of 8.5, platelet count of 25K, leukocyte count of 52, with a prominent large immature cells noted on the peripheral blood smear. Bone marrow aspiration demonstrates an increased number of myeloblasts, and cytogenic analysis shows a T1517 translocation. Exposure to which of the following substances is most likely contributed to this patient's condition? So basically, he is a chemical plant worker with pancytopenia, gum bleeding, and myeloblasts in the marrow. So what is the toxin that caused it? Well, he has acute promyelitic leukemia, and it's a subtype of AML. So the chronic benzene exposure is common in industries like the plastics and the resins and strongly linked to aplastic anemia and AML. Other options are going to be associated with different cancers, not AML. For instance, asbestos, that'd be associated with a mesothelioma, bronchogenic carcinoma, not AML. Formaldehyde is a weak carcinogen that's linked to nasopharyngeal cancer. Radon is lung cancer from radioactive gas exposure, and arsenic would be skin cancer, lung cancer, angiosarcoma, not AML. So benzene destroys the bone marrow stem cells and is a notorious cause of acute myeloid leukemia. There's this dude who works in a plastic resin factory. He's tired, gum bleeding, pancytopenia. His smear shows blasts. Bone marrow biopsy confirms AML with the 1517 translocation. So it's acute promyelocytic leukemia. And there you have a risk of DIC and treatment with all trans-retinoic acid. All right, so the pathophysiology here is that you have benzene, and that exposure damages the hematopoietic stem cells. And that causes chromosomal abnormalities, including translocations like 15 to 17, and myeloid precursors proliferate uncontrollably, which leads to AML. And APL and promyelocytes accumulate and release the Auer rods, which increases the risk for DIC. That's what's going on here, folks. So benzene can be associated with aplastic anemia and AML, asbestos mesothelioma, bronchogenic carcinoma. Formaldehyde is nasopharyngeal cancer and myeloid leukemia. Radon would be lung cancer. Arsenic would be skin cancer, angiosarcoma, and lung cancer. All right, for this next question, odds ratios. Statistical significance occurs when the 95% confidence interval does not include 1. So precision is how narrow the confidence interval is, and narrower means you're more precise. So here's a practice question. A study evaluates relationship between high sugar and incidence of type 2 diabetes. The calculated odds ratios for developing is 1.6, which of the following 95% for the OR indicates most precise and statistically significant result. Contains 1. So it's narrow confidence interval that excludes 1. And so the answer is D. Bottom line, odds ratio of 1.6 with 95 CI not crossing 1 would be significant association for what this dude has, which is type 2 diabetes. All right, this question, we have a 2-month-old with watery mucus, discharge from the umbilicus. Imaging shows persistent bowel umbilical connection. What part of the GI tract is involved? The answer is the ileum. So with that persistent vitelline duct connects to the ileum, and everything else is not involved in the vitelline duct. Not the ascending colon, part of the midgut, but not connected via the vitelline duct. Sigmoid colon is a hindgut derivative. The stomach would be a foregut derivative. Transverse colon, proximal 2/3 midgut. So the pathophysiology is you have a failure of the vitelline duct obliteration that leads to patent lumen. I always think of severance when I see that. And the ileum remains open to the umbilicus. Then you have discharge, and there's a risk of the infection. All right, so this is kind of an interesting condition if you think about it, because essentially what's happening is babies can actually poop out of their belly button. And this happens whenever the vitelline duct, which is a structure that's supposed to disappear during fetal development, stays open. And when it does, it creates a direct pipeline between the ileum, which is part of the small intestine, and the umbilicus. So you see a 2-month-old with mucus or watery discharge from the umbilicus, then it's a major clue that you're dealing from the ileum. It's that failure to close is the pathophysiology there. It's the persistent vitelline duct, complete patency, and so the ileal contents leak out at the discharge happens, and you can potentially have infectious complications. Also enteric fluid loss and obstruction, things like that. And we should know some associations like Meckel's diverticulum is a partial obliteration of the vitelline duct. So we have an outpouching of the ileum, and it may contain ectopic gastric tissue as well. And the patent vitelline duct is the complete failure to obliterate. And the umbilical abnormalities would be like the urethral abnormalities with the bladder and the vitelline abnormalities with the GI. And there's the rule of 2s, right? This is super important. It's going to be 2% of the population, 2 inches long, 2 feet from the ileocecal valve. And there are 2 types of ectopic tissue. A lot of 2s going on there. Bottom line, umbilical discharge in infants suggests a patent urachus or enteric fistula, most commonly connecting to the ileum. All right, in our next question, we have a 28-year-old woman who presents to the emergency department with a 4-month history of intermittent double vision and difficulty swallowing, which worsens toward the end of the day. She also reports a generalized muscle weakness after prolonged activity that improves with rest. All right, some symptoms that we need to know there. Physical examination reveals ptosis that improves after administration of a cold compress. Lab tests are significant for the presence of antibodies against the acetylcholine receptor. Very nice of them to say that. Chest imaging is performed and shows an anterior mediastinal mass. Which of the following likely is the diagnosis for the mass in the patient? Okay, so we know that this is myasthenia gravis, and that's confirmed by the ICE-BAC response, the anti-acetylcholine receptor antibodies, and the most common anterior mediastinal mass associated with myasthenia gravis is what? Everybody say it at once. Thymoma, right? The thymus plays a central role in the T-cell education and the tolerance. And so when it forms tumors, it can generate autoactive lymphocytes, which leads to the autoimmune disorders like myasthenia gravis. Okay, how about a pericardial cyst? Well, that's also the middle mediastinum, and that's benign and non-immune related. How about the teratoma? Well, that can occur in the anterior mediastinum, but usually it's asymptomatic and there's no myasthenia gravis association. And how about the lipoma? That's rare in the mediastinum, usually subcutaneous, and it's not linked to autoimmune disease. And so that is not going to be our answer either. It's a thymoma. Well, because 65% of myasthenia gravis patients have some sort of an abnormality in their thymus. And in this case, it's going to be an anterior mediastinal mass. The most likely culprit is going to be the thymoma. So thymomas are the epithelial tumors of the thymus, and they're infamous for triggering autoimmunity, including myasthenia gravis. And so when you see myasthenia gravis and you have a mass in the anterior mediastinum, you should every single time be thinking of a thymoma. That's a rare type of cancer that arises from the epithelial tissue of the thymus associated with myasthenia gravis and other autoimmune disorders. So the bottom line is a thymoma is commonly associated with myasthenia gravis and presents as an anterior mediastinal mass. All right, here we have a 45-year-old woman with a history of chronic lymphocytic leukemia presenting with a follow-up examination. She has been on standard chemotherapy and is currently stable. Lab studies show leukocytosis, but her lymphocyte morphology is unremarkable. A third-party research trial is utilizing cultured cell samples from the patient like hers to investigate cellular resistance to apoptosis. In vitro, when the patient's lymphocytes are treated with chemotherapeutic agents known to induce apoptosis, researchers observe minimal apoptotic features. In contrast, treatment of control lymphocytes typically results in a significant apoptotic change. Genetic analysis reveals lymphocytes with minimal apoptotic change overexpress a gene. What is that gene? So what inhibits apoptosis? This is pretty much all this is saying. Long questions now just for all of that. But let's reciprocate by just explaining in depth what's going on here with this condition. So CLL cells commonly overexpress BCL2. And BCL2 inhibits apoptosis by stabilizing the mitochondrial membranes and preventing cytochrome C release. So that explains the lack of the apoptotic features in the patient's lymphocytes despite chemotherapeutic challenge. And so BCL2 is a well-characterized anti-apoptotic oncogene. All right, so our answer is indeed A, but what about the MYC protein? Well, a transcription factor that promotes proliferation, not apoptosis, right? And it's common in Burkitt's lymphoma. MYC-Burk. That's why I remember MYC-Burk. It's not classic for CLL. How about the EGFR proteins? Well, that's a receptor tyrosine kinase that's involved in cell growth. That's more relevant to the lung and colorectal cancers, not anything related to this. How about the caspase-3? Well, that's a pro-apoptotic executioner, not anti. And then the tumor suppressor that's involved in WNT signaling in colorectal cancer, like FAP, would be your APC protein, okay? So that is not the answer to this question. So they're just asking basically what's happening in CLL, and that's a disease where the white blood cells accumulate because they divide super rapidly, or rather, it's not because they're dividing super rapidly, it's because they refuse to die. So CLL is where the white blood cells refuse to die. But here the researchers are exposing lymphocytes from a CLL person to chemotherapy, and they expected to see the classic signs of apoptosis and shrinkage and fragmentation. But the cells hardly responded at all. And the reason why is because the cells overexpress BCL2. That's anti-apoptosis. So the bottom line is BCL2 overexpression confers resistance to chemotherapy-induced apoptosis in chronic lymphocytic leukemia. All right, our next question, we have a 72-year-old woman visiting the clinic with difficulty using her right hand and unsteadiness while walking, which has been worsening over the past year. She has a history of type 2 diabetes, diagnosed 20 years ago, which has been poorly managed. Neurologic examination reveals atrophy of the hypothenar muscles in the right hand and inability to spread her fingers. Additionally, she struggles with balancing on her right heel and exhibits a foot drop on the right side. Which of the following pairs of nerves is most likely affected? Okay, so we're being asked about diabetic peripheral neuropathy, which tends to cause multifocal or symmetric nerve damage. And multifocal just means that it's more than one location or area of the body rather than confined to a single site. All right, so diabetic peripheral neuropathy would be multifocal or symmetric nerve damage, especially in long-standing, poorly controlled diabetes. And so this will localize to two separate nerves. In the hands, the hypothenar atrophy and inability to spread your fingers lets us know that it's an ulnar nerve palsy. And in the leg, that's foot drop, and so there's difficulty walking on the heel. That's going to be ulnar. Inability to spread the fingers, that's the interosseous weakness of the ulnar. So you check it out, ulnar. Foot drop is paralysis of the dorsiflexion. The deep fibular is a branch of the common fibular and has a motor in the anterior compartment of the leg, the dorsiflexion, and the lesion is associated with the foot drop and the high stepping gait and the loss of sensation between the first two toes. Now, diabetic neuropathy is where you have a microvasculature injury to the nerves, and that can cause neuropathy multiplex. Here we have a 28-year-old man presenting to the emergency department with a history or a severe headache and muscle aches and fever of 102.2. Symptoms began 3 days ago when he was on a hiking trip in the Pacific Northwest. Physical exam reveals conjunctival suffusion and calf tenderness. Initial laboratory tests show elevated liver enzymes and mild transaminitis. Blood cultures are pending. Which of the following infections is caused by an organism most similar to the likely causative agent in this patient? All right, so he has leptospirosis. It's a spirochete infection. All right, so this is leptospirosis, which is a spirochete infection. And they're asking the similar morphology here. So it's similar to Treponema pallidum, which causes primary syphilis as our answer. So the answer is a C. It's not cat scratch disease. It's a gram-negative bacillus, not a spirochete. Gonorrhea, Neisseria gonorrhea is gram-negative diplococcus, not a spirochete. Rocky Mountain is an obligate and intracellular coccobacillus, so different, and tetanus as well as a gram-positive spore-forming rod. Whereas syphilis is a spirochete that causes, or that is associated with Treponema pallidum. So leptospirosis has that in common with Treponema pallidum, which is the spirochete that causes primary syphilis. So the bottom line is leptospirosis, indicated by fever, conjunctival suffusion, and muscle aches, is often linked to exposure in freshwater environments. And it's also important to know that it shares that commonality with primary syphilis. Leptospirosis and Treponema pallidum both have that spirochete morphology. And the pathophysiology is where you have exposure to contaminated fresh water. So leptospira enters via the abraded skin or mucous membranes, and then you have flu-like symptoms, myalgias, especially the calves and conjunctival suffusion. And then later you can have jaundice, azotemia, and hemorrhaging due to the hepatic and renal involvement, right? So the spirochetes are those hook-shaped ends like leptospira, and the freshwater exposure is the key clue there. Also, especially in the calves, they have the fever, the headache, and the myalgia, and the conjunctival suffusion, the redness without the exudate, and the history of exposure to contaminated water while hiking. Didn't really focus on that there, but the thin, spiral-shaped spirochete bacterium has the hooked end since transmitted by water with animal urine in it. Hopefully this has been a nice little step 1 study session, and we'll see you guys in the next video. Hello everybody, we're covering 10 high-yield step 1 concepts. Be sure to like and subscribe. All right, the first question you might see on step 1, we have a 9-year-old boy brought to the clinic by his father for routine checkup. The father mentions that he's noticed some changes in his son's body odor recently. The child has no significant past medical history and is up to date on immunizations. He's at the 55th percentile for height and 50th percentile for weight. On physical examination, axillary hair development is observed, but there are no signs of testicular enlargement or penile growth. The father asks if his son's development is progressing normally. Which of the following is most appropriate response by the physician? Early puberty would require testicular enlargement, which he does not have, and so that's not the answer. Hormonal imbalance testing, that's unnecessary without abnormal growth or any sign of true puberty. C, the development is indeed within normal range. D, development of body odor is concerning and needs investigation. That is not true. That's expected. With adrenarche, it's not a red flag, and is that normal age-related maturation of the adrenal glands, which starts around ages 5 to 8, and it leads to an increased production of the adrenal androgens and the physical signs of puberty, like pubic hair, underarm hair, adult body odor, and oily skin in the hair. If this occurs before the age of 8 in girls and 9 in boys, then it might be a slight variant of normal development, but here he's a 9-year-old boy, so it's normal. And then height and weight means he's maturing faster than expected. Nope, the percentiles are normal, so there's no evidence of early maturation. 58th percentile, 55th percentile, totally normal. All right, this is just normal. The bottom line here is that axillary hair development with testicular enlargement indicates normal pre-pubertal changes, not early puberty. And a concept that I wanted to hit on is development. Around 8 to 11, the adrenal zone reticularis matures, and that increases this DHEAS, which causes body odor, axillary hair, and mild acne. And this is independent of the HPG axis, so no testosterone surge occurs yet. And there's also no testicular enlargement, and so there's no true puberty. So you get the body hair because of that. You also get a little bit of body odor, but there's not testicular or penile growth. There's no central puberty yet. And typically we measure those T levels and they'll be greater than 4 milliliters if puberty is occurring. Okay, so the fact is that puberty does not begin with body odor or hair. In boys, the very first sign is testicular enlargement. All right, nicely done. Now on to our next question. All right, you guys are doing great. And our next question, we have a 15-year-old woman, or I guess a girl, presents to the clinic with increased pain in her left shoulder over the past month. The pain is constant and worsens at night. She denies recent trauma or injury. On examination, there's swelling and tenderness over the proximal humerus. An X-ray of the shoulder reveals a sunburst pattern. That should tell you what the answer is, or at least what the condition is, along with a mixed lytic sclerotic lesion of metaphysis in the humerus. Biopsy shows pleomorphic cells. That just means it has various, just different, distinct forms. Basically, pleomorphic means that you got cells and tissues, entire organisms that just vary in their size and their shape. Like a pleomorphic adenoma would be a tumor in the salivary gland with a diverse mixture of epithelial cells and myoepithelial cells, while pleomorphic bacteria can change their shape in response to the environment. In some cancers, like a pleomorphic, an undifferentiated pleomorphic sarcoma, the tumor cells will show significant variation in the form and the size. I always like to explain these words that we use almost every time they come up just so we can really hammer them home, because there's a lot of insider baseball in medicine. vernacular to learn. So considering the most common site for metastasis of this disease, what should be assessed next? All right, so you have the answer here. The answer is indeed the lung, and this is osteosarcoma, which we should know because of that classic sunburst pattern. It spreads hematogenously, so through the blood and most often to the lungs. And so what do? You do chest imaging. That's super essential in diagnosis. And you guys have probably heard of the sunburst pattern, but that's whenever you have that brief appearance of the full sun behind the clouds, right? That's what the sunburst is referring to. It's like, sunburst. And now let's talk about the pathophysiology here. So it starts with malignant osteoblasts that produce the osteoid in the metaphysis. Osteoid is just like the bone stuff, is the unmineralized stuff made by the osteoblasts. It's made up of primarily type 1 collagen and other bone matrix proteins. It's the precursor to mature the hard bone tissue. That's what the osteoid is. And the metaphysis is that wide trumpet-shaped part of the immature long bone. And that's the site for the longitudinal bone growth in childhood and adolescence. All right, so putting it all together, malignant osteoblasts, right, they're just turning out a whole bunch of that unmineralized stuff in the metaphysis. That leads to aggressive periosteal reaction, which is that sunburst pattern or Codman's triangle. And periosteal, by the way, is just a nice little adjective that describes something situated on or originating from the periosteum. And the periosteum is this fibrous sheath that covers the outer surface of most bones. It provides nourishment, sensation, and attachment points for the muscles and the ligaments, and it's super important for healing and growth, right? And so if you have that malignant osteoblast production making all that osteoid in the metaphysis, then you have that aggressive periosteal reaction, which is the sunburst look. And this will invade the local bone and the soft tissue. That's what causes the pain. We have some pain here. And that will then invade the local bone and the soft tissue, causing pain and swelling. And then it metastasizes early via the blood, especially to where? The lungs, right? The pulmonary nodules. And this is commonly going to be seen in teenagers in the metaphysis of the long bones, the sunburst pattern, the osteoid producing stuff. Lung metastasis is most problem. And so the answer is indeed B. Now, it's good to talk about some of the other answers here. So the kidney, well, osteosarcoma does not metastasize to the kidney. That'd be renal cell carcinoma metastasized to the bone. The pancreas is not associated at all. The spleen, rarely a site of metastasis. Honestly, I'll probably never see anything with metastasis related to the spleen. And thyroid can metastasize to the bone, but osteosarcoma does not metastasize to the thyroid. All right, so on step 1, if you see a teenager with bone pain at night that is swelling over the metaphysis and sunburst pattern on x-ray, it's osteosarcoma. And the hallmark is osteoid production by the pleomorphic cells. And what you have to worry about isn't just this like destruction in the pleomorphic cell stuff. It is actually the metastasis that could actually occur and spread to the lungs. And so the next step is always, every single time, what do? You image the lungs. Chest imaging, right? Look for metastasis, so look in the lungs. All right, the bottom line, sunburst pattern osteoid in young patients suggests osteosarcoma. Assess the lungs for metastasis is the next good thing that you should do. Besides getting rid of this phantom arm right here. See that arm right there? Freaky, but I digress. Okay, for this question, I want to do something a little bit different. I want to talk about the science, and then we'll hit the practice question together. But today what I want to cover is, what does the science say about why smoking feels good? All right, and so let's just give the lay of the land here. All drugs of abuse, including nicotine, increase dopamine. And it increases the dopamine in the nucleus accumbens. And the nucleus accumbens, which I'll refer to as the NAC here, is a subcortical brain structure in the ventral striatum that is crucial for reward, motivation, and reinforcement learning. Cortical just means below the cortex. Ventral refers to like the underside part of anything, like an animal or plant. All right, so there's a structure inside of your brain which is crucial for reward. And it plays a big old role in behaviors like feeding, and it integrates signals related to motivation and a process of rewarding and aversive experiences. So you receive dopamine from the ventral tegmental area, which is referred to as the VTA. You receive that dopamine via the mesolimbic pathway. And this is what's implicated in addiction, depression, and other physiological disorders. All right, so the nucleus accumbens is the pleasure center of the brain. Pleasure, motivation, satisfaction, and it drives the behaviors that are essential for survival. It's also involved in learning and memory, right? So it associates the cues with reward that facilitate the reinforcement learning. And that's awesome because it helps us do things that drive desired outcomes. But this could go haywire in patients. That's the reason we're talking about it in a medical context. The nucleus accumbens regulates a variety of behaviors like eating, drinking, sexual activity, and social interaction even. But also aversive experiences are involved there because it teaches us how to avoid them. And the last thing I want to say about the nucleus accumbens is that it has extremely extensive connections. And that allows it to integrate signals from various brain regions to influence your behavior. All right, so a 45-year-old woman comes to the clinic and she's like, oh my gosh, I freaking love smoking. It gives me immediate pleasure and it's difficult for me to quit. She is asked like, hey, why is this so addictive? Which of the following neurotransmitter pathways is primarily responsible for the addictive pleasure that she's experiencing. All right, so is it serotonin release of the prefrontal cortex? Well, the answer is no. That modulates mood and anxiety, not the primary reward pathway. All right, so the answer is not A. What about B, norepinephrine and the locus coeruleus? Well, that's for arousal and alertness, not pleasure and reward. What about acetylcholine in the basal forebrain, right? D. Well, it's memory and attention, so no, not addiction reward. Endorphin release in the hypothalamus, pain modulation and euphoria for opioids, but not nicotine's primary mechanism there. All right, so the answer is C, dopamine release in the nucleus accumbens. All right, so if it feels really good when you smoke, it's not about willpower or personality. It's literally just your brain's wiring. Nicotine activates the receptors in the ventral tegmental area, then dump the dopamine into the nucleus accumbens. And your brain has that pleasure center, and so it's the same pathway that's hijacked by cocaine, alcohol, and opioids. And so the surge of dopamine is what creates the addictive pleasure and why it feels so hard to quit. Dopamine in the nucleus accumbens. All right. And for those of you who just want a little bit more, the only other thing you could possibly be asked on step 1 about this is that nicotine binds to acetylcholine receptors in the VTA. And it's like, hey guys, depolarize, send this message of joy to the whole family. And you're increasing the dopamine release. So dopamine then enters the nucleus accumbens, and you get this feelings of reward and pleasure, and that reinforces the positive reinforcement, and that causes addiction. All right, the bottom line here is dopamine release in the nucleus accumbens drives the addictive pleasure of smoking. All right, in this question, we have a 72-year-old woman with back pain, anemia, hypercalcemia. Okay, we already know what this is. That's the Crab criteria for multiple myeloma, right? You know Crab, don't you? He's a good guy. Just kidding. I used to play chess. I was on the chess team at Harvard, and there were a lot of people without homes who played chess in the square, and they would always, one of them would always speak with this exaggerated voice. He'd be like, you know Crab, don't you? So anytime I think you're here or want to say something weird, I always say it in that voice. Anyways, Crab, okay? C stands for calcium elevation. R stands for renal involvement. A stands for anemia. B stands for bone pain. All right, so calcium, renal, anemia, bone pain. That's the Crab criteria, right? So you have the apple green, bifurcations, and Congo red. All of that tells us that we have some amyloid deposition. Why do we have amyloid deposition? It's secondary to multiple myeloma. Okay, so let's zone in on this amyloid light chain, this AL, amyloidosis, particularly when it's secondary to multiple myeloma. Let's just explain how this works, right? Because we have to know it for step 1. There's no way around it. You just got to know this. And that's why I moved myself over to this side so you guys can kind of see all of the stuff I'm about to do. Amyloid light chain amyloidosis is a disorder that's caused by the misfolding and the deposition of immunoglobulin light chains. Usually we call these guys lambda or kappa, and they're produced in excess by the abnormal plasma cells. And when multiple myeloma produces excessive monoclonal light chains, these can misfold and aggregate into insoluble amyloid fibrils. And these deposits in organs like your kidneys or your heart or your liver or the peripheral nerves. Now, it's not extremely important to know all of those guys, but essentially the mechanism here is there's the plasma cell to the organ damage. So the clonal plasma cell disorder, like multiple myeloma, causes the overproduction of these free light chains. And these light chains misfold and they form beta-pleated sheet. And these fibrils deposit extracellularly into the tissues and they disrupt that normal organ architecture. And you get the Congo red staining, which deposits the apple green boots with the bifurcations under the polarized light, right? And the organs then become dysfunctional, like they have the renal failure, the restrictive cardiomyopathy, all that good stuff. And so the most common that you'll probably see tested on this is the kidney. It's the renal involvement, because you get deposition where? In the glomeruli and the mesangium. And this is nephrotic syndrome or progressive renal failure is what you'll see with this amyloidosis and this light chain because the plasma cells are going haywire. So on biopsy, you have amorphous eosinophilic deposits and the Congo red stain that's positive. Apple green boots with the fur, bifurcations, can also involve blood vessels and tubulointerstitial compartments. And so how do you recognize this from multiple myeloma? Well, the classic presentation is going to be somebody who is like an elderly patient. That's why I drew out 72 years old female, a young, sprightly young lassie who is feeling fatigue and weight loss and the Crab features, okay? If you can recognize the Crab features, you'll be A-okay. In fact, one of my friends recently took step 1 and she said, Crab features. You got to know them. It showed up twice, right? So calcium, renal problems, anemia, and bone pain, right? Crab. Just get that in your head. Elevated calcium, renal dysfunction, anemia, and bone pain. Say it like as many times as you want. Name your dog elevated calcium. Whatever it takes to get that in your head. Monoclonal spike of the serum protein electrophoresis, right? Look out for that, and also the elevated free light chains in the urine or the serum in the biopsy. Proven amyloid with the Congo red stains. For treatment, you address the plasma cell. So dyscrasia is just the abnormal disordered state of the body. Kind of a fun, fancy word if you want to impress people and also confuse them at the same time. But anyways, the answer is amyloidosis, my friends. I don't get too much crazy into the weeds, but it's a combination of this dyscrasia, Congo red, renal, amyloidosis, AL type secondary to multiple myeloma. Hopefully I explained that pretty well. So you have a renal amyloidosis and also Bence-Jones protein on urine analysis. All right, so that's pretty much everything that I wanted to explain on this question. But in multiple myeloma, you have abnormal plasma cells that proliferate in the bone marrow, and these plasma cells produce monoclonal immunoglobulins. Particularly, they're going to produce IgG and IgA, along with an excess of free light chains, which I described earlier as your kappa. or your lambda, and the light chains circulate freely and overwhelm the normal protein folding mechanisms. And so you have misfolding of the light chains, the free light chains. They misfold the beta-pleated sheet structures, which resist normal degradation. And then they aggregate in the amyloid fibrils, and they cause insoluble protein deposition in the kidneys, glomeruli and mesangium, in the heart, restrictive cardiomyopathy, and in the liver, and the nerves in the GI tract. So Congo red staining is how you see them. They demonstrate the apple green bifringence, and they're pathognomonic for amyloid. If you're finding what I'm doing here helpful, then please consider liking and subscribing. Monoclonal spike in that apple green stuff tells you amyloidosis is a likely diagnosis. In our next question, a 70-year-old woman presents to the clinic with a 2-month history of progressive difficulty walking due to numbness and tingling in her feet. She has a history of hypertension and diabetes, for which she takes lisinopril and metformin respectively. She was recently treated for latent tuberculosis with isoniazid, but she did not take the recommended vitamins. Oof. On examination, she has decreased proprioception and vibratory senses in her extremities, which of the following deficiencies is most likely the cause of her symptoms. All right, so this should just be on the tip of your tongue. In fact, you can just answer this one with buzzwords. The answer is C. Vitamin B6 goes with isoniazid. If you know that, then cool, good job. If you want to learn the mechanism, we'll do that briefly. So, isoniazid interferes with pyridoxine metabolism that causes a B6 deficiency. And pyridoxine is that colorless basic solid that you often find in the cereals, liver oils, yeast. And it's really important in the metabolism of unsaturated fatty acids like vitamin B6. All right, so pyridoxine metabolism requires that B6. And so you have that B6 deficiency, which leads to the peripheral neuropathy and also the loss of vibration and proprioception. Okay, some other answers and why they're wrong. Thiamine, and nicely they give us our B1. That causes beriberi or Wernicke's-Korsakoff. And beriberi is the inflammation of the nerves and the heart failure caused by deficiency of vitamin B. Wernicke is not isolated to that peripheral neuropathy from the INH. Biotin is our B7, and that's a deficiency from raw egg white ingestion. Causes dermatitis and alopecia, not neuropathy though. This would not cause any neuropathy. And vitamin C is scurvy. That's poor wound healing. And iron deficiency is going to be microcytic anemia, fatigue, and neuropathy. All right, so this question is really just a textbook case of pyridoxine deficiency caused by isoniazid therapy without vitamin B supplementation. They literally tell you she doesn't take it. And so our bottom line here is that the numbness and tingling and the loss of proprioception and vibration tells us we have low active B6, pyridoxal phosphate, which is a cofactor that's required for transamination and neurotransmitter synthesis. And so you get sensory neuropathy. All right, so feel free to pause. Let's look at these trap answers. Remember, it's B6. In our next practice question, a 30-year-old woman is seen in the outpatient clinic for a follow-up visit. She recently recovered from a respiratory infection caused by rhinovirus. During the visit, she expressed concern about the possibility of reinfection as she frequently travels for work. To ease her concerns, you explain that her immune system has developed a defense against this, which the following explains the mechanism by which her immune system will protect her against reinfection of the same virus. Okay, so upon re-exposure of the same rhinovirus strain, the immune system neutralizes the virus via antibodies, which bind the viral capsid proteins and they prevent the interaction with the ICAM1 receptor on the epithelial cells. And that halts the infection before the virus can even enter the cell, and that provides protection from reinfection. So rhinovirus immunity is strain-specific, and there are many serotypes that exist, but you get these neutralizing antibodies that block the receptor binding, and IgA and IgG prevent the reinfection, not intracellular killing. And there's no latency, no integration. Protection relies on antibody memory. La da 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 da. Remember cats, memory, right? So really briefly, it's important to know the pathophysiology of this. I like a button that goes pathophys, pathophys. Rhinovirus infects the respiratory mucosa and that activates the immune response, right? And then we get an activation of our B cells. Ciao. They produce the strain-specific neutralizing antibodies, and then upon re-exposure of the same strain, antibodies bind the viral capsid. So this blocks the viral attachment to the ICAM1 receptor on the epithelial cells, and so the result is there's no reinfection. All right, now there are a lot of juicy answers for us to choose. Activation of natural killer cells, that's innate immunity that's used for early viral response, not memory-based stuff. B is our right answer. Suppression of the viral protein synthesis, that would require the virus to enter the cell first, and antibodies prevent re-entry. Direct lysis of the virus-infected cells. That's the CD8 positive T cells that kill infected cells after the infection has occurred, not preventative. And then the inhibition of viral assembly and maturation also occurs after the infection, not relative to the prevention of the reinfection. So after you beat the common cold caused by rhinovirus, your immune system doesn't forget. It never forgets. Instead, it creates the neutralizing antibodies that latch on to the same viral strain, and they stop it from ever getting in again. The antibodies block the virus from binding to ICAM1. Think of ICAM1 as like the door to the house they're trying to get into, and they're like, nope, I'm locking this, so you'll never be able to get in. So our bottom line is immune protection is primarily due to the neutralizing antibodies that block the receptor binding process. All right, in this question, we have a 62-year-old woman presented to the clinic with persistent swelling and pain in her left knee, which has been increasing over the past 3 months. She has a history of rheumatoid arthritis managed with methotrexate. Physical exam shows a warm, swollen left knee with a decreased range of motion. Arthrocentesis is performed, and synovial fluid analysis shows an increased white blood cell count, predominantly composed of lymphocytes. The fluid is cultured, yielding no bacterial growth. Radiographs of the knee show joint space narrowing and erosions. To investigate the immune process further, flow cytometry of the synovial fluid is carried out, focusing on T lymphocyte populations. These T lymphocytes are found to be active due to antigen presentation. Where did the antigen presentation most likely occur? Alrighty, so rheumatoid arthritis, RA, presents extracellular antigens to the CD4 positive T cells via the MHC2 complex. And extracellular proteins are processed for the endosomes and lysosomes, where they're degraded and loaded onto the MHC2 molecules before they're displayed on the cell surface, right? So these proteins have to interact with these endosomes, they're processed inside of them, and then they're degraded and they're loaded onto these MHC2s. So protein to endosome to MHC2. This is not the ER is MHC1 pathway, or the mitochondria or the Golgi of the nucleus, right? So the Golgi is the packaging. It's not where the antigen loading occurs, so it's not the Golgi. Rough ER is where the MHC1 loading happens, not the exogenous stuff. The mitochondria is energy production, so nothing there. And then the nucleus is the gene transcription, not the antigen binding site. So the antigens get loaded for presenting, and for CD4 positive T cells, it's not in the ER, it's the endosome. And that is where extracellular proteins are chopped up and placed onto the MHC2 molecules before they head to the surface. All right, and our next question, a 52-year-old woman presents to the clinic with a 3-week history of fatigue, irritability, and tingling of the hands. She reports recent muscle cramps and that she's been more forgetful than usual. Physical exam shows dry, coarse, and brittle nails and positive Trousseau sign where her blood pressure is checked. Vital signs are normal. Lab analysis shows serum calcium of 7 and phosphorus level of 5.5, which the following is the most likely diagnosis. All right. So we got some key facts that we got to talk about for this condition. I see that cramping, I see that tingling, and then brittle nails, and I'm thinking hypoparathyroidism. So the key facts are hypocalcemia and hyperphosphatemia and Trousseau sign all indicate hypoparathyroidism. And so there we have our low PTH, which leads to low calcium reabsorption and decreased phosphate excretion. So basically we have our 52-year-old woman. She's got neuromuscular irritability. She has the tingling, the cramps, and the positive Trousseau sign. There's cognitive changes, so irritability and forgetfulness. There's the dry, coarse skin and the brittle nails. And that's the hypocalcemia coming in. All right, so this is the hypocalcemia. And indeed, our calcium levels are just at 7 and the phosphorus at 5.5, which is high, and the calcium at 7 is low. And it's all due to that low PTH. And low PTH causes low calcium reabsorption of the kidney, low calcium mobilization from the bone, low calcitriol activation that causes low intestinal absorption, and increased phosphate retention because PTH normally promotes phosphate excretion. And then you probably are wondering about this Trousseau sign thing. That's the latent tetany due to hypocalcemia. All right, so that's another one of the calcemia problems. So that's Trousseau sign. And here are the other answers. Primary hyperaldosteronism would show hypertension and hypokalemia. Graves' disease would have a heat intolerance. That's hyper. And secondary hyper is be related to chronic kidney disease, and the phosphate would be high, but the calcium typically low to normal due to compensation. And then the vitamin D deficiency would have low calcium and low phosphate. We don't see that here though. All right, in our next question, we have a 22-year-old college student presents to the campus health clinic with a 3-day history of painful urination and foul-smelling thick yellow discharge from the urethra. He reports multiple sexual partners admits to inconsistent condom use. He denies fever, but mentions that the scrotal pain worsens when walking and improves when he lies down and elevates the area. On examination, there's tenderness on palpation of the right epididymis and notable purulent urethral discharge. NAAT is performed in the discharge. Which organism is most likely responsible for his condition? Alrighty, so we got a young boy who shows up with painful urination and a thick yellow discharge. Then you should think of gonorrhea, because if you see the yellow discharge, you are gone. But especially if he's sexually active with multiple partners and not using protection. So this discharge is purulent, which means that it's got pus, right? Containing discharging pus. That's what purulent means. And the scrotal pain that gets better with elevation, that immediately should point you to epididymitis. And I know that I've covered this in another video. So if you're watching the channel at this point, you should be in pretty good shape. But this is classic presentation for Neisseria gonorrhea, which is confirmed with the nucleic acid amplification test. And that's the reason why the right answer here is Neisseria gonorrhea. Okay, so our answer is D. Now we got to break down the other one. So chlamydia, trichomonas, that is the more common overall, but it causes a clear, watery discharge, not purulent. All right, so I'm going to draw chlamydia in blue, watery discharge, not purulent. E. coli is common in older men post-surgical patients, but it's not typical in the young sexually active males. Klebsiella causes granuloma inguinale and a painless ulcer, not urethritis. Urethritis is the inflammation of the urethra that we see in this patient. And Treponema pallidum is the syphilis, which causes a painless chancre, not discharge or epididymitis. And so really it's that thick yellow discharge which is cueing us into this, and also the NAAT positive for gonorrhea and the scrotal pain that improves its elevation, immediately tells us this is epididymitis. And the gram stain is gram-negative diplococci inside of the neutrophils, and the treatment is ceftriaxone and doxycycline for possible chlamydia co-infection. So here we do need the ceftriaxone and doxy as well for possible co-infection. And the real kind of mechanism here is just unprotected sex. So you get Neisseria gonorrhea that enters the urethra. Then the bacteria adhere to the mucosa. They do that how? Pili. That's a question that you might see. And then they invade and cause inflammation, urethritis, and they can ascend and infect the epididymis, causing epididymitis. And that presents with dysuria, perianal discharge, and scrotal pain. But you lift it up, you elevate it, and the epididymitis doesn't hurt anymore. So all that points us to Neisseria gonorrhea, gram-negative diplococci, Diplococcus, that is the cause of epididymitis. So it's that urethritis in a young male, so just Neisseria gonorrhea. All right, for this question, we were asked to identify the type of study design. Case control compares past exposures with those with and without a condition retrospectively. Cohort follows a group over time. Prospective, cross-sectional measures the exposure and outcome at the same time, like a Snapchat. Case series is similar individuals, and randomized control is the gold standard. With that being said, we have a very easy practice question to enter a nice little video on. We have a group of 2,500 adults in metropolitan city, randomly selected and surveyed about their dietary habits and their current blood pressure levels. As you can see over there, we got a nice stunning man with his blood pressure cuff. The data is collected on the frequency of fruit and vegetable consumption along with the simultaneous measurements of systolic and diastolic blood pressures. Which of the following types of studies is this an example of? The answer is cross-sectional, right? Because you're just measuring both the exposure, which is the diet, and the outcome, which is the blood pressure, at the same time. And there's no follow-up. You're just, boom, let's examine everything and let's freaking do a cross-sectional study. We did it, folks. And this is important because imagine you're like me. Now I'm the person getting my blood pressure checked. You guys are going to be the one who treats me someday when I'm old, gray, and wise. And you'll have to know. Cross-sectional study design assesses dietary habits and blood pressure at a single point in time. Now, all I'd like to know from you guys is, was this helpful? If it was, go ahead and like and subscribe. I would really appreciate that. It helps with the channel. And hopefully you guys are having a great dedicated period out there. Give yourself a pat on the back. You're doing so well. Thank you for choosing the path to become a physician. And we'll see you guys in the next video. My goal for you is that you pass step 1, and I want you to pass step 2 as well. If you'd like to support the free work we're doing here, consider liking and subscribing. Your time is very valuable, so let's dive right in. A 42-year-old woman with a history of HIV infection is currently receiving antiretroviral therapy, including stavudine. And just as a reminder, stavudine is an NRTI, which stands for a nucleoside reverse transcriptase inhibitor, that mimics and it terminates the viral DNA chain. So it stops DNA synthesis. All right, so it's a medication that you can take, and you have to know it's a thymidine analog, NRTI. So think you are inhibiting reverse transcriptase after phosphorylation. All right, her latest lab results show an increase in her HIV viral load over the last 2 clinic visits, despite good compliance with the medication regimen. All right, so there you can see the patient. There's a rough sketch in the body. There's a helpful little diagram. There's the bottom line. Genetic testing of the HIV strain reveals a mutation associated with resistance to stavudine. Which of the following molecular targets is most likely implicated in the development of the resistance? All right, so we already talked about how this is going to inhibit the reverse transcriptase. And we know that because it's an NRTI. So the high yield fact you need to know for step 1 to answer this question correctly is that mutations in the reverse transcriptase gene are the most common mechanism of resistance to NRTIs. Basically, we have a drug that inhibits this, and so if we change this, then we get resistance. And the way to think about drug resistance on step 1 is anytime you have a high viral load despite compliance, that is to say they're taking the medication, then you should think of drug resistance. And in order to answer the questions about drug resistance, you need to know the mechanism of action. And the mechanism of action is all over this exam. You have to know the MOA of every single drug. But it's easier than you think because you can cluster the drugs together, and usually they have common nomenclature. So we have a reverse transcriptase mutation, and that disrupts the binding of the drug to the enzyme, right? You can no longer bind there. M18V, K65R, or thymidine analog mutations, commonly referred to as TAMs, reduce the efficacy of stavudine. All right, so make this super crystal clear before we go over the answer together. You should first recognize this medication is an NRTI. You should know this is phosphorylated in host cells to activate the triphosphate form. And now these will incorporate into viral DNA during the process of reverse transcription. And that causes what we refer to as a chain termination. I like to think of that one scene from Emperor's New Groove. He's like, you threw off my groove. NRTIs, they throw off the groove, right? They're activated triphosphate. They just throw off the groove of the reverse transcriptase. And that is the reason why our answer is HIV reverse transcriptase. What happens is you get a mutation that alters the enzyme structure, and that reduces this binding process. That is how we develop resistance. This allows increased viral replication, even though the patient is compliant. So we got a patient right here. Look at her. She's so compliant. And the bottom line is stavudine resistance in HIV is primarily due to mutations in HIV reverse transcriptase. You know this because you recognize that this is an NRTI. You know it's a thymidine analog that targets HIV reverse transcriptase. You distinguished it from other HIV drugs And you probably knew that because you watched our video on NRTIs. And because of that, you selected reverse transcriptase gene. It's important to know why the other answers are wrong. A, viral entry co-receptor. A good example of this is Maraviroc that targets the CCR5. And this is irrelevant to NRTIs like Stavudine. What about neuraminidase? That is a flu drug. Oseltamivir is the drug. That step 1 will question you on there. HIV protease. The answer is not C because these guys end in navir. And if you watched my video, you would know that the proteases work and they make it so you can navir transcribe. That's the mechanism of action of protease inhibitors. And Stavudine, being an NRTI, is not affected by protease mutations. D is winner, winner, chicken dinner. E, DNA-dependent DNA polymerase. Well, that would be the herpes viruses, like acyclovir. The HIV uses RNA-dependent reverse transcriptase. So those are the reasons why the trap answers are wrong and why D is correct. I was working with a student the other day and they had a question about DNA-dependent DNA polymerase. It's kind of confusing, but in the name DNA-dependent DNA polymerase, we know that it's an enzyme that's used by DNA viruses. So you have to know the DNA viruses, and again, I have a video on that, but for DNA virus, let's think of like herpes or CMV. And DNA-dependent DNA polymerase is used to copy their DNA to make more DNA. Drugs like acyclovir and ganciclovir, their job is to stop that enzyme, which then will stop the virus. Okay, so why is that not the answer? Well, this does not apply to HIV. What? Yes, it does not apply to HIV. And why not? Well, HIV is not a DNA virus. It starts as RNA. So let's zoom in here. HIV uses a different enzyme. It's not DNA-dependent DNA polymerase. You know this answer. They use reverse transcriptase. And that turns the RNA into DNA. And so drugs like acyclovir don't work on HIV because they target the wrong enzyme. Cool beans? That wasn't so bad. Again, if you like this content, please like and subscribe. Question 2, you're doing great. Here we have a 32-year-old woman, you can see her right here, very smiley, is undergoing an experimental trial involving the administration of a beta-adrenergic agonist, boy, that's a mouthful, to study its effects on different organ systems. The medication is delivered intravenously, and over several hours, various psychological effects are recorded. Which of the following effects is most likely attributable to the activation of beta-2 adrenergic receptor by this drug? Good question. I think so too. Here are the potential answers, but I want to give us the lay of the land. What's all this talk about the beta agonists? Well, beta adrenergic receptors are part of the sympathetic, or the fight or flight system, and there are 2 major types you need to know for step 1. It's the beta 1s and the beta 2s. This question's asking about the beta 2s, but it's important to also know the beta 1s really quickly. Promise this won't take a lot of time. This is high yield for step 1. For these beta receptors, you need to know 2 things. 1, where? Where is it located? And 2, what does it do? So answer along at home with your popcorn. Hopefully you guys are treating yourselves. Beta 1 acts on the heart, and it also acts on the kidneys. What does it do? It increases the renin. I like to remember you have 1 heart, and it kind of seems like you have 2 lobes of your lung. Beta 2, where do you think that acts? It also acts on the GI and the uterus. Okay? Those are some examples there. And so what does this do? Smooth muscle relaxation. And so now we're kind of getting the lay of the land here, and we understand that beta 2 acts on the lungs, and this is a question involving the beta 2s. And so the answer is going to be something involving the airway, and bronchodilation is indeed correct. So here's an explanation that you can pause and read. But basically, beta 2 is your smooth muscle relaxer. What it does on the lungs is it does bronchodilation. That's a fancy word for saying we're opening the airways. We can breathe. The vasculature is going to vasodilate in the skeletal muscle. And we mentioned the uterus is involved too. It's going to relax the uterus, right? It stops preterm labor is what that's used for. In the GI tract, it's going to slow motility. Smooth muscle is just going to be relaxing. That's its job. Beta 2, nice and relaxing. The pancreas and the liver, well, there we have to go into a little bit more detail, but not too much because, again, we're super high yield on this channel. We like to go into just the right amount of depth. Beta 2's effect on the pancreas and liver would be increased insulin, increased glucagon, and increased glycogen breakdown. It can also act on the eye, and that's interesting because that's actually going to decrease the aqueous humor production. All right, so that's what the beta 2 does. And you probably heard a lot of these guys, like albuterol. Heard of that one? That's used in rescue inhalers for asthma because of that bronchodilation. So beta 2 agonists, really think of that an inhaler as your first thought when you're taking this exam. Also like someterol, terbutaline. Those are beta 2 drugs. Terbutaline is used to stop premature labor. Okay, so the big point here for beta 2 is that we are doing smooth muscle relaxation everywhere except for one place. What is that one place we're not doing? The heart. Why? Because the heart you only have 1 of, and it's a beta 1. The lungs you have 2 of, and so it's beta 2. That's the way that you should try to remember this, okay? And so this question's like, okay, which one are we activating? And the answer is the beta 2 effect. Remember the lungs, Remember asthma. So beta 2 relaxes smooth muscles. The lungs, bronchodilation. The GI, there's less motility. The uterus stops contractions. The blood vessels have vasodilation. It tells the muscles to chill out. And then the only thing you should really know that's just kind of hard about this is what we mentioned with the pancreas. Because beta 2 also acts on the cells that are not muscle, right? Like the pancreatic islet cells, like insulin, glucagon, the hepatocytes with the glycogen storage. And their beta 2 does not relax. Instead, it stimulates the secretion and metabolism via the CAMP pathway. Okay, so you might be thinking, Blake, you just said that all this stuff is nice and relaxing in beta 2, and you're saying it's nice and relaxing, but then the pancreas is doing this fight or flight stuff. Yeah, beta 2 does not relax. It stimulates the secretion and the metabolism through the GS protein pathway. All right, so what's the deal? Smooth muscle, relaxation. Pancreas, increased insulin and glucagon. All right, so the big old TLDR, beta 2 relaxes smooth muscle. Beta 2 also releases the sugar and the hormones to fuel the body. And that can seem like they're at odds with each other, but it's actually perfectly coordinated. Let's imagine you're being chased by a bear. Your body has to run fast, right? Muscles need glucose. You have to breathe better, right? So the lungs are going to open. You have to think sharp, right? So the brain needs glucose as well. You have to delay the digestion. You don't need to digest your cornflakes right now. You need to run away from the bear. And so beta 2 does all of that. It's like, thank goodness for that beta 2 pathway. Lungs, bronchodilation, more oxygen, nice. The skeletal muscles, right? It sends more blood and sugar to the muscles so they can do the thing. They can run away from the bear. You pause the digestion, right? The GI, the bladder stuff, the uterus. You pause that. If you're having a baby, put that on hold. Got to run away from the bear so we can have a successful baby. Successful baby. Anyways, the liver releases glucose to power the muscles. And then the pancreas mobilizes and uses the glucose more efficiently. All right. So that's how we make sense of this in a fight or flight scenario, even though I said it was like a relaxing thing. Yeah, smooth muscles, but sometimes we have to use the glucose too. So kind of different tools to be able to escape the bear. Cool beans? Hopefully that was helpful. Hopefully that was very, very clear. The bottom line is beta 2 adrenergic receptor activation primarily causes bronchodilation. All right, here's our nice looking 28-year-old man presenting to the clinic with a 3-day history of sore throat, fever, and swollen lymph nodes. Yikes, look at that swollen lymph node. Check out that diagram as well. He has no significant medical history and takes no medications. On examination, his temperature is 101.3, pulse 90, blood pressure 110/70. Physical examination reveals erythematous pharynx and bilateral cervical lymphadenopathy. Lab tests show leukocyte count of 14,000. A peripheral blood smear is obtained, which of the following leukocyte patterns is most likely to be seen in this patient. All right, so I like to start with the buzzwords because this test, they give you the answers in the question, right? So we got a dude who has sore throat. He's got a fever. And the only thing that stops it is more cowbell. If you know, you know. Wink. He's got some swollen lymph nodes. And so these things should make you think of a diagnosis that is Epstein-Barr virus or strep, right? So at this point, our differential diagnosis is Epstein-Barr, strep, and he's 28, right? So that's the peak age for infectious mononucleosis. And then we have a peripheral smear, and there we should look for atypical, what? Atypical lymphocytes, not neutrophils. Everybody loves to choose neutrophils, and we'll talk about that in a second. But we also see bilateral cervical lymphadenopathy, and that is classic for EBV. All right, so they love to trick you to think of neutrophilia, neutrophils, because they want you to think that it's a bacteria, but it's a viral illness, right? So pick lymphocytosis. So let's learn just a little bit about Epstein-Barr virus, shall we? The most important things for step 1. Here, I cut the fluff. Here's exactly what you need to know. Nothing more, nothing less. Epstein-Barr virus is transmitted via saliva. That's why they call it the kissing disease. Which cells does it infect? You should know this. And if you don't, that's okay. You'll know it in 5 seconds. The B cells. Via the CD21 receptors. You got to be 21 to enter this bar, right? And that leads to reactive cytotoxic CD8 T cell proliferation. And that's what causes our atypical lymphocytes. It's those infected B cells, those CD21 receptors, activating these CD8 positive T cells, which causes the atypical lymphocytosis. And the common symptoms, we already discussed those. What are they? Fever, sore throat, generalized fatigue, and posterior cervical lymphadenopathy. And that's why in our beautiful photo right here, you can see posterior cervical lymphadenopathy. You can also see some splenomegaly as well. So Epstein-Barr infects the B cells, and you get viral replication on the inside of the B cells. Check out this B. Oh my gosh, what's going on in there? Did you see this? There's a viral guy right there inside of the B cell. What are you doing, viral guy? He's replicating. And so the body responds with a massive CD8 positive T cell response. And the CD8 is looking for this guy. They're going to find him. They're going to kill him with their particular set of skills. And so these activated T cells appear as atypical, right? It's not typical to have a bunch of CD8s wandering around your neighborhood being all weird. trying to chase after my little viral guy inside of my B cell. Not fun. However, the total white blood cell count is going to rise, but it's due to the lymphocytosis, not the neutrophils. Okay, so don't pick neutrophils. Por favor, whenever you're picking Epstein's-Barr virus, you got to pick the lymph. All right, so there's the explanation, kind of basically what we said here. The trap answers why they're wrong. Basophilia would be myelogenous leukemia. Eosinophilia would be allergies. Monocytosis would be for TB. And the interesting thing is 90% of adults worldwide are infected with Epstein's-Barr virus by age 40. Everybody's just out there kissing each other. Cool beans? Bottom line, lymphocytosis is the most likely leukocyte pattern in a young adult with viral pharyngitis. That wasn't so bad. Again, if this is helpful, like and subscribe. It's free, it's easy, and it definitely supports the work we're doing here. Moving on to question 4. Here we have a freaky man with a hand growing out of his arm. There we go, much better. Had to regenerate that one. In 3 weeks after undergoing open repair of his forearm laceration, he's got that numbness and tingling. Upon examination, there is diminished sensation of the distribution of the median nerve. Okay, we got our buzzword. So the first thing to note, if you're highlighting this, I would say there's numbness, and there's numbness after some sort of an injury or a surgery. And so there's numbness in the peripheries, so we're thinking a peripheral nerve injury. And here they literally tell you that it's the median nerve. Okay, so that's the important stuff that we got so far. We have diminished sensation, and diminished sensation should actually make us think of axonal disruption. If it's just diminished sensation, it's probably not a complete transection, right? And a transection is if you completely cut across the nerve. The surgeon says the sensation will slowly improve. Wow, what does that mean? Regeneration, okay? That's what they're trying to get at, regeneration. Which of the following is the primary factor determining the rate of recovery? And now, here's the real kicker. The nerve needs to rebuild the axon, right? We have axonal disruption. We have to rebuild this. We know it's regeneration because the surgeon says it's going to grow back, and the surgeons are always right. Just kidding. They're not always right. So the nerve needs to rebuild the axon, and that means sending the components from the cell body to the distal axon end. So let me show you what I mean. Here's the cell body, there's the axon end. That is anterograde axonal transport. It's going the way you think it's A-OK, so it's anterograde starting with an A. All right, they told you that it's the median nerve, and that was awfully nice of them, right? Well, median nerve injuries can have some motor associations. That would be like the thenar muscles, right? The thumb opposition, that kind of stuff. They can also have a sensory component. That'd be like the lateral palm, the first 3 fingers. And the peripheral nerve regeneration, for that, you need intact Schwann cells. And so our answer is slow anterograde axonal transport. You need those intact Schwann cells in the basal lamina, and axonal regrowth follows the Wallerian degeneration that has occurred in this patient. And it's kind of slow, right? So the anterograde transport is the rate limiting step of this recovery. Okay, so the breakdown of this question is simply we had a nerve injury. Ouch. No fun. Our nerve is hit. Our Schwann cells and our macrophages clear the debris, and then your cell body begins rebuilding the axon via slow anterograde transport. And what happens there is you have structural proteins, right? Like tubulin, actin, and that gets moved down the axon very slowly. And so the nerve regrows along that preserved Schwann cell tube, and it happens pretty slow. It's like 1 to 3 millimeters every day. All right, so that's the rate limiting, but that's why the surgeon said that it's going to be okay because of that anterograde axonal transport. You're moving the cytoskeletal components. It's the rate limiting step for peripheral nerve regeneration. Fast transport would not be enough for this regrowth, and so you have to take the slow path. All right, so there's our brief explanation. Here's some trap answers why they're wrong. Schwann cell mitosis has a supportive role, but that regrowth there does not dictate the speed. It's that axonal transport. Fast retrograde, that would be signal to the cell body, used for transporting signal molecules, not for the rebuilding. Plasma membrane receptor turnover, that would be a signal thing. And myelin macrophage clearance, Wallerian degeneration is necessarily on, but it's not rate limiting. All right, so the bottom line is the rate of sensory recovery after nerve injury is primarily determined by slow anterograde axonal transport. All right, last question, and we'll take a quick break. Here we have a super jacked 22-year-old dude presenting to the emergency department with a 4-day history of fever, joint pain, and new skin rash. Recently started sulfonamide antibiotic for acne. Temperature is 100.8. Pulse is 88. Respiratory rate is 14 per minute. Blood pressure is 120/78. Physical examination reveals a diffuse macular-papular rash on his trunk and extremities. Lab results show serum creatinine of 2, which is elevated from the baseline of 1. Urine analysis shows the following. What do we got? We got blood, protein trace, white blood cells, and eosinophils at 20%. What is the diagnosis? All right, so we should know that this guy's got some kidney problems. The key features to watch out for in this case are the increased creatinine, that's the acute renal failure, the urine analysis, which shows white blood cells, but also it shows eosinophils. There are no casts like you'd expect in a glomerular disease. There is some sort of a recent drug exposure, so make sure you mark that. So there's a fever, there's rash, there's arthralgias. That's just a fancy word for saying pain in the joint. And this occurs 3 to 5 days to 2 weeks after starting. So the medication probably caused it, right? And it's causing problems in his kidney. We knew that because of the creatinine. And so this should make us think of a classic case for acute interstitial nephritis. You have recent sulfonamide exposure, fever, rash, arthralgia, elevated creatinine, white blood cells, and eosinophils. All of those things point us to D as our answer. All right, here's our explanation. Why is it not a drug-induced vasculitis? Well, there you would see purpura, hematuria, and maybe some systemic symptoms. But here we do not have hematuria with the red blood cell cast or the purpura. And eosinophiliuria is not going to be typical here. How about the nephrotic syndrome? Well, nephrotic syndromes, you would have massive proteinuria. And by massive, we mean like greater than 3.5 grams per day. I'd also see edema and hyperlipidemia, but they have trace protein, no edema, inflammation that's not nephrotic. Membranous nephropathy, a spike in dome, that would also have heavy proteinuria because that's a nephrotic syndrome. Renal artery stenosis would have refractory hypertension. His was normal. You'd also see like an abdominal bruit there, and you don't see that in this particular patient. So this is acute interstitial nephritis. The pathophys is you take a drug, the drug acts as hapten triggering immune reaction, right? So you get those haptens acting up. This leads to the infiltration of the interstitial kidney tissues by a couple of things, the lymphocytes, the macrophages, and the eosinophils, right? And that causes tubular interstitial inflammation. So you have impaired tubular function and acute kidney injury, and eosinophiliuria is going to be the diagnostic clue there. So the creatinine tells us that we got renal problems. Urine analysis shows that we have eosinophils. And there's no CAS, so it's not glomerular disease. And there's a recent drug exposure. This is all pointing us toward acute interstitial nephritis. Thank you so much for getting to the end of this video. Please like and subscribe if you found this helpful. I made this channel because I want you to succeed. Whether you're a medical student, frantically studying, and this is your last day before you take step 1, or you're just binge watching YouTube and you came across this channel, I'd hope that you'd like and subscribe and learn more science facts, more medical facts every single day. Take care and have a great rest of your day. Hey everybody, you know what this is? High yield step 1 questions. Let's get right into it. A 27-year-old woman presents to the emergency department with complaints of increasing shortness of breath, fatigue, and swelling in her legs the past week. She mentions that she feels more shortness of breath when lying flat and often wakes up at night feeling breathless. Her medical history is significant for the delivery of a healthy baby girl 6 weeks ago. Prior to her pregnancy, she had no significant medical issues. Her recurrent medications include only prenatal vitamins. On physical examination, her temperature is 98.2, heart rate is 112 per minute, blood pressure is 110 over 70, respirations are 22 per minute. Jugular venous detention is noted, and auscultation of the chest reveals bilateral crackles. There is a +2 pitting edema in both lower extremities. Her chest x-ray shows cardiomegaly and pulmonary vascular congestion. Which of the following conditions is the most likely diagnosis? All right, to crack this question, you have to think like a cardiologist would. We have a young postpartum woman who is now showing signs of congestive heart failure. Some important signs in the question are orthopnea, that's the shortness of breath when she's lying flat, the paroxysmal nocturnal dyspnea, or PND, that's the waking at night and she's gasping for air, and also the leg swelling, and the JVD, and the pulmonary crackles, that means there's volume overload. So those are classic signs of systolic dysfunction, and given her postpartum status, the condition points to peripartum cardiomyopathy. And peripartum just means done or occurring shortly before or after labor and delivery. So this is like 6 weeks postpartum. So perfect timeline for peripartum, right? Orthopnea, PND. And that tells us that there is probably left-sided heart failure. There's a crackling, the JVDs, the pedal edema. That's pulmonary and systemic congestion. And so you have cardiomegaly on the chest x-ray. That means there's the dilated heart chambers. So she probably has the dilated weakened left ventricle that can't pump the blood forward. And so instead it causes a backflow up to the lungs and the venous systems. Now there are a couple of associations that are sometimes relevant for STEP. This is more common in African ancestry, so higher incidence in Black women. And also each pregnancy increases the risk. Also tocolytic use like beta agonists can contribute to cardiac stress. And for the diagnostic criteria, you look at the ejection fraction, and if it's less than 45%, that would be very important for the diagnosis. And that can actually progress to a fulminant heart failure or even require a transplant. And so the pathophysiology here is you have a pregnancy-induced hemodynamic stress. So you increase the blood volume and the cardiac output, and then you get myocardial remodeling. And that leads to the left ventricle dilation and the systolic dysfunction. And so you get dilated chambers, you decrease the ejection fraction, the fluid backs up into the lungs and the systemic circulation. And if it's untreated, then it can lead to a thromboembolism or arrhythmias or a cardiogenic shock. And there are some key features here, like the S3 sound. That's whenever you have volume overload, so it makes sense that you'd see that S3 gallop and the displaced apex beat, which means that you have left ventricle dilation. So you have cardiomegaly, pulmonary vascular congestion, and of course that ejection fraction is less than 45% in naked cardiogram. That's the super important diagnostic test. Now, why is it not, let's say, acute viral myocarditis would be a recent viral illness, and that's not mentioned. And that's usually in like younger males and kind of just different presentation. Deep vein thrombosis, that'd be a unilateral leg swelling and no JVD or crackles would be seen. So that's not the right answer. Mitral stenosis would be a diastolic murmur. So you have rheumatic fever, and anxiety disorder would be like hyperventilation. You'd also see normal vitals on an anxiety disorder. And this patient has some very clear objective findings. They got JVD, they got edema, they have that kind of stuff. And so basically this is heart failure in a young, healthy mom weeks after delivery. So it's peripartum cardiomyopathy. And usually this is going to be in the last month of pregnancy or within 5 months postpartum. And they have orthopnea, paroxysmal nocturnal dyspnea, JVD, crackles, and leg swelling. And all that is going to be the left-sided heart failure. So the bottom line is peripartum cardiomyopathy should be suspected in a postpartum woman with heart failure symptoms and no prior medical history. All right, for this next question, I'm going to need you guys to memorize this photo right here, this diagram, great saphenous, anterior branch, posterior branch, and the greater saphenous right here. There's our popliteal vein and the lesser saphenous as well. So just make sure you're looking at these diagrams, try to memorize them as best as you possibly can. The veins of the leg, you have the external iliac, the femoral, the perforating veins right here, and the great saphenous is on this medial portion. There's the small saphenous vein and the dorsal venous arch. One more photo, here's the great saphenous vein, and then there's the small saphenous right there. You can see we're looking at the back of their leg right here. By the way, legs are super heavy. They're always heavier than you think. I remember in an anatomy lab lifting up a leg for the first time, and I was like, man, like just a leg. And I was like, wow, that is heavy. Saphenous vein, tributaries of the saphenous vein, great saphenous vein. Cool, let's do our practice question. So here we have a 45-year-old woman undergoing surgical preparation for vein harvesting to treat chronic venous insufficiency. The surgeon plans to use the great saphenous vein for venous bypass. Where should they make the incision? All right, if you remember those diagrams, then it's going to be just anterior to the medial malleolus. So the great saphenous vein runs just anterior to the medial malleolus, and it's the most accessible site would be right there, D, for vein harvesting. And it's going to be superficial and it's like super consistent. It's really easy to identify. And it's going to ascend from the foot medially up to the femoral triangle. But the ankle region is going to provide the easiest entry point. All right, it's not the lateral malleolus. There you'd think the small saphenous vein, not the great saphenous vein. So it's the wrong like anatomical side there. Posterior calf, the Achilles, that would also be the small saphenous vein. That's the wrong vein, wrong purpose. The femoral triangle, that drainage, that's the drainage point of the great saphenous vein, but it's not going to be optimal for the initial access. So not quite it, chief. And E, behind the knee joint, is going to be the popliteal region. So it's deeper and it's not used for superficial harvesting. So the key takeaway here is that the initial incision for great saphenous vein should be just anterior to the medial malleolus. All right, this question is truly fascinating. There's a 54-year-old woman, and you can see here, I actually love this picture. I think it's a really good illustration of what's going on here. She arrives at the urgent care clinic with sudden left arm pain, pallor, and coldness that began approximately 3 hours ago. Her medical history includes a recent diagnosis of AFib. She's on warfarin for anticoagulation, and her latest INR is 1.5. On physical examination, her left upper limb is cold and pale, with the absent pulses distal to the brachial artery. Capillary refill is delayed and sensory loss is present in the fingers. Which of the following is the most likely diagnosis? Now, you might have been tempted to choose Raynaud's phenomenon, a phenomenon, or whatever that song is. But that actually has a triphasic color change, and that's with cold and stress. So Raynaud's is going to be episodic, and also it's symmetric. It's not going to be pulseless either. So it's not that, even though everybody likes to choose that whenever there's anything weird going on with the fingers or hands or what have you. But for this one, I think we'll just talk about the relevant facts for this case. And that is that we have the sudden cold and painful pulseless limb. And the very important part here is that it's pulseless. What does that mean? That means you have some sort of arterial occlusion probably. So you have an arterial blockage. And AFib mixed with that subtherapeutic INR means it's the prime setup for some sort of an embolism. And so the lay of the land for this question, to interpret this case correctly, you have to combine the cardiology and the vascular emergency knowledge together. And so if a patient has atrial fibrillation, that's a rhythmic disorder where the atria is going to quiver instead of contracting. And that causes stagnant blood flow, and that can promote the formation of clots, especially in the left atrial appendage. And so when anticoagulation is subtherapeutic, that's the INR of less than 2, then the thrombi can actually dislodge and it'll travel through the atrial system. And that is just a classic embolism. And this patient is presenting with the 5 Ps of acute arterial occlusion. All right, so let's write those out because they are important to know. Pain, pallor, pulselessness, paresthesia. And this last one is interesting. It's poikilothermia. That's coldness that fluctuates with your environmental temperature. And so that means we have a vascular emergency and you need rapid correction, right? So this is atrial fibrillation. That's the embolic source. You have inadequate anticoagulation because we have 1.5 on warfarin. And there's that sudden limb coldness, the pallor, the sensory loss, absent distal pulses. That's going to be an embolic arterial occlusion. And there's a capillary refill that's delayed, and that means there's some sort of an impaired arterial inflow. And so this is all just telling us it's going to be some sort of an atrial embolism. So it's a left-sided emboli because if it's left-sided, then it can go straight to the brain like in a stroke, or it can go to the peripheral arteries, and that causes limb ischemia. And this is very time sensitive, right? Greater than 6 hours means that there's a big risk of irreversible limb ischemia. So let's look at these answer choices here. Raynaud's, we already kind of covered that one. Acute hemorrhaging, that would be with like hypotension, tachycardia, pallor, and that would definitely not be causing unilateral limb symptoms with pulselessness. So C is going to be our answer, embolic arterial occlusion. Brachial plexus injury is totally not going to be our right answer because that's going to be weakness and sensory loss. They're not cause coldness or pallor or absent pulses. That's a nerve issue, not a vascular issue. Thoracic outlet syndrome, that's going to be like a chronic positional symptoms that's going to present more gradually and not with like a sudden vascular compromise. And so every 5 minutes, somebody with an AFib is going to throw a clot. Happens pretty frequently. In fact, you should think of AFib clot when you're taking this exam. And sometimes this doesn't go to the brain, instead it goes to the limb. And so here we got this 54-year-old woman. She's got AFib. She's got a subtherapeutic INR. And that basically means that she is not being properly anticoagulated. And so this is going to show up with a cold, pale, painful arm, and there's no pulses and there's delayed capillary refill. And so there's a cardiac embolus that's lodged into the brachial artery and it's cutting off the blood supply to her forearm and her hand. And that is called an acute arterial occlusion. And that is one of the few limb-threatening emergencies that you actually will see on the Step 1 exam. Okay, so the bottom line is embolic arterial occlusion is likely due to atrial fibrillation and presents with sudden limb ischemia. In this question, we have a 29-year-old woman who presents to the clinic with post-coital bleeding and persistent pelvic pain. She reports that her last pap smear performed 3 years ago was normal, and physical examination reveals a friable lesion on the anterior vaginal wall. A biopsy is performed and reveals invasive squamous cell carcinoma. In this patient, cancerous cells are most likely to metastasize first to which of the following nodes? Okay, so we got to talk about the lymph. And the lower 1/3 of the vagina drains to the superior inguinal lymph nodes. And squamous cell carcinoma is the most common vaginal cancer. And this usually arises from the posterior or the anterior vaginal wall. And so to solve this question, we have to know a little bit about the pelvic lymphatic drainage, especially in the vagina and the vulvar regions. And so the vagina has a dual lymphatic drainage pattern. The upper 2/3 drains to the internal and the external iliac nodes, and then the lower 1/3 drains to the superficial inguinal nodes. And so she has a lesion on the anterior vaginal wall, and then also the post-coital bleeding with the biopsy-proven squamous cell carcinoma is going to be a common presentation for some sort of like a vaginal cancer. And so the location of the lesion is very important, and it's lying on the lower third, and so that makes it the superficial inguinal node is going to be the very first sign of metastasis, the site of metastasis. And that is why our answer is C. So the post-coital bleeding is a common red flag for cervical or vaginal squamous cell carcinoma, and the anterior vaginal wall lesion suggests that it's the lower vaginal involvement, and the friable description is going to be the ulcerated or malignancy. And the invasive squamous cell carcinoma is the most common histological type of vaginal cancer. And this has several associations that are important to know, like HPV, especially 16 and 18. And that's associated with squamous cell carcinoma of the cervix and the vagina. Squamous cell carcinoma is the most common type of vaginal, vulvar, and cervical cancer. And the lymphatic spread is going to follow the embryologic origin and the anatomical locations of the lesions. So the superficial inguinal is going to cover the lower 1/3 of the vagina, the vulva, and the anal canal below the pectinate line. And that can be kind of weird because it's below and then you think superficial, but it's one of those things you just kind of have to memorize. And the pathophysiology kind of goes with, at least with HPV, is that you have some sort of an HPV infection or like a chronic irritation, and that triggers some sort of like a squamous dysplasia. And then the dysplasia evolves into invasive squamous cell carcinoma. And if the lesion is on the lower third, then it metastasizes first to the superficial inguinal. And if it's untreated, then the cancer will spread upward and it'll go deeper and interact with the external and the internal iliac and the periaortic. So the postcoital bleeding really tells you that it's the vaginal or cervical cancer. The friable anterior vaginal wall means that it's in the lower third, superficial inguinal. And the squamous cell tells you that it's HPV associated because that's the most common, especially in the lower GU tract. And then you have to know the lymphatic spread is in the lower 1/3 is superficial, and then the upper 2/3 of the vagina and the cervix are going to be the iliac. If it's in the ovaries or the testes, then that's always para-aortic. All right, and so that covers most of these questions. The bottom line is invasive squamous cell carcinoma of the vagina typically metastasizes first to the external iliac lymph nodes. Now, please note that this would be the lymph from the lower rectum to the anal canal above the pectinate line. So this bottom line right here is referring to the cervix, the upper vagina, and the uterus, but not the lower 1/3 of the vagina. This question is asking about the lower 1/3, but the bottom line here is about the cervix and the upper vagina, and the uterus would be draining into the external iliac lymph nodes. Axillary drains the upper limbs of the breast. There's the external iliac that we just talked about. The para-aortic drains the ovaries and the testes. The deep cervical drains the deep neck structures. In our next question, we have a 62-year-old woman presenting to the clinic for a follow-up appointment after a routine colonoscopy. Procedure was performed due to the anemia detected on the recent laboratory tests. During the colonoscopy, several polyps were removed for histological evaluation. The pathology report describes a 1.5 centimeter polyp with dysplastic features and a tubular architecture. She has no significant gastrointestinal symptoms or family history of the colorectal cancer. Which of the following is the most likely classification of this polyp? All right, there are a lot of different types of colon polyps. Some are harmless and others are very, very dangerous. And so she is coming into the clinic because she has some sort of anemia detected on her laboratory tests. And she has a 1.5 centimeter polyp. And then the pathology says dysplasia and the tubular architecture. And so that's probably going to be tubular adenoma. And it's less aggressive than like the villus or the serrated types. It's still going to be precancerous. And so the answer is tubular adenoma. Especially since this is over 1 centimeter, the risk of cancer is going to start to be increasing. So because of the dysplasia and the tubular histology, it's going to be a tubular adenoma, which actually is the most common type of adenomatous polyp. They're neoplastic lesions with the potential to progress to colorectal cancer through the adenoma-carcinoma sequence. Let's look at some of these other choices, like the hyperplastic polyp. Well, that would be seen with no dysplasia, and that's common in rectosigmoidal colon, and these are actually benign and non-neoplastic, so that's not the answer. The sessile serrated polyp would be the sawtooth, those crypts in the right colon. You'd have serrated architecture, not tubular architecture. And those guys actually have a higher malignant potential, so we're glad that it's not that one. The juvenile polyp is going to be like hematomatous, and that's seen in children, and it's not going to fit our demographic for this one. And the villus adenoma, that has the finger-like projections and the high malignancy risk, and that's not going to be seen here. This has a tubular architecture, and so it's going to be tubular adenoma. It really is that simple. And a 1.5 centimeter dysplastic tubular polyp indicates tubular adenoma, and that is indeed a precursor to colorectal cancer. That's the bottom line. All right, in this question, we have a 58-year-old man. He has difficulty achieving and maintaining erection over the past year. He's got a history of type 2 diabetes and hypertension. Current medications include metformin and lisinopril. A thorough evaluation indicates no significant psychological factors contributing, and on examination, he exhibits normal secondary sexual characteristics. The peripheral pulse is intact. Blood work, including testosterone levels, is normal. Following discussion of treatment options, he's prescribed sildenafil to improve the erectile function, primarily by acting on what structure in the penile architecture? The answer is the corpora cavernosa. All right, so it's probably helpful to kind of draw this out. This right here is going to be the superficial dorsal vein of the penis. This right here is the connective tissues that surround the corpora cavernosa. And this right here is the corpora cavernosa. And this right here is the urethra. And this does not have any role in erections, but this does. And what's wild is that 50% of men with diabetes experience some form of erectile dysfunction. And that's why we need the help of the little blue pill. And this definitely does not work on the urethra. It's on the arteries. It targets the corpora cavernosa. And those are the two spongy columns that fill with blood during an erection. And by blocking the PDE5, what it does is it keeps the cyclic GMP levels high, and it relaxes the smooth muscle, and it lets the blood rush in. And so it's the corpora cavernosa that does the heavy lifting there. No pun intended. Urethra would be a urine and a semen conduit. So that's A. Deep arteries of the penis are involved in perfusion, but sildenafil acts on the smooth muscle in the corpora, not the arteries themselves. Tunica, albuginea, those are the connective tissues, and those are important for erectile rigidity, but they are not the actual target here of this medication. And superficial dorsal vein. The venous drainage is what you think of for that one, and it's not involved in the erection, initiation, or the PDE5 action. Next is the easiest question ever. 52-year-old man comes in, he gets a bunch of lab tests. Which of the following statistical measures is most appropriate to summarize the average 10-year cardiovascular risk? The answer is the mean. All we need to know about this guy is that the mean is the measurement of central tendency, and it's just like the average. That's all that it is. Mode is the most frequently seen. Medium is the middle value, the range, max, min, and the standard deviation is the variability. Mean is the mathematical average. Big population with normal distribution, that's going to be good. The median is good when the data is skewed. Standard deviation tells you how spread out the data is. But if we're summarizing the average cardiovascular risk, then use the mean. Simple, simple. There's the bottom line. You can read it if you'd like. Moving on to the next question. All right, in this question, we have a 5-year-old girl is observed by her school teacher to have yellow discoloration of her sclera. Concerned, the teacher informs her parents, who seek medical advice. The child has no significant medical history, and her parents report that she has been slightly more tired than usual, but has had no recent infections. On examination, the child appears jaundiced and has moderate splenomegaly. There are a whole bunch of findings here. The big ones are that the hemoglobin is low, the hematocrit is also low, at just 4%. A peripheral blood smear shows numerous spherocytes. Which genetic finding is most likely identified in this patient? All right, so let's just get the lay of the land for this question. This is hereditary, because she's so young. Hereditary, and then it has what? Spherocytes. Hereditary spherocytosis. It's a hemolytic anemia that's caused by defective red blood cell membrane proteins, and the one that we need to know for this question is the spectrin. So she's a 5-year-old girl, and she's got jaundice, and that's from the increased unconjugated bilirubin, and also normocytic anemia and reticulocytosis. That's the marrow response to the hemolysis. And there's also splenomegaly, because that's the site of the red blood cell destruction, and the spherocytes on the peripheral smear. So she has some sort of extravascular hemolysis, and so it's going to be a mutation of the spectrin gene. So there's spherocytes on the peripheral smear, and that's hallmarks hereditary spherocytosis. Splenomegaly is classic for extravascular hemolysis. Retic count is going to be high because the marrow is compensating, and there's normal MCV, and that rules out microcytic or macrocytic anemia, and there's no infections, and so it's not going to be like a G6PD or a parvovirus-related crisis. And it's the spectrin, the ankyrin, the band 3, the protein mutations. It's the red blood cell membrane instability that's damaged in this kiddo. And you have increased osmotic fragility. And so the cells will lyse easily in hypotonic solution. And that's what you do when you give them a fragility test. You see how easily they lyse. Also, you can see like some pigmented gallstones from chronic hemolysis. Splenectomy is definitive treatment, but it's usually delayed until after the age of 5. And this is autosomal dominant inheritance pattern. So the pathophysiology is that there's a mutation in the spectrin or the other membrane proteins, and that causes a loss of the membrane surface area. And now the red blood cells become spherocytes. They're like really, really round, and they have no central pallor whatsoever. And they are less deformable, and they get trapped in the spleen, the splenic cords. And the macrophages then destroy them. And so you get extravascular hemolysis that leads to anemia, jaundice, and splenomegaly. And so the spherocytes are going to appear on the smear. They're small, round red blood cells that do not have the central pallor, increased osmotic fragility, and there's a risk of pigmented gallstones. All right, and so the answer is going to be a mutation of the spectrin gene. Deletion of the alpha globin gene, that would be microcytic anemia. That's an alpha thalassemia. Mutation of the G6PD would be some episodic hemolysis after oxidative stress, like infections or like some fava beans or something like that. Some like drugs would cause that, but it's not going to be chronic and no spherocytes to be seen there. D is wrong, mutation of the beta, because that's going to be sickle cell anemia or beta thalassemias, and those would be target cells, sickle cells, not spherocytes. And mutation of the hepcidin regulatory gene, that's iron overload, that's going to be seen in some sort of diseases like hemochromatosis or adult onset conditions that are like not pediatric, not hemolytic anemia. So here is an explanation. A lot of what we said, increased retic count in the spherocytes. The spleen is kind of breaking these things apart. The bone marrow is trying to help out, and that's the reason for the high retic count. There's the bottom line, spherocytosis, mutation of spectrin. All right, one of the easier questions. A 28-year-old man is found unconscious in his apartment, brought to the hospital by emergency department. Medical services. His friends report that he has been dehydrated and vomiting for the past 2 days. Due to food poisoning, on examination, his blood pressure is 80/60, heart rate is 110, started on intravenous fluids for hypovolemic shock. For the next 24 hours, his blood pressure and heart stabilize. However, on the second day of hospitalization, it's noted that the urine output has decreased significantly. Labs tests show elevated creatinine. Which part of the kidney is most likely to have sustained damage due to his condition? All right, now they love this question. Basically, this guy's got some sort of a hypovolemic shock, and that's due to his acute kidney injury. And the proximal tubule and the thick ascending limbs are the most ischemia-sensitive segments of the nephron. And so this patient has some sort of a pre-renal acute kidney injury, and that's due to his hypovolemia from vomiting and dehydrating because of his food poisoning, and that decreases the perfusion. But after the fluid resuscitation, he actually is going to develop oliguria and rising serum creatinine. And now this has evolved into an intrinsic renal injury. So first, it's pre-renal, now it's intrinsic, specifically the ischemic acute tubular necrosis. And so the part of the nephron that's most vulnerable to this is the proximal convoluted tubule, and that's because of the high metabolic activity and the oxygen demand that occurs there. And so the vomiting, the dehydration, the hypotension, those are the biggest things that cue us into his hypovolemic shock. So that's what I would like to key you into here, right here, is the shock. And so you give him IVs and his blood pressure is stabilized, and then the pre-renal turns into intrinsic problems with the kidney. And now you have decreased urine output on day 2, and that is going to be the transition to the ischemic ATN. And you have increased creatinine, and that's going to be a reduced GFR and tubular damage. And the most affected area is the PCT and the thick ascending limb. So the proximal tubule and the thick ascending limb have a high O2 demand, and there's a lot of ATP use for the sodium reabsorption that occurs there. And so you get ischemic ATN, that's going to be the muddy brown casts are going to present in the urine, and oliguria is going to be present despite the normal blood pressure, and that tells us that there's some sort of acute kidney injury. Oliguria is going to be the production of abnormally small amounts of urine. So the kidney is basically not working, is what that's telling us. And there's a tubular injury that leads to a back leak and an obstruction. There's going to be some like delayed recovery phase. So it's going to be like weeks. You're going to have possible polyuria phase as well as the tubules start to recover. So the pathophys is we have hypovolemia, less perfusion, pre-renal azotemia, and then prolonged ischemia, tubular necrosis, especially in the PCT. Then you have damaged tubules and you lose the ability to reabsorb. And that would increase the creatinine and also decrease the urine. And you also get those slough cells from the cast that obstruct the flow, and that worsens the injury. And so our answer is going to be the proximal convoluted tubule. They love asking about that. That is going to be the most vulnerable to ischemia. So here's our wonderful bottom line. Acute tubular necrosis from hypovolemic shock typically affects the proximal convoluted tubule. Awesome. In this question, we have a 70-year-old woman presenting to the clinic with the complaints of continuous urine leakage that began soon after undergoing pelvic surgery to address a large uterine fibroid. She has since experienced constant dribbling of urine, even without any urge. Physical examination reveals a distended bladder, which of the following tissues is most likely dysfunctional as a consequence of her condition. Okay, so a woman has some sort of a pelvic surgery, and then days later, she starts to leak urine nonstop, even though she doesn't feel like she needs to go. So that means that this is not going to be stress or urgency incontinence. This is rather overflow incontinence. And so the big problem here is the damage to the detrusal muscle, and that is made of the smooth muscle. Bladder contraction. And so now the bladder is filling and it gets over distended, and then the urine just starts to trickle out. You don't have any urge or any squeezing, it's just the overflow. So there are different types of urinary incontinence that are tested on this exam, and for that you need to know the anatomy as well of the bladder and the urethra. And after pelvic surgery, a common complication is the injury to the pelvic nerves that supply the detrusor muscle, and that's made of the smooth muscle. The distended bladder with a continuous leakage and also no urge to void is going to be overflow incontinence, and that's caused by bladder disruption of the detrusor muscle. So some sort of a detrusor underactivity is happening here. All right, so here's the explanation. Continuous leakage, no urge, distended bladder. Non-keratinized stratified squamous would be vaginal mucosa. It's not involved in bladder contraction. Hyaline cartilage would be in the joints and airways. There's no role here in the urinary tract. Skeletal muscle would not be involved here unless we're talking about like the pelvic floor. Adipose tissue does not have a functional role in the storage or voiding. And the skeletal muscle, I will say, is involved in stress incontinence, not overflow incontinence. If you guys found this helpful, like and subscribe. Here's the bottom line. Post-surgical urinary incontinence suggests smooth muscle dysfunction in the bladder control. Now stick around if you would like to have a nice recap song over the 10 topics that we covered in this video. Please share this, like this video, comment, let me know how I can improve, and we'll see you guys in the next one.
Mama's breathless, baby just came. Now her lungs filled up, her chest x-rays the flame. Her upper knee creeping, she's gasping on flat. Crackles in her bases, what's up with that? Heart's enlarged, DF's taking a dive. Months postpartum, she's trying to survive. No clots, no bugs, no mass in the lung. It's the heart muscle weak, ain't properly strung. Endothelial stress and the volume low. Got her ventricles stretched in dilated mode. Surgeon scalpel ready, where the vein at though? Trace it from the ankle, that medial glow. Runs up the leg like a straight up vine. Longest in the body, it's graft in time. Anterior to that malleolar spot. Subcutaneous baby, harvested hot. No need to stress, the leg drains well. When saphenous steps out of the veins gel. Arterial occlusion, postless. Yeah, sudden cold limb, pain screaming wild. Leg turn ghost like frostbitten child. No pulses distal, time ticking out. It ain't no DVT, that's Venice clout. This is fast and furious, arterial block. A clot shot south and the blood got locked. Could be AFib or valve debris. Now the limb's on fire with ischemic spree. Bleeding post-intimacy, lesion looking red. Pap missed the threat, now malignancy spread. Cervix is the spot, squamous cells gone rogue. Now where's the drainage? You gotta know the road. Deep in the pelvis, first stop on the line. Internal path, no superficial sign. Not legs, not gut, not the inguinal set. Know your no change, don't ever forget. Peel it on a scope, blood hitting the stool. Dysplastic histol, now that's the rule. Architecture's tubular, danger's real. It's Prevantis path on the Adrenal Medallary. Villas got more risk, but don't relax. Tubular still stacks them neoplastic facts. Colonoscopy's key, find it before the blast. Or CRC, gonna show up fast. Till the navel, blood, blow, boss. Oh. Get the rise, now it's time for a boost. Slick little pill making blood get loose. Blocks PD5, let CGMP climb. Nitric oxide shining vascular prime. Hits the corpora, fills it with might. Penile engine, revving into the night. But don't mix with nitrates. Crash it you do, the hypertensive ride gon' flatten you. Can't get the rise, now it's time for a boost. Slick little pill making blood get loose. Blocks PD5, let CGMP climb. Nitric oxide shining vascular prime. Hits the corpora, fills it with might. Penile engine, revving into the night. But don't mix with nitrates. Crash if you do, the hypertensive ride gon' flatten you. Can't tubular tread. Kid looking yellow, got a big old spleen. Normocytic anemia, what does it mean? Spherocytes in the blood, retic count up. RBCs around and no central cup. Membrane issue, spectrin anchor and lost. Tight squeeze and capillaries. Cells get tossed, get caught in the spleen. Hemolysis bright, and if it gets worse, splenectomy might. Shock took him down, pressure hit the floor. Now his kidneys quiet, ain't peeing no more. Proximal tubule, the first to get wrecked. Metabolically active, now cells are checked. Brown cast muddy, up the UA scene. Oliguric first, then a polyuric stream. Anaphylaxis, sepsis, or toxic drugs. Organ causes, hit the nephrons like thugs. Hit the nephrons like thugs. Yeah, hit the nephrons like thugs. Yeah, hit the nephrons like thugs. Hit the nephrons like thugs.
Hello, everybody, and welcome back. We've got some awesome practice questions for you today. Please like and subscribe, and let's get started. A 28-year-old male, he is a competitive cyclist, participates in a high-intensity interval training session. He performs multiple short bursts of maximum effort cycling, followed by a 1-minute recovery period at a slower pace. After completing several of these intervals, he experiences significant leg muscle fatigue and burning pain. Laboratory analysis after the session shows a temporary decline in the blood pH. Which of the following is the most likely contributing to his symptoms? All right, so the big takeaway here is we have a high intensity interval training, and that implies anaerobic metabolism. I used to play baseball competitively. We went around the nation, and I was a pitcher. And after I would throw, I remember one of the parents would always massage my arm, and they'd say, you got to get that lactic acid out. And there's actually a little bit of truth to that, right? In this patient, we saw a temporary decline in the blood pH, and so that's like the acid. That's the metabolic acidosis. And that's usually lactates because of the anaerobic conditions. The burning pain in the muscles is also classic for lactic acid buildup. And so during anaerobic exercise, oxygen becomes limiting. And so to keep glycolysis running, the only available ATP source whenever you're doing anaerobic exercise, the cells have to convert pyruvate into lactate so that they can regenerate NAD+, and that leads to the acid buildup. And so the big associations here are lactate dehydrogenase, LDH. That's the enzyme that's responsible for the pyruvate to lactate conversion. We should also know that this is going to be associated with your type 2B muscle fibers. They're fast-twitch, anaerobic, high lactate producers. And the Cori cycle is relevant here too. The Cori cycle is where the liver converts the lactate back to glucose via gluconeogenesis. And so you get that NAD plus regeneration, and it's super critical to sustain that glycolysis during the oxygen debt. And so you get exercise-induced acidosis, and it's self-limited, and it resolves with rest and reoxygenation. So the pathophysiology is very important here. First, you have the oxygen depletion during the intense exercise limits. Right, you can't breathe while you're doing that intense exercise, and so we're undergoing glycolysis. So we're limiting the oxidative phosphorylation that can occur. So that's the first thing. And the second step is super related to this. Glycolysis is all of a sudden now the very predominant source of ATP. And that's great, but this produces NADH as a product. And then we're going to convert this pyruvate, which is made through glycolysis, into lactate via LDH, and that regenerates NAD+, that allows glycolysis to continue working, right? Because you need NAD+ for this to work. And so you do pyruvate to lactate so you can go enter into glycolysis again. And then lactic acid accumulates, and that causes intracellular and systemic acidosis, which manifests as the burning muscle pain. So that's the reason why he has the burning muscle pain. That's the reason why the blood pH is low. That's the transient metabolic acidosis. And there's no oxygen, and that leads to glycolysis-dependent ATP generation, and you get the short bursts of the effort, and that's the type 2 fibers. Those guys are involved in anaerobic glycolysis. And so our answer is indeed going to be C, the conversion of pyruvate to lactate, regeneration of NAD+ in the muscle cells. So it's during the anaerobic exercise, the muscles rapidly consume ATP, oxygen delivery can't keep up, and so you switch to anaerobic glycolysis. Pyruvate is converted to lactate by lactate dehydrogenase, which regenerates NAD+, allowing glycolysis to continue. Lactate buildup causes acidosis, manifesting as burning, pain, and fatigue. So that's the reason why your legs feel like they're on fire after you do the big old sprint. Your muscles demand the energy quickly, oxygen delivery can't keep up, and so we switch gears to glycolysis, and it turns glucose into pyruvate. But to keep going with that oxygen, we have to convert it to lactate to regenerate NAD+, causing acidosis, fatigue, and pain. That's why you have that drop, muscle pain. It's the intense anaerobic exercise. Okay, in our next question, we have a 12-year-old boy evaluated for muscle weakness, episodes of confusion, and temporary vision loss on his right side. His maternal uncle experienced similar symptoms, and the boy has experienced difficulty keeping up in physical education class due to fatigue and muscle cramps. On physical examination, there is a right-sided hemiparesis and decreased visual acuity in his right eye. Laboratory studies reveal elevated serum lactate levels both at rest and after exercise. The MRI of the brain shows areas of hyperintensity in the occipital region. Which of the following is most likely genetic abnormality in this patient? The answer is mutation in mitochondrial RNA. And there are two main facts that we have to know to be able to answer this question. One, we have to know what MELAS is. Your mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes. So it's mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes. And this is often maternally inherited. That's why it says the maternal uncle has experienced this as well. This is caused by mutations in the mitochondrial tRNA, commonly with lysine or leucine, and that can disrupt oxidative phosphorylation. So maternal inheritance strongly points to a mitochondrial disorder. And the elevated lactate at rest and after exercise is going to be a clue for the defective mitochondrial metabolism. It's the same kind of thing as the last question. Here we have defective mitochondrial metabolism, which means you have more lactic acidosis because glycolysis is going to be relied upon to a greater extent. There are also some stroke-like episodes in a child, and that's due to the S in MELAS. Whenever you have a stroke in a child, especially without any vascular causes, then that should definitely lead to think of a mitochondrial cytopathy, because unlike ischemic strokes, the MELAS-related lesions don't actually have any respect for those vascular territories, and that's the super important clue on imaging. You have stroke-like episodes, lactic acidosis, and maternal inheritance. So here's the pathophys. You have a mutation in mitochondrial DNA, causing defective proteins for oxidative phosphorylation, decreased electron transportation function, so you have less ATP, and so then you have lactic acid from the anaerobic metabolism, and then the energy-demanding tissues like the brain and the muscle are going to have stroke-like episodes, even though it's not like that same vascular problem that you're used to whenever you have stroke-like episodes. And this most often affects like the posterior cortex, the occipital lobes, and can cause vision loss. And really, you're going to see the ragged red fibers on the biopsy, and that's because of the accumulation of the abnormal mitochondria. All right, and the next question, we have a 55-year-old woman participating in a research study investigating the relationship between dietary patterns and the development of hypertension. She presents with a medical history that includes type 2 diabetes, mellitus, and hyperlipidemia. Part of the study, she is asked about her regular intake of fruits and veggies and her consumption of processed foods. The study involves comparing groups of people with and without hypertension to determine if scientific dietary habits are associated with the presence of the condition. What is the most appropriate statistical measure to quantify the association between dietary patterns and hypertension in this study? All right, so there's our patient. She's got her fruits and her veggies. And what's important to know is that you cannot calculate the risk in a case control study. And that's because you've already chosen your outcome cases and controls before you even look at the exposures. And so here we're comparing people with and without hypertension, and we're asking them about their dietary history. And that is the hallmark of a case control. And so this is going to be an odds ratio. And this tells us how much more likely the cases were exposed to certain diets compared to the controls. And this one, you start with the odd person. That's the way I like to remember this. So they can then determine the likelihood or evaluate the likelihood of exposure of a risk factor based on whether or not they have the disease. Here, a 16-year-old girl is brought to the emergency department by her father due to confusion and difficulty walking for the past day. He mentioned that she had several episodes of dizziness for the last months and her grades have dropped significantly. On examination, she has nystagmus, dysmetria, that's whenever you can't touch the finger that somebody else is holding up on the fingers to nose testing, and also a wide-based gait. Her speech is slow. She appears lethargic, but she is able to follow simple commands. She has no history of chronic medical conditions. Her father says they recently moved and she's been spending more time in the garage working on projects. Which of the following exposures is most likely responsible for her symptoms? Now, this is a really good question. Now, something that not a lot of people know is that inhalant abuse is one of the most underdiagnosed substance use disorders in teens, and it can actually mimic serious neurological diseases. So we have a 16-year-old, she's confused, ataxic, nystagmus, her grades are slipping, and she's been spending a lot of time in the garage working on projects, right? Sounds innocent, but this is going to be glue sniffing. It's glue solvent exposure. So it's usually the glue solvent. So this is toluene, and that's found in a lot of products like adhesive, paints, and also aerosols. And when you inhale it, it damages the cerebellum and the white matter. And that leads to the exact symptoms we see here: wide-based gait, dysmetria, slow speech, and confusion. Okay, so lead would be too chronic and it doesn't hit the cerebellum like this does. Carbon monoxide would be the wrong exposure pattern. Mercury is definitely not going to be likely in that group or the setting. And carbon monoxide, you'd probably think of like a headache, cherry red skin, a flu-like illness. That affects the globus pallidus, not the cerebellum. And asbestos would have the pleural plaques and mesothelioma. That's more of a pulmonary carcinogen. And mercury would have like a tremor or psychosis, and that would cause peripheral neuropathy, but not these cerebellar signs. That's the glue solvents here. All right, in this practice question, researchers are evaluating the relationship between smoking habits and COPD. They enroll people with different smoking habits and they see what they have. And so this is going to be a cohort study because they're analyzing the relative risk. Relative risk always goes with cohort. You just have to kind of memorize this. I'm going to get to the bottom line really quickly because this is super easy. Cohort, relative risk, impact of COPD incidence over time, but they're assessing smoking's impact. Case control, you start with the disease. Case series, distributive collection of things. Cross-sectional is a snapshot in time, and randomized control is the gold standard. Super easy question. Free points on test day. Relative risk goes with cohort. Okay, for this next question, we have a 20-year-old female presents to the clinic with primary amenorrhea. She reports normal breast development starting in age 12, but has never experienced menstrual period. She has noted little to no pubic or axillary. On examination, the patient is tall, with a height of 182 centimeters. Physical examination reveals normal appealing female external genitalia, but no palpable uterus is noted on pelvic exam. Serum hormone levels show increased testosterone and luteinizing hormone. Which of the following karyotypes is most likely present in this patient? Very interesting question, right? So let's do a quick lay of the land. But the way to think about this one is girl on the outside and then guy on the inside. So amenorrhea is going to be commonly occurring in step 1 as a question. And the first question that you should ask is the uterus present or is it absent? If the uterus is present, then you think about the outflow tract tissues, like an imperforate hymen, transverse septum, that kind of stuff. If the uterus is absent, then all of a sudden you're thinking about Mullerian agenesis, right? That's the 46XX, and you have normal pubic hair versus androgen sensitivity, and there you have scant pubic hair. And so the case here we have a couple of conditions that we just have to note. And this is the best way to think about this is the uterus present or not? So the uterus here is absent, and then breast development and then also minimal pubic hair tells us that this is androgen insensitivity. So that absent uterus, that helps us understand if it's Mullerian agenesis or androgen insensitivity, right? We know it's going to be one of those two things. The scant or the absent pubic hair is going to be the hallmark of an androgen receptor defect, and then tall female phenotype with an XY karyotype is going to be androgen insensitivity, and that's why the answer for this question is, so in genetics, how this typically will show up is we have an X-linked receptor or an X-linked recessive mutation in the androgen receptor gene. And typically you'll see elevated LH and elevated testosterone. Why? Because it's in the male range. And also you have elevated estrogen from the aromatization that occurs. So the pathophysiology is you have a mutation of the androgen receptor gene, so the body cannot respond to testosterone or to DHT. That's usually what's happening here. And you have anti-Mullerian hormone from the Sertoli cells. And that causes the regression of the uterus and the fallopian tubes. That's why you do not have those when they're on physical exam. And the testosterone is aromatized into estrogen, and that's why you get the breast development. And there's also this effect of the lack of androgen-dependent hair growth, right? There's no internal male structures because there's no DHT signaling. And so there are some people, and this is where I kind of get frustrated at like the scientific illiteracy in the population, just because they don't allow for some basic biological facts. Just as Homo sapiens, we need to know that some people can have a male karyotype, but then they look completely female. And that is complete androgen insensitivity hormone, androgen insensitivity syndrome. And so typically the way this presents is you have somebody who's like relatively tall, maybe like 20 years old, and they have primary amenorrhea. They have normal breast development and no uterus on the exam. And there's actually an episode of House that I think was very interesting where somebody had this syndrome where there's very little pubic or axillary hair, and the labs are showing high testosterone and high LH. And so the breast development means, okay, then we have some estrogen that's hanging around there, right? And where's that coming from? Well, the answer is it's the testosterone is being aromatized into estrogen, but the androgen receptor itself is defective. And so testosterone itself cannot drive the male development like it would if you did not have this condition. And that explains also the absent uterus, because Mullerian inhibiting factor was secreted by the Sertoli cells. It also explains the normal breast, but in the scant body hair, because that would require the androgen action, but that receptor is broken, so you can't do that here. And so testosterone is produced normally from the functioning testes, right? But because of the androgen receptor being defective, the hormone cannot exert its masculinizing effects. And so you get a big old portion of that testosterone is aromatized into estrogen, and that drives the breast development in these patients. And so they're going to be phenotypically female, even though they have the karyotype of a male. So the chain is basically of the testes to testosterone, which cannot act on the receptor, and then it's aromatized to estrogen that causes breast development. So here's the bottom line. Primary amenorrhea with normal female genitalia and elevated testosterone suggests 46 XY karyotype indicating androgen insensitivity hormone syndrome. All right, in our next practice question, we have a 54-year-old woman presenting to her primary care physician with complaints of chronic joint pain, recently worsening fatigue, and a 15-pound unintended weight loss over the past 3 months. She also mentions that her skin has become darker over the past year. Maybe that leads us to think of bronze skin. Her father had diabetes and died of liver disease. Yep. On examination, the skin is bronze. She has palpable tenderness over the second and third metatarsal joints. AST 95, ALT 102, ferritin is at 1,500. Total iron binding capacity is 180, and transferrin saturation is 85%. Liver ultrasound shows mild hepatomegaly. Which of the following is most likely the pathological process causing this patient's condition? All right, there are some classic triads that we should be aware of. One is that we have bronze diabetes in the skin. We have the hyperpigmentation, diabetes, and liver disease, right? That's the triad. The skin hyperpigmentation, diabetes, and liver disease. That is hemochromatosis triad. And the pathogenesis is this genetically increases the intestinal iron absorption, and so the answer is going to be D. So the lay of the land here is that we have a primary complaint of chronic joint pain. They got the joint pain, they got the weight loss and fatigue. And on exam, you see the bronze skin and the tender MCP joints and the hepatomegaly. There's elevated AST, very high ferritin, and low total iron binding content, and a high transferrin saturation. And all of that points to iron overload. It's a disorder that's caused by the increased intestinal absorption of iron because you have a mutation of the HFE gene. And so really, the big takeaway here is that bronze skin, that's like very pathognomonic for this. The increased melanin causing that hyperpigmentation. And also the diabetes and liver disease, bronze diabetes. And that's caused because the iron damages the pancreatic beta cells and the hepatocytes. And you can also have MCP joint pain. And that's because of the pseudogout. You get the arthropathy, which basically is just like, anything that affects the joints, arthropathy. And that's because of the calcium pyrophosphate deposition and the increased ferritin, increased transferrin, and the decreased TIBC is the hallmark of iron overload. And so there is an HFE mutation. It's a gene mutation, and it has some comorbidities. There's hepatocellular carcinoma risk. It's 200 times increased. There's also the restrictive and dilated cardiomyopathy and testicular atrophy. And the epidemiology is that there's an autosomal recessive disease, and it's more common for people of Northern European descent. So you get the mutation, and then the enterocytes, the gut cells, they sense the low iron. And so they increase, and this is a little bit beyond the scope, but DM21 and ferroportin, and that increases the iron absorption in the intestinal cells. And that causes iron overload, and that deposits in the parenchymal cells, right? The functional tissue cells, like in the skin, the joints, the heart. And you get reactive oxygenation species formation and organ fibrosis, which leads to cirrhosis and diabetes and cardiomegaly. And so you get bronze diabetes and cirrhosis and cancer risk. All right, so here is the bottom line. Genetically increased iron absorption leads to hemochromatosis, causing joint pain, fatigue, and skin changes. In our next question, we have a 3-day-old newborn girl brought to the emergency department by her parents due to increased lethargy, poor feeding, and vomiting. The infant was born at term via uncomplicated delivery and initially did well on the nursery. On examination, she's sleepy, minimally responsive with mild lab studies reveal elevated blood ammonia levels and metabolic acidosis. Urine analysis shows increased excretion of orotic acid, and a genetic analysis reveals a mutation consistent with the disorder affecting a specific enzymatic step. Which of the following conversions is most likely impaired in this infant? All right, so we have a neonate, which by the way is just a way of saying a newborn child, or it could actually be like any mammal that's newborn. And they have vomiting, lethargy, so they have a lack of energy and enthusiasm. They got elevated ammonia, and so you got to think of the urea acid cycle, urea cycle disorders. And this is probably like an OTC deficiency. We have high ammonia, and that's obvious because the urea cycle is blocked. You've been blocked. And erotic aciduria, that's excess carbamoyl phosphate that's shunted into the pyridamine synthesis pathway. And also there's no megaloblastic anemia, and that distinguishes this from hereditary orotic aciduria. And so the enzyme step affected is transcarbamylase, and that's the conversion of carbamyl phosphate and ornithine to citrulline. And the most important kind of buzzy words here is that there's a 3-day-old with vomiting, lethargy, and that means that it's probably some sort of a metabolic disorder. And so we have increased ammonia and metabolic acidosis, and that means that it's a urea cycle defect. And erotic acid in the urine means that we have excess carbamyl phosphate that diverted to the pyridamine pathway. And the lack of anemia means that it's not erotic aciduria or like a UMP synthase deficiency. OTC deficiency is X-linked recessive, and basically we have that OTC problem, and then that leads to the carbamyl phosphate accumulation, and then overflow then goes into pyridamine synthesis, and then that increases the erotic acid in the urine. So the urea cycle is blocked, and that causes the ammonia buildup, and that's neurotoxic. And if it's a UMP synthase deficiency, then you would see loblastic anemia. So for this type of question, you're going to see newborns that are totally fine at birth, but then they start to have vomiting, lethargy, and high ammonia. And it's because of that urea cycle disorder. And it's important too because they have erotic acid in the urine, and that means that carbamyl phosphate is building up and it's spilling into the pyridamine synthesis. And so that's the supersignature look, like the diagnostic criteria for ornithine transcarbamylase deficiency. And that's why our answer is our citrulline to argininosuccinate. And all these other options aren't going to explain erotic aciduria with hyperammonia. So here's your argininosuccinate right there, carbamyl phosphate synthetase, and your ornithine transcarbamylase leading to this. So it's that citrulline to argininosuccinate right here. So they're asking which conversion is most likely impaired in this infant. The big thing to know about the urea acid cycle or the urea cycle is the carbamyl phosphate synthesis 1 is the rate limiting step. This part occurs in the mitochondria, and this part is in the cytoplasm. So here's a really nice photo, a really nice diagram of what occurs in the mitochondria and what goes out to the urine. This is like the whole pathway, starting with this rate limiting step right here, carbamyl phosphate synthase 1. You start with ammonia, and you get carbamyl phosphate, argininosuccinate to arginine to ornithine. And there are enzymes that govern each step. And so when you're dealing with the urea cycle, hyperammonia is going to explain the lethargy, the vomiting, the poor feeding, and the carbamyl phosphate shunted into the pyridamine synthesis will produce excess erotic acid. And so this step right here is the one that's kind of damaged. All right, and our next question, we have a 60-year-old male presenting to his PCP with difficulty holding liquid in his mouth while drinking, which began following a recent dental procedure. He notes that the left side of his face feels weak. On exam, there is decreased movement on the left corner of his mouth, and the patient is unable to completely close his lips on the left side. There are no sensory abnormalities in the face. Which of the following cranial nerves and branches is most likely affected? Boy, we love those cranial nerves, don't we? So it seems like there's some facial expression weakness without any sensory loss, and so we're probably dealing with a motor branch, and we have cranial nerve 7 with a motor branch, and there's difficulty holding liquids in the mouth. So that's probably an orbicularis oris weakness. That's the facial nerve. And so anytime a patient is presenting with unilateral facial weakness, the first step is to ask, is it motor only, like the cranial nerve 7 motor branch lesion, or does it also involve sensation? And there you could think of maybe the trigeminal nerve, cranial nerve 5. But here there's no sensory loss, and that rules out the trigeminal nerve divisions. And that's how we know that it's not the trigeminal nerve here or the trigeminal nerve there. So B and D are now out. And now taste is also not mentioned, and so the chordae tympani is not going to be the culprit. And there's also weakness localized to the lower lip area, and that's the marginal mandibular branch of cranial nerve 7. And so there's a weakness of the lips, you can't hold in liquids, and so that's the orbicularis oris dysfunction. There's no sensory deficit, and so it's not going to be trigeminal. And that history of the dental procedure means that the local anesthesia can actually injure the nearby facial nerve branches. So there are some associations you should know on tests, say like the buccal branch of the cranial nerve 7, and that controls the the upper lip muscle. And then there's also like the lingual nerve, right? Cranial nerve 5-3, that's the tongue sensation on the anterior 2/3 of the tongue. And the chordae tympani is cranial nerve 7, that's the taste anterior 2/3 of the tongue, and the parasympathetic to the submandibular and the sublingual glands. So those are some other nerves that are high yield and come up all the time. But here the pathophysiology is that you go to the dentist. I am your dentist. I was in Little Shop of Horrors, and I just think of that every time I think of a dentist. But basically there's a local anesthetic or some sort of dental trauma that damages the marginal mandibular branch of cranial nerve 7. I'm going to have to ask my brother about this. He's in dental school. And there's a loss of motor supply to the orbicularis oris, the lower lip muscles, these guys right here. And the patients cannot keep their lips sealed, and so the liquid is just going to be dribbling down their mouth. And so there's a cranial nerve 7 motor lesion, and there's difficulty holding the liquids in. No sensory loss rules out cranial nerve 5 involvement. So the big thing, lower lip muscle, motor nerve, cranial nerve 7, marginal mandibular branch of the facial nerve. And that's our answer, E. So it makes it so you can't seal your lips, and so the drinks will leak out. All right, in this question, we have a 3-year-old girl is brought to the clinic by her parents due to persistent coughing fits. They describe the child as having episodes of intense coughing followed by a high-pitched whooping sound when she inhales. The child has a recent upper respiratory tract infection. Vaccination status is not up to date, and her parents have delayed some immunizations. On examination, the child is alert but periodically has paroxysms of coughing. Lab shows leukocyte count of 28,000 with 65% lymphocytes. Which enzyme is likely upregulated, leading to the dysfunction in the immune response due to the increased cyclic adenosine monophosphate levels, the CAMP levels? All right, so let's talk about whooping cough and CAMP stuff. So the classic paroxysmal cough with the inspiratory and the lymphocytosis in a child without full vaccinations is going to be Bordella pertussis. That's why you got to get your vaccinations, folks. Here, Trump recently announced that Tylenol is linked to autism and said he shouldn't even use it. And he couldn't even say acetaminophen. I mean, it's just scary when somebody that incompetent is in charge of actual health concerns. The problem is that in order to understand the mechanism of action of acetaminophen, you have to know a lot of other things. Like, how do you talk about the NAPQI accumulation and glutathione reduction only in excess to somebody who doesn't even know where the liver is? Anyways, I digress. The pathogenesis here is the pertussis toxin. ADP ribosylates the GI protein. So basically it adds those ADP ribose moieties to that target molecule, and that will inhibit GI. So you get uninhibited adenylyl cyclase inhibited activity, and so you get increased CAMP, and you have impaired phagocyte function. And the lay of the land here for Bordella pertussis is, of course, you have that cough, the paroxysmal cough and the inspiratory whooping sound, and also the marked lymphocytosis, and you have incomplete vaccination history. So those three things are the biggest ways that they'll test you on this for step 1. And the key mechanism you also have to know is increased CAMP. It's the increased intracellular CAMP levels in the immune cells, and that paralyzes the ability to phagocytose and clear bacteria. So whooping cough, paroxysmal cough, that's the repeated like machine gun coughing fits. Lymphocytosis, an unvaccinated child means that they have a high risk for this. And so there's a pertussis toxin that disables GI, and it increases CAMP, and it impairs neutrophil recruitment. Adenylyl cyclase toxin directly increases CAMP, and so that's like an association you should definitely know. And there's some complications here like pneumonia, seizures, encephalopathy due to hypoxia. And to prevent this, you just give them the DPAC vaccine, right? the DTaP vaccine, because that will contain acellular pertussis antigens, and so you're good to go. But you have the pertussis toxin, and then the ADP ribosylates the GI protein. The GI inhibition leads to unchecked adenylyl cyclase activity that increases the camp inside of the host cells, that impairs phagocytosis, causes massive lymphocytosis. Sorry, I think I said that wrong. It impairs phagocytosis and causes massive lymphocytosis, and that leads to a persistent infection. So that pertussis toxin increases the camp, get whooping cough, vomiting. You just got to get your vaccines. All right, and so the answer is going to be adenylyl cyclase. Good question is, why is it not catalase? Well, catalase breaks down H2O2, and so it's relevant in chronic granulomatous disease, not pertussis. Lactate dehydrogenase is a marker of cell damage, and it's not actually involved in pertussis. G6PD. A deficiency there causes hemolysis with oxidative stress, not coughing and lymphocytosis. And superoxide dismutase is an antioxidant defense not related to the pertussis toxin. So it's really that just pertussis toxin sabotaging the immune cells by the ribosylation of the GI protein. And normally the GI breaks the adenylyl cyclase. But when that's disabled, the adenylyl cyclase just goes wild, like crazy. And now you get like insane levels of camp in your system, and that paralyzes the phagocytes and it prevents the bacterial clearance. And then you get lymphocytosis during a bacterial infection. All right, I think we're ready for our bottom line. Whooping cough in an unvaccinated child is due to Bordella pertussis, which upregulates adenylyl cyclase and increases camp levels. So I know this is just an AI-generated kiddo, but holy cow, vaccinate your children. The biggest risk factor for Bordella pertussis is stupid parents. And we'll see you guys. Oh, I might actually make another song if you guys like that. Kind of a fun way to kind of recap all of these questions. It's kind of a fun way to make sure that you get the key facts from these last 10 questions. So I'm going to go ahead and make that song for you guys. If you think this is helpful, if you like this content, please like and subscribe. If not, let me know how I can improve. I'm always trying to improve. My goal is to help you pass step 1, step 2, and increase both the quantity and quality of content out there that'll help you prepare as affordably as possible. We got to increase scientific literacy in this country. So without further ado, please enjoy the song.
Fibrosis in the skin, heart stiff inside. Diastolic compliance takes a dive. Home pressure rises, vessels constrict tight. Coronary resistance climbs in the night.
Fast twitch fibers, oxygen low, radiation and lust, glycolysis flow, pyruvate the lactate, acid builds fast, burn in the quads but the energy lasts, mitochondrial code from mama passed down, Tularemia mutation makes the body shut down, stroke like seizures, lactic acidosis flame, ragged red fibers, Miller's is the name, Miller's
50 over 30, 300 over 7, multiply it out, the retro's 3.8 heaven. Case control style, odds not a risk, know the formula clean, that's the test maker's trick. Blue sniffing teen with confusion and sway, broad basic aid, school grades decay, cerebellum hit, headaches in time, bronze skin's not here, it's solve and grind.
Follow the groups, exposure's the key, exercise halves and miles you see, relative risk from incidents known, cohort design when outcomes are shown, and Rox's insensitivity, 46XY but looking like she, no uterus inside but breasts you see, testosterone aromatized, hair is scarce, AI's answer, genetics and fair.
Hemochromatosis, iron overload, bronze skin shine, cirrhotic liver, pancreas decline, H5 mutation, gut absorbs too much, ferritin high, joints hurt to the turn.
On the team can't meet carbon oil fake, erotic acid rises, ammonia's great, baby lethargic, seizures might hit, OTC deficiency, urea can't fix it, paroxysmal cough with the whooping tone, unvaccinated kid, white count grown, pertussis toxin, G gets fried, adenylyl cyclase camp worldwide.
right, welcome back. Today we're covering 28. These are all original questions. And let's start this off strong with a 70-year-old woman presenting to the emergency room with a increased abdominal distension and vague discomfort over the past 3 months. She has a history of weight loss and occasional changes in bowel habits. On exam, her abdomen is mildly distended, as you can see there, with dullness to percussion on the flanks, just suggesting ascites. Laboratory testing reveals microcytic anemia. A CT scan of the abdomen shows a large irregular mass in the sigmoid colon with multiple small lesions scattered throughout the liver. Which of the following is going to be the most likely cause of her liver findings? All right, so the answer is going to be metastatic colonic carcinoma. And this often will metastasize in the liver. And the one thing that you'll see on histology is you're going to see a lot of diffuse spreading through the liver. And you're just going to have tons and tons of these masses on imaging and gross examination. It's going to look absolutely disgusting. So indeed, there are signs of primary colorectal adenocarcinoma, weight loss, changes in bowel habits, microcytic anemia, and the presence of ascites and liver lesions that spread hematogenously through the portal vein. The sigmoid colon drains directly into the portal system, making the liver the most common site of metastasis. Why is it not ALL? There you'd have pancytopenia and bone pain, which is a bone marrow disease, not associated with your liver problems. Why is it not hepatic adenoma? There you'd likely see a young woman, oral contraceptive use, and it's a benign tumor, not linked with microcytic anemia. Why is it not hepatoblastoma? That'd be children under 5, increased AFP. And then why is it not renal cell carcinoma with liver metastasis? There you'd see hematuria and the flank mass and polycythemia. And the big fact to know is that the liver is the most common site of metastasis for colorectal cancer. Why? Because of the portal vein. So the liver is super common because of the hematogenous spread from the colorectal cancer. That's because of the portal circulation that drains the colon directly into the liver. All right, so colon directly to the liver, and you have all of these problems. If you have a history of a sigmoid colon mass, then that's going to be highly suspicious for a colorectal carcinoma. Plus, you'd see multiple hypoechoic lesions in the liver, and that's a sign of a decompensated liver function. You might see like jaundice, ascites, or confusion. That's likely from some sort of a hepatic encephalopathy. And the hypoechoic lesions would indicate metastasis, particularly from the colorectal, the breast, and the lung cancers. Now, it's also important to distinguish between other different types of adenocarcinomas like pancreatic, because pancreatic can metastasize to the liver, but the clinical picture, like here we have the sigmoid mass, multiple liver lesions, and no pancreatic symptoms, like for instance, epigastric pain would be a pancreatic symptom, or you'd have weight loss with steatorrhea. So this is all pointing more toward colorectal origin, and so there's no mention of any pancreatic mass or any related symptoms there. You should also be able to distinguish between primary biliary cholangitis, PBC, and that's an autoimmune disorder that's seen mostly in middle-aged women, not the elderly, and it presents with fatigue, pruritus, cholestatic patterns of liver enzymes, and anti-mitochondrial antibodies, the AMAs, and you don't see any of that in this question stem. Also, it's important to distinguish between gallbladder carcinoma and gallbladder cancer can spread to the liver, but it usually would present with right upper quadrant pain, and it's often associated with gallstones. And there's no mention there of those, and so it also wouldn't explain that sigmoid mass. Okay, hopefully that's clear. So here's the bottom line. The CT findings of the liver lesions in a patient with sigmoid mass, just metastatic colonic carcinoma. On to the next question. For this next question, we have a 50-year-old woman visiting her primary care physician with complaints of dizziness and visual disturbances when she's out gardening. These episodes last for a few minutes and then they resolve spontaneously whenever she stops the activity. She denies any chest pain, shortness of breath. Her past medical history is significant for hypertension and hyperlipidemia, for which she takes lisinopril and atorvastatin. Physical exam shows blood pressure of 140/85 on the right, and there's a different one on the left. This is subclavian steal syndrome. There are no significant cardiovascular and respiratory findings, which the following is likely on further examination. So the correct answer, I'm going to hold off and let you guys kind of look at this question for a second. So in the blood vessels, we can get retrograde collateral blood flow from the vertebrobasilar system whenever you have some sort of atherosclerotic disease. And so the answer is a Brui over the left supraclavicular fossa. The reason why is this is subclavian steal syndrome, where you have neurologic symptoms with arm use, and then there's a difference in the blood pressure between the arms. And that's due to that turbulent blood flow through the stenotic left subclavian artery, especially proximal to the vertebral artery. You might see like dizziness, visual disturbances whenever you use one arm, lower blood pressure in one arm, and it resolves with rest. The pathophysiology is you have a atherosclerotic plaque that narrows the proximal subclavian artery, and then the arm exercise increases demand, so you have a drop in the distal pressure, and vertebral artery reverses the flow to perfuse the arm. That's why they call it subclavian steal syndrome. It steals the blood from the brainstem. So here's a nice image of the reversal of the flow. There's that left vertebral artery and the right vertebral artery. And here is another example of subclavian steal syndrome. It's all because of that stenosis right here. Normally you'd have that safe passage to the left arm, and instead we have that stenotic block. All right, so subclavian steal because it steals blood from the brain, and the physical exam clue would be a bruit over the left supraclavicular fossa. All right, so the bottom line is a blood pressure discrepancy suggests possible subclavian steal syndrome, and there's a bruit over the left supraclavicular fossa is likely on examination. In this next question, we have a 62-year-old woman presenting to the clinic with a 3-month history of throat discomfort, particularly when she's swallowing solid foods. She describes a sensation of the lump in her throat and has noticed a significant increase in her nighttime coughing and bad breath. Physical exam shows neck ultrasound reveals no neck masses, but lateral neck film shows significant outpouching near the upper esophagus. Which nerve is responsible for the motor innervation of the affected muscles in her condition? Correct answer is the pharyngeal branch of the vagus nerve. So there is something called the cricopharyngeus muscle. Zoom out and go to 43. And that is innervated by the pharyngeal branches of the vagus nerve via the pharyngeal plexus. And there's also some contribution through the external branch of the superior laryngeal nerve and the recurrent laryngeal nerve. But the motor innervation comes from the pharyngeal branches of cranial nerve 10. Now the facial nerve innervates the muscles of the facial expression, not pharyngeal constrictors. The trigeminal nerve, V3, innervates the muscles of mastication, not the cricopharyngeus. The external branch of the superior laryngeal nerve innervates the cricothyroid, not the pharyngeal constrictors, and the recurrent laryngeal nerve innervates the intrinsic muscles of the larynx, except for the cricothyroid, but does not do the pharyngeal constrictors directly. Okay, so it's important to know on this exam, what exactly is Zenker's diverticulum? Well, it's a false diverticulum, which means that it's only mucosa and submucosa herniation that occurs at the weak area between the oropharyngeus and the cricopharyngeus parts of the inferior pharyngeal constrictor. It's caused by impaired relaxation or the incoordination of the cricopharyngeus muscle. And that'll lead to increased pressure during swallowing and formation of the diverticulum. So the cricopharyngeus is actually innervated by the pharyngeal branch of cranial nerve 10, and that's through the pharyngeal plexus. So you have the outpouching near the upper esophagus, dysphagia due to solids, the halitosis, the bad breath, regurgitation, chronic cough, all that stuff. Killian's triangle is the weak area right there that we talked about. The associations are going to be commonly seen in elderly patients. And the pathophysiology is the cricopharyngeal muscle and the upper esophageal sphincter fails to relax during swallowing. And that increases the interluminal pressure, causing the herniation through that area, and it forms a false diverticulum, and then you get food there, causing the bad breath. On a lateral neck x-ray, you can see the air fluid level. Barium swallows diagnostic gold standard, and it's not associated with an increased cancer risk, unlike a true. That's why our answer is D. Here's our brief explanation. We kind of went over all these trap answers and why they're wrong. And the big thing for this one is remember that yesterday's lunch gets trapped up there in an elderly patient, and there's a false diverticulum made only of the submucosa and the mucosa. Think of bad breath and even nighttime choking. So the bottom line here is that the pharyngeal branch of the vagus nerve innervates the muscles affected by the upper esophageal outpouching, and that is Zenker's diverticulum. For our next question, a 32-year-old woman is coming to the clinic with progressive fatigue and shortness of breath. She has a history of mild anemia, but has never undergone comprehensive evaluation. Physical exam shows a mild pallor and splenomegaly. Lab studies show hemoglobin 9.5, mean corpuscular volume of 62, retic count of 5%. Hemoglobin electrophoresis demonstrates decreased synthesis of the beta chains. Genetic analysis reveals a mutation where the consensus polyadenylation signal sequence AAT AAA has been altered to AAT AGA, which the following processes in the mRNA maturation is most directly affected by this mutation. Okay, so the big things here are fatigue, microcytic anemia. We have an MCV of like 62, was it? So that's pretty low, and there's a high reticulocyte count, and there's low beta chain synthesis, and there's a mutation of the polyadenylation signal. And so that should make you think of a beta thalassemia. And so the key molecular defect is a disrupted 3' polyadenylation. So polyadenylation signal sequence, the AATAAA, is super essential for the proper addition of the poly A tail during mRNA processing. And so the correct answer is the addition of that tail. So it's B. The polyadenylation signal sequence, usually AAU-AAA in the RNA, actually corresponds to this, AAT-AAA, and that is located near the 3' end of the pre-mRNA. And it signals for the cleavage of the pre-RNA and the addition of the poly A tail. And that is super important. Why do we need a poly A tail? Well, for one, it provides stability for the mRNA, and it allows you to export from the nucleus and also increases translation efficiency. And so if you have some weird mutation and all of a sudden this isn't TAAA but TAGA, then that will impair the recognition by the polyadenylation machinery. And so then you all of a sudden have defective or absent poly A tails, and you have unstable or poorly translated mRNA. So you have a decreased beta globulin production and beta thalassemia. which is what's happened in this particular patient. So recognition of the mRNA by the ribosome. Well, that would depend on the 5' cap and the start codon and not the polyadenylation signal. So that's not the answer. Removal of the introns, that relies on the splice site sequences, the GUAG rule, not polyadenylation. Binding of the transcription factors, that would occur at the promoter or the enhancer regions, not the polyadenylation sites. And the degradation of mRNA in the cytoplasm, well, the poly-A tail helps to prevent degradation, but the mutation affects the poly-A addition, not the degradation directly. So the poly-A signal, you can remember that because of all the A's. AATAAAA. Like they're just 3 A's at the end. And so you can get a lot of trouble if that's mutated at the end. Because if you don't have a tail, then all of a sudden you have unstable mRNA, then you have no protein, and that leads to, what is it? Thalassemia. And that's why the microcytic anemia was noted, because this is a thalassemia, which is one of our microcytic anemias, and so the answer is indeed B. Now, here is the pathophysiology. Normally, after transcription, a poly-A tail is added because of this awesome little signaling. But you get a mutation, and now it's instead of Ta, it's Taga. And now you prevent the recognition and cleavage, the polyadenylation factor, and then there's no poly-A tail, so it's unstable, and you have degradation in the nucleus. The result is a beta thalassemia. That's how it works, folks. Decreased beta chain production. So here's our bottom line. Mutation alters the polyadenylation signal, affecting the addition of the poly-A tail in mRNA mutations. There we go. Lastly, here are the key features that you'd see. Low hemoglobin, high retic count, because the bone marrow is responding to the anemia. So the bone marrow is not a problem. That's why you have a high retic count anytime you have the anemia. Non-deletional mutation affecting the mRNA maturation process. By the way, if this is helping, then please like and subscribe. These videos take hours to make. Without further ado, let's proceed. Okay, in our next question, we have a 62-year-old woman presenting to the clinic with severe pain and swelling in her left knee that started abruptly 2 days ago. She has a history of hypertension and hyperlipidemia, for which she takes thiazide diuretic and a statin, respectively. She lives in a rural area and enjoys a homemade fruit liquor, particularly cherry brandy, which she consumes regularly. Physical examination reveals a swollen erythematous left knee due to limited range of motion due to the pain. Synovial fluid analysis from the arthrocentesis, that joint aspiration basically, shows the needle-shaped negatively bifringed crystals. Lab studies reveal a serum uric acid level of 8.6, which of the following is most likely contributing factor to her current condition. Okay, so on questions like this, the things that you should look out for are the sudden monoarticular joint pain. Obviously, the swollen red knee is huge. And the negatively bifringent crystals, that tells you that it's gout. The serum uric acid level is going to be elevated. So here it's like 8.6. All right, so that's high. And the key risk factor is the thiazide diuretic. And so here our answer is actually going to be D. So for those of you following along at home, we should know this might be a departure from what you were thinking if you thought about maybe, I don't know, some brandy. Well, gout is caused by monosodium urate crystal deposition. Make no mistake, that is what gout is. And the deposition is due to that hyperuricemia. And so thiazide diuretics, for instance, hydrochlorothiazide, decrease the renal excretion of uric acid that increases the serum uric acid levels. And this is a very well-known iatrogenic cause of gout. And iatrogenic, by the way, is just relating to an illness that's caused by medical examination or treatment. And so we have crystal characteristics. We have the needle-shaped, negatively bifringent under the polarized light, and it's yellow, by the way, when it's parallel to the axis. And you might be thinking, okay, well, why isn't it the brandy? I thought alcohol was related. And yes, while alcohol, especially beer and spirits, can precipitate the gout attacks, cherry products have actually been associated with lower uric acid levels, okay? So we're being really tricky here. And the alcohol component contributes, but it's not as strong as the thiazides, okay? So thiazide would be even stronger. Okay, why is it not the statins? Well, there's no direct effect of the uric acid metabolism on gout. Why is it not rural living environment? That's just kind of irrelevant. Just threw that in there for funsies. And why is it not dietary intake of low purine diet? Well, that would be protective, not causative, right? Purine would make it worse. And so the buzzwords are the sudden knee pain, erythema, the swelling, the needle-shaped negatively bifringent stuff, the serum uric acid of 8.6, the trigger of low excretion of the uric acid, thiazide diuretics, they're used for hypertension, they impair the uric acid excretion. You just can't get rid of it like you should, causing secondary hyperuricemia and the gout. So really it's that monosodium urate stuff. And I always love doing the pathophysiology, so thiazide diuretic use increases the sodium and water loss, leading to volume depletion. Volume depletion increases proximal tubule reabsorption of uric acid. So you get hyperuricemia, supersaturation monosodium urate crystal precipitation in the joints, and phagocytosis by the neutrophils, and intense inflammatory response of pain, swelling, all that sad stuff. Some associations, Leach-Nyhan syndrome would be the HGPRT deficiency. If you guys think back to the earliest NBME that I ever did, that was an answer choice. Purine salvage failure, increased uric acid there. High purine diet leads to organ meats and seafood leads to uric acid, increased levels in the serum. And tumor lysis syndrome would have massive cell turnover, so high. And alcohol increases the purine breakdown, causing the urate accumulation. All right, in our next question, a 36-year-old man presents to the clinic with a 1-year history of progressively worsening difficulty swallowing both solid and liquids. He reports regurgitating undigested food and experiencing bad breath, halitosis. He denies any heartburn, chest pain, and recent vomiting. He has unintentional loss, so 11-pound loss for the past 6 months. A barium swallow study reveals marked dilation of the esophagus with narrowing at the gastroesophageal junction. This resembles a bird beak. Which of the following is most likely the cause of the patient's condition? Okay, so the things to note on a question like this are the progressive dysphagia to solids and liquids, and the regurgitation, the bad breath, the weight loss. And what they'll say, or maybe it's going to be a little bit too obvious, but what you'll probably see on imaging is a bird beak sign on the barium swallow. And that means that it's achalasia. And the pathophysiology is a failure of the lower esophageal sphincter to relax. It just can't relax, and that's due to the loss of the inhibitory neurons. So you lose those inhibitory neurons, and so it's going to be C. And this is caused by degeneration of the myenteric, the Auerbach plexus, specifically the inhibitory neurons. Those are the guys that release nitric oxide and VIP in the lower esophagus and the lower esophageal sphincter. So you have the bird beak sign, the progressive dysphagia to solids and liquids. Unlike just the solids, you have the liquids as well, the bird beak sign, regurgitation of the undigested food and halitosis, the stasis of the food, and then weight loss. Why? Because you have poor passage of the nutrients. You lose that inhibitory factor, seen in Chagas disease, and an increased risk of squamous cell carcinoma, and you see it in young and middle-aged adults. It's the destruction of the myenteric plexus. The esophagus cannot push the food down, so it's like basically an obstruction, and then you get that proximal, so above the dilation, food stasis, regurgitation, halitosis. So achalasia, degeneration of the inhibitory, that releases nitric oxide and VIP. Now you can't relax. Now you can't swallow. Rather, you can't get the food down the pipe. Okay, now let's look at some of these answer choices. Hypertonic contraction, that is not primary achalasia, or rather, this is not primary. Achalasia is due to the failure of relaxation, not the increased contraction. So that's not it. That would be diffuse esophageal spasms. Fibrosing degeneration of the esophageal wall, that describes a scleroderma, which causes the hypotensive lower esophageal sphincter and the reflux, not achalasia. That's seen in scleroderma, hypomotility and reflux. Traumatic tear, that's Mallory-Weiss syndrome, or it could also be Borhave syndrome. That's acute with the vomiting and the chest pain. And eosinophilic infiltration, eosinophilic esophagitis is seen in young atopic patients with food impaction, non-progressive dysphagia from solids and liquids. That's eosinophilic esophagitis. And that would be in young men with allergies, and that causes intermittent dysphagia. And also you would see some like rings on endoscopy. You would definitely not be seeing a bird beak there. And so really it's the absence of the Auerbach inhibition. And so you have a lower esophageal sphincter that just cannot relax. It cannot be inhibited. It cannot let go. You cannot secrete nitric oxide and VIP. And so you have a bird beak sign. And so you can't swallow, or you can't have it's a proximal obstruction where you can't have food, solid food, or liquids pass successfully. In our next question, a 30-year-old man presents to the clinic with a 6-month history of abdominal pain, occasional episodes of diarrhea, fatigue, and an intermittent sensation of the lump on his throat. He sees numerous specialists, but has not found any explanation for his symptoms. His past medical history is unremarkable, and he is currently taking over-the-counter pain reliever as needed, physical examination, blood tests, and imaging studies, including a CT scan of the abdomen, reveal no significant abnormalities. He expresses significant distress and frustrations about his symptoms, which he states have greatly affected his life and his personal relationships. Which of the following is the most likely diagnosis? There are a couple of words that were thrown into this question stem so that we could make sure that we have the diagnosis, which is indeed somatic symptom disorder. And that is, we have multiple unexplained physical symptoms. And this has to have a long duration of the 6 months. There's also significant distress and life disruption. You have to have that. That's the reason why we added that little bit there. There's no medical cause that's found, so there's somatic symptom disorder. And so somatic symptom disorder often involves one or more somatic symptoms. So you might have pain or GI issues, and these are distressing, they're disruptive, and also you could have excessive thoughts and feelings and behaviors that are related to the symptoms, like worry or repeated visiting specialist, things like that. And the symptoms actually persist for greater than or equal to 6 months, and the symptoms are not intentionally faked or exaggerated. That's what distinguishes this one. So generalized anxiety is more diffuse, and it's focused on multiple life areas, not centered on one physical symptom. And that's the reason it's not GAD. Factitious disorder, that involves intentional production of symptoms to assume the sick role. There's not any external gain there, but that's not what we see in this question stem. Panic disorder, that involves the sudden, discrete panic attacks with physical symptoms, not the chronic somatic complaints. Malingering, these are symptoms that are faked for external gain. And the way that I like to think of this one is it starts with M, and so I think they're doing it for money. M for money. And so you're avoiding work, you're malingering, you're lingering around, avoiding work, or you need for money, avoiding work. And so that's why it's not D, it's a somatic symptom disorder. That's all there is really to say about this one. I don't want to spend too much time on it. And so here's the bottom line. Somatic symptom disorder is characterized by distressing physical symptoms without a clear medical explanation that impacts daily functioning. For the next question, we have a 30-year-old man that is participating in a renal physiology study. Okay, so there's our guy. And also we have some helpful photos as well with the anatomy of the kidney. So he's doing a study. During the experiment, he receives intravenous infusion with a substance called substance Z, which is primarily eliminated by renal clearance. Measurements are taken at 2 different plasma concentrations of substance Z. At plasma concentration of 10, the substance Z clearance rate is 600, and I'm going to write this down, milliliters per minute. Higher plasma concentration of 30, and the clearance is at 300 milliliters per minute. Which the following best explains why the clearance of substance Z is lower at a higher plasma concentration? So here is our plasma concentration, and we want to know why. So here are all the answers, and I'll let you guys kind of stew over that for a second. And so this question is really getting at the clearance decreasing as the plasma increases and renal elimination. And so what we have to be thinking about here is the active tubular secretion and the transporter saturation stuff. So first of all, we need to kind of clarify some topics. So let's start with clearance. What is that? What is clearance? Because they might just straight up ask you. Well, that is going to be the urine concentration multiplied by the urine flow divided by the plasma concentration. And if you have a clearance that's greater than your GFR, like 125 milliliters per minute, then it's going to be active secretion. You're clearing more than the GFR, so you're actively secreting stuff. That should make sense, right? And at low concentrations, like let's say we have just 10 right here, the high clearance of 600 implies that the substance Z is actively secreted, right? Because that's pretty high, and so we have active secretion going on. And then at high concentrations of 30, the clearance falls below all the way down to 300, despite the increased plasma levels. And that means the secretion is now being saturated. And so basically what's happening is there's a transporter saturation. And this is actually a figure that if you've taken some biochem classes, TM, transporter saturation, or the transport maximum. And that has occurred. There's a maximum, TM. And so once the secretory carriers are fully occupied, then increasing that concentration is not going to do anything. It's not going to increase the amount of the secreted per unit time. And so the clearance is just going to start to decrease. Okay, so let's look at several answers. Maximum tubular reabsorption capacity for substance Z is exceeded. Well, that would increase the excretion and possibly the clearance, not decrease it. This would apply to reabsorbed substances. For instance, glucose is reabsorbed, not secreted substances. B, the excretion rate of substance Z is higher at the lower plasma. Well, that's not even physiologically correct, right? Because the excretion rate increases with the plasma concentration, but the clearance falls due to saturation. Right? The clearance would be the excretion, the plasma. What about D? The filtered load of substance Z decreases at higher plasma concentrations. That's incorrect. The filtered load, what actually is the filtered load? Let's dissect that. So our filtered load is literally the GFR multiplied by the plasma concentration. And that increases with higher plasma levels, right? Obviously. That's not our answer. GFR decreasing, well, there's no evidence or like a physiological basis for that to happen, especially in the setting of an IV infusion or a solute. And so our answer is the renal transport maximum for substance Z is reached. Now, it's easy to get super confused by all this stuff, and so I want to explain this very, very, very simply. And the way that I would try to do this is I would say, look, you've got kidneys, and at first they're really good at getting rid of substance Z. They're even actively pushing it out into the urine, right? And they have special transporters to do this. This is just a mechanism that we like to call secretion. And that is why the clearance is super duper duper high. It's at 600 milliliters per minute. Wow, holy cow, look at that. It's much higher than normal kidney filtration rate, because kidney filtration rate is normally like 125 milliliters per minute. But then the plasma levels of substance Z gets too high, then the secretion transporters are overwhelmed. They're what we call saturated. And then they're working at full speed and they can't keep up. And so even though there's more substance Z in the blood, the kidneys cannot remove it faster. And so the clearance actually goes down. So the key idea here is that at high concentrations, the kidney secretion system maxes out and that will actually lower the clearance. And that's why the correct answer is C. All right, so that's my best kind of way of explaining that as simply as possible. If you think my explanations are helpful, then please like and subscribe. It really helps out the channel. For the next question, a 32-year-old woman is presenting to the clinic with complaints of episodes of palpitations, dizziness, and new onset headaches over the past 2 months. During physical examination, and I just updated the photos, her blood pressure is recorded at 155/95 in both arms, and a systolic Bruby is auscultated over the right lateral abdomen. Lab tests, including complete blood counts and metabolic panel, are within normal limits. A magnetic resonance angiography of the abdominal vasculature reveals characteristic string of beads appearance. What is the underlying cause of her findings? The answer, string of beads, would make you think of fibromuscular dysplasia. And there are a couple of different things that cue into this diagnosis. So let's just write out this question right here. The big things that cue into this diagnosis are going to be 1, it's a young woman. 2, she has hypertension. 3, she has a bruit over her lateral abdomen, the string of beads. That's fibromuscular dysplasia every single time. And this is a non-atherosclerotic, non-inflammatory vascular disease that commonly affects young women. It most often involves the renal arteries, and it leads to secondary hypertension. And this is caused by abdominal growth of the arterial wall layers. And it's typically the media producing the alternating areas of stenosis and aneurysmal dilation. So it's that string of beads is really, really pathognomonic for it. Why is it not the atherosclerotic plaque? Well, that affects older individuals, usually in the proximal renal artery, and there's not going to be any beads in that. Why is it not polyarthritis nodosa? Well, that's a systemic necrotizing vasculitis that affects the small medium arteries, and it can cause renal infarcts, but not the string of beads appearance. Why is it not osteoarthritis? Well, that would affect the large vessels, right? The aorta, the major branches, things like that. Not usually the renal arteries, and it's more common in young women, but there are different patterns, right? The stenosis, the occlusion, that kind of stuff. Why is it not renal artery thromboembolism? Well, that causes acute myocardial infarction, not multiple alternating stenosis and aneurysms. So really, it's going to be A on this one, and that's because of the patient's profile: young, elevated BP, string of beads, fibromuscular dysplasia. And the pathophysiology is where you have medial fiber and irregular thickening of the arterial media, alternating stenotic and aneurysmal segments. Renal artery stenosis, RAS activation, and then complications are going to be resistant hypertension, kidney ischemia, and aneurysm ruptures as well. All right, so females, fibromuscular dysplasia, beads on a string. It's the common cause of secondary hypertension in young women. Now, I always like to explain this super duper crazy simply. And so on test day, what you should look out for is you have a young woman, high blood pressure, headaches, palpitations, and a bruit. What is a bruit? It's just like a big old whooshing sound. That's all it is. Over the abdomen. So you listen to the abdomen, you're like, all right. And then you look at the imaging and it's a string of beads pattern. And that string of beads pattern is present in the renal artery. And that's classic sign of fibromuscular dysplasia. So that's a disease where the arteries, like the walls of the artery, they grow abnormally. And it creates these narrowed areas, which narrowed areas are it's just going to be stenosis. That's basically how we as physicians refer to narrowed areas. And also some bulges. What is a fancy word for bulge? Aneurysm. All right, so this makes the artery look like it's got like a string of beads. So young woman, high blood pressure, reduced blood flow to the kidneys. And then atherosclerosis, that happens in older people. Polyarthritis is a type of vasculitis. That's like the inflamed blood vessels, not this type of pattern you see in the woman. Osteoarthritis affects the larger arteries like the aorta, not the renal ones. And then renal artery embolism causes a blockage, not that beaded pattern that we talked about. Cool. Now, if you still want it, here's the bottom line. String of beads appearance on an MRI indicates fibromuscular dysplasia as the likely cause of renal artery stenosis. Cool beans. Please be sure to like and subscribe. All right, the last question. I'm just going to make up a question. We have a study investigating how Site A affects the workers in lung disease. And in Site A, out of 100, 30 develop it. And then in Site B, 50 out of 200. And they're asking, hey, what is the relative risk for Site A over B? So now all we have to do is just to get Site A as 30 over 100, Site B is 50 over 200, and then we just divide them. And that is the relative risk, or the risk relative to each other. A over B, so 0.3 over 0.25 is 1.2. And so we do 0.3 divided by 0.25, and that gives us 1.2. So 1.2 is the relative risk of A over B. All right, folks. Whoa, I'm like a ghost. Hopefully you guys found this helpful. If you did, please like and subscribe. These videos take a long time to make, and we'll see you guys in the next video. Hello, everybody. Welcome to the channel. Today, we're covering 10 more high-yield questions. Be sure to like and subscribe if you guys like a fun, easy, and digestible way to learn the Step 1 content. We're going to be covering a lot of fun, complex topics, and the goal is that you will pass Step 1. So starting off, we have a 4-year-old boy who was brought to the pediatric clinic with a 3-week history of persistent cough and fever. So you can see him right there. Cute little kid coughing, got a fever of 100.8. Pulse is 100 per minute. Respirations are 24 per minute, and blood pressure is 95 over 55. On examination, he has cervical lymphadenopathy and hepatosplenomegaly. Chest x-ray reveals diffuse interstitial infiltrates. A biopsy of the cervical lymph node is performed and reveals aggregates of macrophages with intracellular acid-fast organisms. There's no granuloma formation. Lab studies show normal levels of IgA, M, and G, and normal numbers of B cells and T cells. The child's condition is most likely due to a defect of which of the following components of the immune system. All right, so some big things that you should note in this question are the acid-fast organisms in the macrophage. And this leads us to think of mycobacteria, and mycobacteria require interferon gamma to activate macrophages. And so that is the reason our answer is interferon gamma receptor. We should also note on this question that there are no granulomas. Okay, so without interferon gamma signaling, the macrophages are going to fail to organize in these granuloma formations. All right, so it's because of that lack of interferon gamma that you don't get that granuloma formation. We also see the normal IgG, IgA, and IgM and normal B and T counts. That tells us that the primary lymphocyte development is intact, and there's some sort of a defect in the communication and the activation, not necessarily the production. And there are a couple of associations that you should be thinking of, like a BCG vaccine reaction that could lead to a disseminated infection of interferon gamma pathways. Or if interferon gamma pathway is defective, then you can have a disseminated infection. Also, if you have that impaired macrophage activation, you can get recurrent salmonella infections. So the pathophysiology goes something like this. In a normal human body, you have normal defenses. The macrophages ingest the mycobacteria. So here's our macrophage, and it's going to chomp down on that mycobacteria. And this is going to release IL-12. And the IL-12 stimulates the T and the natural killer cells, and those guys produce interferon gamma. All right, that's how it works. And the interferon gamma receptor defect means that the macrophages can't respond. So there's no activation, there's no nitric oxide burst, and there are no granulomas. All right, so that's kind of what's going on here. The outcome is disseminated mycobacterial infection, even though you have intact T and B cells. So here we have normal numbers of B and T cells, but we're still having some problems because there's a disseminated mycobacterial, you know that because it's acid-fast infection in this 4-year-old boy. And so this is going to be a life-threatening, like early infections in childhood, even though he has the normal immunoglobulin levels and the lymphocyte counts. And so you have an infection with mycobacteria. That's like the MAC, tuberculosis, BCG, that kind of stuff. And you're not going to see any granulomas on biopsy because interferon gamma is defective, the interferon gamma receptor, or it could be like an IL-12 pathway defect that's causing this kid's condition. All right, so there's the explanation. Here are the answers. And you also might see this in the BCG vaccine as well. Normally, T cells make interferon gamma to activate the macrophages. The problem isn't the lymphocytes, it's the macrophages cannot respond to interferon gamma. All right, let's talk about why these answers are wrong. So complement factor, that would cause the recurrent bacterial infections, but it wouldn't be associated with mycobacteria, the acid fastness with the granuloma formation not happening. So that's why it's not A. T cell receptor, for that you think of SCID. You'd have abnormal lymphocyte counts. CD40 ligand causes hyper IgM and elevated IgM and low IgA and G. But these guys are normal, so that's why it's not D. An IgE receptor would be anaphylaxis, that parasite stuff. So different presentation there. If you found this helpful, please like and subscribe. All right, this next question is a little tricky. We have a 54-year-old man working as a construction manager presenting to the clinic with persistent joint pain, previously diagnosed with osteoarthritis, managing his pain with over-the-counter medications. Now he's trying something new. Drug Y as prescribed. It's a weak acid pKa of 3.5, known to be absorbed mainly through the stomach lining. Given the pH of gastric environment is 1.8 or 1.5, and the blood pH is 7.4, which of the following states of drug Y in the gastric and blood environments would facilitate optimal absorption? Now we have to figure out the ionization in the blood versus the gastric pH. All right, so when we're thinking about weak acids in the context of step 1, and just medicine generally, one of the first things that should come to mind is aspirin, and that is absorbed best in the stomach and not the intestine. And the reason is obviously going to be the pH and the non-ionization and the lipid solubility. And whenever you get aspirin in the stomach, because of that lower pH, they're non-ionized and lipid soluble, and so they're just going to go whoop, slip right through. And so here in this patient, they have a weak acid, drug Y, with a pKa of 3.5. And the stomach is 1.5, which is lower than the pKa. So what does it mean if the pH is 1.5 lower than the pKa? That means the drug holds on to its proton and it stays non-ionized. And that allows it to just cross really easily. And once in the blood, the pH is like 7.4, and that's a lot higher than the pKa. And so the drug is going to lose its proton and becomes ionized. And that means it's trapped. It's called ion trapping. And so that will keep the drug in circulation and prevents it from diffusing back. And so the right state for the optimal absorption is non-ionized in gastric pH and ionized in the blood pH. And that's the reason why the answer is C. All right, so I just want to make this super, super simple because I know that this topic can be a little bit more complicated based on your familiarity with acids and bases. So the way to think about this is drugs can either be ionized, which means that they are charged, or they can be non-ionized, which means they are uncharged. And non-ionized or uncharged drugs cross the membranes very easily. And so if it is non-ionized, then that is good for absorption. And ionized drugs, they get trapped. It's called ion trapping, and they cannot cross the membranes, okay? So the ionized ones get trapped. And so now if drug Y is a weak acid with a pKa of 3.5, then that means the acid stays protonated. What I mean by protonated is it stays in that HA form. And then if it's non-ionized, then it gets absorbed to there. And so in the blood, it's 7.4. And so the 7.4 in the blood is going to be greater than the pKa. And so that means the acid is going to lose the proton and becomes ionized. And so it gets stuck in the blood, ion trapping, and it can't diffuse back. And so the stomach is non-ionized to absorbed. And then the blood is going to be ionized, and so it's going to be trapped. So basically in the stomach, the weak acid is happy, right? It stays unchanged, it's chilling, it likes it there. But then in a base, like the blood, it gets stripped of its proton. Because if it's a weak acid, it's going to be giving that H over to the basic environment, the blood, and it becomes charged then, and then it gets trapped inside. So the bottom line is drug Y is a weak acid, and it's best absorbed when non-ionized in gastric pH and ionized in blood pH. And the last thing that you might have some confusion on here is ion trapping and its implications. So drugs actually change how ionized they are depending on the pH of the environment. We know that, right? And when a drug moves from one compartment to another with a different pH, then it becomes ionized and it can become trapped there. So if we think of aspirin as the quintessential example, because this is a super common medication that everybody's going to be taking, so it's really good to know how this works. The stomach is very, very acidic, right? 1.5. And so there, the pH is less than the pKa. And that means the drug stays protonated, right? Because this environment is so acidic, it's like, ouch, that is so acidic. I'm not going to be donating my H to that party. I'm going to be keeping it. It's non-ionized, and so it passes the stomach lining. But in the blood, it's very basic, and there you have the reversal where the pH is greater than the pKa, and it's like, oh gosh, I got to give that protein over, right? And if you donate that protein, now you become ionized, right? You lose that charge, and now you're off balance, right? So now you are a charged molecule. Now you are trapped in the blood. And that actually keeps the drug from diffusing back into the stomach, and it enhances the net absorption. And so there are a lot of clinical uses for this. One is drug overdose treatment. So another one is like in fetal circulation, weak bases can cross the placenta and they become ionized in lower fetal pH, and they're like trapped in the circulation, like fetal ion trapping. But it's just important to know that ionization can happen, and know that you're going to donate that H, you're going to lose that H, and you yourself are going to become charged if the environment that you are around is very basic, right? They're going to take your sparkle. Cool bean? On to the next question. In our next question, we have a 15-year-old boy. He's seen in the clinic after experiencing 2 months of persistent dizziness and occasional episodes of vomiting. The symptoms have progressively worsened, and he also reports some recent difficulty concentrating at school. On examination, his coordination appears diminished, and he has a mild tremor when attempting to perform fine motor skills. An MRI reveals a contrast-enhancing mass in the cerebral region. A biopsy is performed, confirming it to be a pilocytic astrocytoma. The tumor originates from cells that are responsible for which of the following functions in the central nervous system? And these are our answer choices. All right, so this is a pediatric neuro question. And what we have to know is that the most common brain tumor in kids is a pilocytic astrocytoma. And that's often found in the cerebellum. And so here we have a 15-year-old boy. He's got dizziness, he's got vomiting and coordination problems. And the MRI has a cerebral or a cerebellar mass. And the biopsy has pilocytic astrocytoma. And that's the first step. The second step is to remember that astrocytes are like the supportive cells in the central nervous system. Their job is they mop up all of this extra glutamate. They also regulate potassium, and they provide nutrients to the neurons. And so if a tumor comes from astrocytes, then its cell of origin is responsible for the uptake of neurotransmitters like glutamate. And so that is why our answer is E. Now, all of these other answers are distractors for various reasons, like the phagocytosis of cellular debris. That would be the job of the macrophages of the CNS, microglia, do that phagocytosis. Formation of the myelin sheaths in the peripheral nervous system. Peripheral nervous system, that's going to be the Schwann cells, right? That's not even the central nervous system. Maintenance of the blood-brain barrier. The astrocytes do help there, but the primary unique role of these astrocytes is going to be the uptake of glutamate. It's very specific to them. So E is definitely a better answer than C. The secretion of the cerebrospinal fluid. The ependymal cells of the chorioid plexus would do that. So totally different. All right, there's our brief explanation. Here are the trap answers and why they're wrong. A, microglia. B, Schwann cells. C, not the primary function of these astrocytes. And then D, ependymal cells, the ones that line the ventricles. So the bottom line is that pilocytic astrocytomas arise from the astrocytes, which are responsible for the uptake of neurotransmitters like glutamate. In our next question, we have a 32-year-old man presenting to the clinic with a 2-week history of sharp anal pain during bowel movements and bright red on the toilet paper afterwards. He denies changes in stool caliber or frequency and has had no significant medical history. Examination shows a small linear tear in the anal verge at the posterior region. Which of the following is most likely to diagnosis? So here we actually have our answer. It's anal fissures. Reminds me of that episode of The Office where they're like, anal fissures, that's a made-up disease. Nobody has that. And then Kevin's like, somebody has that. Oh, man. But this question would actually kind of show up maybe on some surgery shelf exams. The patient is coming in with sharp anal pain every single time that he uses the bathroom, right? He has a bowel movement. And there's also this bright red stuff on his toilet paper. And so that means there's a linear tear at the posterior anal verge, because that almost always occurs at the posterior midline because the blood supply there is the poorest. So hemorrhoids bleed, but they don't usually cause that sharp pain, and that's the reason why it's not hemorrhoids. These cysts right here, those are usually higher up near the scrotum or the sacrum. Rectal prolapse would be like a bulge, not a tear. And these abscesses, they would bring the fever and the swelling, not just the bleeding. So it's not an abscess. All right, so there's the pathophysiology. It's a tear, the mucosa of the posterior midline. You have pain, retention, harder stools, more tearing in the posterior midline, predilection because of the poor blood supply there. You can see that in Crohn's disease, chronic constipation, HIV, TB, syphilis. Look out for that when you're dealing with fissures. Okay, here's the bottom line. Sharp anal pain and bright red blood with a linear tear indicate an anal fissure. So that's how you could have diagnosed Kevin from The Office. In our next question, a 48-year-old woman presents with a 3-day history of fatigue, shortness of breath, episodes of chest discomfort. She has a history of hyperlipidemia and hypertension. She's on a statin and lisinopril. Her blood pressure is 146/88. Pulse is 102. She's slightly diaphoretic. She has ST elevation and leads 2, 3, and VF. Troponin 1 is elevated. Lab analysis reveals increased serum activity of lactate dehydrogenase. Which of the following is most likely explanation for the elevated serum LDH? All right, so a lot of these signs are actually pointing toward a myocardial infarction, and these 2, 3, and VF leads are telling us that this is an inferior wall problem, and so that is going to be the RCA territory in most individuals. And so elevated LDH, which is the lactate dehydrogenase, and troponins would tell us that there's cell membrane damage, and that means that there's some sort of an enzyme leakage here. So because of the ST elevation in these leads, that leads us to believe this is an inferior wall myocardial infarction. And we know that troponin 1 is elevated because troponin 1 is elevated at any time that there's necrosis of the myocardial tissue. And there's enzyme release. So LDLs, CKMBs, AST, ALT, all that stuff due to the membrane disruption. So what happens here is we have a myocardial infarction that leads to necrosis, the cell contents leak, that's the LDH and the troponins. There's reperfusion injury that can elevate LDH due to the free radical damage. There are other causes as well of high LDH. Some of them might be like hemolysis, liver disease, muscle injury, or lymphoma. And the pathophysiology to really look out for on questions like this is, one, it starts with ischemia, right? So you have ischemia, which leads to a decrease in ATP, which then leads to your sodium-potassium ATPase failing, which then leads to an ionic imbalance. And then 2, that leads to some osmotic swelling, plus that calcium influx, and you get the activation of these degradative enzymes. Now we start to lose our membrane. The integrity of our membrane is lost. And so you have cytosolic enzymes like LDH, troponin, CK, all of that stuff just leaks into the serum. And the LDH rise is always going to be, on step 1, LDH, a biomarker of necrosis, not necessarily just that increased metabolism. So LDH is elevated in tissue necrosis. That's like the key thing to know for this. Also, you have to know the myocardial infarction classic labs. Troponin is the most sensitive. CKMB is useful for reinfarction. And LDH is like actually kind of an older test, but it's a little bit more nonspecific. And so the mechanism is cell membrane disruption and the leakage of intracellular enzymes. And so our answer is going to be the increased cell membrane permeability. Why is it not reduced activity of the ATP dependent ion pumps? Well, that does happen in ischemia, but that's not the direct cause of the LDH elevation. That just sets up the cascade so that it can happen. Increased glycolytic activity in the ischemic tissues, that's ischemic adaptation, but the glycolysis does not actually release the LDH into the serum. Why is it not enhanced endocytosis of LDH? That's actually going to be like the opposite of what actually happens in reality. The LDH exits the cells. It does not enter them. And mitochondrial ATP production boost, that's wrong because ischemia impairs ATP production. So that would not make any sense at all. All right, just to make this like super duper clear, what's happened in this question is we have our patient and she had a myocardial infarction. And when the heart muscle cells die, their membranes break apart. That should make sense to us, right? And inside those cells, there are enzymes. And some of those enzymes are LDH and also troponin. And when the membrane ruptures, the enzymes spill into the blood. And that's the reason why you look at the blood and it has a lot of LDH there. So it's really the membrane problem. It's not like an ATP pump failure, right? That happens in early ischemia, but doesn't necessarily relate to why the LDH is there. It's not more glycolysis. That's just a metabolic shift. Who cares? Doesn't really leak the LDH there. It's not endocytosis of the LDH either. That's the wrong direction. The cells don't eat LDH. They're actually releasing it. It is not more mitochondrial ATP, right? That's false because the mitochondria actually are going to shut down whenever you have ischemic events because the oxygen is like that last little receptor in that whole cascade of the electron transport chain. And so you're going to have less ATP production. All right. And so the bottom line is elevated serum LDH in myocardial infarction indicates increased cell membrane permeability due to the ischemic injury. For our next question, a 45-year-old man visits the clinic because he's got some lower back pain, as you can see. Look at that. He's just clutching. He's like, oh, I got my lower back pain. That started 7 months ago, and he is a construction worker and states that the pain has been affecting his ability to perform his job. Upon examination, findings are consistent with a mild lumbar strain. The physician suggests starting a course of naproxen. But the patient is hesitant and he expressed interest in trying acupuncture first. Which of the following is the most appropriate response by the physician? All right, so this dude is like, hey, I need alternative therapy. The first thing is that you explore their perspective. You do not dismiss their perspective. All right, so this is just like a simple ethics question. Do not be dismissive, okay? Don't be dismissive. Don't be dismissive. What is that from? Parks and Rec? Anyways, high yield fact here is just shared decision making, right? Open-ended communication. Those are the big ethic points for this type of question here. And ethics, you always answer them on a kind of a principle level, unless it's like an actual regulation that you have to be aware of, like next of kin stuff. But the patient is hesitant about prescribed medication. So you don't shut them down, right? You show interest in alternative therapy, acupuncture, then you just have to explore that. You have to be open-ended. You have to be non-judgmental. You have to be patient-centered. And so the answer is, tell me more. That's always the answer, by the way. Tell me more about this acupuncture for pain, unless you're like dying and they need actual like help. But yeah, tell me more. And then you provide the evidence-based guidance. But first you have to respect their autonomy. Okay. Ethics question, super simple. That's the bottom line. Encourage their preference. Ask them about their knowledge of acupuncture to foster shared decision-making. Before we start this next question, if you're liking this stuff, please just like and subscribe. It really helps out the channel and it makes it so I can provide even better videos for you guys in the future. More likes, more comments, more engagement, more students. It just means that the quality keeps improving. And I'm trying to make this as fun, as affordable, and as free as possible. So just please like and subscribe if you're liking this. It really, really helps out. A 72-year-old woman arrives to the clinic and she has frequent gum bleeding and she's got some pain and she had tea and toast. That right there is enough to give you the answer that it's probably vitamin C, it's probably scurvy. So immediately go to the answer and pick hydroxylation of lysine. Like that's how I want you to do this on step 1 test day. The scurvy and vitamin C questions always appear and they're so easy, right? It's just a classic nutrition question. You've got some man or a woman, they're usually kind of old and they only eat tea and toast. If they see tea and toast, it's vitamin C, right? They avoid the fruits, they avoid the veggies, and now they have gum bleeds, bruises, joint pain, all that stuff. And the labs show like normal clotting studies, which means the bleeding is not from a coagulation problem, it's scurvy, right? Vitamin C is super duper important for collagen synthesis. And this is like one of those things you just have to kind of memorize, just clonk, put it in your head, hydroxylation of lysine, right? Because vitamin C is super important for the collagen synthesis. And the reason why is it's a cofactor for hydroxylation of proline and lysine. And so if you don't have that step, then the collagen gets super weak and then the tissues fill and then you start to get all these symptoms. So now let's look at the other answers. Yep, it's scurvy, proline, lysine. Synthesis of heme is totally different. That would be B6 and allosynthetase, not vitamin C. Decarboxylation of pyruvate. That would have the neurologic symptoms and lactic acidosis. That's a thiamine deficiency, not vitamin C. You'd have the Wernicke signs for decarboxylation of pyruvate. You'd have some lactic acidosis there. Conversion of folate to methyl tetrahydrofolate, that'd be megaloblastic anemia, dependent on vitamin B12. And the nucleotide excision repair is a UV sensitivity problem, DNA repair mechanism. Alrighty. So the gums are bleeding, all that stuff. Just immediately go down, trust me on this one, pick hydroxylation of lysine. It's always going to be the correct answer. They also might have proline in there, but just no scurvy like the back of your hand. You're definitely going to see it, and it's like free points on test day. Okay, and so the bottom line is vitamin C means impaired collagen synthesis, and that leads to gum bleeding and bruising and scurvy. Okay, in our next question, they are not 72. Now they are just 6 years old and they're brought to the pediatrician. They have difficulty healing from a minor cut that has developed into an ulcer over the past 2 weeks. There you can see the patient kind of looks like Boo from Monsters, Inc. She has had multiple episodes of delayed wound healing and severe infections, including pneumonia and otitis media. Lab tests reveal persistent leukocytosis. Flow cytometry has decreased expression of CD18. Okay, that should clue us into something. Her nitroblue tetrazolium test shows normal results. Further evaluation says normal phagocytic function and isolated neutrophils. Which of the following defects is most likely responsible for this patient's conditions? All right, we got a nice selection of answers here. The lay of the land here is that we have a 6-year-old kiddo, recurrence infections, and poor wound healing. And also there's a high neutrophil count and a low CD18 expression. So low CD18 expression, poor wound healing, high neutrophil counts. This right here, this combination should already cue you into something, and that is leukocyte adhesion deficiency. This is LAD1. All right, so the problem is the impaired neutrophil migration due to the defective CD18. And that's those beta-2 integrins. And so neutrophils, the problem is that they can't exit the bloodstream to reach their infection sites. So you have delayed wound healing for that reason, right? The neutrophils, they cannot get into the tissue. Like they're trying, they just can't because of that deficiency. And so you have recurrent bacterial infections, usually pneumonia and otitis media, and there's persistent leukocytosis, right? The neutrophils are stuck in the blood, and so there's a lot of them. And the CD18 is low, and so that's the hallmark of LAD1. So CD18 should really make you think of LAD. And they also have that normal NBT test. That's the oxidative burst showing that it's intact. And that tells us that it's not like some chronic glomerulus deficiency or like some CGD deficiency or anything like that. There's normal phagocytosis, right? And the killing machinery is totally fine. That's what they're trying to tell you if there's normal phagocytosis. Okay, and so let's look at through all these answer choices, and probably by now you guys have some sort of a choice here, but decreased production of reaction oxygenation species, that's CGD that we're talking about. And that test that they ran, the oxidative burst test, shows that it's normal, and that's why that's not the right answer. Deficiency in the neutrophil granule enzymes, that's Chidiac-Higashi, and that is tested on step 1, even in 2025, right? So neutrophil granule enzymes is Chidiac-Higashi. There you'd see the giant granules, you'd see the albinism, that's the neutrophil granule enzymes. Impaired neutrophil migration, yes, that is indeed what's happening here. Cyclical decrements in the neutrophil count, well, that would be the cyclic neutropenia, not the constant leukocytosis. And the deficiency of the hypochlorous acid production, that's the MPO deficiency, and that mainly present with like infections in Candida. So that's the reason why the answer is C, and this is leukocyte adhesion deficiency caused by CD18 deficiency, which impairs the neutrophil adhesion and transmigration. It's the neutrophils that cannot exit the bloodstream to reach their infective tissues. There's our bottom line. For this next question, which we're going to answer super quickly, we're analyzing multi-generational family history of autosomal dominant disorder associated with a particular genetic marker. As you can see, this loving little family here, they're worried about their family history. Most family members carry a unique allele of the marker of locus close to the disease gene. However, one affected son and his affected grandma have the disease. Okay, what explains this? I'm going to do this really, really quickly. The answer is recombination. And all they're trying to get at with this question is linkage analysis, linkage questions, right? So there's a marker that's close to the disease gene, then it's usually going to be inherited together. Birds of a feather flock together. And so if somebody is affected without that marker, that's because recombination split the two that are far apart. And so there's a disease gene and a marker allele, and they start out linked. And during meiosis, there's this crossing over that occurs. And the result is you have an offspring that inherits that disease without the marker allele. And that explains why, this IL-5 and the I2 here, that explains why this individual 2, 5, and then individual 1, 2 have that disease, but not the unique marker. And so the answer is C. Now, I want to explain this super simply. Basically, the family has some sort of autosomal dominant disease. The doctors are using a genetic marker near the disease to track who's been affected. And usually if you inherit the disease, you also inherit that marker. But in this family, one affected son and his grandma have the disease without the marker. Okay, so sometimes when chromosomes swap their places during meiosis, the disease gene and the marker get separated away. And that is known as recombination. It's that crossing over event which separates the disease and the marker. So basically, if they are close together, they usually travel together. But the crossing over happens between them whenever you inherit the disease gene, but you don't inherit the marker, or like vice versa, right? So it's not gene amplification, non-disjunction. Non-disjunctions like trisomies or monosomies. Gene conversion would be like a DNA repair process, and anticipation is like Huntington's. Okay, so those are kind of the trap answers that you should be looking out for, and we'll move on to our last question. All right, here we have a 35-year-old man, and he is presenting to the clinic with this 5 month history of fatigue and also joint pain and skin tightness affecting his face and his hands. His fingers change color and blue, Raynaud's. Okay, cool. Shiny, thickened over his finger and face. Sclerodactyly is noticed on both of his hands. Lab tests show a positive ANA and speckled pattern anti-SCL70 antibodies. Pulmonary function tests now show reduced lung volumes consistent with the restrictive pattern. Okay, what is most likely to be increased in this patient due to his underlying condition? Okay, so the pathophys here is there's autoimmune damage, and that's fibroblast activation that causes excessive collagen deposition. The skin thickening and the organ fibrosis that occurs in like the esophagus, the lungs, the kidney, the heart. Pulmonary fibrosis is going to stiffen those lung tissues, and that reduces the lung volumes. And then you get fibrosis and vascular remodeling, and that increases the mean pulmonary pressure, and then you get pulmonary hypertension and this right heart strain or cor pulmonale. All right, so it's not going to be serum alpha-1 antitrypsin. That's associated with emphysema and not systemic sclerosis. ESR, that actually can be mildly elevated, but it's not going to be most specific to this particular condition. Serum creatinine levels, those guys can rise in scleroderma, renal crisis, but we're kind of emphasizing the pulmonary aspect here, and so it's going to be more pulmonary focused, and its mean pulmonary arterial pressure is going to be increased for sure. And the total white blood cell count is not going to be characteristic of systemic sclerosis. So it's diffuse cutaneous systemic sclerosis, and you confirm that by those 70 antibodies, the anti-SCLs, Raynaud's, skin tightening, all that stuff. And that leads to the pulmonary vascular remodeling, so you get pulmonary hypertension, and that means that you have increased pulmonary arterial pressure. And so the bottom line here is that those antibodies, the anti-SCL70 autoantibodies, indicate systemic sclerosis, and that often leads to an increased mean pulmonary pressure due to the pulmonary hypertension. And last thing I'll say, this is the diffuse type of systemic sclerosis. And so you have the tight, shiny skin on the hands and also the face. And Raynaud's phenomenon is when your fingers, they turn blue. And that should be like a dead giveaway. Fingers turning blue, anti-SCL70 antibodies, and the restrictive lung disease is all going to be associated with this. So the body's just making way, way, way too much collagen, causing fibrosis. That's like basically scarring in your skin and your organs. And so the lungs, you have fibrosis in your lungs. Well, that makes it hard to expand. And so that means the compliance is going to decrease. And the blood vessels in the lungs also get scarred, and there's increased pressure in the lungs because of that. So you get pulmonary hypertension. And so your mean pulmonary arterial pressure is definitely going to be increasing because of that pulmonary hypertension, because of that scarring, that fibrosis. Hopefully this is fun and helpful. All right, so hopefully you guys enjoyed this video. If you did, like and subscribe. And now, just as a little study break, you can enjoy this little wrap that will consolidate all of the information that we've learned in this video. Take care and have a great rest of your day.
Raynaud's chillin', skin tight and tough. Anti-skull 7 ego lungs feeling rough. Restrictive vibe, jerk on the way. Mean pulm pressure rising, that's power. Fancy run down, TLC up high. No bronchodilator fix, that's no lie. Increased resistance, lungs too compliant. COPD's in play, airflow defiant. Mac in the gut, baby system broke. Histiocytes full, this ain't no joke. Increased resistance, lungs too compliant. EOPD's in play, airflow defiant. Mac in the gut, baby system broke. Histiocytes full, this ain't no joke. FN gamma, receptors MIA. IL-12 can't activate that macrophage play. Drugs are weak acid, pKa 4-4. In the stomach is not ionized to the core. Blood pH flips it, ionized and stuck. Absorbed like a boss, pharmacokinetics truck. Posterior fossa, with gate all off. Pulmonary astro, glutamate cough. Astrocytes catch that neurotoxic wave. Suck up the back, keep neurons brave. Posterior fossa with gate all off. Polycytic astro, glutamate cough. Astrocytes catch that neurotoxic wave. Suck up the back, keep neurons brave. Posterior midline tear with sunburn. Constipation pressure, that's how you learn. No wart, no abscess, no hemorrhoid show. Anal fissure pain with each bowel flow. Chest pain sharp, CKMB flies. Membranes leaky, cardiomyocyte cries. Ischemia is real, not ER hype. Early necrosis, enzymes take flight. Old lady ate down for NSAID meds. Wants glucosamine instead of what doc said. Open and divide, ask what she knows. Shared decisions, empathy grows. Bruising easy, no factor mess. Vitamin C low, choline in distress. Hydroxylation fails, collagen weak. Scurvy's in play, that's your physique. Love the keys high, but chemotax is low. Lads the block, can't reach the show. FMLP ignored, plus can't form. Adhesion defect, classic immunostorm.
high but chemotaxis low. Lads the plot, can't reach the show. FMLP ignored plus can't form. Adhesion defect, classic immunostorm. Leukocytes high but chemotaxis low. Lads the plot, can't reach the show. FMLP ignored plus can't form. Adhesion defect, classic immunostorm.
Everybody already know what this is. Step 1 prep. Here we go. A 28-year-old man presents to the clinic with complaints of persistent shortness of breath and wheezing despite using asthma medication. He has a history of mild asthma and is currently taking a daily inhaled corticosteroid along with an as-needed short beta agonist. Pulmonary function shows an FEV1 improvement of only 10% after administration, whereas typical improvement is around 35%. Genetic testing reveals a single nucleotide polymorphism on a gene encoding the beta-2 adrenergic receptor. Which of the following most likely explains this suboptimal response? All right, is it A, increased alpha-1 receptor density? So alpha-1 receptor density, well, alpha-1 causes bronchoconstriction, but this would not be relevant to the short-acting beta agonist. All right, what about beta-arrestin? At least has beta in the name, right? Well, that mediates the receptor desensitization with chronic agonist use, not genetic baseline polymorphisms. So that's not the answer. How about elevated bronchial, smooth muscle, CAMP degradation? All right, so CAMP degradation is going to involve PDE overactivity fixed with the PDE inhibitor, and it's not linked to the ARB2 polymorphism I'm talking about here. And what about this guy? Polymorphism affecting the receptor signal transduction. That sounds right because they have asthma, but they're failing to albuterol because of the beta-2 adrenergic receptor polymorphism. So it impairs the receptor's ability to activate, how does this normally work? GS, and thereby stimulate CAMP production that we talked about. And so bronchodilation is thereby limited. So the other stuff like PD activity, muscarinic upregulation, that affects CAMP, but downstream, or it affects the parasympathetic tone. But the key here is the genetic receptor defect, right? This GS to CAMP pathway, so it's the receptor polymorphism that affects the receptor signal transduction. That's our correct answer. All right, how about the upregulation of muscarinic receptors in the airway? Well, that would increase the parasympathetic bronchoconstriction, but there's no genetic testing clue there, and so our answer is going to be D. The bottom line is beta-2 adrenergic receptor polymorphism impairs albuterol's efficacy, leading to suboptimal asthma control. In our next question, we have a 50-year-old woman presenting to the clinic with a sudden onset of severe lower abdominal back pain and fever for 24 hours. Her medical history is significant for long-standing type 2 diabetes and hypertension. On exam, her temperature is 101.3, blood pressure is 130/85, and a heart rate is 110 beat per minute. She exhibits guarding and rebound tenderness in the lower abdomen. Lab results show a leukocyte count of 16K with a left shift. A computed tomography scan of the abdomen reveals pneumoperitoneum and thickening of the colonic wall. Which of the following is the most likely diagnosis? Okay, so what's important about this question? Well, first of all, what in the world is a pneumoperitoneum, right? Pneumo, air, peritoneum, you know what that is. So it's basically the medical term for the presence of free air in the abdominal cavity or peritoneal cavity outside of the digestive organs. And this could be super serious. It could signal the perforation of a hollow viscus like the stomach or the intestines, and that would need urgent, sometimes surgical intervention. But it can also be spontaneous, like mechanical ventilation. And you can see this in X-ray. Also, by the way, you can go through your whole entire medical school career and never be explicitly told what viscera is, right? Those are the internal organs in the main cavities of the body. And this is one of my gripes with medical school generally, is they don't teach you things. They just assume that you should know those things. So viscera is literally the internal organs in the main cavities of the body, like the abdomen or the intestines. And so viscous perforation is the most common and serious case where you get a hole in the gastrointestinal tract, and that releases air into the abdomen. Okay, so how about of these answer choices? Let's start with mesenteric ischemia. That causes severe abdominal pain out of proportion to the exam, but no pneumoperitoneum. So this is going to hurt, ouchie, ouchie, but that is not going to explain the symptoms. Diverticulitis with perforation. So they do have acute diverticulitis that's complicated by perforation. That's evidenced by the colonic wall thickening and the pneumoperitoneum. And the clinical signs also indicate this: the peritonitis, the fever, guarding, rebound, all of that supports this. The other answers don't match that intraperitoneal symptom profile. Crohn's disease. That's a chronic diarrhea, weight loss, and skip lesion condition. You have the fistulas as well. It's not going to be acute perforation with free air. So that's not what Crohn's disease is. Endometriosis, definitely different. That's a cyclic pelvic pain with menses, not acute peritonitis or pneumoperitoneum. And acute cholecystitis, that'd be right upper quadrant pain and Murphy sign, and colonic wall would not be seen, right? What you do see is the right upper quadrant pain and Murphy sign and gallstones, but you don't see that pneumoperitoneum stuff. So anytime you see pneumoperitoneum, you should immediately be thinking of the perforation every single time. And so this time we got a woman who shows up, she's got all that abdominal pain, the fever, leukocytosis guarding and rebound. CT shows the free air, and all that leads us to think of a diverticulitis that has perforated. And diverticulitis starts with an obstruction in the diverticulum, leading to an infection, inflammation, and then rupture. And the rupture spills the air and the bacteria into the peritoneum, and that causes a dramatic clinical picture that we're seeing in this patient. So the bottom line is diverticulitis with perforation is indicated by pneumoperitoneum, fever, leukocytosis, and abdominal tenderness. All right, I'm going to hide myself in front of the answer. A 32-year-old woman decides to take a hike on the Appalachian Trail, reaching an elevation of 4,000 meters above the sea. She has no significant past medical history, and she describes her physical condition as excellent. I would agree, just check out that image up there. After spending several hours at this altitude, she begins to experience shortness of breath and mild lightheadedness. Her vital signs include a blood pressure of 110/70, heart rate of 90 beats per minute, respiratory rate of 20 breaths per minute, and oxygen saturation of 88% in room air. Which of the following would most likely be increased in this woman as a direct physiological response to the decrease in atmospheric oxygen available at this altitude? Okay, so the answer is pulmonary vascular resistance. Okay, this is an awesome step one concept. So at 4,000 meters elevation, the atmospheric pressure of oxygen drops. There's just less oxygen up there, and that leads to alveolar hypoxia. And so the immediate response is going to be hyperventilation, right? You got to breathe, so increase your respiratory rate. The body's like, hey, have you tried that? Let's start breathing a bunch. And that improves oxygenation, but it also lowers the partial pressure of carbon dioxide. And carbon dioxide, you should think of that as pretty like acidic. And so if you lower that, then it causes respiratory alkalosis. And so the key point is that systemic circulation generally vasodilates in response to hypoxia, but pulmonary arterioles constrict. And so that's the opposite response. It shunts the blood away from the poorly ventilated alveoli. And at a high altitude, however, the hypoxia is global. And so you have diffuse pulmonary vasoconstriction, which leads to elevated pulmonary arterial pressure and PVR. Okay, so the super big buzzwords here: high altitude means low PaO2, which means then hypoxic pulmonary vasoconstriction increases the PVR. Tachypnea comes from the early acclimatization response. And so after days to weeks, the erythropoietin goes up, and that can cause polycythemia. And no, polycythemia does not refer to my junior year at Harvard where everybody started getting interested in political science. It refers to the abnormally high number of red blood cells in the blood. It can be primary or it can be secondary, and secondary is usually associated with the lung or heart disease or living at a high altitude. So then we get elevated 2,3 BPG, you get a right shifted hemoglobin curve, and it's easier for the O2 to unload, and you can have chronic hypoxia, and there's a risk of pulmonary hypertension. It goes hand in hand with the right ventricular hypertrophy or cor pulmonale. So the bottom line is at high altitude, decreased oxygen availability increases cardiac output to enhance oxygen delivery to the tissues. Our answer is D, pulmonary vascular resistance. If you found this helpful, please like and subscribe. In our next question, we have a 68-year-old man presenting to the emergency department with progressive worsening fatigue and exertional dyspnea over the past few months. On exam, he has a blood pressure of 135/80. His heart rate is 88 beats per minute and respiratory rate is 18 per minute. Auscultation reveals a loud S4 heart sound and a harsh mid-systolic murmur best heard at the right second intercostal space radiating to the carotids. An echocardiogram shows left ventricular hypertrophy with marked valvular calcification. The physician explains the patient's condition has placed increased demands on his heart. Which of the following sets of changes in the patient's left ventricular physiology is most likely? All right, so they've told us with the labs that this person has aortic stenosis that causes the pressure overload and the increased work. Right? You have to pump harder, don't you? If you have to pump harder, then the oxygen demand goes up. There's hypertrophied myocardium, that we know that from the S4 sound. And there's also increased wall tension. We know that because of the high left ventricle pressure, and increased adenosine, which is a marker for ischemia ATP breakdown. And so our answer is increased oxygen consumption, decreased wall tension, and increased adenosine. So in aortic stenosis, the left ventricle can generate pressure over 200 milliliters of mercury just to push the blood out. That's like super brutal, right? And so we have a harsh systolic murmur that radiates to the carotids, plus concentric hypertrophy, and all that tells us that it's aortic stenosis. And so the heart now has to do a whole bunch of work to go against that tight little valve. And so the work goes up, oxygen consumption also climbs because the thickened heart rate or the heart muscle needs more fuel, right? It's like a bad marriage. If somebody's constraining, somebody's just being a horrible person, then it takes a lot of work to make it work. takes a lot of oxygen consumption to make a bunch of blood go through a tiny little valve. And that is the reason why our answer is C. The key takeaway is in aortic stenosis, left ventricular workload increases, leading to an increased stroke work and myocardial oxygen consumption. Here are the clues as to why it's aortic stenosis. The 68-year-old man, you get the calcific aortic stenosis there. Fatigue dyspnea, signs of left ventricular outflow obstruction, and the loud S4 tells you that it's hypertrophied left ventricle, not dilated. And this, the harsh mid-systolic murmur at the right second intercostal space, tells you for sure that this is aortic stenosis. And so the tension goes down. In our next question, we have a 70-year-old man with progressive sensorineural hearing loss and is evaluated for possible interventions. He has struggled with understanding speech in noisy environments and has limited success with traditional hearing aids. After considering his options, he undergoes a procedure to improve his hearing. This procedure involves the direct stimulation of which of the following components of the auditory system? Okay, so sensorineural hearing loss, that's due to the dysfunction of the cochlea, the hair cells, or the auditory nerves. Hearing aids just amplify the sound, but it relies on the functioning hair cells. And so if you have enhanced sensorineural hearing loss, then the hair cells are just too damaged, right? You can't convert mechanical sounds into neural impulses if you don't have the hairs to sense those impulses. And so cochlear implants will solve this, though, by converting the sound into an electrical signal. And then they directly activate the spiral ganglion neurons. Those are the first order neurons of the auditory pathway that form the cochlear nerve. And that restores the perception of sound and speech comprehension in noisy environments in somebody who has sensorineural hearing loss. Why? Because sensorineural hearing loss is a problem with the inner ear or the nerve. And you have limited success because of what I described with hearing aids, right? Because you have damage to the hair cells. It's not just an amplification issue completely. And so you have to have a procedure that improves the hearing via direct stimulation through a cochlear implant on the spiral ganglion neurons, which is the site that are stimulated by the implant. And so our answer is C. Conductive hearing loss is improved just by traditional hearing aids, not implants. And the spiral ganglion nerves transmits to the cochlear nuclei in the superior olive, the inferior colliculus, and then the medial geniculate nucleus, and then the auditory cortex. And so the normal way that sound works is it's in the environment as a wave, and then it hits your tympanic membrane, and then you get the basilar membrane vibration and the hair cell transduction, which feeds into the spiral ganglion neurons and then to the brain. In sensorineural loss, you have damaged hair cells, and so you have the spiral ganglion neurons that are not stimulated. And in cochlear implant, bypasses the hair cells and stimulates directly the spiral ganglion neurons. Basilar is one of those words that we often don't explain as well. That's just the base of something. The bottom line is cochlear implants stimulate the spiral ganglion neurons to improve hearing in patients with sensorineural hearing loss. There's our guy. He's going to hear again thanks to you. Studying hard. In our next question, we have a 35-year-old woman with a history of persistent hypertension and facial acne evaluated for a new diuretic. She has been taking hydrochlorothiazide for 3 months, but her blood pressure remains elevated at 150/95. Holy cow. Lab tests show serum potassium level of 3.1. Given the patient's clinical picture for lab findings, a drug of which of the following mechanisms should be considered for her management? And we got some beautiful answer choices right here. All right, so the big thing in this patient is we have some uncontrolled hypertension. We got to take care of that. And also there's hypokalemia. On-thiazide therapy indicates the need for a potassium-sparing diuretic. And that's what we have to look for when we're dealing with drugs that affect the kidney. And there are drugs like spironolactone not only prevent potassium loss, but they also help with her acne in this case via the anti-androgen effect. So spironolactone is a double whammy for this patient. Just say, hey, would you like something that not only prevents potassium loss, but also helps with acne? She's going to say, oh yeah. All right, so the mechanism of spironolactone, you have to know. Which one is it? It is the blockade of the sodium channels, the ENaC, or aldosterone receptors, in the distal nephron. And so the answer is going to be C, blockage of sodium channels in the distal nephron. All right, angiotensin II receptors in the distal, those would be not acting on the nephron channels at all. They act on the AT1 receptors, so not quite. Inhibits sodium and chloride reabsorption in the distal convoluted tubule. Well, that's exactly what thiazides already do, and she's failing this, right? So don't give her more of the thing that she's failing. That would be loop diuretics like furosemide that worsens potassium loss, and it's not helpful here. Okay, so thiazide diuretics like hydrochlorothiazide lower the blood pressure, but often they cause hypokalemia. That's a huge side effect of chlorothiazide, hypokalemia. And so that's already what the woman is on, and her potassium is all the way down to 3.1. On top of that, that's literally pie, but on top of that, she has facial acne, which hints at androgen excess. And so the best next step is potassium-sparing diuretic like spironolactone. And these drugs block the sodium channels in the distal nephron, and it reduces the potassium loss, and spironolactone also blocks androgen receptors to help her skin. And so loop diuretics would waste even more potassium. Don't do that. Thiazide, she's already on it, right? And then angiotensin receptor blockers are not diuretics, so what are you doing there? And then the calcium reabsorption changes don't even apply here. And so it's just going to be the blocking of the sodium channels on the distal nephron. The bottom line is consider an aldosterone antagonist for hypertension and hypokalemia in patients who are on thiazides, especially if she has acne, which for some reason I failed to do. So just imagine it's me and I have acne. Oh my gosh, give me some spironolactone. Hopefully you guys can continue to learn at my expense. That's what I'm here for. All right, here's the next practice question. A 72-year-old woman is evaluated in emergency department, progressive lower back pain and weakness over the past 6 weeks. She reports nausea, constipation, and polydipsia. Her medical history includes type 2 diabetes untreated for 10 years. Physical examination reveals a frail appearing woman with mild lower thoracic spine tenderness. Lab studies show all of these things. Radiographs show multiple lytic lesions in the vertebrae. Bone marrow biopsy is pending, and after initiation of a rehydration and a loop diuretic to treat her hypercalcemia, which of the following classes of medication should be administered to address the underlying pathophysiology contributed in her condition? By the way, I make tons of awesome pieces of software that help you study for step 1, so visit the Chrome store to check that out. For instance, here's one. If you didn't know what potassium was related to, you can actually just search it on Sketchy. If you want that extension and many others, visit the store. And if you just want to help me out, then like and subscribe. But I digress. So, what should be administered to address the underlying pathophys contributing to her condition? All right, sorry I kind of derailed us there, but essentially the high yield facts here is that there are a couple of things which cause lytic bone lesions and hypercalcemia, anemia, and bone pain. And one of the biggest ones you should think of is multiple myeloma. And the best long-term pharmacologic management of hypercalcemia of malignancy is a bisphosphonate. It inhibits the osteoclast activity. And I want to tell you guys that on test day, if you're sitting there and you see a lytic lesion, then you should think plasma cell myeloma until you're proven otherwise. Especially if they have hypercalcemia and low phosphorus. Well, that's due to the bone breakdown from the osteoclast activation. And the symptoms would be nausea, constipation, polydipsia, weakness, and hypercalcemia classic presentation. And so the immediate therapy is IV fluids and loop diuretics. That's the first line to lower the calcium. And the definitive therapy is bisphosphonates that bind hydroxyapatite and induce osteoclast apoptosis and reduce the bone reabsorption. So the buzzwords are the lytic bone lesions, myeloma, right? Back pain, hypercalcemia, anemia. That's the CRAB criteria. Rehydration and loop diuretics already given. And so now we need definitive anti-resorptive drug. And the answer is bisphosphonates. Okay, so let's give her a bisphosphonate. The answer is D. The associations are multiple myeloma. And what to know about multiple myeloma, just really, really quickly, increased IL-6 and also that RANK-L activation, which increased the osteoclast activity. And so bisphosphonates inhibit osteoclast-mediated bone resorption. And by the way, resorption literally just means the process by which something is reabsorbed. So that's cool. But calcitonin is a short-term effect and it's not sustained. And corticosteroids are useful in lymphomas or granulomatous diseases, hypercalcemia, but not myeloma per se. And calcimimetics treat secondary hyperparathyroidism, not cancer hypercalcemia, and thiazides worsen hypercalcemia. So that's a really, really bad choice. So really the pathophysiology here is you have a malignant plasma cell that secretes cytokines, so IL-6 and RANK-L, and that makes the osteoclast activity go up, and then there's bone resorption, and then there's hypercalcemia and lytic lesions. And so bisphosphonates block the osteoclast function, and that reduces the bone breakdown and stabilizes the skeletal disease. And so the key features are bone pain, lytic lesions, multiple myeloma, hypercalcemia, nausea, constipation, weakness, polyuria, and bisphosphonates are the mainstay for malignant bone disease. You want to turn those off, look into the bisphosphonates. Okay, I can't tell if Giardia is like the most cute or the most terrifying parasitic organism. Maybe you guys can let me know in the comments. But that's my best attempt at drawing it. Here we have a 30-year-old woman, visits her PCP, recurrent episodes of watery diarrhea, abdominal cramps, and bloating. She did a humanitarian mission where the sanitary conditions were poor and she kept drinking out of the river. And she appears dehydrated with dry mucous membranes and has lost 6 kilograms since her last visit 3 months ago. Stool exam shows motile trophozoites with distinctive falling leaf motility patterns, and they look like a little pear, like I've drawn there. What is the pharmacotherapy of this condition? What's the mechanism of action of it? Okay, so this is metronidazole, because this is Giardia. Oh, that was off key. Giardia. That was still off key. I don't know. I can't sing. Giardia is the formation of the destructive free radicals. That's how it works. And so up to 30% of multiple myeloma patients present with hypercalcemia due to bone breakdown. And you think that's a high figure? Well, 20 to 30% of developing countries have a Giardia prevalence due to their contaminated water and poor sanitation. And the attack rate after exposure is like 7% for campers and drinkers of untreated stream water. I've done it before. I don't know why I did it. I was young. I was in Boy Scout camp and they dared me to. But Giardia lambdia is the most common intestinal protozoan infection in the United States with a prevalence of 2 to 5% in healthy adults and up to 30% in developing regions. Crazy, right? What about inhibition of ergosterol synthesis? Well, that's azoles, right? That's for fungi, so no thank you. How about disruptive proton gradient through ATP synthase? Well, that's atovaquone. That's for malaria, babesia. How about competitive inhibition of dihydropterate synthesis? Well, that's like sulfonamides, bacteriofoliate synthesis stuff. So that init chief binding to beta-tubulin, preventing polymerization. That's like albendazole, right? Those are for nematodes and helminths. So that's different here. You treat this Giardia with metronidazole, which becomes reduced in anaerobic organisms, and it produces cytotoxic free radicals that damage DNA and other critical molecules. That's why it works on the protozoa like Giardia. All All right, in this question, we have a 65-year-old man who was brought to his primary care physician by his wife because she is concerned about his memory. Over the past several months, he has difficulty remembering recent events and conversations. He recalls events from distant past, but neuroimaging reveals a bilateral hippocampal atrophy. Which of the following cognitive abilities in this patient is he most likely to struggle with? So I've kind of drawn this dude's brain right here, and there are the lesion points. Always, this is the right side, this is the left side. All right, so that's my beautiful drawing. What is he going to struggle with? Okay, they kind of gave this away in the question sim, but before we answer this question, I want to talk about the pathophysiology so that we can understand why without having to memorize it. The hippocampus consolidates new episodic memories. And I like to think of this because I like Krapopolis, the TV show, and Hippocampus is like one of the people there, and he always consolidates new episode memories, right? It's like an episode. Also, atrophy will lead to the failure to encode the recent experiences. That's called anterograde amnesia. And older memories are stored where? In the cortex. They remain preserved until later stages. So the hippocampus is the memory consolidation, and the loss of recent memory occurs first. Alzheimer progresses, then the language and the visuospatial defects, right? So our answer is going to be the remembering of recent appointments, not the old stuff. It's the forming of the new memories. So the bottom line is bilateral hippocampal atrophy indicates difficulty with recent memory, making remembering recent appointments the most effective cognitive ability. All right, folks, this is our last question of this set. A 29-year-old woman presenting to the emergency department complaining of persistent fatigue, lack of appetite, and difficulty sleeping for the past 2 months. She mentions feeling frequently overwhelmed and describes a low mood. She recently delivered a healthy baby girl 8 weeks ago, and the patient also has experienced moments where she feels disconnected from her baby and questions her ability to be a competent mother. She reveals that she has little interest in seeing friends and participating in activities, signs of depression, and her partner has been traveling over, which adds to her stress. And she denies alcohol and drugs. On examination, there's no remarkable findings. Which of the following steps is most appropriate in managing this patient? Should we suggest the patient enroll in a support group? Yeah, that's helpful later. But what they're really trying to get at here is this is like a safety check, essentially. So it's not quite enough. We need to do this expeditiously. What about initiate a discussion regarding her relationship dynamics with her partner? No, that's silly goose. Inquire about any thoughts and feelings of wanting to harm herself or her baby. Yes, infanticide, self-harm, very important. Assure her that such feelings are common and will resolve in time. No, our job is to assure when we have evidence to do so. But here, this is wrong, right? This is not just baby blues. This is actually a safety check, very important that we expeditiously inquire. Recommends an increased physical activity to boost her mood. That may help mildly with the depression, but it's not first line in a suspected postpartum depression. So before you think about support groups or medications, you have to do a safety screen. Point blank, just ask, do you have thoughts? That determines how urgent the intervention is. All right, so the baby blues, that's super common. It's self-limited mood disturbances, less than 2 weeks. But then postpartum depression is greater than 2 weeks, major depressive features, and it impairs the bonding and the function. And the first step in management is screening for this kind of stuff. And if she responds yes to question C, then emergency psychiatric referral or hospitalization is needed. And if no, outpatient treatment for psychotherapy and SSRIs, like sertraline, would be preferred if she's breastfeeding, for instance. There's the bottom line for postpartum women. Guys, you did it. Good job. Look at that. You did it. This is my message for you. You're going to pass. One thing that's proven to help is clicking the subscribe button. Just kidding, it's not proven to help, but actually I take that back. You know how many people have sent me saying they've passed 4 students recently? I love getting comments all the time like, hey, I just passed my exam. That's the whole reason that I'm doing this, so please be sure to like and subscribe. Let me know what I should cover next. Thanks so much for the 1,000 subscribers. Let's just keep taking this higher and make sure that you pat yourselves in the back. Wake up every day and say something amazing, something wonderful is going to happen to me today, and it will. The parking spots will open up for you. You'll notice the little things. Life is meant to be enjoyed. You can make it fun. Be kind to people. Be giving. Take it easy on yourself and tell yourself that something wonderful will happen every single day, and I tell you it will. All right, folks, you got this. We'll see you guys in the next video and in the community post. Have a good one. Hello, everybody. You know what this is. Step 1 prep. Here we go. A 35-year-old man with pulmonary arterial hypertension is treated with an endothelin receptor antagonist. Which receptor is targeted? Okay, so we have to talk about PAH, pulmonary arterial hypertension. And it's a specific subset of pulmonary hypertension where the small pulmonary arterioles narrow due to endothelial dysfunction, smooth muscle proliferation, and fibrosis. And that increases resistance, and that raises the pulmonary arterial pressure, and that overloads the right ventricle, and that leads to cor pulmonale. All right, so you have that loud P2 sign, BMPR2 mutations, and endothelin 1 is overexpressed, and so you get vasoconstriction and proliferation. And that's why our answer is going to be C. And we're thinking specifically of bosentan here. It blocks the endothelin 1 receptors, preventing vasoconstriction and vascular remodeling. That's the drug of choice. All right, so the 2 things to know is that PAH is caused by increased pulmonary vascular resistance, and endothelin 1, BMPR2, and right heart failure are associated. All right, so the mechanism here, the pathophysiology. First, we have an endothelial injury, and that decreases a lot of things. Nitric oxide is 1, prostacyclin is 2, and endothelin 1 would be increased. Then you get vasoconstriction and smooth muscle proliferation, the narrowing of the arterioles, and that increases the pressure. And then the pressure Increase causes right ventricular hypertrophy, and then you get right-sided heart failure. And you have that loud P2 sign, dyspnea, fatigue, syncope. And you have normal wedge pressure because it excludes the left heart failure. And so becentan blocks endothelin A and B receptors. And you monitor the LFTs because hepatotoxicity is a known risk. Now, other things like the PDE5 inhibitors like sildenafil, those increase nitric oxide signaling. But here we're talking about bosentan. So the answer is indeed going to be C. Muscarinic would be parasympathetic. Histamine would be allergies and asthma. Dopamine, renal neurologic pathways, and serotonin would be carcinoid syndrome migraines associations. So endothelin receptor antagonists are the primary treatment for pulmonary arterial hypertension. All right, our next question, we have a 45-year-old man presenting to the dermatology clinic with a progressively enlarging dark spot on his upper back that he first noticed about 2 months ago. He reports some itching but denies bleeding or pain. He has a history of frequent sunburns but no significant past medical history for medications. Physical exam shows a 1.5 centimeter irregularly shaped asymmetric darkly pigmented lesion. A biopsy is performed and histopathology demonstrates atypical melanocyte proliferation with pleomorphic pigmented dendritic cells. Which of the following is the diagnosis? A lot of nice answers here. So let's go through each one by one. But first, I want to talk about the signs. 1, we have progressive growth, asymmetry, and irregular border. We have UV exposure, frequent sunburns, and histology shows pleomorphic melanocytes, dendritic, and pigmented, and so that's a key melanoma feature. And so some trap answers are going to be seborrheic keratosis. That's a stuck-on, waxy appearance, and the histology shows horn cysts, not pleomorphic melanocytes. Dermatofibroma is a small, firm brown papule, and histology shows fibroblasts, not melanocytes. Kaposi's sarcoma is going to be HHV-associated vascular tumor, especially in HIV. Histo would show the spindle cells, not the melanocytes. Merkel cell carcinoma is a neuroendocrine tumor, and histology shows the small blue cells with a high mitotic rate, not the pigmentation or the dendritic. All right, so melanoma accounts for just 1% of the skin cancers, but it causes the vast majority of skin cancer deaths. And so you got to do stuff about it really early on. And you got to learn your ABCs, right? It's asymmetrical. The borders, right? Benign moles are symmetric, but melanomas are chaotic, and that's because the genetic mutations, which causes their irregular shape. The border irregularity as well happens because melanomas invade adjacent borders. So they have the scalloped or the notched borders. And there's also C, A, B, C, D, right? So C is color variation. And I should actually just write this down. So A is asymmetry. I mean, that's why I got my notepad here, right? A, B, C is the color, right? So the color variation, there's black, brown, blue, red, white. That's just the uneven melanin production or hemorrhaging. And then D is the diameter. And if it's greater than 6 millimeters, larger lesions have more time to mutate and grow unchecked, whereas the benign stuff is usually pretty small. And then the evolution, is it changing? So the change in the size, the shape, the color, the symptoms, that's a key sign of the malignancy. So melanoma is a malignancy of the melanocytes and is driven by BRAF V600E mutation and induced P53 mutation. It grows rapidly at first, and then it grows vertically, and there's a risk of metastasis. So it grows radially at first. And so if you see an irregularly shaped dark pigmented lesion with atypical melanocyte proliferation, you should think of a melanoma. All right, so we have a 15-year-old girl who presents to the dermatologist with a dark spot in her lower abdomen that she's noticed for the past 2 months. She has denied pain, itching, and changes of color. She has no significant medical history, and she's going through puberty, and she has a 4 millimeter round hyperpigmented lesion located 2 centimeters lateral to the umbilicus. It has a darker center, smooth borders, and appears slightly raised. Surrounding skin is otherwise unremarkable. What is the diagnosis? Okay. Pubertal girl, small pigment along the milk line. Going to be accessory nipple. Lentigo is a flat sun-related lesion. And these dermatofibromas are going to be firm and fibrous nodules, often the dimpling signs. And the epidermoid cysts present with a mobile dome-shaped nodule with a central punctum, and they're typically not pigmented. In our next question, a 65-year-old man has a history of cough, COPD, and chest discomfort. He has large bloody pericardial effusion with high protein and low glucose. Which malignancy caused it? All right, so lung cancer is the most common source of malignant pericardial effusion. Breast cancer and lymphoma are also common in women and younger patients, and prostate cancer is from bone mets, not pericardial. And the pancreatic cancer has the peritoneal spread, not pericardial, and the esophageal cancer has direct invasion or fistula, but it's rare in the case of effusion. And laryngeal cancer is associated with a local tumor, no pericardial involvement. And so our answer is going to be the lung, because it's a leading cause of malignant pericardial effusion. Other ones are just less common. You got to know those associations. And basically, there's a tumor invasion or lymphatic spread to the pericardium, and there's exudative effusion that forms that increases the protein and decreases the glucose, and there's bloody fluid due to the tumor vascular invasion, and the pericardial space fills up and you get tamponade and decreases the preload, and hypotension is going to be caused. All right, so it'll usually be like an older man with COPD, and that suggests there's like a smoking history, maybe some lung cancer risk. You'll see distant heart sounds at the pericardial fluid that dampens the heart sounds. JVD and hypotension would be the tamponades triad, the Beck's triad, and you have the enlarged cardiac silhouette, and that's just pericardial effusion. And the bloody exudated pericardial fluid would be a malignancy until it's proven otherwise. All right, so here are the other answers. Prostate metastasizes the bone, pancreas spreads to the liver, esophagus may invade the mediastinum, larynx spreads locally to airway structures, not the heart. So 40% of lung cancer patients actually have pericardial metastasis on the autopsy, and that's just how often this will just sneak into the sac around the heart. Loves to do that. And so neoplastic pericardial effusion in older adults is most commonly due to lung cancer. All right, next we have a 6-month-old girl is brought to a pediatrician with persistent diarrhea and failure to thrive. Her parents report that she had several episodes of respiratory infections over the past months, including 2 incidents of otitis media and recent hospital administration for bronchiolitis. On physical examination, she appears pale and lethargic, and lab studies reveal anemia with the hemoglobin level of 7.2, and flow cytometry shows absent expression of human leukocyte antigen DR. Further analysis reveals marked deficiency in which of the following cell types. All right, so this is Bayer lymphocyte syndrome. This is type 2. It's a form of SCID due to an MHC2 deficiency. All right, and so we have to know MHC1 interacts with CD8 positive T cells. MHC2 interacts with CD4 positive T cells. And if MHC2 is missing, then CD4 T cells can't positively be selected for in the thymus, and you have profound CD4 deficiency. And that impairs the B cell help and the antibody production, so you get combined humoral cellular immunodeficiency. All right, so if you have an absent HLA-DR on flow cytometry, then think of an MHC2 deficiency. And if you have recurrent respiratory and GI infections of infancy, then it's going to be a severe immunodeficiency, and the failure to thrive and chronic diarrhea is a hallmark of SCID. So we have some genetic defects. Autosomal recessive defect of the transcription factors that regulates these MHC2 expressions. And so the answer is CD3 positive T lymphocytes. And this is including both your CD4 positive and your CD8 positive T cells. Because in flow cytometry, CD3 is the universal marker for all mature T cells. And so CD4 is a subset marker, but it's not listed as one of our options. Otherwise, we would have chosen that. CD4 is that subset marker. And if CD4 positive T lymphocytes was an option, then that would be the more precise answer. But basically, CD3 is basically saying, hey, this is a T cell. And an MHC2 defect, you'd have no CD4 positive T cells. And so a loss of a whole subset of CD3 would be the case. Kind of weird, but yeah. So you think of SCID with a deficiency in the CD3 positive lineage. All right, so here we got a 35-year-old man, history of type 2 diabetes, struggle with weight management, basically obesity, poor adherence to lifestyle changes, and HbA1c of 8.5. So which strategy would improve his adherence to the recommended lifestyle change? And our answer is going to be to schedule monthly check-ins and monitor progress and adjust skills as needed. Got to do those ongoing structured follow-ups, very important. The journaling, family member, educational stuff, cool beans, but it's the reinforcement is what gets the adherence higher. The 1-year follow-up is way too infrequent. Journaling is just self-awareness, but it's not going to provide accountability. You have to literally do the follow-ups. Family fitness class can help, but structured follow-up is going to be more impactful. All right, monthly check-ins for type 2 diabetes. Okay, so hypertensive patients are randomized to drug A or drug B, and the outcomes are measured, and then after a washout, the groups swap treatments. What type of study design is this? This is a classic crossover study. So participants receive both treatments in the sequence, and they act as their own control. RCTs compare groups in parallel, not switching treatments. Cross-sectional is single point snapshot. Cohort is observational. Case series is just descriptive. Bottom line, crossover design allows each participant to receive both treatments sequentially. All right, we have a 45-year-old man, palpitations, sweating, shortness of breath that has occurred intermittently in the past couple of months. He's been feeling intense fear and discomfort, and he's got that feeling of impending doom. On exam, his vital signs are within normal limits, and there's no significant abnormalities noted. After a thorough evaluation, he's diagnosed with a panic disorder. Medication is prescribed that enhances the effects of neurotransmitter gamma-aminobutyric acid, GABA. By binding to the specific sites of the receptor, which of the following medications is most likely prescribed in this patient? All right, lorazepam. That's a benzodiazepine that enhances GABA-A by increasing the chloride channel opening frequency. Barbiturates would increase the duration. This is a frequency. So it's provided, or it would provide rapid relief in acute panic symptoms. And sertraline is going to be the long-term use, and propranolol is for performance anxiety. And Trazodone is for depression, insomnia, and phenobarbital is a barbiturate, so you don't use that in panic disorders. All right, so here's the explanation. First-line panic disorder would be a benzodiazepine like lorazepam, enhancing the GABA's receptor effects. Now we have a 14-month-old Hispanic boy brought to the clinic by his mother due to concern about unusual leg shape and frequent crying. He was born full term and has been primarily consuming a homemade diet of pureed foods and cow's milk without any supplements. On examination, the child exhibits genu varum and swelling of the wrists and the knees. Additionally, palpation of the ribs reveals a rhacitic rosary. Lab tests reveal normal calcium levels and low serum phosphate levels. Which of the following lab findings would be most likely observed in this patient? All right, so we got some rickets going on, and this is resulting from the defective mineralization of the bone due to vitamin D deficiency. So vitamin D, calciferol, to that 25-hydroxy-vitamin D in the liver, then leads to that 1,25-dihydroxy-vitamin D in the kidney. And vitamin D is required for calcium and phosphate absorption in the gut, and so deficiency leads to less phosphate and sometimes normal calcium, but that's thanks to the parathyroid hormone mobilization and secondary hyperparathyroidism. And so we have a Hispanic boy, 14 months, homemade diet, cow's milk. So there's a risk for vitamin D deficiency, the low sun, and the poor supplementation. And we see all this other stuff that leads us to think of rickets. And so in labs, you have low phosphate, maybe some normal calcium, and secondary hyperparathyroidism. So the risk groups are going to be those exclusively breastfed infants in the dark skin, limited sun exposure. And the complications are bone deformities, hypocalcemic seizures. And this is kind of similar to osteomalacia in adults, the defective mineralization of the osteoid. And so the pathophysiology here is you have less vitamin D intake, which leads to less 25-hydroxy-vitamin D storage form. And you get decreased intestinal absorption of calcium and phosphate. And the lower calcium triggers increased PTH, and that mobilizes bone calcium, increases the phosphate wasting. And the net effect is low phosphate and normal to low calcium and high parathyroid hormone. And so our answer is indeed going to be B. All right, so here's the explanation. Here's kind of the mechanism that we more or less outlined. So low serum phosphate and a nice little kiddo here is nutritional rickets. You can see what it looks like over here on this side of the screen where my face is pointing. And you can expect an increased parathyroid hormone and decreased vitamin D. All right, our next question, we have a 45-year-old woman presenting to her primary care physician for a routine annual checkup. She's concerned about her bone health, as her older sister, who is 52 years old, was recently diagnosed with osteoporosis. The patient has no significant medical history and reports leading an active lifestyle, which includes jogging and yoga. She smokes occasionally in some social gatherings and drinks 2 glasses of wine weekly, BMI 22, takes no prescription medications, and relies on meals prepared at home. The patient asks what she can do to assess her risk of developing osteoporosis, which the following additional information would be helpful in evaluating her risk. Well, definitely calcium and vitamin D intake, right? Your dietary history. So the 2 most important factors, risk factors that is, for osteoporosis and calcium intake, or the 2 most important modifiable risk factors for osteoporosis are calcium intake and vitamin D status. Now, lifestyle matters, but without the adequate bone-building nutrition, the prevention is going to fail. All right, so here we just have to understand that osteoporosis is due to low bone mass and microarchitectural deterioration, and it's a fragility failure. So you have the peak bone mass in your late 20s, and there's a rate of bone loss after menopause, and that determines your lifetime risk. And the risk factors are going to be low calcium, vitamin D intake, smoking, alcohol excess, and low BMI, and a sedentary lifestyle and estrogen deficiency. And she exercises, she has a normal BMI, she drinks moderately, and so really the key missing piece is just her calcium and her vitamin D. All right, there's our brief explanation. And what's crazy is that most women actually don't reach their recommended calcium intake, and that is one of the biggest preventable causes of osteoporosis. So you got to watch out for that diet. Calcium and vitamin D are crucial for assessing osteoporosis risk in women, especially if they have a family history. Thank you guys so much for watching. Please like and subscribe if you found this helpful, and we'll see you guys in the next video. For our next question, an 8-year-old boy presents to the pediatric clinic with a 3-week history of fever and tender lump on his neck. His mother reports that he had been playing with the neighborhood kittens. On examination, there's a 1.5 by 1 centimeter tender erythematous lymph node in the right cervical legion. A small healing scratch with a papule is noted on his right forearm. Ultrasound of the neck shows a lymph node with central necrosis. Which of the following is the causative organism? All right, this is Bartonella henselae. This is caused by cat scratch disease. And this is a self-limited granulomatous infection in immunocompetent children. And usually this presents with regional lymphadenopathy. By the way, let me know if you guys like this layout. I did this because the feedback was you'd like to have the question in the middle. The way to think about this question is in a patient with lymphadenitis, which is just inflammation of the lymph nodes, and after just a minor trauma with a pet, especially little kittens, and with an ultrasound of central necrosis, then you should think of Bartonella. And so what happens here is he gets scratched, and so Bartonella then gets into the skin, and then you have a local multiplication that forms a papule or a pustule. at the scratch site, and then the organism travels to the regional lymph nodes, and that causes granulomatous inflammation. There's an immune response that leads to necrosis and supportation within the node, and that just means the formation and the discharge of the pus, right? That thick and whitish yellow fluid that has all the dead white cells that you hate, that. And so in immunocompromised patients, you can also get those vascular proliferating events because Bartonella actually infects the endothelial cells, right? And those are the cells that line your blood vessels. And so it releases the angiogenic factors, which basically tells your body, hey, let's make new blood vessels. Like the key ones are the VEGF, IL-1 beta, and other ones. And that causes vascular proliferation. So you get the abnormal growth of the small blood vessels. And they start to look like little red papules and nodules. And those can easily be confused with Kaposi sarcoma. But yep, this is just cat scratch disease, and so the answer is B. Okay, in our next question, we have a 3-day-old infant born to a mom with O-negative blood type and presents with lethargy, poor feeding, and high-pitched crying. On examination, the baby is jaundice and has hypotonia. A complete blood cell count shows anemia with hemoglobin level of 12 and elevated retic count. Total serum bilirubin is 28 with the predominance of unconjugated form. Despite phototherapy, the infant's condition deteriorates and MRI shows characteristic signal changes to the basal ganglia. Which of the following conditions is most likely responsible for these findings? So the big takeaway here is that a baby's brain can actually turn yellow. All right, so that's the little baby's brain, and it'll start to look like this. And the answer is hemolytic disease of the newborn. This is kernicterus, and this is a complication of untreated hyperbilirubinemia. So there's a kid, he's getting tired, he's got poor feeding, he's got a high-pitched crying sound, bilirubin toxicity, and the bilirubin level is like 28, right? So that's super crazy, dangerously high. And mom has an O-negative blood type, and so that's going to be a clue for us that there's a suspicion for Rh incompatibility. So if the baby is Rh positive, then there's going to be a maternal anti-D IgG that can cross the placenta and attacks the fetal red cells, and that triggers hemolysis. And that leads to an overload of unconjugated bilirubin. And that then deposits in the brain, especially in the basal ganglia, and that causes permanent damage, right? So phototherapy is not going to be enough at this level. You need an exchange transfusion, and the diagnosis is hemolytic disease of the newborn. All right, congenital adrenal hyperplasia, and that's going to be the the salt wasting, hypotension, and also here you'd see ambiguous genitalia, which we don't see here. Hereditary spherocytosis, first of all, they would probably show you the spherocytes on the smear, but also you'd have family history there. And this is just non-immune hemolysis. And what's happening in our condition is hemolytic disease of the newborn. What about neonatal sepsis? Well, that would be with fever, hypothermia, lethargy, poor feeding, but that does not explain the extreme unconjugated hyperbilirubinemia or the basal ganglion lesions. And toxo. So with toxo, you'd see like the hydrocephalus, chorioretinitis, intracranial calcifications, but there's no mention of any calcifications or any eye findings here. And so this is definitely going to be hemolytic disease of the newborn. And so the bottom line is elevated unconjugated bilirubin and neurological deterioration of a newborn suggests hemolytic disease of the newborn. So there you go. All right, in this question we have a 60-year-old man. He's got a history of alcohol use, abdominal pain, jaundice, and elevated bilirubin and liver enzymes. He's got dilated CBD and ERCP showing a stone in the biliary tree. Which structure is obstructed? All right, so here's what we're looking at. We got a gallbladder here, we got the bile duct and the pancreatic duct. There's the pancreas. And there, right there, is the ampulla of Vater, right there in our duodenum. And the structure is indeed going to be C. That's our correct answer. The correct answer is going to be C. And that's where the common bile duct and the main pancreatic duct are going to merge before they drain into the duodenum. All right, so why is it not A? That's proximal to the gallbladder, and that only affects the bile, not the pancreas. Why is it not B, the cystic duct? Will that be gallbladder drainage? That doesn't affect the bile outflow to the intestine, so you'd have no jaundice. What about the main pancreatic duct? Well, that's pancreatic secretion, right? So that would just cause pain, but you wouldn't see the jaundice. And the hepatopancreatic duct, that's usually like just a pretty vague and often just misused term, but it usually refers to the common bile duct near the ampulla, but this is definitely not as specific as C. All right, so there are the associations and the pathophysiology. The gallstone formation, it lodges in the ampulla. You get biliary stasis, jaundice, hepatocyte injury, elevated bilirubin, and liver enzymes. So the obstruction at our answer choices causes the jaundice and abdominal pain due to the biliary tree Stone. All right, in this question, we have a 19-year-old female grocery store clerk is stocking shelves when she accidentally pricks her finger with a box cutter. She notices that the bleeding stops almost immediately after applying light pressure. Which of the following mechanisms is primarily responsible for the rapid cessation of the bleeding immediately following the injury? Okay, so for this question, we have to talk about how the body stops the bleeding, and it all starts with vasoconstriction. That's the first reflex after the vessel injury. And so here we got a 19-year-old pricking his finger and the bleeding stops instantly, but that's like way too fast for the clotting factors or the platelets to act. And so what's actually happening is that there's damaged endothelial cells that release endothelin, and that's a potent vasoconstrictor. And that combined with the reflex nerve signals causes the vessels to spasm and also to narrow, and that then slows the blood. And so that gives the body some time to start building the platelets and the clots. But the initial bleeding is going to stop because of the vasoactive substances. And so that's why the answer is the local release. It's that immediate stoppage, which is the vascular spasm, the local secretion of endothelin. Here's the bottom line. Rapid cessation of bleeding post-injury is primarily due to the local release of vasoactive substances. All right, for this question, I just want to go over the pathophysiology of cystic fibrosis. You have 2 copies of mutated CFTR that's needed for the disease. Carrier patients. So we have a 3-year-old boy brought to the pediatrician due to chronic cough, failure to thrive, and frequent foul-smelling stools. Exam shows nasal polyps and digital clubbing. Sweat. Chloride testing reveals a value of 72. Genetic testing confirms we got that mutation of both alleles, which is the best explanation of the underlying defect caused by this mutation. It's going to be the abnormal post-translational folding and degradation by the proteasome. All right, so that CFTR refers to the cystic fibrosis transmembrane conductance regulator. And this is an ATP-gated chloride channel that's found in the epithelial cells, so like the lungs, the pancreas, the intestines, the vas deferens. And this kiddo's got the classic CF problems, right? They got the chronic cough, failure to thrive, nasal polyps, digital clubbing, positive sweat chloride tests, and they even confirm it genetically. And so they're asking, hey, what is the cellular consequence of this mutation? And that's the most common CF mutation. And it's a deletion of the phenylalanine in the position of 508. And so that causes the misfolding of the protein that causes the ER retention and then the degradation, at least the absence of the CFTR gene at the membrane. And that causes the thick mucus and the blocked ducts and the pulmonary infections and the pancreatic insufficiency, all of that stuff. So you have no chloride transport, so you get the thick secretions. And you confirm that with the sweat chloride test. All right, so here we have a 45-year-old man who goes to the dermatologist with complaints about an intensely itchy rash, predominantly affecting his elbows, knees, and lower back for the past 2 months. He reports he was diagnosed with iron deficiency anemia 6 months ago, and he has a history of gastrointestinal discomfort that improves with dietary changes. Physical exam reveals multiple excoriated papules and vesicles with crusting, primarily on the extensor surfaces of his extremities and lower back. No mucosal involvement is observed. Skin biopsy is performed, and direct immunofluorescence demonstrates granular IgA deposition on the tips of the dermal papillae. Which of the following is the most likely diagnosis? Okay, so we have the itchy elbows and the knees. And so here we should actually think about the gut. So he's got a rash that keeps him up at night. It's itchy, vesicular, and the extensor surfaces is where it's located. He also has iron deficiency anemia and other gut symptoms. And skin biopsy shows the IgA, the granular deposits there in the dermal papillae. That's going to be the signature finding of dermatitis hepatiformis. That's the skin manifestation of celiac disease. And so we just pick dermatitis herpetiformis and we move on. The answer is C. All right, there are a couple of trap answers here. Bullous pemphigoid would be the tense bulle in the elderly that have linear IgG along the basement membrane. Linear IgA bullous at the basement membrane. Well, that would be linear, not granular, and it lacks the celiac associations. Lichen planus is the pruritic papules. You see the Wickham striae there, so there's no vesicles or IgA findings, so that's not the answer. And then psoriasis would have the silvery scale ospit sign stuff. So wrong lesion type, wrong histology. All right, so there's the explanation. Basically, you get those immune complexes get formed at the cross-reactive IgA antibodies because you mistake the skin for the gluten targets. The body's stupid. And the bottom line is granular IgA deposition at the dermal papillae confirms dermatitis hepatiformis, often associated with gluten sensitivity. All right, here's the next practice question. We have a 3-year-old girl brought to the clinic by her parents due to concerns about skin sensitivity in the sun. They reported that her skin appears unusually pale and she's easily developing sunburns after minimal sun exposure. Upon examination, the child's hair is noted to be lightly blonde, almost white, and her eyes have strikingly light blue color. She's hesitant to open her eyes full and broad examination of lights, which of the following best explains the reason for her skin findings. This is definitely going to be a genetic defect. And I've already written out some of this pathway here that we got to know. We have to know about melanin biosynthesis, especially in the context of albinism, which this kid has. She's got the very fair skin, the white blonde hair, the silvery kind of hair. And she's got that sun sensitivity and the photophobia, the light sensitivity. That's due to the lack of the melanin in the iris and the retina. And so this is going to be a type 1 oculocutaneous albinism. And this is most commonly caused by a mutation in the tyrosinase gene, TYR. And so our answer is enzyme tyrosinase. Let's talk about these other answers. So the autoimmune destruction of melanocytes would be vitiligo. That's the localized depigmentation that's acquired patchy, and you would have normal eye and hair color. Disruption of the migration of melanocytes. That's in Waardenburg syndrome. So not it. Decreased number of malignant melanocytes. That'd be like a nevus, like a birthmark. And the melanin distributed to the dermis. Those would be the bluish patches in the infants, not the generalized hypopigmentation. And so what happens is you have a mutation here in this TYR gene. So you have defective tyrosinase. And so you can't convert the tyrosine to dopa to melanin. You just can't do it. So the melanocytes are present, but they just can't synthesize the pigment. And so the result is hypopigmentation of the skin, the hair, the iris, the retina. And so you get photosensitivity, increased risk of UV damaged DNA, and also some visual issues due to that absent melanin. And so that genetic defect causes albinism, leading to pale skin, light hair, and increased sun sensitivity. All right, last I want to talk about ARR. So here we have a 60-year-old female with hypertension, type 2 diabetes. Her medications are metformin, lisinopril. Study compares the new drug to the placebo. Placebo, 20% experienced MI, and the group receiving the new drug, 15% did. And so the absolute risk reduction is going to be 20 minus 15, so it's 5%. Yay. And really the one thing I wanted to let you know about this one is that if you do 1 over the ARR, then you get the number needed to treat. So there you go. It's that simple. Absolute risk reduction would be 20% minus the 15 equals 5. Hopefully you guys found this interesting and helpful. Now I'm going to create a song so you guys can listen to recap all the high yield information. And if you like this, then like and subscribe. We'll see you guys in the next video.
Yeah. Firm neck fatigue, she's feeling cold. Lymphocytes attack and thyroid's uncontrolled. Anti-TPO, hurtless cells on deck. Hypothyroid swag, keep that T4 in check. In autoimmune hypothyroidism, lymphoid infiltrate. Phagocytes eat but can't kill the staph. For the pH oxidize missing from the path. Catalase positive bugs stay alive and spread. Neutrophils work but ROS is dead. And the PF deficiency. CGD impaired ROS killing. Yeah. Girl got a note and a scratch on her hand. Axillary swelling she don't understand. Gram neck plume morphs under silver's glow. Bartonella in the blood let the fever flow. A leg cat scratch disease and necrotizing granulomatous lymphadenitis. Yeah. Mismatch bilirubin flying high. Unconjugated trouble basal ganglia cry. Exchange transfusion trying to clear that flame. But bilirubin bound got a deadly name. The hemolytic disease of reborn and conjugated bilirubin kernicterus. She got gallstones blocking ducts that meet at the ampulla of artery inflammation heat. Lipase elevated pain hits the back. ERCP for stones to get her on track. And gallstone at ampulla and acute pancreatitis. Yeah. ES preserved but the ventricle stiff. HTN made that myocardium thick. Yeah, S4 knocking, lungs got rails. Left heart failure with diastolic nick. The lip blood tries to spill, but adrenaline tightens up the drill. Vasoconstrictions first to act. Febrin comes later, that's a fact. Link immediate vasoconstriction post-injury. Endo then release yippee. Sibling got CF, so check your draw. Parents both carriers, that's the law. You ain't sick, so you ain't AI. Leaves 2/3 chance that you carry that flaw. Lame carrier risk, an unaffected sibling. When sibling has CF. Herpetiformis rhyme, I'm gluten flaring rash on that butt and knee. Papulas, vesicles, itchy as can be. Iga in dermal papillae stay. Treat with gluten free and dapsone spray. Late dermatitis, herpetiformis. Ike at dermal papillae. Sock with celiac.
Hey everybody, welcome back to these high-yield Step 1 questions. Be sure to like and subscribe if you find this is helpful. In this question, a 12-year-old girl is brought to the emergency department by her parents due to severe abdominal pain and vomiting that started 6 hours ago. She recently began treatment for non-Hodgkin's lymphoma. Physical exam reveals diffuse abdominal tenderness. Lab tests show elevated serum potassium level of 6.5 and a low serum calcium level of 7.2 and elevated serum creatinine of 2.2. An abdominal ultrasound indicates the presence of renal crystal deposits. Which of the following compounds most likely contributes to this renal pathology in this patient? All right, in order to answer this question, we have to understand what tumor lysis syndrome is. That's when massive numbers of tumor cells die super rapidly, typically after chemotherapy, in hematologic malignancies like non-Hodgkin lymphoma. And it spills their contents into the bloodstream. And this sudden flood overwhelms the body's homeostatic mechanisms, and it leads to a couple of things. The first one that you need to know is hyperkalemia. That's from the cell cytoplasm. Next is hyperphosphatemia. That's from the nucleic acids. Next is hypocalcemia, and that's due to the phosphate that binds to the calcium. And then there's hyperuricemia, and that's from the DNA breakdown. So that recent chemotherapy causes the rapid cell turnover, and then elevated potassium, low calcium, and elevated creatinine would be the electrocyte triad of tumor lysis syndrome. You get the renal crystal deposits on imaging, and non-Hodgkin's lymphoma means that there's a high tumor lysis risk. So uric acid is the byproduct of the nucleic acid metabolism. And at high concentrations and an acidic urine pH, it precipitates into the crystals and it damages the tubules. And so our answer of what's contributing to the renal pathology here is uric acid. So there's your bottom line. For our next question, and I know you just got a sneak peek there, but I'll show it again. A 30-year-old man presents with a 2-week history of increasingly bizarre behavior. He has been speaking about receiving secret messages through the radio. He's been neglecting personal hygiene, and he has stopped showing up to work. His medical history is significant for multiple psychiatric hospitalizations. First occurring when he was 22. He's unkempt, poor eye contact, speech is scant, and he says they might be listening. Which of the following is the diagnosis? This is pretty clearly going to be schizophrenia. And so the diagnosis for schizophrenia must include greater than 6 months duration. That's greater than or equal to 6 months duration, greater than or equal to 1 month of active phase symptoms. That's like delusions, hallucinations, disorganized speech, and negative symptoms. Also the functional decline. And the negative symptoms are more disabling and they're harder to treat than the positive symptoms. And the risk factors are family history, early cannabis use, and obstetric complications. The negative symptoms would be like restricted affect and scant speech, and then also the functional decline. And all of this meets the DSM-5's criteria for schizophrenia. It's not major depressive disorder with psychotic features because that's mood congruent delusions or hallucinations. Here, the psychosis isn't confined to periods of depression, so that's not the answer. Schizoaffective disorder, that'd be like psychotic symptoms and a mood episode, so that requires a concurrent mood episode of mania or depression with at least 2 weeks of psychosis without mood symptoms, and that's not demonstrated here. Definitely not OCD, there's just no evidence for that. That's intrusive ego-dystonic thoughts. And also compulsions. And this patient has fixed delusions. They're not obsessions or compulsions. There's no compulsive behaviors that are being described here. And paranoid personality disorder involves the pervasive distrust without psychosis. So that's not going to be it. The bottom line is schizophrenia is characterized by delusions, disorganized behavior, and negative symptoms persisting for at least 6 months. If you like this new format, please let me know by liking and subscribing. I'm always trying to improve. For the next practice question, during a research study, investigators observed that a certain virus has developed the capability to escape immune recognition by interfering with the host's antigen presentation system. Specifically, this virus downregulates the expression of class 1 MHC molecules on the surface of infected cells. A second variant of this virus, which lacks the ability to interfere with the MHC class 1 expression, is also studied. Which of the following components of the immune system is most likely to play a heightened role in combating the original virus rather than the variant virus? And you can see the answer is natural killer cells. Let's talk about why. So there are some viruses that actually shut down the MHC class 1 expression. They're trying to hide from the immune system. And normally CD8 positive cytotoxic T cells will patrol the infected cells by scanning for their MHC1 display. And if that display disappears, then we could have some problems, right? So the natural killer cells are the immune system's weapon when the viruses are trying to be really sneaky. So natural killer cells, these NKCs, are wired to do the opposite of CD8 positive T cells. They look for what is missing, not what is present. And so if you don't have an MHC1, then that's a red flag. And so they activate and release perforin and the granzyme B, and they kill the infected cell on the spot. And so in this question, the virus that downregulates the MHC can get away from the CD8 positive T cells, but not away from the natural killer cells. And that's why the immune component plays a heightened role against the original virus, and it's going to be natural killer cells. Okay, now why is it not the lymphocytes? Well, that would be like antibody production, right? The B cells target extracellular pathogens. They do not clear MHC1 deficient infected cells. What about CD4 positive T cells? Well, those would be MHC class 2 recognition cells. And remember, the 4 times 2 is equal to 8, and they always have to add up or multiply it to be 8. That's why 1 times the CD8 positives and the MHC class 2s line up with the CD4 positives. It's not macrophages because that'd be phagocytosis, and those guys target the opsonized extracellular pathogens, not the intracellular viruses. And it's not neutrophils because that would be like bacterial infections and pus, and that's not involved in viral clearance. So the big takeaway here is that natural killer cells are super important for targeting virus-infected cells with downregulated MHC class 1 expression. The CD8 positive T lymphocytes induce apoptosis in cells that express class 1 MHC. And natural killers, they kill the guys that do not express class 1 MHC on the surface. Okay, in our next question, we have a 55-year-old woman presenting to her primary care physician, complaining of weakness in her right arm. She sustained a Coles fracture of her right wrist in a car accident 3 months ago. Then she had a cast, and when they removed it, she noticed her right forearm is significantly smaller than her left. Exam shows a 3 centimeter decrease in the circumference of the right forearm compared to the left, and decreased strength in the right hand. There is no tenderness, and sensory examination is normal. Which of the following is the most likely mechanism responsible for the observed difference in the muscle mass? Now, intuitively, we know that it's going to be smaller, right? And interestingly, you can lose up to 5% of your muscle mass per day during immobilization. So if you don't use it, then you lose it. So she has some problems with her forearm muscle loss after the cast was applied through a fracture. 3 months later, now her grip is super weak, but the sensation and the nerve function is totally intact. And so it's not a nerve injury. This is just diffuse atrophy. So when a muscle isn't used, the body shuts down the protein synthesis and it ramps up the protein breakdown using the ubiquitin proteasome system. And so that shrinks the muscle because it's no longer needed. And so the correct answer here is going to be the acceleration of the protein breakdown. That's our correct answer. Diminished acetylcholine release, that would be seen with something like myasthenia gravis. That would cause weakness, not atrophy with sensory loss or immobilization. What about increased expression of anabolic signaling? Well, that's like mTOR or IGF-1. That would promote hypertrophy, not shrinkage. What about inhibition of calcium reuptake into the sarcoplasmic reticulum? That's more like the circa pump and the prolonged contraction. So that would affect the contraction dynamics, but not really the long-term muscle size. What about enhanced production of the connective tissue factors? Well, that would lead to fibrosis, and that would cause stiffness and scarring, but not muscle mass reduction. So the bottom line here is diffuse atrophy from immobilization leads to decreased muscle mass and strength after the wrist fracture. In our next question, a 72-year-old man presents with shortness of breath and chest discomfort for the past month. He has a history of chronic obstructive pulmonary disease and hypertension. Physical exam reveals absent breath sounds on the right lower lung field and jugular venous distension. Lab tests show mild leukocytosis. A CT scan of the chest reveals a large mass in the right hemithorax invading the mediastinum and causing compression of adjacent structures. The mass appears to extend to the diaphragmatic surface of the right pleura. Which of the following structures is most likely affected due to the mass's location? All right, so this is going to be like an anatomy kind of pathology question. And you've got a right-sided thoracic mass, right, which is right here. You have mediastinal invasion and a diaphragmatic pleural involvement. So now we have to identify the structure that's vulnerable here. And the answer is the right phrenic nerve. And that travels anterior to the hilum of the right lung, and it courses alongside the right heart border. And it passes over the right pericardium, and it ends at the diaphragmatic surface of the pleura. And so a mass on the right lower hemithorax extending to the diaphragm and the mediastinum is in the perfect position to compress the right phrenic nerve. Now, the right phrenic nerve has its origin from the C3 to C5, the cervical plexus, and is the motor for the diaphragm. 3, 4, 5 keeps the diaphragm alive. Also, sensory, you have the central diaphragm, mediastinal pleura, and the pericardium, and it runs anterior to the hilum, unlike the vagus, which is posterior to the hilum. The mass effects are, for the phrenic, it would be associated with diaphragmatic paralysis. You could see recurrent laryngeal problems like hoarseness. The azygos would have venous congestion, and the thoracic duct would be chylothorax. That'd be a left-sided issue, though. So the mass is on the right. It's compressing the mediastinum and the diaphragm, and so it's just going to be that phrenic nerve. Now, why is it not the left recurrent? That'd be vocal cord paralysis. What about the azygos? That's the posterior mediastinum. This mass is anterior and lateral. What about the thoracic duct? Well, that would be chylothorax and left-sided structures, because the thoracic duct ascends on the left side. It's not near the right lower lung. What about the esophagus? There you'd have dysphagia and posterior mediastinum problems. So you get a big old bulky tumor on the right side of your lower chest, and it presses against the mediastinum, the diaphragm. And by the way, the mediastinum is just that membranous partition between the two body cavities and the parts of the organ, especially between the lungs. And so what gets caught in the crossfire is that right phrenic nerve. It controls the right half of the diaphragm. And if you compress it, you get dyspnea, especially when you're lying flat, and especially if this patient who has underlying COPD. So the bottom line is you have a mass in the right hemithorax that is likely going to compress the right phrenic nerve, causing a diaphragmatic dysfunction. All right, here's a good high-yield practice question. A 55-year-old man comes to the clinic with a 3-week history of low-grade fever, fatigue, and unintentional weight loss. He recently underwent a dental cleaning, and he has a history of mitral valve prolapse. So this right here should already be cueing us in to our condition. It's subacute bacterial endocarditis. So don't be spooked by all these weird names. Basically, we have a heart murmur and a recent dental procedure, and then we get fatigue and we get fever and weight loss. And this is subacute bacterial endocarditis, and it's caused by that slow growing bug from the mouth. So it's going to be Viridans group Streptococci. And so those bugs, they really love hanging around the damaged valves. And in this case, it's going to be the Streptococcus sanguinis. That's the alpha hemolytic optochin resistant, commonly found in the dental plaque. And so anytime you have a dental cleaning, mitral valve prolapse, that should immediately cue you into Viridans strep. It's optochin resistant alpha hemolytic gram-positive coccus. Now, there are a lot of kind of freaky options here, but we can break them down one by one. A, that's associated with like GU instrumentation. It's a nosocomial infection, and that's not associated with dental procedures. Epidermitis, that'd be with prosthetic valves and catheters. Streptococcus pyogenes, that's a group A strep. You'd have pharyngitis and impetigo. And A. galactiae would be the group B strep, and that's neonatal sepsis. So it's really mitral valve prolapse gives it away. It's going to be D. It's the one by elimination you can tell that that's the Viridans one. Subacute bacterial endocarditis, the Viridans strep. So the bottom line is optochin-resistant alpha hemolytic gram-positive cocci in a patient with mitral valve prolapse suggests infective endocarditis by Streptococcus sanguinis. There we go. Okay, in this question, a 29-year-old woman visits the clinic to discuss her options for contraception. She plans to pursue a high-stress career and is not considering children for at least another decade. Relatable. Her medical history is unremarkable and she has no known allergies. Her priority is a highly effective contraceptive method that requires minimal maintenance. After discussing the potential side effects of various methods, she is concerned about long-term impact of her fertility. Which of the following contraceptive methods has the greatest association with a potential delay in return to fertility after discontinuation? The answer, progestin-only injection. So that is a DMPA, is a progestin-only injection, and that provides long-term, highly effective contraception with minimal use effort. So it's super ideal for somebody like her. It's not recommended for those who are concerned about delayed return to fertility, though, because ovulation can take a couple of months to resume after discontinuation, and that's a known side effect that's not shared by IUDs or rings or barrier methods. All right, why is it not a male condom? Well, that's just a barrier method. There are no hormones involved there, obviously. So the fertility is actually unaffected there. What about the copper device, your IUD? So that's going to be a long-acting, non-hormonal treatment. And so fertility will return immediately after removal. C is our correct answer. Vaginal contraceptive ring. So that would be hormonal and reversible. Fertility would resume super rapidly after stopping that use. So that's why that's not the right answer. And fertility awareness methods, that does not suppress ovulation, right? So that's not it. She wants long-term contraception, and most options like IUD, vaginal ring, or even the barrier methods allow immediate return of fertility once it's stopped. And the one that's different is the progestin-only depot injection. That can cause delayed ovulation for up to 18 months after the last shot. And so this is asking, hey, what's the greatest delay in return to fertility? And the answer is going to be progestin-only injection. So the bottom line is progestin-only injection is associated with the greatest delay in return to fertility after discontinuation. And our next question, a 32-year-old woman visits the dermatology clinic with a persistent skin condition on her elbows and knees. On examination, there are well-demarcated erythematous plaques with adherent silvery scales. The patient mentions that her symptoms improve during the summer months as she spends more time outdoors. As part of her treatment plan, the dermatologist prescribes topical ointment along with advice to increase certain dietary components that might aid in the treatment. The effectiveness of this treatment suggests a biological role for which of the following vitamins in modulating keratinocyte activity and immune responses. So if your psoriasis gets better in the summer, then the reason is because you're making vitamin D. Here, there's a 32-year-old woman who has classic plaque psoriasis. It's thick, scaly plaques on the elbows and also the knees that improve with sunlight. And that's because of the UVB exposure that helps your skin produce vitamin D. And that in turn slows down the keratinocytes' overgrowth and it calms the immune system. So vitamin D is not just like a bone vitamin, right? It's a key immune modulator. So let's walk through why these answer choices are incorrect. So vitamin A for step 1, you should be thinking about acne and retinoid therapy because that can regulate skin turnover, but it's more associated with acne and epithelial stuff. B12, cobalamin, that's associated with megaloblastic anemia and neurologic symptoms. It's not involved in keratinocyte proliferation and immune suppression. Folic acid is involved in cell division and DNA synthesis. It's crucial in pregnancy and hematopoiesis, but it's not used in psoriasis therapy. And biotin, for step 1, you should think of the hair and the skin and the nails. And there's not any like autoimmune or keratinocyte regulation association there. So the bottom line here is psoriasis treatment highlights vitamin D's role in modulating keratinocyte activity and immune response. All right, in this question, we have a 24-year-old man of Korean descent presents to his university health clinic with complaints of palpitations and sweating after consuming a mixed drink at his parents' or at his friend's party, his parents' party. He reports that a similar symptom has occurred in the past after drinking alcohol, along with episodes of facial redness. Family history reveals his father experiences flushing as well. Which of the following enzymes is most likely associated with his symptoms? And before I show you all of these answers, I want to give you kind of the lay of the land here and try to answer this for yourself. So this Asian descent, this is Asian alcohol flushing syndrome, and this is involved in a genetic polymorphism that's common in East Asian populations. So Korean, Japanese, and Chinese predominantly. And the key metabolic pathway to understand is the ethanol metabolism, right? And so what we need to know is that ethanol turns into acetaldehyde via alcohol dehydrogenase. And then acetaldehyde turns into acetate via aldehyde dehydrogenase, which we call ALDH2. And when that is deficient or inactive, acetaldehyde builds up and it causes an unpleasant symptom shortly after alcohol ingestion. So flushing, palpitations, sweating, nausea, and headache, that kind of stuff. And so the facial redness, the flushing, the palpitations, the sweating after drinking alcohol, and especially in somebody of Korean descent with a family history of the same symptoms, all that leads us to think that there's some autosomal dominant inheritance pattern of ALDH2 variant of alcohol dehydrogenase, right? Because acetaldehyde is toxic. It's a toxic intermediate, and it causes vasodilation and also sympathetic activation. And so if somebody has East Asian descent, then up to 50% will carry that inactive ALDH2 allele. And so that's why our answer is D. So again, the pathophysiology is you drink alcohol, it turns into acetaldehyde or acetaldehyde. Then acetaldehyde via alcohol dehydrogenase is now just chilling, and then we can turn that into acetate via aldehyde dehydrogenase. But we have this deficiency in this patient, and so acetaldehyde accumulates, and that will trigger vasodilation, which is the flushing that you see. Geez, these words are like tongue twisters sometimes. But it's the flushing after the small alcohol doses in East Asians, and it's that ALDH2 deficiency, the facial redness, the tachycardia, the nausea, the dizziness. It's the failure to convert acetaldehyde into that harmless acetate. Now let's look at these quickly. Acetyl-CoA carboxylase, that's involved in the fatty acid synthesis, so it's unrelated to alcohol flushing. Succinate dehydrogenase, that's involved in the TCA cycle, complex 2 as well. So it's not involved in alcohol or aldehyde metabolism, so that's not the answer. Alcohol dehydrogenase, that converts ethanol to acetaldehyde, and that enzyme is intact. It's just the downstream with the acetaldehyde clearance. And xanthine oxidase, that's going to be in uric acid production and gout. That's unrelated to the alcohol flushing and acetaldehyde buildup. So the bottom line here is that the alcohol flush reaction in Asians is often due to a deficient aldehyde dehydrogenase, leading to acetaldehyde accumulation. Hopefully you guys have enjoyed this video. If you have, please like and subscribe. More videos come out every single day. We've made over 860 videos. Stay tuned for a song that recapitulates all this information, and hopefully you guys have a great rest of your day. Take care of yourselves during dedicated period, and enjoy this song.
Yeah. A 10-year-old kid, chemo's on the scene. Wakes up in pain, uric acid's mean. Tumor lysis popping, pouring this breakdown. Kidney gets wrecked, crystals come round. The xanthinoxidosis makes that acid rise. Watch out for gout and nephro that fries. Raspberry Kaizen, drop the uric fast. TLS management, built the last asthma. 27 paranoid, won't leave the pad. Flat effect delusions is bad. Auditory vibes, hearing ghost talk. She's deep in psychosis, can't even walk. That positive and negative both in play. Chronic and strange, schizo all the way. Not just sad, not borderline mad. It's dopamine gone wild, brain gone bad.
Virus gets slick, drops MACI. Trying to hide from T cells, oh my. But natural killers don't need the code. If MHC low, they ready to explode. CD16 binds that opsonized game. Perforin, granzyme, apoptotic flame. Innate on the rise, mutant can't hide. Parental strain, better run or die.
Tendon rupture, gas stays tight. 6 months later, calf ain't right. The Zeus kicks in, muscle breaks down. Protein degradation takes the crown. Head tumor pushing near the heart wall. Right atrium pressure, breathing stall. CT shows it's taking space. Who runs here? The phrenic sets the pace. C35, keep you alive. Diaphragm's buddy, takes a dive. Forget the Vegas, forget the duck. Phrenic nerves, the one that's stuck.
Yeah. Root canal done now, fever's high. Blowing murmur, bugs nearby. Alpha hemolysis, opto can resist that strep mitis. Can't be missed, the Rufferinks native, now gone rogue. Damaged mitral valve, ascending cardio code. Post-dental, Midas, it's sly. Evidence crew makes that valve cry. 29, the career in mind. Once no kids got time to find. Low maintenance vibe, birth control queen. But ILE might mess the scene. Long acting, but may delay. Fertility bounce back, not the same day. Still safe and fine for most to choose. Just be aware before you cruise. Yeah.
Black switch scale on knees and arms. Sunlight helps UV charms. Doctor says rub this D cream. Calcipotriene joins the team. Vitamin D binds nuclear code. Immune mod down, symptoms slow. Keratinocytes take the cue. Vessel 23, flare-ups few. Yeah.
Wedding toast, champagne sip. Face turns red, heart starts to flip. East Asian roots, it's in the gene. AODH2 ain't keeping clean. I start to hide, builds up tight. Flush fast heart, not a pretty sight. Histamine dump, mast cell scream. Interferons mimic alcohol meme.
Hello, everybody. For the next 10 questions, we're going to do something very different. I actually went through and recorded this for 30 minutes, but I realized that the record button was not on. So I'm going to blitz through the next 10 and explain the most high yield breakdown for each one. Our first question, we have a 60-year-old woman presenting to the clinic with progressive fatigue and weight loss. She's smoking a lot, 136/85, decreased breath sounds, and dullness to percussion of the right upper chest. She's got those engorged veins and the swelling above the clavicles. That tells us that it's a superior vena cava thing. And indeed, the answer is E. So this is SVC syndrome. Swelling, hoarseness, and dilated neck veins would be seen here. And there's a mass effect. It's not the right lung apex. That'd be the pancostemur. It's not the right mainstem bronchus. That'd be the atelectasis. And the left would not be on the right side, so it's not C. And the pulmonary trunk would cause pulmonary hypertension. All right, so those are the notes that I took on it the first time I did it, but now we're going to move on. Oh, last thing, chronic smoking, the mass grows in the SMA, or rather the mass grows and then it compresses the SVC, leads to JVD. And JVD is a distinguishing factor there. All right, these are the notes that I took on this next question. Here we have a guy, he's got recurrent episodes of quadrant pain, right upper quadrant pain after meals. He denies any nausea. He's doing okay. He takes metformin and a statin, and he doesn't have any rebound tenderness. What medication are you going to give him? He's just got gallstones. That's what this dude is suffering from. And so we're just going to give him some medication that just helps him out a little bit. because he doesn't want to do a cholecystectomy. You don't want to do this because it'll increase the bile acid. You don't want to give a medication that inhibits gastric acid secretion. That's like a PPI or a Prazole. He has uncomplicated symptomatic cholelithiasis. And so the next best step is ursodeoxycholic acid, and it reduces the cholesterol content. So it just makes them into little weak stones, super non-invasive. So it doesn't require any surgery. So that's why it's good for this guy. Yes, this A would worsen it. B, bile acid sequestrant. That would also worsen it by increasing cholesterol synthesis. PPIs don't have any role here, and increasing the pancreatic enzyme secretion is used for like cystic fibrosis or chronic pancreatitis. So these are the notes that I took on it, and now we'll move on to the next one. So here we got a dude, and he's got the world's most normal physical exam findings ever, and they're just asking you, hey, what's the area of cardiac conduction system that is responsible for the longest delay in the electrical propagation in this patient? And the answer is the atrioventricular node. Okay, so the AV is going to be the slowest, and there's that big pause before it goes into the left ventricle and does its big pumpy thing, because you have to squeeze every last drop of blood from the atrium into the left ventricle, and the AV has the slowest conduction and the longest delay before you go through the heart. All right, it's not the left anterior fascicle. That's not the delay, not the Purkinje. Those guys are super fast. The SA initiates the impulse, and the left bundle branch conducts very quickly. So the AV is going to be the slower one. And you got to know there's like a big pause there. All right, so for this one, I did a deep dive on the last video, which did not get saved. But we have a 14-year-old male, and he has some difficulty walking, and he's got like some neurological problems. And it's interesting because all they give us is like his cholesterol, and they're like, hey, what's deficient? And so you have to know that it's ApoB. And the reason is because he has an MTP defect that prevents him from making the ApoB 48s and the 100s. That means that you don't get the chylomicrons that you need. You get the low plasma lipid levels, and you get vitamin E deficiencies, because ApoB is super important for you to do those fat-soluble vitamin absorptions. And if you don't have it, then you have retinitis pigmentosa, which is vitamin A, and also you get the vitamin E problems. And so these A ones, like A1 and A2, those are going to relate to HDL, and A1 activates the LCAP metabolism with a high HDL metabolism. The ApoC activates lipoprotein lipase, so kind of different, and it would not cause hypocholesterolemia, and ApoE would not lead to malabsorption. All right, so here are the notes that I took on this, but basically you can't make the chylos or the VLDLs or the LDLs if you have an ApoB deficiency, because that 48 and also that 100 defect, and so he's got a beta lipoproteinemia, and that's why he has the ataxia. The reason he has the ataxia is because of that vitamin E deficiency. Again, I'm blitzing through all these because I already did all these questions beforehand. So here a 14-year-old male is presenting because he's complaining about walking and falling over. He's been struggling academically. He's got a wide-based gait. Oh, this is the same question. It's just ApoB. That's the retinitis pigmentosa stuff is the vitamin A deficiency. Okay, this one is super duper simple. It's just incidence versus prevalence. And so you just have to know that incidence is going to be 20 new cases of obesity per 1,000 patients that occurred during the 1-year time period. The only thing that's hard about this one is realizing that if they give you 5 years time, then you have to divide by 5. And that's pretty much all there is to it. Okay, so new cases, incidence numerator, total population over the past year, and then the qualifying factors. New cases, incidence. All right, super easy. Now this one is very important because the biggest things that you have to note here are the fever and the white blood cells and the flank pain. All of those things should tell you that this is pyelonephritis, and that is ascending. That's an ascending problem, ascension of the bacterial infection. So the answer is C, because this is pyelonephritis, because the white blood cell casts are there, and there's fever and flank pain. The translocation of the enteric bacteria has nothing to do with this. That's bacteria in the intestinal mucosa. Immune complex stuff would be post-streptococcal glomerulonephritis, not pyelonephritis, and that's hematuria, so that's not seen here. And the bloodborne spread of the infection, a rare cause of pyelonephritis. And the fetal compression of the vasculature would cause hydronephrosis. Next question, we have a woman who has ALS, and she has some like upper motor neuron signs, and they're going to ask, hey, what are you going to give her? You're going to give her a GABA B receptor. That's just going to be the first line therapy for ALS. And MDA is targeted by riluzole, slows the ALS progression by inhibiting glutamate. Alpha-2 adrenergic receptor is the target of tizanidine. The dopamine D2 receptor is targeted in movement disorders like Parkinson's, and the serotonin stuff, that's like ondansetron, so that's the antiemetics. Okay, the next question, a 32-year-old woman at 34 weeks gestation comes to the clinic, routine checkup. She's got no issues with her pregnancy except for the little baby does a little ultrasound, and you see there's a fluid-filled sac even though the testes have descended. Okay, so we know that this is not cryptorchidism because the testes have actually gone into the scrotum, but they have not closed. And so that's the patent ductus. It's the patent processus vaginalis. And so it's the deficient obliteration of the processus vaginalis is what's caused that opening there. Here's a really good picture so you can kind of see this descends and embryology. The peritoneum kind of descends and it goes from the abdomen down into this scrotal space. And if that does not close, then you get that fluid there. But it's benign and it'll usually go away with time. This is crazy to say, testicular torsion, because that would be like, blockage of blood flow, much more acute and severe. And these other ones just don't talk about the issue, the failure of the urachus to close. That'd be like if you're peeing out your umbilicus. And so that's why the answer is B for this one. All right, this next one's pretty easy as well. It's a 67-year-old man who's got a history of hypertension and diabetes, a routine checkup, no problemos. And by the way, these are the notes on the last ones. And here is our guy. He's got some light brown pigments. They're just asking, hey, what is this? It's not hemochromatosis because that stains blue with the Prussian blue. And so this is indeed going to be lipofuscin. And basically what happens is as your cells age, they kind of start to break down. And you can see in the hepatocytes, the cardiomyocytes, and the elderly, and it's not harmful, and it just does not stain like iron. Melanin would be the black and brown stuff. Calcium is chalky white, so not a cavere there, nothing to see there. Amyloid would be the pale apple green bifringent Congo red stuff when it's displayed in a polarized light. So it's not the brown stuff. The brown is just benign. You're getting older, you're getting damage. All right, this next question is just a 50-year-old man presenting to the clinic because he's got some unexplained weight gain, and they also tell you that he has Urethral cells. Yeah, here it is. And so that just tells you immediately that it's Hashimoto's. Very nice of them to give you that. Just very textbook Hashimoto's. Essentially, he's got cold intolerance. Subacute is going to be painful, follicular, would not have the Urethral cells and no lymphocytes. And anaplastic thyroid carcinoma is aggressive in elderly patients, and acute bacterial thyroiditis would cause fever and pain. And that brings us back to the present, where I noticed that this recording was not working. And as you can see, the bottom line here is that elevated TSH and low free T4 and lymphocytic infiltrate confirm chronic autoimmune Hashimoto thyroiditis. All right, folks, we did it. That was 30 minutes of recording that I've just consolidated down into just like 5 minutes or so. It takes a lot of time to make these questions and find the resources and find the best ways to explain them to you. So if you are benefiting from this, then please be sure to like and subscribe so we can grow this channel. And I'm going to make a quick song as well so you can listen to. And we'll see you guys in the next video.
Right up below, mass, yo, it ain't no joke. Smoker with hoarseness, that airways broke. Try tears shifting, percussion's dull. Post-obstructive pneumo lungs ain't full. Risk tobacco, radon, fam 2. Right bronchus blocked, now what you gonna do? Right up below, with suspect cancer. Hoarseness, recurrent laryngeal nerve. Dull percussion and fromotes consolidation. Post-fat meal, pain in the rook, stones chilling in the gall without chola duck flu. No cut, cool, dissolve that rock, give her sodio, let the bile unlock. No surgery or sododoxycholic acid, mechanism cholesterol and bile. Stones but no cholecystitis, watch and wait. ECG clean, but what's taking time? PRR's still 60, that's rhythm in line. AV no slowing, so the atria can squeeze, filling them ventricles with absolute ease. AV node longest delay allows ventricular preload. PR interval atrial to ventricle. Aphylexia pigmentosa in the eye, spiny RBCs got you wondering why. Low cholesterol, MCPs, the gene of Paul B's gone, fat malabsorption seen. Paul B absent to deadly povertiniac. Facts hit hard, do the math fast. 50 new cases in a 2,500 cast. Divide, multiply, incidence in sight. 20 per thousand, epidemiology's tight. Incidence new, total Paventage in years. Don't confuse with prevalence. Fevers, flank pain, 34 weeks in. Progesterone's chilling, ureters can't win. Urine's backing up, WBC casserole. Multiply by 1,000 patient years. Don't confuse with prevalence. Fevers, flank pain, 34 weeks in. Progesterone's chilling, ureters can't win. Urine's backing up, WBC casserole. And GABA B agonist used for Emerson Bay and a spasticity. Hyperpolarizes motor neurons. Ultrasound drops. What's that fluid sac? Test is descended, but fluid got back. Patent PD, that's process cyst left wide. Perinal juice in the scrotal tide. Drosocilus patent processes vaginalis. Test is present, fluid's benign. Usually resolves on its own. Heart's looking small, brown in the shade. Iron stains neg, but age never fades. Lipofuscin's the pigment wear and tear grind found in old folks. Perina clear fine. Lipofuscin edging pigment, not iron. Found in heart, liver, brain. Fatigue, dry skin, cold all day. Got her with limps and hurtless slay. Anti-TPO got the gland in flames. Hashimoto's taking thyroid out the game. Ultrasound and processes vaginalis. Test is present, fluid benign. Usually resolves on its own. Heart's looking small, brown in the shade. Iron stains neck, but age never fades. Lipofuscin's the pigment wear and tear grind found in old folks. Perina clear find.
For our next question, an 8-year-old boy presents to the pediatric clinic with a 3-week history of fever and tender lump on his neck. His mother reports that he had been playing with the neighborhood kittens. On examination, there's a 1.5 by 1 centimeter tender erythematous lymph node in the right cervical lesion. A small healing scratch with a papule is noted on his right forearm. Ultrasound of the neck shows a lymph node with central necrosis. Which of the following is the causative organism? All right, this is Bartonella henselae. This is caused by cat scratch disease. And this is a self-limited granulomatous infection in immunocompetent children. And usually this presents with regional lymphadenopathy. By the way, let me know if you guys like this layout. I did this because the feedback was you'd like to have the question in the middle. The way to think about this question is in a patient with lymphadenitis, which is just inflammation of the lymph nodes, and after just a minor trauma with a pet, especially little kittens, and with an ultrasound of central necrosis, then you should think of Bartonella. And so what happens here is he gets scratched, and so Bartonella then gets into the skin, and then you have a local multiplication that forms a papule or a pustule at the scratch site, and then the organism travels to the regional lymph nodes, and that causes granulomatous inflammation. There's an immune response that leads to necrosis and supportation within the node, and that just means the formation and the discharge of the pus, right? That thick and whitish yellow fluid that has all the dead white cells that you hate, that. And so in immunocompromised patients, you can also get those vascular proliferating events because Bartonella actually infects the endothelial cells, right? And those are the cells that line your blood vessels. And so it releases the angiogenic factors, which basically tells your body, hey, let's make new blood vessels. Like the key ones are the VEGF, IL-1 beta, and other ones. And that causes vascular proliferation. So you get the abnormal growth of the small blood vessels. And they start to look like little red papules and nodules. And those can easily be confused with Kaposi sarcoma. But yep, this is just cat scratch disease, and so the answer is B. Okay, in our next question, we have a 3-day-old infant born to a mom with O-negative blood type and presents with lethargy, poor feeding, and high-pitched crying. On examination, the baby is jaundiced and has hypotonia. A complete blood cell count shows anemia with hemoglobin level of 12 and elevated retic count. Total serum bilirubin is 28 with the predominance of unconjugated form. Despite phototherapy, the infant's condition deteriorates and MRI shows characteristic signal changes to the basal ganglia. Which of the following conditions is most likely responsible for these findings? So the big takeaway here is that a baby's brain can actually turn yellow. All right, so that's the little baby's brain, and it'll start to look like this. And the answer is hemolytic disease of the newborn. This is kernicterus, and this is a complication of untreated hyperbilirubinemia. So there's a kid, he's getting tired, he's got poor feeding, he's got a high-pitched crying sound, bilirubin toxicity, and the bilirubin level is like 28, right? So that's super crazy, dangerously high. And mom has an O-negative blood type, and so that's going to be a clue for us that there's a suspicion for Rh incompatibility. So if the baby is Rh positive, then there's going to be a maternal anti-D IgG that can cross the placenta and attacks the fetal red cells, and that triggers hemolysis. And that leads to an overload of unconjugated bilirubin. And that then deposits in the brain, especially in the basal ganglia, and that causes permanent damage, right? So phototherapy is not going to be enough at this level. You need an exchange transfusion, and the diagnosis is hemolytic disease of the newborn. All right, congenital adrenal hyperplasia, and that's going to be the salt wasting, hypotension, and also here you'd see ambiguous genitalia, which we don't see here. Hereditary spherocytosis, first of all, they would probably show you the spherocytes on the smear, but also you'd have family history there. And this is just non-immune hemolysis. And what's happening in our condition is hemolytic disease of the newborn. What about neonatal sepsis? Well, that would be with fever, hypothermia, lethargy, poor feeding. But that does not explain the extreme unconjugated hyperbilirubinemia or the basal ganglion lesions. And toxo. So with toxa, you'd see like the hydrocephalus, chorioretinitis, intracranial calcifications, but there's no mention of any calcifications or any eye findings here. And so this is definitely going to be hemolytic disease of the newborn. And so the bottom line is elevated unconjugated bilirubin and neurological deterioration of a newborn suggests hemolytic disease of the newborn. So there you go. All right. In this question, we have a 60-year-old man. He's got a history of alcohol use, abdominal pain, jaundice, and elevated bilirubin and liver enzymes. He's got dilated CBD and ERCP showing a stone in the biliary tree. Which structure is obstructed? All right, so here's what we're looking at. We've got a gallbladder here. We've got the bile duct and the pancreatic duct. There's the pancreas. And there, right there, is the ampulla of Vater. Right there in our duodenum. And the structure is indeed going to be C. That's our correct answer. The correct answer is going to be C. And that's where the common bile duct and the main pancreatic duct are going to merge before they drain into the duodenum. All right, so why is it not A? That's proximal to the gallbladder, and that only affects the bile, not the pancreas. Why is it not B, the cystic duct? Will that be gallbladder drainage? That doesn't affect the bile outflow to the intestine, so you'd have no jaundice. What about the main pancreatic duct? Well, that's pancreatic secretion, right? So that would just cause pain, but you wouldn't see the jaundice. And the hepatopancreatic duct, that's usually like just a pretty vague and often just misused term, but it usually refers to the common bile duct near the ampulla, but this is definitely not as specific as C. All right, so there are the associations and the pathophysiology. The gallstone formation, it lodges in the ampulla. You get biliary stasis, jaundice, hepatocyte injury, elevated bilirubin, and liver enzymes. So the obstruction at our answer choices causes the jaundice and abdominal pain due to the biliary tree stone. All right, in this question, we have a 19-year-old female grocery store clerk is stocking shelves when she accidentally pricks her finger with a box cutter. She notices that the bleeding stops almost immediately after applying light pressure. Which of the following mechanisms is primarily responsible for the rapid cessation of the bleeding immediately following the injury? Okay, so for this question, we have to talk about how the body stops the bleeding, and it all starts with vasoconstriction. That's the first reflex after the vessel injury. And so here we got a 19-year-old pricking his finger and the bleeding stops instantly, but that's like way too fast for the clotting factors or the platelets to act. And so what's actually happening is that there's damaged endothelial cells that release endothelin, and that's a potent vasoconstrictor, and that combined with the reflex nerve signals causes the vessels to spasm and also to narrow, and that then slows the blood. And so that gives the body some time to start building the platelets and the clots. But the initial bleeding is going to stop because of the vasoactive substances. And so that's why the answer is the local release. It's that immediate stoppage, which is the vascular spasm, the local secretion of endothelin. Here's the bottom line. Rapid cessation of bleeding post-injury is primarily due to the local release of vasoactive substances. All right, for this question, I just want to go over the pathophysiology of cystic fibrosis. You have 2 copies of mutated CFTR that's needed for the disease. Carrier patients. So we have a 3-year-old boy brought to the pediatrician due to chronic cough, failure to thrive, and frequent foul-smelling stools. Exam shows nasal polyps and digital clubbing. Sweat. Chloride testing reveals a value of 72. Genetic testing confirms we got that mutation of both alleles, which is the best explanation of the underlying defect caused by this mutation. It's going to be the abnormal post-translational folding and degradation by the proteasome. All right, so that CFTR refers to the cystic fibrosis transmembrane conductance regulator. And this is an ATP-gated chloride channel that's found in the epithelial cells, so like the lungs, the pancreas, the intestines, the vas deferens. And this kiddo's got the classic CF problems, right? They got the chronic cough, failure to thrive, nasal polyps, digital clubbing, positive sweat chloride tests, and they even confirm it genetically. And so they're asking, hey, what is the cellular consequence of this mutation? And that's the most common CF mutation. And it's a deletion of the phenylalanine in the position of 508. And so that causes the misfolding of the protein that causes the ER retention and then the degradation, and leads to the absence of the CFTR gene at the membrane. And that causes the thick mucus and the blocked ducts and the pulmonary infections and the pancreatic insufficiency, all of that stuff. So you have no chloride transport, so you get the thick secretions. And you confirm that with the sweat chloride test. All right, so here we have a 45-year-old man who goes to the dermatologist with complaints about an intensely itchy rash, predominantly affecting his elbows, knees, and lower back for the past 2 months. He reports he was diagnosed with iron deficiency anemia 6 months ago, and he has a history of gastrointestinal discomfort that improves with dietary changes. Physical exam reveals multiple excoriated papules and vesicles with crusting, primarily on the extensor surfaces of his extremities and lower back. No mucous involvement is observed. Skin biopsy is performed, and direct immunofluorescence demonstrates granular IgA deposition on the tips of the dermal papillae. Which of the following is the most likely diagnosis? Okay, so we have the itchy elbows and the knees. And so here we should actually think about the gut. So he's got a rash that keeps him up at night. It's itchy, vesicular. In the extensor surfaces is where it's located. He also has iron deficiency anemia and other gut symptoms. And skin biopsy shows the IgA, the granular deposits there in the dermal papillae. That's going to be the signature finding of dermatitis hepatiformis. That's the skin manifestation of celiac disease. And so we just pick dermatitis hepatiformis and we move on. The answer is C. All right, there are a couple of trap answers here. Bullous pemphigoid would be the tense bulle in the elderly that would have linear IgG along the basement membrane. Linear IgA bullous at the basement membrane. Well, that would be linear, not granular, and it lacks the celiac associations. Lichen planus is the pruritic papules. You see the Wickham striae there, so there's no vesicles or IgA findings, so that's not the answer. And then psoriasis would have the silvery scale ospit sign stuff. So wrong lesion type, wrong histology. All right, so there's the explanation. Basically, you get those immune complex forming. Those immune complexes get formed at the cross-reactive IgA antibodies because you mistake the skin for the gluten targets. The body's stupid. And the bottom line is granular IgA deposition at the dermal papillae confirms dermatitis hepatiformis, often associated with gluten sensitivity. All right, here's the next practice question. We have a 3-year-old girl brought to the clinic by her parents due to concerns about skin sensitivity in the sun. They reported that her skin appears unusually pale and she's easily developing sunburns after minimal sun exposure. Upon examination, the child's hair is noted to be lightly blonde, almost white, and her eyes have strikingly light blue color. She is hesitant to open her eyes fully under broad examination of lights, which the following best explains the reason for her skin findings. This is definitely going to be a genetic defect. And I've already written out some of this pathway here that we got to know. We have to know about melanin biosynthesis, especially in the context of albinism, which this kid has. She's got the very fair skin, the white blonde hair, the silvery kind of hair. And she's got that sun sensitivity and the photophobia, the light sensitivity. That's due to the lack of the melanin in the iris and the retina. And so this is going to be a type 1 oculocutaneous albinism. And this is most commonly caused by a mutation in the tyrosinase gene, TYR. And so our answer is enzyme tyrosinase. Let's talk about these other answers. So the autoimmune destruction of melanocytes would be vitiligo. That's the localized depigmentation. That's acquired patchy, and you would have normal eye and hair color. Disruption of the migration of melanocytes. That's in Waardenburg syndrome. So not it. Decreased number of malignant melanocytes. That'd be like a nevus, like a birthmark. And the melanin distributed to the dermis. Those will be the bluish patches in the infants, not the generalized hypopigmentation. And so what happens is you have a mutation here in this TYR gene. So you have defective tyrosinase. And so you can't convert the tyrosine to dopa to melanin. You just can't do it. So the melanocytes are present, but they just can't synthesize the pigment. And so the result is hypopigmentation of the skin, the hair, the iris, the retina. And so you get photosensitivity, increased risk of UV damaged DNA, and also some visual issues due to that absent melanin. And so that genetic defect causes albinism, leading to pale skin, light hair, and increased sun sensitivity. All right, last I want to talk about ARR. So here we have a 60-year-old female with hypertension, type 2 diabetes. Her medications are metformin, lisinopril. Study compares the new drug to the placebo. Placebo, 20% experienced MI, and the group receiving the new drug, 15% did. And so the absolute risk reduction is going to be 20 minus 15, so it's 5%. Yay. And really the one thing I wanted to let you know about this one is that if you do 1 over the ARR, then you get the number needed to treat. So there you go. It's that simple. Absolute risk reduction would be 20% minus the 15 equals 5. Hopefully you guys found this interesting and helpful. Now I'm going to create a song so you guys can listen to recap all the high yield information. And if you like this, then like and subscribe. We'll see you guys in the next video.
Yeah. Firm neck fatigue, she's feeling cold. Lymphocytes attack and thyroid's uncontrolled. Anti-TPO, hurtless cells on deck. Hypothyroid swag, keep that T4 in check. In autoimmune hypothyroidism, lymphoid infiltrate. Phagocytes eat but can't kill the staph. For the pH oxidized missing from the path. Catalase positive bugs stay alive and spread. Neutrophils work but ROS is dead. And the PF Niacin Deficiency, CGD impaired ROS killing. Girl got a note and a scratch on her hand. Axillary swelling she don't understand. Gram neck plumorphs under silver's glow. Bartonella in the blood, let the fever flow. A leg cat scratch disease and necrotizing granulomatous lymphadenitis. Rhyme mismatch, bilirubin flying high. Unconjugated trouble, basal ganglia cry. Exchange transfusion trying to clear that flame, but bilirubin bound got a deadly name. Hemolytic disease of reborn and conjugated bilirubin kernicterus. She got gallstones blocking ducts that meet at the ampulla of farther inflammation heat. Lipase elevated pain hits the back. ERCP for stones to get her on track. And gallstone at ampulla and acute pancreatitis. ES preserved but the ventricle stiff. HTN made that myocardium thick. S4 knocking, lungs got rails. Left heart failure with diastolic nick. The lip blood tries to spill, but adrenaline tightens up the drill. Vasoconstrictions first to act. Febrin comes later, that's a fact. Link immediate vasoconstriction. Post-injury, endothelin release. Yippee. Sibling got CF, so check your draw. Parents both carriers, that's the law. You ain't sick, so you ain't AI. Leaves 2/3 chance that you carry that flaw. Lame carrier risk and unaffected sibling. Equine sibling has CF. Herpetiformis rhyme, I'm gluten flaring rash on that butt and knee. Papulas, vesicles, itchy as can be. Iga dermal papilla stay. Treat with gluten free and dapsone spray. Dermatitis, herpetiformis. Ike at dermal papillae. Sock with celiac.
Hello, everybody, and welcome back to MBME 28. These are original questions, but it's everything that I think you should know by the time you finish MBME 28. Now, in this question, I'm going to have to talk about sensitivity, and sensitivity is simply the true positive rate. And the way to think about this is if you're dating somebody and they are a sensitive person, you think, oh, that's truly a positive trait. But if you're dating somebody and they have to specify who they're dating, that's a truly negative trait. Like, who are you dating again? Let me think. Negative, red flag, stay away. And the only other thing to know about this question is that screening tests must be highly sensitive. And the reason why is that will minimize the false negatives and rule out the disease. And the way you remember that is SNOUT. Sensitivity for SN rules out the disease. So you have to be highly sensitive, which is, again, a truly positive rate. Because if that truly positive sign is high, then it minimizes the false negatives and it rules out the disease. Also, predictive values, they change with the disease prevalence. And so in high-risk patients, a low sensitivity screen is especially dangerous. So the big takeaway on this one is a high sensitivity will rule out, and the way you remember that is SNOUT. Because sensitivity maximizes the true positive detection, and specificity minimizes the false positives. You remember that one by SPIN. Specificity rules in the diagnosis because it minimizes the false positives. And the reason I've got these awesome little images over here on this side of the screen in the bottom line is that colorectal cancer begins as adenomatous polyps. You detect them early through a colonoscopy. But if you just do a fecal oral blood test, then you can miss the non-bleeding lesions. A colonoscopy is the gold standard, has high sensitivity and specificity. But if you just did a fecal occult blood test, you miss the polyps and the bleeding tumors, and you might have a false negative. You might say, oh, you're totally fine. But if you don't do the colonoscopy, you won't know that for sure. And so here we have a 59-year-old man, it could also be a woman, hence this photo, comes to the clinic for routine evaluation. His or her father died of colon cancer as well. The patient is asymptomatic and has no personal history of gastrointestinal disease. He or she requests to avoid invasive procedures and instead do a stool-based screening test. However, the physician is like, hey, that's not ideal. And what is the reason why? The answer is C, the poor sensitivity. And if we look here, sensitivity rules out the disease, and that's what we're trying to do. And this test that he wants to do does not have a high enough sensitivity. So the rationale is that we have a family history of colorectal cancer. That means we have a high pretest probability. And so this fecal occult blood test is not going to be good enough because it's not sensitive enough. If it's low sensitive, then it might have a false negative. You might be like, oh, you're totally fine, even though you're not. And that's the reason that we want to do a colonoscopy in this case. False positive means you have a low specificity because the problem here is missing cancer. If you flag it and you're wrong, no big deal, you don't die. But if you miss it, then you do die. That's the way to think about these things. All right, moving on to question 22. Here we have a 44-year-old man developing acute kidney injury after several hypotensive episodes. during surgery? And this question is really just getting at some basic science stuff, and so it could really be any demographic. But just so that you guys can visualize this particular scenario, I'm going to go ahead and update this image on the left. That will happen soon. Over the next 2 weeks, there it is. Over the next 2 weeks, his renal function gradually improves. This improvement is most likely mediated by which of the following mechanisms? Okay, so he's improving. And again, I mentioned this is a basic science question. And the two most relevant facts you need to answer this question are, one, most of your hepatocytes and renal tubular epithelial cells are actually in the G0 phase, the quiescence phase. That's basically the state of inactivity or dormancy. And that's where they're at in normal conditions. But if you get injured, then these mature cells are going to regenerate by being recruited from the G0, the quiescent phase, back into the cell cycle. And the cell cycle, as you know, goes from G1 to S to G2 and then to M. And so this is the inactive state, the G0. And basically what you need to know is that this person has stable cells until the injury occurs. You know, in your hepatocytes, renal tubular epithelium, and your smooth muscle, they're all normally in the G0, but they can re-enter into the cell cycle after the injury. All right, so the answer is C, recruitment of the renal epithelial cells from quiescence, which means inactivity or dormancy. Let's look at the other reasons why these other answers are false. Bone marrow-derived stem cells does not contribute to the renal regeneration. Resident immune cells do not replace the epithelial tissues. And a shortened G2 to M phase doesn't help if they're quiescent to begin with. And transdifferentiation, they don't become renal epithelium. They're organ-specific, and so they stay in their lane. And the mechanism is important. You have injury, and how is this actually able to be signaled? Well, the answer is growth factor signaling. So HGF, EGF, TGF-alpha, that kind of stuff. That's the growth factor signaling, and that causes the quiescent cells to transition from G0 to G1 to replication. And so this is going to be associated, they'll ask you about this on test day, with liver regeneration after a partial hepatectomy. It's because the hepatocytes are re-entering into the cycle, not the stem cells. Also, they'll ask you about a kidney recovery after some sort of acute tubular necrosis. So for instance, there you could have your proximal tubule cells. Those replicate to restore your architecture. And so the injury leads to the loss of the cell-to-cell contacts. And once those guys don't have that contact, then the growth factor is released and then the cell cycle goes into re-entry mode. So just to be very, very clear on the pathophysiology, what's happening here is that in our normal cells, most of your hepatocytes, and again, hepatocytes is just a nice way of saying like a liver cell, and your renal tubular cells, they all start in G0. And that's the normal phase. Like if you're just sitting in your body, that's what you see. Then you undergo some sort of a toxic or ischemic injury, and that causes some cell loss. And the surviving cells receive growth factor signals. And we discussed what those growth factor signals are. Here they are right there. And the surviving cells receive those signals, and then they re-enter into the cycle at G1. And this replication restores the organ mass and the function. So you have stable cells, and then you use the growth factors, and then stem cell activation is going to be actually like a minimal repair compared to the existing mature cells that are actually there in the G0 quiescent phase. So another big trap in these questions is you don't want to confuse decreased apoptosis or a shortened cycle time. What actually happens is our G0s just go, okay, forget this, I'm going to be a G1 now. And they're mature, they're in the hepatocytes and the renal cells. Okay, so that's how this works, a basic science question. Now we're moving on to 23. All right, so now we're going to be tackling an ethics question here. So we're going to change this so that it's just some adolescent. It could really be any demographic though. And what's happening is somebody's going to come in and they're going to say, hey doc, I'm worried, I don't know what to do. And the ethics question here is going to be getting at asking open-ended questions to clarify the concerns. So just to show you it's a different demographic, here we have a 9-year-old girl is brought to the pediatrician because her mom is saying that something's wrong. And the correct answer is, tell me more about your worries and what you're eating. Always ask open-ended questions to clarify and understand this better. Don't do unnecessary testing. Don't just start educating them. Try to figure out exactly what they need. And most of the times, especially in pediatrics, like half of the medical complaints are just going to be parental concerns, not actually the child themselves. So this is actually a very important skill. All right, so here it could be a different demographic, but we're using a 45-year-old man, could be a woman as well, but I'm going to go ahead and change that in the upper left corner. And they have a history of psoriatic arthritis, presenting to the clinic with persistent fever, weight loss, and chronic cough. He began treatment with the new medication 6 months ago that significantly improved joint pain and skin lesions. Chest x-ray reveals bilateral upper lobe infiltrates. Sputum shows as positive for acid-fast bacilli, and the mechanism of action in this patient's medication is most likely interfering with which of the following processes. Okay, so here are our answer choices. And to kind of get at this question, I want to talk about the pathophys. Let's talk about Mycobacterium tuberculosis. That's what persists within intracellularly. That persists intracellularly within the macrophages. And there's this thing called TNF-alpha. And TNF-alpha, that goes ahead and it activates the macrophages where it drives granuloma maintenance. And so if we give anti-TNF-alpha, if we block that TNF-alpha, then we're going to block that granuloma disintegration. And so this guy's got some chronic coughing. He began this medication that seems to be reactivating his tuberculosis. That seems like the mechanism of what's happening in this patient. And they're going to be saying, okay, well, why is this occurring? And the answer is the sequestration of the pathogens through granuloma formation. So they're using anti-TNF alpha therapy that has reactivated latent tuberculosis due to the impaired granuloma maintenance. TNF alpha is very important for walling off the TB, and if you don't have it, then it can escape and reactivate. Interleukin-2 is associated with hot T-bone steak, so it's T-cell activation. IL-5 is relevant in parasitic infections, not in TB reactivation, and germinal sensor B cells. For that, you would use rituximab and anti-CD20, not TNF blockers. And the complement-mediated lysis is not the mechanism for clearing intracellular TB. So as we discussed, this TNF alpha maintains the granulomas, and that's super crucial for containing tuberculosis. If you think about tuberculosis, it's active inside of your body, and TNF alpha is the reason that it's contained. It maintains that wall, so to speak. And if you give them anti-TNF therapy, that'll disrupt the granuloma integrity, and that leads to reactivation. They could try to give you other trap answers, like they could say, hey, what about interleukin, 8? Well, interleukin 8, that attracts the neutrophils, but that would not be getting at the main mechanism here. They could try to say B cells and antibody responses, but that's not going to be relevant. Rituximab isn't relevant here. The TNF alpha does not directly kill the bacteria either, and if they said something else like, IL-10, well, that would dampen the immunity, but it's unrelated to the granuloma maintenance. And so granuloma maintenance is really going to be most affected by that TNF alpha, and so you inhibit it with your anti-TNF alpha therapy, and that actually gets at the disruption of that granuloma, causing the reactivation of tuberculosis. So in this patient, you have to recognize that they have tuberculosis, they have caseating granulomas, infliximab, monoclonal antibody inhibitor, you have the cough, fever, night sweats, and a lack of TNF alpha causes the poor macrophage containment of the tuberculosis, and that's why this person got sick. Cool. All right, in our next question, we have a relatively young boy is brought to the emergency department after experiencing persistent bleeding several hours after a minor bike accident that resulted in a cut on his history of easy bruising and missed multiple school days due to joint swelling. Physical exam shows large, swollen right knee. Coagulation studies show normal PT. PTT is prolonged, so that's the intrinsic pathway. When mixed with normal plasma, it corrects. The sample from the maternal uncle shows no correction in a PTT when mixed with this patient's plasma. Which of the following is the diagnosis? All right, so for this one, we have to know the coagulation cascade, and we also have to know some basic science facts about this condition. So first of all, let's talk about hemophilia. We'll talk about hemophilia B. That is an X-linked factor 9 deficiency, and that causes a prolonged PTT with a normal bleeding time and platelet count. And mixing studies correct the PTT if the missing factor is supplied. In the uncles, it wouldn't if he has the same condition. So if it corrects with plasma mixing, that means it's a true deficiency, not some sort of inhibitor. And the mechanism here is just factor 9 deficiency, which blocks the activation of factor 10, and that stalls the formation of thrombin. And this is X-linked inheritance, and so boys are often going to be affected, and family history is going to have a male bleeding disorder if it's hemophilia B for boy. Hemarthrosis and deep tissue bleeding is the hallmark of hemophilia versus mucosal bleeding. And so the treatment is really just going to be recombinant factor 9. And again, it's just a simple deficiency. You've got a deficiency of factor 9, so you have impaired activation of, if you remember the coagulation cascades, that means you can't activate the factor 10. And if you can't activate factor 10, you have decreased thrombin. Decreased thrombin means decreased fibrin clot stability. And then you have prolonged bleeding after something like a tooth extraction or circumcision. That's why usually they're going to be a younger patient. So deep muscle bleeds, hemarthrosis, which is the bleeding into a joint causing the joint pain and swelling. That's why you miss several days of school. Now, von Willebrand's would actually show a prolonged bleeding time, and that's the reason that's not the answer. And we can kind of scroll down and see some of these explanations here. Hemophilia A would be factor 8 deficiency. It would not correct because they both lack the factor 8. We mentioned von Willebrand's has a prolonged bleeding time because it stabilizes factor 8. Antiphospholipid antibody syndrome would be a lupus anticoagulant, be thrombosis, not bleeding. DIC would have decreased platelets, increased both of these, and also increased D-dimer. And so oftentimes these kids don't even know that they have this disorder until they go to the dentist, and then they start bleeding like crazy, and then it's like, okay, you have hemophilia type B. But typically you can find that through B as in boy looking through the family history. Hemophilia A is an 8 deficiency. Mixing with this patient's plasma does not correct. So here we have an intrinsic pathway defect, X-linked, and it's corrected by mixing. Just to make this super simple about hemophilia A versus B, mixing studies will distinguish between them. Hemophilia A versus B and a clotting inhibitor like lupus. Basically, you add normal plasma, then you recheck the PTT. If it corrects, you have a factor deficiency like A or B. And if PTT does not correct, then it's a clotting inhibitor. So you actually get that plasma from a known hemophilia patient and find out the missing factor. So look out for the big things here would be like trauma, easy bruising, hemarthrosis, and that's the reason why this kiddo was missing school. Here we also have the bottom line, prolonged PGT, and let's go to the next question. All right, next, alpha blockers. Here we have a 59-year-old man started on some new medication for hypertension. A few days later, he's feeling lighthearted when standing up quickly from a seated position. Blood pressure is 134/84. Heart rate increases from 72 to 96. Medication he's taking most likely decreases which of the following pharmacological physiologic parameters the most. All right, so there is a picture of our guy, and our answer is peripheral arterial resistance, and we have to know why. And basically what we're doing here is we are turning down the squeeze. This is an alpha-1 blocker. So alpha-1 adrenergic receptors on the arterial smooth muscle, they raise the systemic vascular resistance and it blocks. And if you block them, you will lower the SVR. And if you lower the SVR, then you're going to be decreasing the mean arterial pressure. And so the venous alpha-1 tone will fall too. But then the dominant acute blood pressure effect on the alpha-1 blockade is then dropped in the peripheral arterial resistance. So arterial vasodilation, the alpha-1 blockade relaxes the arterial smooth muscles and that decreases the systemic vascular resistance. So you have less afterload and lower MAP, mean arterial pressure. So why would you even give these guys? Well, BPH, prozazine, doxazosine, these are alpha-1 blockades that relax the prostatic urethral smooth muscle, lets it just chill out. But that same mechanism will also lower the SVR. And one thing that they like to test you on is that you can have reflex tachycardia because the baroreceptor, it's like, oh, look at that MAP, look at that mean arterial pressure going down from the decreased SVR. And it's going to say, okay, well, we have to increase the contractility. So that's reflex tachycardia. And they do that via the beta-1. And that's like a compensatory mechanism. It's not going to be a primary mechanism. So they're able to drop his blood pressure and the heart rate increases because of that reflex. So we have alpha-1 antagonism. And the alpha-1 antagonism actually decreases the GQ signaling in the vascular smooth muscle, and you get arterial dilation. So you decrease the SVR and you decrease the mean arterial pressure, and you have venodilation. And so the key features, you'd have heart rate contractility can rise, but the SVR is definitely going to drop, and you have an orthostasis risk. That's the reason why this person was like feeling a little bit woozy when he's standing up. That's highest with the first dose of the volume depletion, because the beta-1 is also going to be driving the heart rate and the contraction, whereas the alpha-1 is going to drive the vascular tone. All right, so here we have a 19-year-old college student, could be a male or female. So I've shown a picture of a female here. Later, I will put up another demographic so you don't get fixated on that, but it'll be of a 19-year-old college student. Evaluated for decreased exercise tolerance. He denies chest pain, syncope, or prior illness. He has never smoked. On exam, his lungs are clear. Cardiac auscultation reveals a grade 2 out of 6 systolic ejection murmur at the left upper sternal border. Also a widely split heart sound that does not vary with respiration. Which of the following best explains this patient's findings? So a lot of this stuff is super pathognomonic. We have a fixed, widely split S2 that does not go away with inspiration. So it's going to be an atrial septal defect with a left-right shunt. And you have increased right-sided flow. That delays the pulmonic valve closure. And so you have a P2 delay. So here's our 19-year-old college student with a decreased exercise tolerance, denying any chest pain. And really what gives this away is the fixed split S2. The right ventricle stroke volume is going to be chronically elevated because of that left to right shunt. And so the P2 is always going to be delayed regardless of the respiration. And so the answer is a defect in the endocardial cushion development. You might be saying, okay, well, why is that the case? Well, that's what you have to memorize for ASD. It's the ostium primum or secundum. So you have the left to right shunt, and then the right heart is overloaded. So you have that fixed S2, the split S2. Patent arteriosus is going to be machine-like. We all know that. It's not fixed. S2, pulmonic stenosis. The splitting would be respiratory dependent, not fixed. VSD is a hollow systolic murmur at the left, the lower left sternal border. Tricuspid regurgitation, a hollow systolic murmur, increasing with inspiration, not a fixed S2. And this is about 1 out of every 1,500 adults have some sort of ASD, and it's that fixed, widely split sound. And that happens because of the increased blood through the pulmonic valve. And later on, you can have the development of Eisenmenger syndrome, where it reverses from that left to right shunt. Next, we have a 61-year-old obese man presenting for evaluation of chronic cough and intermittent hoarseness. He reports worsening symptoms over the past 6 months, including a sour taste in his mouth after meals. All right, so there's our more obese man. He's got retrosternal burning, so that's GERD, yep, and he has been non-compliant with his medications. Upper endoscopy reveals a salmon-colored mucosa extending proximally from the gastroesophageal junction. Biopsy of the affected area demonstrates mucin-secreting columnar epithelium with scattered goblet cells. Which of the following is the best histologic finding? All right, so this is going to be GERD gone kind of rogue here. This is Barrett's esophagus. And what you should be thinking of for this condition is intestinal metaplasia with the goblet cells. And you have squamous epithelium of the distal esophagus. The distal, they're always going to say something like the lower, maybe they'll say the lower third of the esophagus, something like that to denote that it's going to be the distal esophagus. And it adapts to the chronic acid injury by transforming the columnar epithelium. And so it starts to resemble that intestinal mucosa. It's like, hey, you're doing things that the stomach is doing, so let me give you some of that good intestinal mucosa. And the goblet cells are trying to help, right? They secrete the protective mucin. And so you have a pre-malignant lesion, which then leads to adenocarcinoma, and that metaplasia increases the risk of dysplasia and eventual adenocarcinoma. And so you know that this is GERD because of that retrosternal pain, the repeated acid reflux, and the smoking and obesity also increases the intra-abdominal pressure and acid exposure. So smoking is bad, obesity is bad, GERD is bad. The hiatal hernia also predisposes an individual to a reflux. And then adenocarcinoma, well, Barrett's is going to be the strongest risk factor because of that dysplastic intestinal epithelium that progresses to malignant transformation. So you have chronic acid reflux that damages the squamous epithelium. Then you have adaptive metaplasia that replaces the squamous with the intestinal type of the columnar cells. And then the goblet cells are like, hey, we got to get in there and do some protection. And they essentially supply the esophagus, the lower part of the esophagus, with intestinal type material, the columnar cells. And then the goblet cells produce the mucin for protection, but they do that pretty much at the cost of genomic stability. And so you have ongoing injury, dysplasia, and that all increases your risk for adenocarcinoma. And so the big risk factors here are going to be GERD. Look out for GERD. Acid reflux, the biopsy would show columnar epithelium and maybe even some goblet cells, and the risk is adenocarcinoma, not necessarily your squamous cell carcinoma, but yes, certainly some metaplasia. And so our answer is going to be intestinal metaplasia of the esophageal epithelium. Here's the brief explanation. We kind of went over this stuff. Why is it not A, squamous hyperplasia? Hyperplasia is reactive, does not explain the goblet cells. Chronic inflammation of the lymphoid, that's chronic gastritis, so maybe H. pylori, but not GERD and metaplasia. Squamous and keratin is squamous carcinoma that's not related to GERD. That'd be smoking, alcohol, and a mid-esophagus, not distal esophagus. Again, they're going to say the lower third. Adematous transformation of the submucosal glands is not going to be involved in Barrett's because that does not undergo that intestinal metaplasia that we talked about. And this is going to be 1 in 10 patients who have chronic heartburn are later going to develop a condition that rewires that cellular esophagus and turns it more into mucosal cells. All right, that's called Barrett's esophagus, and that changes intestinal metaplasia because those goblet cells are in the place that they shouldn't be. So it's that C intestinal metaplasia of the esophageal epithelium. Okay, so that's Barrett's esophagus for you. All right, this is a good question, and this technically could be a man, but the practice question I'm giving you guys is going to be a woman just because I want you to be a little bit more familiar with how this is most commonly going to be presented on the exam. So we have a 43-year-old woman presenting to her clinic, her PCP. I'm going to give you kind of an updated photo there. With progressive fatigue and exertional shortness of breath over the last 3 weeks, she has no cough or chest pain. Vital signs are normal. Pulmonary and cardiac exams are unremarkable. She is a vegetarian and has some heavy menstrual periods. Hemoglobin is at 8. That's actually super crazy important. If it were normal, this would be a totally different diagnosis. So hemoglobin is at 8, which is low. Hematocrit is low. Here's some other labs. Which of the following best explains the symptoms? All right, so it looks like they have maybe some normal PaO2 and SaO2, but we have some low arterial O2 content. This is at 11%. And that's probably because of the reduced hemoglobin. And the hemoglobin is, of course, the main oxygen carrier. Let's go over the basic science. The O2 content is the hemoglobin times a coefficient times the SaO2 plus a coefficient times the PaO2. And so even if you have normal PaO2 and SaO2, these are just 2 of the variables here. The hemoglobin could actually drop as well in anemia, and that lowers your O2 content because of that anemia. So these are the 3 factors you should consider if somebody's struggling with their O2 content. So you have normal PaO2 and a low O2 content. It's probably going to be anemia because of that hemoglobin deficiency. You have hyperventilation without hypoxemia. It's anemia because you have a compensatory mechanism to tissue hypoxia. Low oxygen delivery, even though you have the PaO2 and the CO2, is just fine. And you have reflex tachypnea and hyperventilation, and that decreases the PaCO2. So some associations that you should be aware of are chronic kidney disease. That's where you have a decrease in the EPO. That makes total sense because that's where the production occurs. Yeah, that's normocytic anemia. Iron deficiency would be a microcytic anemia. You have low O2 carrying capacity. Cancer is marrow causing the anemia. And then pregnancy is dilutional, and lead poisoning is defective heme synthesis. So these are kind of all the associations that you should be aware of, at least for anemia in this particular question. And the pathophys is that you have low hemoglobin, and that decreases the carrying capacity. And so if there's less oxygen that's going to be transferred to your tissues, and you have that normal because there's intact lung oxygenation, it's just that you don't have the things that carry that oxygen. And so the PaO2 and SaO2 are normal, but the CO2 is going to be low. The reason why is there's poor tissue delivery and there's compensatory hyperventilation. And the hyperventilation gets rid of the CO2. And that's the reason why you have normal PaO2 and low CaO2. There's not enough oxygen pressure, there is enough oxygen pressure, but there's not enough hemoglobin trucks. Think about like little hemoglobin trucks that carry that oxygen. And so you get hyperventilation because your tissues are like, I need to breathe, man. Give me some more oxygen. But they can't. And so they have no trucks. And so this is a hemoglobin problem. All right, and so our answer is going to be iron deficiency anemia, and I think that was one of the only anemias listed here. The brief explanation, we kind of went over that. Alveolar hypoventilation. If you're hypoventilating, then you have an increased PO2, so that doesn't make any sense. High altitude would have decreased PaO2, but we said that was normal. Pulmonary embolism would have some sort of a VQ mismatch or tachypnea and also chest pain. We don't see that here. And anxiety hyperventilation, dizziness, tingling, but we do not reduce the arterial O2 content unless it's combined with another pathology. All right, so the real kind of big takeaway here is we got somebody with fatigue, menstrual bleeding, shortness of breath. Everything looks normal, but the oxygen content is low. And if the content is low, then there's not enough hemoglobin trucks that can carry this thing. And so it's just some sort of anemia. The anemia they gave us was iron deficiency anemia, and that's why it was the correct answer. All right, this is a really cool question. Here we have a 40-year-old woman undergoing evaluation for fatigue is found to have low free T3 and T4 levels. All right, so I'm updating that. So she's a little bit older, but she has a high total T3 and T4 level, and her TSH is mildly elevated, and she has recently started estrogen therapy, which the following best describes how thyroid hormones exert their effects on the tissues. Now, this is a really interesting basic science question, and we have to know how thyroid hormones work, like T3, and how it works is that it binds to the nuclear receptor, and that kind of functions as like a transcription factor. And we might have increased TSH, decreased T3 to T4, and this makes us think of primary hypothyroidism, right? So typically that would be like Hashimoto thyroiditis. It's most common in middle-aged women, and also there's autoimmune destruction, and that causes increased TSH from the loss of the feedback. So you have decreased TSH and decreased T3, T4 would be a secondary problem, like a pituitary, or maybe a tertiary problem, like a hypothalamic problem. So there's like Sheehan syndrome, pituitary adenoma. And another scenario that you could also have, and I'm just kind of giving the lay of the land of all of this TSH stuff. So again, this right here would be Hashimoto's. If they were both decreased, then we just mentioned that's secondary or tertiary hypothalamic hypothyroidism. So like a pituitary adenoma or Sheehan syndrome, or maybe a hypothalamic tumor. If you have normal TSH, that's interesting, and you have decreased T3 and T4, then that could be just sick euthyroid syndrome. And that's where you have a low T3 due to illness with a low or normal T4, and the TSH is just not elevated. And so just some other kind of facts to look out for here. Thyroiditis is autoimmune antithyroid peroxidase, so the anti-TPO is what's associated there. And the risk also is increased of non-Hodgkin's lymphoma with Hashimoto thyroiditis. In sick euthyroid syndrome, that's in hospitalized patients who are chronically ill, and that's due to a decreased peripheral 5' deiodinase activity, and that causes the low T3, even though you have normal TSH. And then the secondary hypothyroidism, that's like a pituitary disease. All right, so what's happening in this question? Well, here they're just kind of asking, hey, what describes how the thyroid hormone exerts their effects on the target tissues? And the answer is that they bind to the intracellular receptors that regulate the gene expression. So T3 binds there to the nuclear receptors that function as transcription factors. They are amino acid based, but they kind of are like steroids because they're lipophilic character and nuclear mechanism of action. All right, GPCRs, that's like a lysosomal degradation. That's when you have excess proteins. Cyclase stimulation would be with a peptide hormone, and ribosomal binding is seen in mRNA translation. So yeah, your T3s, they are kind of special. They sneak in through the cytosol, go straight to the nucleus, and then the T3 binds to nuclear receptors. So it's kind of like a steroid. And T3 is going to be the activated, T4 is like the pro-hormone. So these, even though they're like amino-generated, they don't sit on the cell surface. They actually go into the nucleus. And so the answer is that they bind with the receptors to regulate gene expression. All right, guys, hopefully you found this helpful. If you like some of these new things that I've incorporated over here on the side, then please let me know. If you like the green screen, let me know. I could also switch it back if you'd like. Take off that green screen. Hopefully this is helpful. Hopefully you guys are crushing step 1. I've also scheduled about 100 different questions. So every single day in the community tab, you'll have a new question. So everybody be sure to like and subscribe for more content, and we'll see you guys later.